consequent to acute heart failure and cardiogenic shock of various causes. And to have a nephrologist's perspective on this, may I invite Dr. Arun Kumar Subaya. He's an assistant professor of nephrology at the All India Institute, from where come, please.
Thank you, sir. A very good morning to one and all present here. At the outset, I would like to thank the organizers, Dr. Abraham Uman sir, and my nephrology teacher, Dr. Professor Edwin Fernando sir, for giving me this opportunity. So we have had multiple topics which were discussed yesterday, and one among them was a similar topic which was discussed from an intensivist point of view. So that is why the topic does say that this is from a nephrologist perspective, and I would be speaking about kidney failure, renal replacement therapy, particularly in patients with only acute heart failure and cardiogenic shock. So the talk I would be taking out with some definitions about the renal injuries, epidemiology, pathophysiology, and then we'll probably speak about the managements. So overall, acute heart failure, whenever that is present, has a component of acute myocardial dysfunction, hypotension with derangements in renal function, which often exist as a triad and worsens as a vicious circle. In this, renal function is both an associated variable as well as a very important endpoint. And almost all studies have shown that the baseline chronic kidney disease and the development of new onset acute kidney injury, either acute kidney injury on chronic kidney disease or a new onset acute kidney injury, is going to have a very important prognostic predictor of the outcome of such patients. Overall, despite the advancements which has happened in diagnostics, prevention and therapies, there is still overall 50% in-hospital mortality for patients with cardiogenic shock, and especially patients with cardiogenic shock or heart failure and acute kidney injury. They tend to have higher complexities, more comorbidities, a longer hospital stay, and higher 30-day mortality and higher readmission rates. All this accounts for a worse outcome in these subset of patients. That is precisely the reason why renal function would be important whenever we see patients with acute heart failure and or cardiogenic shock. So with regard to the diagnosis of AKI, the diagnosis of AKI can either be preclinically, we can suspect AKI, or it can be a clinical diagnosis. This varies because the definitions of AKI has changed over the years. We initially had the rifle classification, followed by the AKIN, which came in 2007, Acute Kidney Injury Network, and thereafter the KDIGO, Kidney Disease Improving Global Outcomes Network. What was precisely the difference was that the understanding that renal dysfunction need not be severe enough to affect outcomes, one, and two, output per se would also be an important prognostic factor. So these were the changes which were there. So it was understood that a creatinine increase of as much as even 0.3 milligram per deciliter is going to affect patient outcomes. So that was the reason why the stage 1 AKI, even a 0.3 increase would suffice within 48 hours, or if you have a baseline kidney function, an increase to about 1.5 to 1.9 times normal is important, or if there is oliguria, that is less than 0.5 ml per kg per hour urine output for around 6 hours. So when the creatinine increases to 2 to 2.9 times, it becomes stage 2, and when it increases to over 3 times, or if the patient stays anuric for over 12 hours, or if the patient has a need for renal replacement therapy, it becomes as stage 3 AKI. So this is the classification which we use at present. The one thing is that this is going to probably change with the onset of biomarkers and e-alert systems which are being developed right now. So the numerous biomarkers we'll probably be discussing shortly. So yesterday during one of the sessions, one of the questions was, why is the baseline creatinine is going to be important? The reason why a baseline creatinine would be important would be, one, the patient will obviously ask whether his renal dysfunction is going to improve or not, and whether he is going to stay on dialysis once he gets discharged, or if his renal dysfunction is going to improve completely. So whenever we have a baseline creatinine, we'll be able to prognosticate the patient better, one, and two, probably Patient would be the one who has a stable creatinine always. And there will be some patients who have an acute kidney injury when there is a worsening of heart failure, and that would improve. There will be an improving renal function once the heart failure goes into remission. And then again they will have another effect. So whether the patients who recover their renal function completely, they will have the same outcome as those who are having a stable creatinine is always a doubt. However, studies have shown that those who tend to have an acute increase whenever there is a worsening, they tend to have a worse renal and a worse cardiac outcomes than one who has a stable creatinine. Probably they will have a better outcome than those who have a progressive renal dysfunction, but still this is not normal. So we should always see whether there is an undulating creatinine, because it will affect the way we tell our prognosticate our patients about progression of renal disease. So basically, from what the definitions are there, we should understand only one thing, is that one size does not fit all. We will have to do a personalized diagnosis for each of our patients as to what is AKI and how are we going to manage it. After AKI, the other things which we should remember, probably not in the acute setting, would be acute kidney disease. If the patient continues to have some degree of renal dysfunction after 1 week, but this is something which is considered to be temporal and which is going to resolve within 90 days. If the patient tends to have persisting renal dysfunction even after 90 days, then the patient is classified as chronic kidney disease. This is basically from two angles. One, from an insurance point of view, it does help for hospital co-pays, especially abroad, and also from the other component of whether the patient will require long-term renal as well as cardiac follow-up or not. Considering we know that cardiac failure and renal failure go hand in hand, renal dysfunction is more common in patients with heart disease. So how does renal failure predict worse outcomes? So the three basic major trials of cardiogenic shock, the shock trial, IABP shock 2 trial and the card shock trial, all the three have shown that the mortality is increased with patients with renal dysfunction. As we can see, the criteria used in all of them when they used a clinical prediction score was different. One had a creatinine of more than 1.9, one had a creatinine of more than 1.5, whereas the other one had just told that there is a graded association of worsening renal dysfunction with mortality. So basically we can conclude that renal function is going to increase the mortality in patients with cardiogenic shock, and also we can understand here that the classification or the grading what we use to diagnose AKI is still not very well followed in almost all trials. With regard to individual trials, major trial was the Coroni et al. Trial, where we had 118 patients with cardiogenic shock, and nearly 33% of them had acute kidney injury, and patients with acute kidney injury are more likely to die, have an in-hospital mortality. This was in the line of around 87%. This was as against 53% which is seen in those without acute kidney injury. The study by Maranzi et al. With 97 patients of ST elevation MI and cardiogenic shock, around 55% had acute kidney injury with over 50% mortality, whereas the last study from Tarvaskmi had shown that the 90-day mortality with patients of acute kidney injury was nearly 38%, and both creatinine and cystatin C were predictive variables for outcome. So just to summarize this, acute kidney injury is common. Acute kidney injury affects the patient outcomes in patients with cardiogenic shock with regard to patient numbers also. So overall, the cardiorenal interaction is a dynamic one. It is a complex bidirectional relationship which wherein the primary disease of one organ is going to affect the other organ, and this is by a combination of hemodynamic, neurohumoral as well as cardiovascular disease related mechanisms. So this concept was well shown in the diagnosis or definitions of cardiorenal syndrome, where we have type 1, type 2, where the primary cardiac disease, 3 and 4 where there is a primary renal disease affecting the other organ systems, and a combination of both hemodynamic and non-hemodynamic factors which causes worsening. So for our discussion today, we will be mostly focusing on type 1 cardiorenal syndrome, wherein you are going to have an acute heart failure which causes worsening renal dysfunction. So whenever there is a heart failure, the cardiac output is reduced. This in turn affects renal perfusion. 1, it causes systemic congestion by increasing the central venous pressure. So this congestion, it obviously affects the renal function. 1. 2, this causes an activation of the renin-angiotensin system and the sympathetic system. This would cause and vasoconstriction. So the initial compensatory mechanisms will cause vasoconstriction both intrarenally and systemically. The intrarenal vasoconstriction will also be accompanied by an increase in the filtration fraction. By doing this, the kidneys will be able to maintain their output. However, beyond a point, the compensatory mechanisms tend to fail, and this is where the natriuresis, diuresis would start to go down. This superadded on the fact that there will be pro-inflammatory cytokines which are released both with cardiac dysfunction and renal dysfunction. It causes a vicious circle wherein the renal function deteriorates completely and patient goes in for a complete renal shutdown. There are a number of mechanisms, as again we have spoken. So apart from the congestion mechanism, there is inflammation, there are neurohumoral feedback, there is a fluid overload which causes renal venous congestion, and also hemolysis in the circuits, organ microperfusion, and also at times contrast induced injury, which can all lead on to acute kidney injury. So just shows that there are a number of factors involved, and it is not isolated hemodynamic issue which causes the renal dysfunction. So there is something which I noticed was a death sequence in cardiogenic shock. Patient has a reduced cardiac output, reduction in mean arterial pressures, the perfusion, both the coronary and the systemic end organ perfusion reduces. This results in an end organ failure, which thereby reduces myocardial perfusions, myocardial dysfunction, and this becomes a vicious circle. And this probably leads to multi-organ damage as well as death in cardiogenic shock patients. So that we have seen the pathophysiology. Next step would be how are we going to diagnose it. So we do know that creatinine is important, urine output is important for diagnosis of AK, other biomarkers. Overall, for heart failure, there have been a number of biomarkers which are in development, both for treatment and management, for community-based screening, for risk stratification. As you can see, there are a number of biomarkers which are always there. However, among all the biomarkers, it is only the brain natriuretic peptide which is still in use, which has shown to be useful. And the same accounts for renal markers in heart failure. So of all the markers, cystatin C, it has been shown that it is superior to EGFR and creatinine to predict both heart failure outcomes and cardiovascular events, and it is an independent predictor of mortality. So with regard to the other markers, there were some discussions about whether NGAL is useful or not yesterday. So both serum and urinary levels of neutrophil gelatinase associated lipocalcin or NGAL, they are reflective of renal injury. They prognosticate whether the patient will develop renal dysfunction in anyone with acute decompensated heart failure. The area under the curve for this is 0.71. So it has a modest sensitivity and specificity, though not really high, it is still decent. And almost elevated levels in all studies have shown to be a poor prognostic factor, increasing the risk of mortality by nearly 2.7-fold. With regard to the other markers, KIM1 and NAG, that is kidney injury molecule, and N-acetyl-glucosamine, they have shown that their urinary levels, it correlates with left ventricular function, with the patient's clinical status in NYHA class, and also they are a marker of early tubular injury. The one which is going to come into use would be the nephrocheck test, which is already available. We do tend to use it for in the emergency at times, and also as part of studies where we measure the urinary tissue inhibitor of metalloproteinase levels and the insulin growth factor binding protein levels. The ratio of this is measured, and they have been shown to predict acute kidney injury with an area under curve of nearly 0.80, and this is probably the highest AUC compared to almost any other test any other biomarker which has been used apart from creatinine till now. So this will probably help us to better stratify our patients and also to diagnose acute kidney injury early in our patients. So overall, brain natriuretic peptides still have a prognostic value. They are still useful in patients with heart failure. With regard to newer markers, soluble suppressor of tumorigenesis, SST2 and galactin-3, they have shown some predictiveness. However, it is still early to comment on it. With regard to renal markers for heart failure, in patients with heart failure, NGAL is the most important thing which can be used for now, followed by nephrocheck and cystatin C. Urinary sodium will help us to understand how the patient evolves during hospital stay, and it was also dealt in a very nice session yesterday. So moving on, what are the risk factors? Who are the patients who are more prone to develop renal injury in patients with heart failure? As to all critically ill patients who are elderly, studies have shown that those more than 75 years especially are at a higher risk. The use of the intensity or the number of vasopressors are used in order to maintain hemodynamic instability. The more the number of inotropes, more the risk. And if at all there is a positive cumulative fluid balance after 48 hours. All patients with heart failure tend to have positive fluid balance. If they tend to have it persistent after 2 days, the risk increases. And for every 1 liter increase in the positive fluid balance, the risk of mortality, it increases by nearly 24%. Apart from this, some of the studies have shown that the SOFA scores, the use of mechanical ventilation, and whether the contrast volume, a higher contrast volume, they are all can be predictors of renal dysfunction in these patients. Going on to the management right now of kidney failure and heart failure and cardiogenic shock, we have guidelines for chronic kidney disease, we have guidelines for acute kidney injury, we do have guidelines for heart failure, very good guidelines across all organ systems. However, there is no specific guideline which deals with renal disease in heart failure or heart disease in renal failure. It is mostly consensus statements, probably citing the lack of well-managed trials or lack of evidence in this. And the renal organization Hfai, kidney disease and improving improving global outcomes, it states that the level of heart care should be the same which is given to patients with renal dysfunction and CKD as that is given to someone without chronic kidney disease. This just exemplifies the fact that patients with kidney disease tend to receive less than specific renal therapies. They don't receive the standard guideline directed medical therapies, and probably even if they receive it, the outcomes would be more. That is the only statement which they tend to give. So overall, the management focuses on three things. One would be the disease modifying therapy, where we have AC, ARBs, mineralocorticoid receptor antagonist, beta blockers, evaporatin and cardiac resynchronization therapy. So all this has been dealt with in detail already. We will be discussing only those in the acute setting. So we will be focusing only on either diuretics or with renal replacement therapy. One thing which I want to add would be that there is something called permissive AKI, or I don't know if we should call it permissive hypercreatinemia. So all the patients who are going to receive either of the protective therapies like the RAS inhibitors, mineralocorticoid receptor antagonist, or SGLT2 inhibitors, or those in which we target the intensive blood pressure control, they tend to have some amount of renal dysfunction. So what is the amount which is acceptable? Usually up to 30 to 40% increase in creatinine or a decrease in GFR is going to be acceptable, and this has been shown in almost all the major trials in cardiac disease, consensus, solved, charm and valsartan heart failure trials. So on all these patients, whenever there is an increase in creatinine, we will have to see if there is any other cause for the worsening renal dysfunction, if there is any infection, if there is any hypotension, any other nephrotoxic drug use or GI loss. If at all we are not able to find anything, then we should consider this to be a asymptomatic hypercreatinemia or a permissive AKA, and we should continue therapy rather than stopping it. This probably would improve the outcomes in the chronic setting for all our patients. If at all there is an aggravating factor, the drugs can be stopped, we treat the aggravating factor, and as early as possible we will need to initiate these therapies because they improve both the cardiac outcomes and the renal outcomes in our patients. One thing which I'll also like to add would be the renalism or the therapeutic nihilism, which is there for patients with kidney disease, where patients with kidney disease, they tend to wait longer for effective interventions to reach them as compared to those without renal disease. Though it should be the other way around, that they should receive the therapies earlier. So this is also seen in all the major heart failure trials or heart disease trials, wherein patients with creatinine more than 2.5 or more than 3 have been excluded always, and all the patients with GFR less than 30 have been excluded. So this is something which probably is changing now with the DAPA CKD Emperor reduced and other trials which are coming up, and this is probably a welcome sign right now. So going on to the focus of cardiogenic shock, the management would have 5 aspects. One would be to maintain the hemodynamic stability with pressure or inotropic support, early revascularization in patients with issues, mechanical ventilation for those with respiratory compromise, mechanical circulatory support for patients who are refractory to medical therapy, finally renal replacement therapy. As I mentioned, I will be focusing only on the diuretic and the ultrafiltration aspects. So overall, with regard to the diuretics, the dose trial, it had shown that less than 15% of the patients with a decompensated heart failure tend to be treated appropriately with diuretics. This is something which can change. The diuretics which we use commonly are the loop diuretics. Furosemide and torsemide are the ones which are commonly used. Both of them, they can be used interchangeably. However, it should be remembered that when an oral dosing is given, furosemide has a variable oral bioavailability, which is only 50 to 100%, whereas torsemide has a good oral bioavailability. So this has to be remembered. Second cheese would be that if the patient tends to have renal dysfunction, furosemide has some amount of renal excretion. So it tends to be retained and can have a longer duration of action, and probably in the long run for those with renal dysfunction, it may become equivalent to torsemide in this. And how are we going to approach, or how are we do a inpatient thing? So this was something which was nice, which I noticed, was that once we initiate furosemide or any other loop diuretic in an inpatient, usually it is started at a dose of 2.5 times the earlier dose. We will have to assess either the urine output or the urinary sodium. If at all we are assessing the urine output, we will have to assess it at 2 to 6 hours. We require an output of around 150 ml per hour at least. If at all that is achieved, it is okay. Otherwise, we tend to double the dose of diuretic. Similarly, we can also monitor the sodium, urinary sodiums. It has to be more than 70 millimoles per liter. If it is there, then the diuretic response is thought to be adequate, that is adequate natriuresis. Then we can continue the same dose. Or else we will again have to double the dose of diuretic in this scenario. After this, the next step would be, once we double the dose or we reach the maximum dose of diuretics, if the patient responds, well and good. If they don't respond, then we have to go for add-on therapies with either thiazides like metalozones, or we can also try acetazolamide, which was shown in a recent trial right now. There is always a discussion whether furosemide is better or torsemide is better. Torsemide and furosemide, torsemide has a longer duration of action of around 12 hours, has an equal oral and IV bioavailability overall, whereas furosemide lasts for 6 hours, lasts for 6 hours, and the oral dose is double the IV dose. And the trials, almost all the trials have shown that torsemide probably is slightly better with regard to readmission rates in some of the trials and with NYHA class in some of the trials. However, none of the trials have shown that there is a difference in hard outcome, that is all-cause mortality between either of these loop diuretics. And the trial which was one of the trials which was published probably a couple of weeks back was the Transform Heart Failure trial. So this trial was envisioned in a manner that nearly 6,000 heart failure patients would be included. They would be randomized on an outpatient basis to torsemide and furosemide equally, and the all-cause mortality would be observed. And it was seen that overall around 2,800 patients were included, 1,500 approximately in each arm, and it was seen that all-cause mortality, hospitalization was not significantly different between both the torsemide and the furosemide arms. So probably we can use both of them interchangeably. Physicians or the cardiologist or the nephrologist preference for either of that would hold good. For all acute patients, still torsemide is the one which we use intravenously otherwise. Yesterday there was also discussion about whether acetazolamide would be useful. So the trial which was published, this I think had come out in September 2022 in NEJM, was an ADVAR trial, whether acetazolamide helps in acute decompensated heart failure or not. So patients who are admitted with ADHF already on loop diuretics, they were given acetazolamide of 500 mg, and it was observed that the decompensation, successful decompensation was much better seen in the acetazolamide arm, 42% whereas versus 30%, and this was statistically significant. Whereas the all-cause mortality and rehospitalization, it did show a trend towards better outcomes with acetazolamide, but the confidence interval does cross 1, so it is not statistically significant probably. But one thing that has to be remembered, that this was in a trial setting, and the patients here, they received supplementation with magnesium, with potassium, and they were under continuous bicarbonate monitoring, and also oral bicarbonate supplementation was given. Whether this would be possible in our outpatient setting regularly is something which has to be seen or shown in other trials. But considering that the mechanism of action, where this acts on the proximal tubule, whereas loop diuretics act on the distal tubule, they are something which would probably help in the long run for us to explore. So with regard to renal replacement therapy, the indications which the guidelines state would be a fatal change in volume status, electrolytes, basically hyperkalemia, or acid-base balance, that is severe acidosis. The questions which have to be answered would be, what is the ideal time to initiate, whether we need to initiate early or late. Patient presents immediately, whether we start immediately, early or late. This probably depends upon the inherent risks and the complications which are involved with regard to vascular access, hemodynamic stability, and the bleeding complications which can happen with renal replacement therapy overall. So the studies which have been done for renal replacement therapy in cardiogenic shock, was the one thing was from the Adagbala study. This was a database based study from the United States, where out of 4,02,825 patients were included. Nearly 50% of the patients with cardiogenic shock had some amount of acute kidney injury. 11% of them underwent hemodialysis, and in the subgroup which underwent HD, there was higher mortality, but the patients had more comorbidities also. So whether it is because of higher comorbidities they underwent hemodialysis because they were sicker, or it was the other way around, is something which we cannot tell from a retrospective study always. And the other studies which have been done, they have shown that those who received hemodialysis when they were in cardiogenic shock were more likely to be continuing on hemodialysis even after discharge. So this was other component which has been shown only in retrospective studies. We do not have control trials for this. And one other trial, interesting trial, was a Danish cohort study, which included around 5,000 patients, of which nearly 13% had undergone renal replacement therapy. It was seen that those who underwent renal replacement therapy had a higher in-hospital mortality, higher 5-year mortality, and were at a higher risk of staying on hemodialysis at the 5th year as compared to those who never received renal replacement therapy. So probably this also shows that the patients were sicker to begin with. That is probably the conclusion we'll have to take, rather than the other way around, that RRT is not beneficial for cardiogenic shock patients. With regard to the discussion of whether early or late is good, there have been a number of randomized controlled trials which was done right from 2002, and the Jamale trial was from KEM Mumbai. Apart from that, the other RCTs were the ELINE, AKIKI, START AKI, Ideal ICU, and AKI AKIKI 2 trial. So almost all these trials have shown that early initiation of renal replacement therapy does not give any benefit, apart from one trial which was a ELINE trial. So this was a single center trial from Germany in a surgical ICU. It did include patients who had undergone cardiothoracic surgery also, but considering that it's a single center from a surgical ICU, the data becomes a little difficult to extrapolate to the general population also. Whereas almost all other trials, they were multi-centers, they had a complete good mix of population. So for all practical purposes, a very early initiation of RRT, renal replacement therapy, when the patient presents with either heart failure or with renal dysfunction, is not going to be useful. We do not have any specific trials in those with heart failure or cardiogenic shock. There were some patients of heart failure included in these studies, whereas the exact percentages are not available. So when do we do ultrafiltrate? Obviously it is whenever the patient, we are not able to effectively decongest after giving diuretics, 1, and 2, whenever there is a diuretic resistance, we can try it. But there are issues with regard to one axis, the rate of ultrafiltrate and the timing of initiation, which still stays. There have been a number of major trials for this, the rapid, unload, CARES, CUROR, AVOID, and the UltraDisco latestly. Almost all these trials, they have shown that there is no mortality benefit by initiating ultrafiltration as compared to diuretic use. 1. There is some benefit with hospitalization, duration of hospitalization, as well as the readmission rates. However, this is not going to be very important because the hard outcome of mortality was not there in the trial basis. Some of the trials did show that there is a transient renal dysfunction. When we are doing ultrafiltrate, there's going to be neurohumoral activation, which thereby can cause an increase in creatinine. However, this does not affect the long-term renal outcomes in these patients. This has also been shown in the trials. One trial was the CARAS HF heart failure trial, which had a completely discordant result as compared to the other heart failure trials. The reason probably was that the ultrafiltration which was done in this patient was not adequate. More than 40% of the patients, they were not adequately decongested when they were randomized. That was 1. And 2, even in the ultrafiltrate arm, only 32% had proper ultrafiltration which was done. So probably considering this trial to help us make our decisions would probably be not right. The other thing was that the patients who were initiated on ultrafiltrate, the rate of discontinuation was very high, and the filter clotting, the hemodialysis filter clotting rate was seen in more than 1/3 of the patients. We can think that this is probably because an adequate anticoagulation was not given. However, this was not so in this case because it was under a trial setting and anticoagulation was adequate. The only explanation what we can give is probably because the blood flow rates were not maintained properly in this trial. So that is the reason which we can assess. So this cannot be extrapolated to the real world setting, where obviously it is done on a case-to-case basis and we'll be able to optimize each of these. We still have issues about selecting which patient is going to benefit from ultrafiltrate, about what are the fluid removal targets we have to use. Generally, a target of 100 to 250 ml per hour would be adequate. I'm just completing, sir. We'll probably have to monitor the ultrafiltrate and the biomarkers. These are things which still need to be addressed with regard to ultrafiltration in heart failure. Overall, the guidelines, the AHA guidelines say that it concurs with the KDIGO, the renal guidelines, where renal replacement therapy is given in patients with cardiogenic shock and acute kidney injury stage 2 and above. It is given only in the extreme stages, that is a late onset, initiation is advanced. Continuous renal replacement therapy may be preferred because patients with shock are more prone for volume changes. And with regard to anticoagulation, citrate can be preferred over heparin. This is only a class B indication. So in the future directions, just to show that almost all the data which we have are in those with EGFR more than 20 at least. We'll need more trials in patients with CKD, even for those with chronic heart failure. So this probably will have to change in the coming years. And the future of AKI diagnosis is bound to change. For now, it is based upon only creatinine. It is going to change with the involvement of biomarkers with machine alert mechanisms, where a number of trials in AKI have shown a machine alert or a machine learning based markers are going to make AKI diagnosis earlier. So overall, to just conclude, we have a necessity to standardize the diagnostic criteria of acute kidney injury, particularly in patients with heart failure. This is because all patients with renal dysfunction, there is an inappropriate discontinuation of heart failure therapies. This makes it very important that we have a specialized definition, at least in patients with heart failure. Biomarkers are more sensitive. Studies have shown it. Whether it can be incorporated into daily practice, considering the cost, has to be seen. We'll have to probably integrate the biomarkers, the history of the patient, and various treatment and imaging paradigms in order to give better therapies. Therapeutic role lies with the choice of vasopressors we take, the amount of diuresis and the renal replacement therapy we do. We do need more trials in patients with chronic kidney disease, especially stage 4 and 5, to better understand and better treat even patients with AKI in the heart failure setting. Thank you.
Great. Very good talk. Arun, I would like your comment on one thing. Long years ago, we were taught that you define CKD on two bases. If you have elevated creatinine readings 3 months apart, which you mentioned. The other thing which you were commonly asked to do is a renal ultrasound. Because if you want to make a kind of spot diagnosis of renal failure, if you have a shrunken kidney or you have a corticomedullary differentiation that has been lost, straight and simple, it's a chronic kidney disease, underlying. So at least I use that very often in my practice, and I'm sure everybody does. The other thing is a question. There's been a lot of debate on whether you should give boluses of a loop or you should give a continuous infusion. Most trials said you could use either. Do you have any update on that?
So for the first part of the question, the diagnosis of CKD, the criteria, the guidelines state that it is a 3-month issue in either in renal function measured by a creatinine or EGFR, or if there is an imaging issue, if there is even proteinuria for more than 3 months, it still becomes CKD of some account.
Sure.
And with regard to ultrasound being useful, the size probably is the most important variable which we use. So if for an adult it goes less than 8 centimeters, for a normal sized adult, we still consider the patient to have chronic kidney disease. With regard to corticomedullary differentiation, even patients, it is one, observer dependent, and two, even patients with acute kidney injury tend to have issues with corticomedullary differentiation. So that is the reason why we don't take it totally into account. Probably the size still stays as a good screening variable. We measure the size. If it is going to be low, most likely the patient is going to be of CKD only. Second part of the question with regard to the diuretic dosing, intermittent versus thing, that was last night discussed. So that is why I didn't repeat it right now, and more for time constraints. I felt that, sir, that none of the trials have shown that infusion is more beneficial than boluses. Both the randomized control trials which were done. But at times, if the patient is in shock, we tend to use low dose infusions, and they have been found to be practically useful. Though on trial basis, we would still say that it does not offer an extra benefit over boluses.
Are there any questions from the floor? If there are none, I think we've had a great session. Thank you very much.
Yeah, thank you, sir. Thank you.
Thank you, moderators and panel member, for enlightening us on kidney failure and renal replacement therapy. Moving on to our next session on 9th Annual Conference of Heart Failure. May I take the opportunity to welcome Dr. Madhu Prabhudas and Dr. Tiny Nair to chair the session. May I request the speakers and moderators to stick on to the time, please. Thank you.
I welcome Dr. Abraham Movement to present his new horizons in management of ATTR amyloidosis. Welcome, sir.
Thank you very much, and thank you for coming at 8:30 in the morning. And there were people thought that nobody would turn up, and we have got a near full house, at least 60% full house. That is very good. Thank you very much, and thank you, Dr. Tiny. And I would just mention that Dr. Tiny was my inspiration in the way I give talks. So anything good or anything bad, the blame rests on Dr. Tiny. So with that, I'll go ahead. So new horizons in the management of ATTR amyloidosis. So these are my disclosures. So Dr. J.C. Mohan, 2 years back in our annual conference of HFAI, calculated the number of missing patients. We talk about missing daughters, missing girls, missing children, so many missing. If you take the newspapers, yes, some missing would be there. But he very conservatively estimated that at least 2 lakh ATTR amyloidosis is there in India. Very conservative. And how many we are diagnosing? In low 2 digits. Even the most serious are 10 patients, 20 patients, etc. So that's my first point. We are missing amyloidosis, especially ATTR amyloidosis. Second point is that it's a mortal disease. AL amyloidosis, if not treated, the life expectancy is less than a year. Even chemotherapy, the life expectancy can be increased. ATTR, which we think is a mild disease, rare disease, is neither, and the life expectancy is less than 5 years as per 50% life expectancy is less than 5 years as per the Mayo Clinic data. So first, we should have a cardiomyopathy aware mindset. If you do not think about it, we do not see that. Second is appropriate recognition of hints or red flags. My talk is not on that, but clinically you should be suspicious, both clinical signs and symptoms, ECG, echo, all these things should give you an alert. And the treatment of ATTR, when 2017 we had the meeting, there's a talk, and the highlight was that there was no treatment for ATTR amyloidosis. Now we have FDA approved 3 drugs, and one of them is available in our country. So what is amyloidosis, especially ATTR? There is abnormal synthesis, unfolding, misfolding, and deposition. So abnormal synthesis, unfolding, misfolding, and deposition, especially in the extracellular part of the cardiomyocyte. So therapies, we should talk about the standard therapies, loop diuretics if they are congested. Important thing is beta blockers. This is one situation where I would be very careful in giving beta blockers because they live because of their heart rate. So if you reduce your heart rate, they will go into cardiogenic shock sometimes. So that's again a red flag. Inappropriate beta blocker response can be considered as a red flag for amyloidosis. Then avoid dehydration, then autonomic dysfunction, usual treatment. Then another very important point is that atrial fibrillation. So we have a few electrophysiologists here, very senior people. And here is one situation where anticoagulation is recommended irrespective of the CHA2DS2-VASc score. Irrespective of CHA2DS2, even if it's 1, you have to anticoagulate the patient. Then transplant, heart liver transplant, advanced treatment. So available therapies include tafamidis, diflucanal. Then the diflucanal has got problems like renal failure, thrombocytopenia, GI bleed. Then of course AL has got the chemotherapy, immunotherapy, transplant. So ATTR silencers, two gene silencer type, patisiran and inotersen, they are basically for polyneuropathy associated ATTR. We usually see the wild type, or we are supposed to see the wild type, but we are not seeing. That is the absolute big elephant in the room. So we have a treatment now and it's available in India. So tetramer stabilization by tafamidis. Tafamidis is the only approved treatment that specifically targets TTR destabilization. It's the only therapy to effectively treat ATTR in a randomized controlled trials. And it has got 5 years clinical data, very important, because most of the trials, including some of the heart failure trials, are hardly 18 months, 1 year old, and we do not know their long-term effects. Here we have 5-year data. And importantly, reduce all-cause mortality and cardiovascular related hospitalization. So only 2 endpoints. That's also important because many of the interventional meetings has got 5, 6, 7 endpoints, and that dilutes the effect of the therapy. Then another important thing is quality of life. We talked about quantity of life. Quality of life is also improved, walking distance and KCCQ, and significant difference. Anything more than 5 is considered significant, and you have 14-point difference, and 76-meter walking talk is actually huge. Even 76 may look very small, but actually it is huge. And NT-proBNP, everyone talks about NT-proBNP. So with no increase or reduction, about 45%. That's again wonderful numbers. And safety profile, this is the second thing. So very few drugs have got a very good safety profile. And the common saying is that if there is no side effects, there are no effects also. But here the side effect profile was like the placebo. That was for the short trial, short course, the main trial. When the long-term extension also, they found the same thing. And you can see here, this is the post-hoc 5-year data, and significant improvement in survival. So think of our modalities as cardiologists, which improve survival. There are not many. And Dr. Mohan, I was just quoting your numbers on missing patients in ATTR. So reduction mortality, again, and 5-year data. So many times the benefits becomes narrow at 5 years, but here it continues to widen. So, and reduce all-cause mortality. So, and placebo-like side effects. So basic themes are mortality, hospitalization rates, quality of life, biomarker reduction, 5-year survival rate, and regardless of TTR genotype, and similar safety profile. So that is the present. So in India, and another, we've got 3 more minutes. So we do Mitra clips charging anywhere 30 lakhs to 40 lakhs. We do TAVIs charging from 10 lakhs to 25 lakhs. But about 20% of both groups have amyloidosis. And if you miss a treatment or a disease with a 5-year prognosis quite bad, when a treatment is available, we are doing injustice to the patients. And newer ones are acoramidis. It's a newer fellow about like tafamidis. Then the trials going on, and inhibition of oligomer aggregation and disruption, epigallocatechin 3-gallate, and immunotherapy has been tried with, but it's intravenous. Tafamidis is oral. So with 2 minutes to go, how do I envisage ATTR amyloidosis? So prevention, do a genetic screening. If you see a mutation, do CRISPR. CRISPR is available. We are doing CRISPR now, not for amyloidosis, but CRISPR will become the very favored therapy soon or in the near future, and cured. So you can cure amyloidosis. Then diagnose TTR, genetic testing, stabilizer, silencer, and monoclonal antibodies, and you can reduce the disease and still residual disease, do heart liver transplant. And AL amyloidosis also has got many treatment protocols. So again, with about 1 minute to spare, the fate of amyloidosis should not be like this. What the eye doesn't see and the mind doesn't know doesn't exist. So 2-sentence summary about ATTR amyloidosis. Point number 1, it is not rare. I keep on quoting Dr. Mohan, quoting his name, of course, about the missing ATTR in India. That's point number 1. Point number 2, is it is a mortal disease. It has got much more worse prognosis than many diseases we encounter in our daily practice. Number 3 is that there is treatment available. It's costly, but you have to look at the cost-effective benefit. Third, the treatment increases the lifespan. It's not a very soft endpoint business. 4, the treatment is almost placebo-like in its side effects. So with this, I conclude, and thank you very much for patient hearing. Once again, thank you for coming early in the morning.
Thank you, Dr. Abraham. Thank you. Just a minute if you spend. I think, exactly like Professor J.C. Mohan had shown, we all remember that the missing heart failure, that is it. And today it's so fascinating to know that right from tafamidase to CRISPR, everything, there are a lot of treatment. It's a curable cardiomyopathy. But I think for whoever of us are here, I think all of us are missing so many of amyloid ATTRs, right? So would you please tell us as to what would be the, say, 4 or 5 red flags when we should suspect that, yeah, I should go and work up this patient?
I invite Dr. Mohan to give his comments about, because he's a doyen of amyloidosis in the country. So, Dr. Mohan, please.
Just highlight to our audience as to what are the points that we should keep in mind.
Thank you, Abraham. Actually, there is no doubt that we are missing good amount of ATTR. We do accept this fact. When we were writing the consensus paper, we said wall thickness 11 or more. The experts had said, you have data. We said we have data from India, where our wall thickness actually top limit is 10 millimeter. And so the 11 millimeter and above should be considered. They did not agree to it. We had to put 12 millimeter. So one of the things we realized is that all kinds of heart failure can be, which you see, all kind of phenotypes you see on echo can be the mimickers, can be the amyloidosis, whether it is Hfref, heart failure with mildly reduced ejection, heart failure preserved ejection. And the wall thickness, I think we are overplaying it. In India, we are overplaying it. Don't expect very thick walls like you see in hypertrophic cardiomyopathy or hypertensive heart. You could get much less. So why putting it upside down and starting from echocardiography? Because that is where we start missing. That is where we are not training people who are doing echo, that even at 10, 11 millimeter, if the things are like this, if the atrial dysfunction is out of proportion, it's a non-dilated hypokinetic left ventricle or non-dilated normokinetic left ventricle with enlarged left atrium, consider cardiac amyloidosis. You should at least think of that. The usual red flags which people have described, the clinical red flags, we don't see that often. The carpal tunnel syndrome, spinal stenosis, biceps tendon rupture, macroglossia, periorbital edema, diarrhea. We don't see that often. But one of the other things is proteinuria could be a reasonable red flag. ECG is a reasonably good red flag when read in light of echo. But having said that, I would only focus on one thing, that people who are doing echocardiography, if they actually raise the suspicion, then you can look backward and look forward also. And these people have to be told that these amyloid people don't have very thick ventricles always. If you are waiting for that, you would be missing a lot of it. The low gradient, low flow aortic stenosis above the age of 65 years, yes, I would agree what Abraham said. The data from India says about 10, the All India Institute data published in JSCC. So we have a point. But the only emphasis I would like to make, even if patients have heart failure with reduced ejection fraction and slightly thicker walls, consider amyloidosis.
Thank you, sir. So I think next we have a very exciting paper on something that is extremely unusual.
No, to save time, sir. Already we are running
epicardial fat and heart failure. I think very, very exciting. Dr. Vijay Kumar, please.
I welcome Dr. Vijay Kumar. He is one of the doyens in imaging and like IOS and OCT.
Before we start, we should thank Dr. Abraham for keeping such exciting topics where actually we are learning, right? Please.
Thank you so much for this opportunity. I thank Abraham sir for the same. And so epicardial adipose tissue has recently gained increasing attention for its potential role in the pathophysiology of heart failure with preserved ejection fraction. And epicardial adipose tissue has been associated with structural and functional myocardial abnormalities, typically seen with HFpEF, such as myocardial hypertrophy, diastolic dysfunction, and increased filling pressures. Abundance of epicardial adipose tissue in patients with HFpEF predicts poor prognosis independent of BMI. For the next 10 minutes, we shall briefly touch upon the physiology, pathophysiology, potential treatment strategies, and finally the knowledge gaps and future directions regarding the role of epicardial adipose tissue in HFpEF. To start with some anatomy, this fat tissue, EAT is a fat tissue situated directly between the myocardium and the visceral layer of pericardium, vascularized by branches of coronary arteries in contrast to pericardial adipose tissue, unevenly distributed around the heart, most of the fat being around the coronary arteries and the right ventricle. And it constitutes about approximately 20% of total ventricular weight. There is no basal layer between epicardial adipose tissue and myocardium, and they share a common microvasculature, so that may directly interact with the underlying myocardium. And the various functions, so first one is it is a source of energy when there is a need by providing free fatty acids. And again, it protects the heart from lipotoxicity when it is in abundance. And we all know it is a brown adipose tissue like adipose tissue, so it protects against cold temperatures and stressful hemodynamics of the heart, and again protect the coronary arteries against the pressure waveforms and pulse waveforms and cardiac contractility. And again, we all know it is one of the most important endocrine organs. It secretes anti-inflammatory cytokines, which is cardioprotective. In addition, it acts through the heart through the microvascular structure because there is no barrier between these two. How does the phenotype changes in the neonate and in the early childhood? It is almost like a brown adipose tissue-like, mainly performs a cardioprotective and thermogenic function. And in the later part of the childhood and adulthood, even though the brown adipose tissue-like properties comes down, it continues to be cardioprotective and continues to provide fuel for myocardium. When we become elder, the thermogenic function dramatically comes down. The phenotype becomes mostly of pro-fibrotic and pro-apoptotic. And in pathological conditions such as AF, coronary artery disease, diabetes mellitus, and heart failure, obesity, it becomes pro-atherogenic and pro-arrhythmogenic. And what is the relation between epicardial adipose tissue and heart failure with preserved ejection fraction? Two important things. One is accumulation of epicardial adipose tissue and the change in the phenotype, that is a dysfunction. These are two most important things which contribute to HFpEF in patients with increased epicardial adipose tissue. So what happens? One, you can see that first important thing is inflammatory phenotype. Here you see this increase in the pro-inflammatory macrophages, and increase in the inflammatory phenotype as evidenced by increase in P53, and increase in the pro-fibrotic status as evidenced by increased presence of FMP4 and alpha-1 anti-chymotrypsin. And these two act through paracrine fashion to increase fibrosis and myocardial inflammation, and the free entry of free fatty acids, and that results in increase in apoptosis and the cardiomyocyte disarray, and increased levels of catecholamine biosynthetic enzymes, which results in increased noradrenaline that is freely diffuses into the myocardium that aggravates worsening of cardiac function. In addition, presence of progenitor cells for fibrosis, they easily diffuse from epicardium to the myocardium that again aggravates your myocardial dysfunction. Two additional important concepts. One is a direct invasion of the epicardial adipose tissue into the myocardium, or the next one is a constrictive pericarditis type of phenotype, because there is a constrained space and increase in the epicardial volume. So this all result in phenotype of heart failure with the preserved ejection fraction. How do you quantify it? One is based on echocardiography, where you measure the epicardial adipose tissue thickness And other two modalities, cardiac MR and cardiac CT, both provides epicardial adipose tissue volume. And in addition, when you use MRI and your cardiac echocardiography, both you get additional information on the function and the phenotypic information, whether there is more inflammation or not, based on the heart failure you get with cardiac CT. And if you use a spectroscopy, you can estimate intramyocardial fatty tissue. So these are the various differences between different modalities. And what is the current clinical evidence? So we have plenty of data in the recent times. All the studies are observational, mostly retrospective. They used echocardiography for measuring the thickness, CT/MR for estimate the EAT volume. And HFpEF patients had increased epicardial adipose tissue compared to patients with heart failure with reduced ejection fraction or controls. There is modest correlation between echo measured EAT thickness and the CT/CMR measured volume. There is increased prevalence of comorbidities when you have more EAT in the presence of heart failure present with the preserved ejection fraction, and increased cardiac biomarker levels, increased prevalence of markers of systemic inflammation. There is a lower insulin sensitivity and the presence of endothelial dysfunction. And this proteome, if you analyze it, is strongly related to inflammation, lipid metabolic disorders, and mitochondrial dysfunction. This EAT has been associated with adverse LV remodeling indices on echo and cardiac MRI. And on cath, it has associated with the higher RA-PA pressure, pulmonary capillary wedge pressure, and low peak oxygen uptake. And again, as we know, it is associated with adverse prognosis. And what is the association? What is the link between epicardial adipose tissue and obesity in patients with HFpEF? Both the EAT and obesity are associated with the increased incidence of HFpEF. Both have mechanical impairments typical of diastolic heart failure, such as hypertrophy, dysfunction, left atrial dilatation. However, they are not always mutually related. In a study, HFpEF has been associated with increased EAT volume compared to controls without heart failure. However, when you see the BME, there is no difference between these two groups. And in another study, about 22% of the non-obese patients had high EAT volume, and 18% of the non-obese patients had a low EAT volume. So both are not mutually exclusive. And what are the various mechanisms in HFpEF? One is the epicardial adipose tissue produces local mechanical and inflammatory effects. In contrast, obesity produces systemic volume load and inflammatory effects on the heart. And EAT is associated with increase in the level of natriuretic peptides. Obesity is associated with a decrease in the levels. And both are related to atrial fibrillation in patients with HFpEF. And both increases mortality, even though it is not consistent in patients with obesity. And what is the difference between EAT in patients with reduced ejection fraction or preserved ejection fraction? EAT may play a different role in the pathophysiology of these conditions. And patients with reduced ejection fraction may have few studies have shown lower or few studies have shown higher compared to healthy controls in patients with preserved ejection fraction, which is most of the time it is more than normal. In those with reduced ejection fraction, increased EAT was associated with lower risk of cardiovascular death and heart failure hospitalizations. This means that quality of EAT is different between these two conditions, where EAT and reduced ejection fraction is more anti-inflammatory, and in preserved ejection fraction it is more pro-inflammatory, with a direct adverse effect on the myocardium in reduced ejection fraction and beneficial effect in patients with preserved ejection fraction and beneficial effects in patients with reduced ejection fraction. What are the various treatment modalities that have been explored? Weight loss, and again inconsistent, either you do with exercise or with the diet or with the surgical procedures. Again, this epicardial adipose tissue change is very inconsistent. Pharmacotherapy, various medications with the pleiotropic effects ranging from metformin to mineralocorticoid antagonists. More consistent effects have been shown with the GLP-1 receptor agonist and SGLT2 inhibitors and PCSK9 inhibitors. Other exploratory therapies are browning of epicardial adipose tissue, pericardiotomy, surgical resection, and gene therapy. And going into the drugs, you can just see these two drugs consistently have shown that reduction in the EAT. One is your GLP-1 receptor agonist, which reduces inflammation, free fatty acid oxidation, free adipose differentiation, which is conversion of white to brown adipose tissue, increase in insulin sensitivity, and SGLT2, if you take, there is reduction in the inflammation, FFA oxidation, increase in lipolysis, and increase in ketogenesis and increase in sympatholysis. All this have been shown to be associated with increased outcomes in patients with heart failure with preserved ejection fraction. These are the various studies. This slide summarizes. You see here the maximum reduction in two things we have to see. One is reduction in the inflammatory markers, and the second thing is shrinkage of the epicardial adipose tissue. And if you see the maximum shrinkage occurs with the GLP-1 receptor agonist, and the modest one with the statins, and the SGLT2 inhibitors is somewhere in between. And few more information about the next one is the important aspect is browning of the epicardial adipose tissue. Again, you see that brown adipose tissue has been shown to be cardiac productive, and in patients with the HfpEF, there is epicardial adipose tissue mainly of white adipose tissue. And there is experimentally it has been shown that beta-3 adrenergic receptor agonist results in browning of white adipose tissue. However, currently this has a lot of side effects. Maybe future therapies may increase, but some new therapy will come. So that causes white adipose tissue to brown adipose tissue conversion. The second one is we already showed that there is pericardial restraint in patients with increased epicardial adipose tissue. Whether the pericardotomy results in benefit or not is not shown, but experimental studies have shown that in animals where they have done the pericardiotomy, there is a less increase in the cardiac filling pressure after saline infusion. Again, we are awaiting more data on this. The third thing is the surgical removal of the epicardial adipose tissue. And two animal models. One is your miniature swine model, where surgical resection has been associated with less progression of coronary artery disease. The second one is AMI model. Surgical resection in this model has been associated with a better left ventricular function. And one patient during surgery, when it was done, it has resulted in left ventricular, improved left ventricular diastolic function. There's only one case report that has been available so far. Again, we need more data on this aspect. Finally, as a target for gene therapy, this is the one gene that has been explored, that is overexpression of fibroblast growth factor, that is tried in visceral adipose tissue, that resulted in improved insulin sensitivity and lower inflammatory cytokine release. Whether this is useful in cardiac epicardial adipose tissue, we have to wait and see. And the gap in the knowledge, so even though there is understanding has improved, there is a lot of gap in the knowledge, both in all the aspects, either in understanding the function, development, pathophysiological mechanisms, and diagnosis, and most importantly, treatment aspects. To summarize, evidence is accumulating that epicardial adipose tissue is involved in the pathophysiology, symptomatology, and clinical course of heart failure with preserved ejection fraction. However, many questions on the pathophysiology and potential treatment remain to be answered, and more studies are needed to tackle these questions to identify the therapeutic aspects, specifically to reduce the EAT accumulation and inflammation to improve outcomes. Thank you.
That was an excellent talk by Dr. Vijay Kumar. I just have one question. How confident we can diagnose heart failure with that epicardial adipose tissue by echo? Because most of us see the patients basically with echo. So yeah, after that, then we'll see then availability of the cardiac MRI and other things are there. So is there any key points we can diagnose by echo?
Yeah, it is. So it is echo is mainly the measurement of epicardial adipose tissue thickness. It is measured over the RV free wall, and we use your aortic annulus as a reference. So that is how you make your this thing. But the only problem here is we all know that it's an operator dependent modality. And the again thing is it doesn't give you an additional information about the phenotype. Suppose whether you have inflammation or not, whether you have intramyocardial fat or not. So, but the most important thing is it is easily available and anybody can do it, any settings. So it is, but other two are more specific, but still widespread availability is a questionable value. And again, the normal, which is normal thickness, whether 9 millimeter is used in most of the studies, and still we are not sure which is the normal thing with cutoff that to differentiate between means normal phenotype to the pathological phenotype. Because the two most important things, one is volume, and the second thing is the phenotype, whether it is a pro-inflammatory or a brown adipose tissue-like phenotype. When you have brown adipose tissue-like, that is protective. When you have a pro-inflammatory phenotype, so that is where it results in heart failure with reduced ejection fraction. But again, maybe future imaging modalities will tell you the exact answer.
One interesting aspect is that people are talking about GLP-1 receptor agonist tends to reduce epicardial fat, and that might be one reason why it,
Yes, sir.
do you believe on that? Or?
I'm not sure. I don't have much experience with the GLP-1 inhibitors. You might be a better person than me to answer this question. But it has shown the maximum reduction in the epicardial. You see that the one study has shown, I think liraglutide, it shows 42% reduction in the epicardial in 24 weeks. So there is a maximum reduction that has been shown so far in clinical studies. But whether it translates to improved clinical outcomes, and again, if you see that all the pro-inflammatory, pro-fibrotic, all these factors comes down with the GLP, because the highest exposure means expression of GLP-1 receptors, I think has been noted in EAT. But again, how much it translates into clinical outcomes, we need more data.
I think basic thing is we don't know whether it is the driver of the whole thing,
exactly,
or whether it's just an innocent bystander getting deposited there because of HfpEF and Hfref.
Yeah.
That would be. Any questions, any comments from the floor before we close down the session? Mohan sir?
Yes, sir. I think 9 millimeter is what the most of the studies are. Fluorescent long axis over the RV wall at the level of the annulus, aortic annulus. Thickness. Groove. Exactly. I'm not sure. I've just looked for any other method but I could not find much of literature on that. The maximum literature is on the RV free wall at the level of aortic annulus. But as you said, it has been described that maximum fat occurs in the AV groove. Right coronary artery to the pericardium. I don't think maybe that is a good thing to explore and see. And again, regional variation in the distribution and phenotype. See, if you see that is what has been described. Pericoronary means what is the AV groove? It is mainly pro-atherogenic phenotype. When you have around the atrium, it is pro-arrhythmogenic phenotype. When you see over the ventricle, and it is all pro-inflammatory phenotype that resulted. But we are not very sure whether all these things, how much it translates into clinical outcomes. Exactly, sir. Exactly, sir. They don't. Yeah, I think maybe 12 years ago, the first time I just, when I was a student, just mistook that as a big pericardial effusion sent for cardiac MRI. It came as epicardial fat. That is the first encounter with epicardial fat. But none of the CT reports have that epicardial fat thickness and volume. The problem is to estimate the volume. It is a cumbersome one, because each frame you have to measure the area to get the volume. That in the current scenario, none of our radiologists is willing to do it, unless you specifically ask for it.
Yeah. And do you index it to body surface area on an echo?
Yeah, I think most of the CT studies have reported index to body surface.
What about in echo?
So echo, we're not, because echo you measure only the thickness, and unless you develop a volume or this thing that, so indexing may not make much sense. And this thickness is an easy way to tell. Yeah, because we are used to thickness everywhere in echocardiogram. I think when you come out with the next consensus, I think this has to be taken into consideration. Whether it is going to make clinical difference or we don't know. But suppose some studies have shown, like amyloid, we were just telling that there's nothing is available, but this something might come then which dramatically reduces the inflammatory activity and the volume of epicardial adipose tissue. It is an area of research, sir. Thank you so much, sir.
Thank you, Dr. Vijay, for that excellent lecture. So I think we can close the session. Thank you very much.
moderators and panel members to give us an insight on pathless Troden. Moving on to the third session of today's conference, may I now welcome Dr. Sandeep Bansal and Dr. P. Manohar to chair the session. May I request the moderators to start the proceedings? I request the speakers and the moderators to stick on to the time, please.
Good morning. As was said, the topics selected are extremely good. They're very relevant topics and deal with the controversies that we as cardiologists currently deal with. One of them is that, instead of putting the conventional CRT leads, the cardiac resynchronization therapy leads, this talk is not there. Dr. Muralidhar is not there. Okay, sorry then. Okay, so it's there's a lot of ongoing discussion on whether rate or rhythm is the way to go about in managing atrial fibrillation. And are there any particular subsets where it should be absolutely mandatory to have rhythm control rather than rate control? And heart failure with atrial fibrillation is one such area. And to tell us about this is Dr. Lawrence Jesiraj. Dr. Lawrence.
Good morning all. Thank you Heart Failure Society for this opportunity. My topic for discussion would be on rhythm control in patients with AF and heart failure. I'm not going to discuss in detail about end-stage heart failure where AF comes in, where the management of AF is mostly palliative, where you have to control the rate. Mine will be on early heart failure or patients with atrial fibrillation who are going to present with heart failure. So overall, I think there is a huge change in the strategy of managing atrial fibrillation. More and more data is emerging now that rhythm control strategy should be the preferred strategy in patients with atrial fibrillation. So rhythm control strategy should be the primary one which we have to look upon most of the patients with atrial fibrillation. Most of the patients whom you are trying to do a rhythm control strategy should be anticoagulated prior. We have strategies like direct cardioversion or giving antiarrhythmics. Direct cardioversion, we know it's highly effective. You have to make sure this is not a long-standing atrial fibrillation before cardioverting the patient. Sometimes you may have to cardioverter the patients because patient is hemodynamically unstable. You may have to priorly anticoagulate, or if possible, look for a LA appendage clad by a transesophageal echo. And there are drugs which are available for managing patients with atrial fibrillation, antiarrhythmic drugs which can convert. Unfortunately, we have limited choices when it comes to heart failure. Most of the drugs like flecainide, propafenone and sotalol cannot be used in patients with heart failure. Ultimately, we end up in using only amiodarone for managing patients with atrial fibrillation when they have a heart failure. So other option, a lot of patients with heart failure may require, if you feel that the atrial fibrillation is reason for the deterioration of a heart failure symptoms, or heart failure is produced by persistent atrial fibrillation, one other option should be a catheter ablation. So the patients who are symptomatic with atrial fibrillation, for a proximal atrial fibrillation, catheter ablation is a class 1 indication. For a patient who has a persistent atrial fibrillation, it is a reasonable 2A option. For a long-standing persistent, you can still consider a catheter ablation is a 2B option if the patient is symptomatic even on antiarrhythmic therapy. For a patient who is symptomatic, you can even consider catheter ablation prior to starting an antiarrhythmic therapy. Is recommended as a class 2A indication if it is a proximal atrial fibrillation, and class 2A again for a persistent atrial fibrillation, and for a long-standing persistent, it's a 2B. This is even before trying an antiarrhythmic therapy. So if you have a patient with atrial fibrillation, when we are looking at heart failure, we are going to see as a patient who has a structurally abnormal heart. If a patient has a heart failure, you have only two options for you. One, either you start them on amiodarone, or if the patient is eligible candidate for a catheter ablation, you can consider a catheter ablation. If you fail with a catheter ablation, again your option still remains for rhythm control, only amiodarone. Why we are very aggressive or as a change in strategy about managing patients with atrial fibrillation? Atrial fibrillation is a progressive disease. Like how we look at heart failure, when you treat patients with atrial fibrillation, you have to be aggressive at the earlier part of the disease. Because once the patient reaches permanent atrial fibrillation, you would have already seen a lot of patients who have already developed a lot of structural changes in the heart, where most of your therapeutic options will not work. So when the patient reaches permanent atrial fibrillation, the patient would have developed structural changes in the atrium, and your ablation strategies or your antiarrhythmics will be highly not effective. So not only that, when the patient progresses from the paroxysmal to permanent part, there is an increase in mortality, close to 20% increase in the systemic embolism, and 28% increased risk of death, and heart failure prevalence increases 2 times when the patient progresses from proximal to persistent atrial fibrillation, and there is 1.5 times more hospitalization. And when you see most of the patients who develop or progress into persistent permanent form of atrial fibrillation, the stroke risk also significantly increases. So what we have for these patients in the early part of managing these patients, guidelines recommend catheter ablation as a significant therapy for the patients with atrial fibrillation. The reason being, close to 90% of the triggers for atrial fibrillation are found in pulmonary veins. So that's the reason you can see there is now recommendation from multiple authorities on symptomatic paroxysmal atrial fibrillation even prior to antiarrhythmic drug failure. We all know very well antiarrhythmic drug failure is one of the indication for a catheter ablation, but there is recommendation from multiple societies now, even before an antiarrhythmic drug fails, you can consider a catheter ablation because of few reasons which I am going to say you now. So now we have options which can be minimally invasive. We all know catheter ablation for atrial fibrillation is a very complex procedure. Most of the time we end up doing a procedure for 4 to 6 hours with a significant morbidity associated with the procedure. Now we have minimally invasive procedure like cryoablation. You have a cryo balloons which can be used to create a pulmonary vein isolation. So this is how it is done. Instead of point-to-point ablation, you can use a cryo balloon to give a single freeze pulmonary vein isolation. So the cryo balloon is designed to give a pulmonary vein isolation. As I already told you, the most of the triggers for atrial fibrillation, more than 90% of them comes from the pulmonary veins. So if you are going to electrically isolate these pulmonary veins from the left atrium, the possibility of taking care of atrial fibrillation is very high. The success rates are for proximal atrial fibrillation in a structurally normal heart ranges close to 80 to 90%. So this is the way we do it. We have a catheter which can record the electrical signals. We push the cryo balloon in the pulmonary vein ostium. When you have a good occlusion, we freeze the pulmonary vein ostial area, that's around antral area, and cause a pulmonary vein isolation. This gives excellent results compared to radiofrequency ablation. One of the reasons why cryo was little different from the radiofrequency is it does not cause a lot of endothelial damage which can predispose to thrombus formation. This is one case we had recently, a 55-year-old with AF, had a flutter ablated sometimes back. Holter showed tachybrady syndrome, had a longest AF more than 24 hours, has developed a LV dysfunction now. He was normal LV function to start with. These are the options available right now. You can consider, because of tachybrady syndrome, put a pacemaker or do an AV junctional ablation with a CRT or a left bundle pacing, or you can do an RFA or a cryoablation. So we decided to go ahead with a cryoablation. As I told you, most of the times the triggers come from the pulmonary veins. So we went inside every pulmonary vein. This is the left, the superior pulmonary vein signals, which are having a sharper signals. We have frozen the pulmonary veins, and slowly the pulmonary vein signals gone. So the same way, left inferior pulmonary vein was isolated, and right superior pulmonary vein was isolated, and right inferior pulmonary vein. All 4 pulmonary veins are isolated within around 45 minutes of time. And this is how the 3D map looks like. This is prior to ablation. You can see all purple. Purple shows good voltages and good connections between pulmonary veins and the left atrium. Post-ablation, you can see clearly a darker gray shade across the pulmonary veins, which shows that pulmonary veins have been isolated from the left atrium electrically. So this was a successful ablation. So if you see, this is one of the very important thing about cryoablation. Compared to radiofrequency ablation, cryoablation results are pretty good even at the centers which have just started doing cryoablation. Even at the centers which does not have a great volume, cryos are able to offer excellent results. This is the reason why the success rates are pretty high. You can see a single procedure, freedom from AF, AT and flutter with a cryoablation from multiple centers. You can see the results are more than 80% in most of the centers. That's the reason there's a significantly higher number of cryoballoon mediated ablations for atrial fibrillation, which is across the globe right now. The safety of cryoablation has also been clearly established. You can see these are the 3 large studies which looked at cryoablation and compared with antiarrhythmic therapy. We are not talking here about the efficacy. We know very well cryoablation offers a better efficacy compared to antiarrhythmic drugs for the freedom of atrial fibrillation, but the safety also is very comparable. You look at the side effect profile of both antiarrhythmic therapy and cryoablation, which is an invasive procedure, which are pretty comparable. So these 3 studies have clearly demonstrated that as a first-line therapy, cryoablation is superior to antiarrhythmic therapy for prevention of atrial arrhythmia recurrence, and first-line cryoablation is associated with the larger improvements in AF specific quality of life compared to antiarrhythmic therapy, and more patients were asymptomatic at 12 months of post-blanking period following the first-line ablation versus antiarrhythmic therapy, and cryoablation can become a first-line rhythm control strategy with acceptable safety profile. This applies to most of the patients with atrial fibrillation who have a structurally normal heart. We prefer patients in the early part of atrial fibrillation when left atrium is of good size. Thank you.
Great talk. My question is, there are different ways to deal with the atrial fibrillation now. One of them is to ablate the AV node and give a CRT or give a conduction system pacing. So has anybody tried to compare whether pulmonary vein isolation is a better way, or you could also do AV nodal ablation, which is a relatively more simple procedure?
So ideally, any patients with atrial fibrillation?
No, I'm talking in context of the heart failure patients. There will be a substantial number who will anyway need a CRT. So you could do a AV nodal ablation, give the patient a CRT versus conduction system pacing, which was the topic of the first talk.
Yeah. So we are talking about 2 different kinds of atrial fibrillation. One is an atrial fibrillation which causes a heart failure, which can be cured with an ablation. You have a patient with a heart failure who has developed atrial fibrillation, and heart failure is causing further deterioration of heart failure. These patients, if you are not able to achieve significant rate control, the primary object in this patient is to achieve a rate control. If your beta blockers or an antiarrhythmics are able to offer a good rate control, you don't require to do an AVJ. But if you are not able to achieve a good rate control, this particularly applies to patients with young patients with rheumatic heart disease, where with multiple drugs you may not be able to achieve a good rate control. Here you can try a AV junctional ablation, particularly if you feel that left atrium is hugely dilated. Yeah, left atrium more than 50 millimeter in a long permanent atrial fibrillation, where ablation strategies are not going to work. In this patient, you can consider putting an AV junctional ablation, and when you do an AV junctional ablation, you need a pacemaker. The pacemaker could be either conduction system pacing or a CRT. I would prefer a conduction system pacing, the reason being a simpler procedure, and earlier we were doing CRTs.
Thank you.
Thank you, Lawrence. Now I invite Dr. Jayashankar to give his talk on should CMR be mandatory before each ICD implant in patients with heart failure. What do you say?
Good morning, respected chairpersons, dear friends, Dr. Abraham, very many thanks for having me again. The topic allotted is should magnetic resonance imaging of heart be mandatory before every ICD? First, a few general aspects. We are all aware that sudden cardiac death is one of the major causes of death, accounting for approximately 20% of deaths worldwide. Despite a decreasing cardiovascular mortality in the past 20 years, the survival rates for out-of-hospital cardiac arrest is pathetically low as 10%. And it is commonly assumed that sudden cardiac death results from lethal arrhythmias, and which has been proven in many trials. And most importantly, non-ischemic cardiomyopathy is considered the second most important entity for arrhythmias and sudden cardiac death, next only to ischemic heart disease. And approximately 30 to 40% of patients with non-ischemic cardiomyopathy present with heart failure. But the important caveat out here is two important trials, DEFINITE and Danish trial, showed no overall survival benefit in patients with non-ischemic cardiomyopathy who were given defibrillators. So that's where the whole problem rests. And the SGLT2 trial also, in a post hoc analysis over the years, over 10 years, has not shown great survival benefit of defibrillator when offered to patients with non-ischemic cardiomyopathy. We have no confusion in our mind when we deal with ischemic cardiomyopathy who are on guideline-directed medical therapy, who have had appropriate revascularization, who have a lot of scars, whose EF is persistently low, less than 35, we know that they are an indication for defibrillator. But the non-ischemic cardiomyopathy is a whole different subset. Current guidelines recommend ICD for every symptomatic heart failure, preferably class 2, 3 and YHA, and EF less than 35 on optimal guideline-directed medical therapy. It does not differentiate between ischemic and non-ischemic cardiomyopathy, but then as I showed, the two trials, important ones, have been negative for defibrillator in NICM. But the only thing which we all the time look for when we offer a defibrillator is a left ventricular ejection fraction, which has got a lot of inter-observer and intra-observer variability. The sensitivity and specificity is pathetically low, and this is what we rely upon when we offer defibrillator to our patients. Appropriate ICD therapy is documented only in third of patients, even when we cherry pick the patients for the defibrillator, because EF happens to be the sole criterion based on which we offer the ICD. The predictive value could greatly be improved if we can probably add a magnetic resonance parameters such as late gadolinium enhancement and the pattern of LGE to discriminate different cardiomyopathies, and then also try and evolve a consensus whether we can improve the sensitivity of and specificity and predictive value of defibrillator therapy after implant. It is well known and well established in ischemic cardiomyopathy, the ventricular arrhythmias originate from the post-infarction scar, from the fibrosis, which induces electrical dispersion, leads to slow impulse conduction and non-uniform anisotropy. And these pathogenetic mechanisms contribute greatly to the re-entry circuits. But in dilated cardiomyopathy, the fibrosis as a substrate for ventricular arrhythmias is less extended, less confluent and more heterogeneous. So that's the whole problem. That's where, and then guideline directed medical therapy all the time, and even without giving an ICD, has shown a substantial benefit. Late potentials represent the myocardium where the conduction is slowed by fibrosis, which is the most important pathogenetic mechanism for re-entrant arrhythmias in ischemic cardiomyopathy. The scar tissue, that is fibrosis, it is typically involving the distribution of coronary artery. It is subendocardial. So it's very easy for us to localize, and then, even when we do ablations for ischemic cardiomyopathy, it's fairly simple. In non-ischemic cardiomyopathy, fibrosis can be located endocardially, it can be epicardial, it can be intramural, or exhibit a diffuse pattern depending on the etiology of the non-ischemic cardiomyopathy, as we saw in the previous topics as well. This is a very important paper from Spain, and then over the last 15 years or so, the total number of ICD implants in the bar, and then they have used MRI to substantiate which are the patients who are eligible for an ICD and which are the patients who will have a definitive treatment with an ICD. And we see that over the last 15 years or so, there's a steady increase in MRI over on top of ejection fraction to pick the patients for ICD implant. Why do we need MRI? Because 1 in 4 patients who are referred for cardiac MR have a new diagnostic finding, and 1 in 10 subjects had a meaningful clinical change in pathology as far as etiology and management is concerned. And many a times a thrombus which is missed on the echo is readily picked up on MRI, and then the treatment also changes. Late gadolinium enhancement happens to be an accurate and commonly applied technique for identification of focal fibrosis, and thus can visualize and quantify substrate for ventricular arrhythmias, which is very, very important in ischemic cardiomyopathy. This results in regional abnormalities in myocardial extracellular volume due to loss of myocardial tissue, necrosis, edema, and scar formation. And LGE can be characterized by its overall extension, its location within the left ventricle, and the pattern of distribution. And this has been reported to be a strong independent predictor for ventricular arrhythmias and sudden cardiac death after adjusting for all other clinical or functional prognostic parameters. So this is sort of well known for us, and there's no confusion in our mind when we use LGE for ischemic cardiomyopathy. There's so-called gray zone in ischemic cardiomyopathy, which defines the region at the periphery of myocardial infarction, where the myocardium, which is viable, is intertwined with fibrosis and thus has an intermediate signal intensity. This zone is suspected to be particularly vulnerable for generating ventricular arrhythmias. As I said earlier on, when we go and ablate these patients, these are the targets for ablation. In non-ischemic cardiomyopathy, there is no definite gray zone equivalent to what has been described for ischemic cardiomyopathy. That's where the whole problem lies. So we need to have more and more parameters to incorporate over and above ejection fraction estimation. The most common LGE pattern in non-ischemic cardiomyopathy is linear mid-wall. I'll show some pictures I don't have taken from the textbooks. Subepicardial or patchy enhancement patterns not following a coronary artery territory. So that's the important difference between ischemic and non-ischemic. And NICM patients with septal mid-wall were reported to have an increased risk of sudden cardiac death. So whenever we see an MRI finding of a septal mid-wall late gadolinium enhancement in non-ischemic cardiomyopathy, they are to be looked upon carefully and then probably offered an ICD as early as possible. The LGE score and the risk of arrhythmias have a definite correlation. When we have between 5 to 15 or up to 20% of late gadolinium enhancement, we are looking at higher incidence of VT-VF. There are different parameters for on CMR for evaluation of risk of sudden cardiac death. LGE being on the top, visualization of myocardial fibrosis is an independent predictor, but then there are a lot of contraindications to contrast agents as well. And T1 mapping and extracellular volume estimation, which is also believed to be a marker of diffuse fibrosis, is one of the parameters we looked into. And just like echo, MR strain imaging is also an important parameter, but then there's lack of validation, and that happens to be the limitation. Late gadolinium enhancement for non-ischemic cardiomyopathy can be of different types. As I said, this is from the textbook. Whenever we see a mid-myocardial LGE in an NICM, those are the patients with a low EF. We have to offer them ICD because they're at risk of more ventricular arrhythmias, and it can be subepicardial patchy as shown in the arrows here, and also it could be patchy right ventricular insertion points as shown in the figure C out there. So these are the LGE patterns which we have to look for. And then there is now a nomogram, how to evaluate the patients of it's fairly easy for ischemic cardiomyopathy. For non-ischemic cardiomyopathy, the SCD risk estimation does not rest only on echocardiography. As I said, there's a lot of inter-observer variability. We have to utilize the ECG parameters like T-wave alternance and even prolonged monitoring for NSVTs, and for CMR, T1 mapping, strain imaging, and late gadolinium enhancement, and all the time history and family history, and also genetics plays an important part. So we have to put everything together when we offer to have a better predictive value as far as offering a defibrillator is concerned for non-ischemic cardiomyopathy. Again, taken from the book. I'm sorry I don't have images from our center to share here. For ischemic cardiomyopathy, the important things to look for is the core red zone as it's color coded. We are looking at border zone, which is white, and the blue, which is which is normal. So that is the area which is the usual focus for re-entry. So ischemic cardiomyopathy is very easy to find out, and as shown in the inset box here, that slow conducting channel, the white up there, is believed to be the focus for the re-entrant circuit. And the next one is a core red, red zone, homogeneous, and it has no conducting channels, less of a worry. And down there is the blue color coded where it's all healthy myocardium. So LGE reconstruction of CMR helps a lot. And all of them, a border zone mass, channel mass, number of channels, scar mass, and left ventricular end diastolic volume, they all have predictive value. And the important thing to bear in mind is whenever we have a scar mass greater than 10 grams, it's a very strong predictor for appropriate therapies with ICD, and these are the patients who will benefit the most. They also, the number of channels which are present and the scar mass together, they have a predictive power which is very good, and they predict mortality. I'm probably going to wind up because of lack of time. A scar mass, border zone mass, conducting channels are predictors of appropriate therapy in patients eligible for ICD implant for primary prevention. We have no confusion in secondary prevention as such. A combined algorithm with scar mass, that is 10 grams as a cutoff, and the presence or absence of conducting channels could improve greatly the risk stratification for sudden cardiac death with a very high negative predictive value. Scar assessment and scar characterization bar CMR are likely superior to relying solely on left ventricular ejection fraction for risk stratification for sudden cardiac death. Appropriate ICD therapies can be readily predicted by the distribution of the left LGE on MRI, but we need more data and probably controlled trials and further research to validate this statement and to bring it on to the trials. Thank you very much for being patient with me. Thank you.
Great talk, very, very sharp and incisive. And I think you made the point very well. I have no questions. If there are any questions from the floor, they're welcome, please. I think you drove home the point very well, and thank you very much.
Thank you.
We will close the session.
Thank you.
Thank you, moderators and the panel members, for enlightening us. Moving on to the next section of today's conference on mix and match, I take this opportunity to welcome Dr. Uday Jadhav, Dr. Vinod Sharma, and Dr. Jaishankar to chair the session. May I request the moderators to start the proceedings. General announcement. Delegates are requested to keep their mobile phones on silent mode during the session.
How are you, sir? Good to see you. So thank you. Let's get this session started. It's on mix and match. There have been two talks. Dr. Manokar will speak on the devices for functional MR, and then our good friend Dr. Tiny Nair will take it up on the obesity diabetes combination and how it's linked to heart failure. Dr. P. Manokar, please.
Good morning, everybody. Sincere thanks to Dr. Abraham, sir, for this opportunity. But the topic made me make this disclosure first, that I have no personal experience of using any device to reduce MR, but all through my academic career and clinical practice, I have developed a good experience of creating MR. The reason why this is important is MR, we have been told from day one, MR begets MR and all those things from our undergraduate days. The problem with MR most of the time is the compensatory mechanisms in the body function so well that it is a very tricky challenge as to when that decision to intervene is made. Like, for example, my surgical friend would always tell the patient, you are having significant MR, but my valve is still not as good as your damaged valve for me to suggest a mitral valve replacement. Sometimes it's tough for the patient to understand it, but the reason is the compensatory mechanisms in the body function in such a manner that not all patients who have significant MR benefit by intervention. So that's the reason why there is so much of a challenge to decide which are the patients are going to benefit by treatment for MR. Although there are a lot of papers and a lot of data to suggest, how the LA pressure changes, how the overall changes in the LVEDP, how the transpulmonary gradients change, and how these people benefit by symptomatic manner, especially in patients who are with heart failure, patients with how the reduction in MR can dramatically change from somebody who is moribund, bedridden to ambulant. So that makes a huge impact on them. In fact, in some of the discussions, when some of the other meetings, somebody said doing a Mitra clip produces better quality of improvement in life than a TAVI. I know it's always a debatable issue, but that was put across by one of the speakers. So this is why it is considered that the reduction in MR may have a significant impact. But the trouble with these things is, if you look at this graph,
it makes you understand why this topic is so complicated. So when you compare the MITRA-FR study to the COAPT study, so all of you would conclude that the COAPT study was more well planned and more good patient selection, which made the impact between outcomes. So the reason why I'm suggesting is the thin line of difference between the people who will benefit and the people who may not benefit, or in other words may be harmed, is so fine that it needs a lot of clinical judgment and reasoning to decide which of the patients would benefit by an intervention to reduce MR. The devices available, obviously there's a host of devices. In the last night when I calculated, as of now around 92 devices are being tried, and I definitely don't think I will be going through all those 92 devices today. I'll restrict myself to the devices which may reach clinical relevance shortly. So basic thing, the parameter based on which we decide that which device is suitable is based on whether we think it is a primary MR or it is a secondary MR. If you think it is a primary MR, the first option always comes up as an edge-to-edge repair, where the maximum data with reduction of the regurgitation is noted. The other technologies which are emerging in this field would be with the neocord as well as with the wall replacement. But when you look at secondary MR, in secondary MR, edge-to-edge repair doesn't have that degree of benefit as it is with primary MR. In secondary MR, obviously the other alternatives like going for an annuloplasty or going for a wall replacement tend to score over the benefits of going for an edge-to-edge repair. Obviously, echo forms the basis of understanding the mechanism of MR. Echo forms the basis on defining the severity of MR, the etiology of MR, and deciding the interventional modality. So definitely these are some echo specialists can highlight further about 3D TE in assessment of MR, but I'll try to keep things in a very simpler fashion, that the optimal parameters would expect that patients should not have rheumatic heart disease or should not have any mitral stenosis in the background. So mitral wall area is expected to be more than 4. They should have sufficient mobile length of the PML, and the coaptation depth should be less than 11 millimeter, and this would be the ideal, but the unsuitable ones would be the ones with perforation and where the mitral wall area is less, the mobile length is not, and with multiple flail segment, again it would not be a good criteria. The other issues is the echo assessment helps us in deciding which patients would benefit from a mitra clip or a Pascal, or would benefit from a neocord or a harpoon-like device, and based on that we can, based on echo, fluoroscopy, TTE, all these things will help us understand. So understanding the annulus, whether the annulus is the culprit, then we should consider devices like the cardioband, mitra-align and Carillon devices. Definitely for TMVR assessment, CT becomes a very important parameter, because then the annulus perimeter, the impact of the CT on the new LVOT formation, all these issues make it a big issue. For example, now CT is just like we have a TAVI protocol for CT assessment of for the aortic wall. There are clear-cut designs of CT to assess the mitral wall annulus, but the most important thing that is to be considered in the CT is what happens to the aortic LVOT. So the major role that CT plays in mitral wall assessment is whether the neo LVOT is going to have a significant obstruction. So the neo LVOT is a very key thing that is important in imaging with respect to the CT, and that helps us in assessing. In fact, people have done studies where they have looked at 3D printing in an individual model based on the 3D TE as well as with the CT to develop models in practicality to decide which are the patients who would, for example, look at calcium. So the picture on the right tells you the 3D model, and that also helps you define how one device will look in that patient. So for example, if you see the above picture, it's a very simple case. Mitra clip is the one which will fix the problem, but in the bottom case, if you look at it, there is something like a posterior leaflet has kind of a perforation where they have fixed it with a duct occluder. So these kind of models can help us design which devices will help. This is already there in most of the newer cath lab machines, where we have 3D TE integration with the cath lab, which helps make procedures like septal puncture and all a very safe and easy procedure. This slide is mainly meant to tell you that there are so many studies with device that it is not worth going through each one of them. But to put things in simple, the two devices which have FDA approval, we have the Mitra clip. If you look at how the generations have evolved from 2003 to the present, what we call as the G4 device. The G4 device is the presently most accomplished or with the maximum flexibility in doing the device. Even in that, we from the XTR versus the NTR variants, the certain things favor the XTR. For example, if you have a longer leaflet, the XTR is better. If you have a smaller mitral wall area, then the NTR is better. The competing device is the Pascal device. We had the class 2D randomized trial which showed that both the devices, it's more or less a non-inferiority trial, although the numbers are very small, like 100 patients in each trial. But at least we can safely assume that both the devices would satisfy the similar need. So if you look at what happened, the change from baseline to 6 months in the Pascal versus Mitra clip, more or less the MR reduction is really good. And even in clinical outcomes, except for bleeding, the other things, the need for emergency surgery or the mortality outcomes and all look comparable. Put it in a nutshell, Pascal and device and Mitra clip as on date look to be equally promising options in patients with for mitral wall repair. So these are the two FDA approved options. There are other options which are in the pipeline. This more work to improve the mitral wall function by looking at the other aspects, like the AccuCinch device is nothing but a constrictor somewhere in the below the mitral wall, trying to reduce the improve the contractility by a percutaneous route. Similarly, we have artificial papillary muscles, we have neocord systems, we have the harpoon system. All these things add up to improving the LV mitral wall function. So we have, this is an example of a Novocord implant. Similarly, this is with the cardioband device. So this is an example of how the CT guides in the designing of the prior to the implant and the CT guided thing. Obviously, TMR will be the eventual best option for patients. I'll skip through them. TMR options again are plenty in number. All of these things are being tried, and most of them will reach clinical relevance. The numbers are too many, I'll just go through them. But at the end of the day, there is nothing like an ideal wall. So we all know, we have been from our undergraduate days, we think this is the ideal wall. But sometimes I think the ideal wall is like an ideal husband. They never exist. Before I end, this is about people with cardiogenic shock and acute mitral regurgitation. So this was traditionally handled by an IABP device. So now people have published from the Italian registry, Mitra shock, multiple registries, multiple centers have looked at patients with acute mitral wall presenting with cardiogenic shock and how the mitral, all these devices which were used to reduce the MR have improved outcomes. Although this is little controversial, at the same time thought-provoking, but a day will come, this will be like our primary PCI program. Patient comes to acute cardiogenic shock with acute mitral regurgitation, and this guy goes in for a Mitra clip or some other device to reduce MR, and the patient is wheeled out safely. This is just an example to show that a patient presented this way. They put an impella, kind of rescued the patient, and then went on with the Mitra clip to save the patient. At the end of the day, there are a lot of options present, but nothing supersedes clinical judgment. Skill subset is very important, but patient selection as well as outcome expectation is very important. Thank you.
Thank you. Thank you. Couple of quick comments or questions.
Thanks, Manohar. You went through the all the devices which are available now. I guess you started doing, if I'm not wrong, in your hospital, 1 or 2 Mitra. I mean, I have no experience. I just want to check.
No, sir.
Not yet. There are few centers in Chennai who have started, and
Yes.
frightfully expensive though, but then results are very good. Correct.
Getting the septal puncture right is the first major step, and as Dr. Manokar pointed out, transesophageal echo is integrated in the cath lab. So we have the team that shows us how exactly to go ahead with the puncture. After that, the rest is fairly easy. The first 3 cases were proctored from the US by using the Proximi device. The last 3 we've done ourselves. And it's as Dr. Manokar pointed out, 3 of us are required for doing it, and it's 31 lakh rupees at this point in time. But all the results that we've had, all 6 are doing well, and many of them on follow-up are on very minimum medicines. So it's a big positive for us.
And have you had more than one device implant for?
Only the 6th one that we did required 2 devices, but all the rest have been a single device. And the good news is there's no extra charge for the second device. This is same cost.
Is there any worry of hemolysis like we have it?
No, we've not had any such problem.
Residual MR, no worries?
No. Residual MR, of course, we have to titrate between the residual MR versus the mitral stenosis. There is since you're narrowing down the annulus, there is a gradient that comes, and the cutoff point is 5 millimeters of mercury. So if you have more than 5, you don't put in an extra device. That's likely to worsen things. So this is our present understanding.
From whatever we have been hearing, I guess this is one procedure where T is the most important thing. In fact, it's almost the decider of the success of the program. Before Tiny comes over, you have a question, please.
Actually, I want to ask that as cardiologists, do we defer the patients for surgery? Because most of the patients, they have MR, severe MR, and they have huge atria. Still, we don't recommend surgery for them. Is it like that? Yes.
In fact, surgery is recommended for all patients who are surgically eligible patients. If you look at the MitraClip data, it started with people who are surgically ineligible candidates. If patient remains surgically eligible, I think still surgery has an edge in patients with mitral regurgitation. There's no doubt on it. We are talking about surgically ineligible patients.
Okay. Thank you, Dr. Manokar. Thank you.
Rahul Dravid once told, he is the only Indian batsman, when his wicket falls, everybody claps because Tendulkar comes next. Over to Tiny Nair, sir.
Tiny is now becoming the SK Yadav, right? Sky.
Yeah. Good morning. Good morning. Good morning. Thank you. I think the main, I've been asked to talk about obesity. I think the first paradox is Tiny talking about obesity, right? So, this lecture is supported by Novo Nordisk, who make semaglutide and GLP-1 RA. They are sponsoring this program, but the materials, the slides, the conclusions, as you'd see, are entirely my own. Absolutely. So, we're talking about diabetes and obesity as they call it, and heart failure. Right. Now, if we look into the combination of diabetes and obesity, it creates a huge change in the metabolic milieu. For example, increase in fatty acid, insulin resistance, increase in RAS activity, increase in sympathetic nervous system activity, increase in inflammation, and circulating insulin itself, right? And all of them, we know, that go in the making of diabetes. This picture is borrowed from JACC, right? And that leads to heart failure. But we today know that all this combination of milieu also does a lot of other things. For example, they create dyslipidemia, lipotoxicity, gives rise to excess of coronary artery disease. For example, the Trivandrum heart failure registry, we had about 65% patients of heart failure with the preceding acute coronary syndrome, right? But sometimes what we forget is that on to the right, the mechanical effect of obesity. And that mechanical effect can give rise to OSA, pulmonary hypertension, and contribute to either genesis or worsening of heart failure. So it's a pretty complex picture. But understand that there's a huge bit of confusion in diabetes, obesity, and heart failure. We will show you some. This is a beautiful article that came a couple of years back by Carl Levy from New Orleans, and look at that data. I think this is very interesting, and we have no way of understanding why this happens. Look at that. We are looking at the incidence of heart failure, right? So incidence of heart failure in the obese. Okay, so on the first you have that red curve of obese, and the right you have normal. So what do we see? Obviously, obese people have more heart failure. Logical, right? Obese people have more heart failure. But when you look at the graph of cumulative survival, so survival, right? And we are looking at people who are overweight and obese in that dotted line. The continuous line is normal or underweight. We see what? So the obese people survive longer, right? So obese with heart failure survive longer. So what are we talking about? We are talking about here, yes. So heart failure in obese, more common, right? But heart failure in obese, better outcome, better survival, right? And that is what is the obesity paradox. Obesity paradox is not Tiny talking about obesity, but obesity paradox is heart failure in obesity is more common, but people tend to have a longer survival for a long period of time. We were unable to explain why this happens, right? Why this happens. Today we know that it's pretty complex. So if you look at that concept of metabolic healthy obese, so some people might look, oh, obese is unhealthy. No, some of them might be metabolic healthy obese, MHO. And these MHOs have kind of good outcome, right? But when they migrate on from MHO to that MUO, metabolic unhealthy obese, and the trigger usually is an insulin resistance, when inflammation and hell of other things come in, then things worsen. So we should understand that simply becoming obese is not really a problem, but when you add up obesity to diabetes and you have insulin resistance coming in, probably you are looking at a different subset when the entire thing worsens, right? Look at confusion too. This is purely about diabetes, right? We know that if we are looking at a better HbA1c control, this is old data, everybody has seen that, A1c control, macrovascular comes down, microvascular comes down, everything comes down, including heart failure. So if we control sugar well, obviously heart failure comes down. But then if you look at a much larger database, in fact I say that if you read one article on diabetes prevention, this is it, like this came out a couple of years back in NEJM, where they looked at the Swedish National Registry of 271,000 patients with diabetes. And they tried to see they tried to see what happens if you control A1C, B, blood pressure, C, LDL cholesterol, microalbumin, and smoking in your diabetic patients. So they are trying to see what happens in your diabetic patients if you control A, B, C, and microalbumin and smoking, right? And what they defined, something very interesting, right? If you look at that, let's see acute myocardial infarction. Okay, we are looking at acute myocardial infarction. On the top, those diamonds are in control, non-diabetic. They are all on straight line. The next box is people, diabetes, all these 5 risk factors, A1C, blood pressure, LDL cholesterol, microalbumin, smoking, all controlled. Look at that, they're still on the straight line. No increase in risk at all. In contrast, if you have all the 5 risk factors abnormal, each of this is an age band, you see that the risk goes up to what? 7.6. So if you control the traditional risk factors, your incidence of acute myocardial infarction and diabetes is significantly comes down almost baseline, right? But in contrast, look at heart failure. Look at heart failure. Very interesting, right? Look at heart failure. Even when all the 5 risk factors are controlled, look at that, there's a substantial increase in risk. And that remains same, whatever, whether you're 1 risk factor, 2, 3, 4, 5. So the point is here, control of traditional risk factors do not reduce heart failure risk in diabetes. Okay, confusion 3. Whenever we see a diabetic, we presume, we know that they are fat, right? Even if the Zucker rat or the DBDB mouse, which are our diabetic or the metabolic syndrome model by leptin gene knockout, we know that they are fat. So whenever we see a fatty person, we always think, oh, diabetic, right? But the point is, this gentleman created all the problem. Quetelet, Lambert, Adolphe, Jacques Quetelet was a polymath, a physicist, an astronomer, a genius, truly a genius. And when the French government wanted to decide who would benefit by an intervention, who is healthy in this group and who is unhealthy, they gave him the chart that you find out. But he had very little knowledge of biology. So what he did was he drew 6 models on the paper and tried to connect with different parameters and evolve an equation. And he failed. And because he failed, he did what all of us does. He went back and created some unusual formula to fit in health and unhealthy models and came out with this BMI. So kilogram by meter square. In an interview, I was asked, why did you square the meter? He said, I have no idea. That was the only thing that fitted in, right? So why we are talking about this? Because if you look at this paper, for example, this came in Lancet Body Mass Index and cause-specific mortality in India, right? Look at the data. The x-axis is body mass index, right? Body mass index. And the y-axis, you have what? Cause-specific mortality ratio in India. Okay, now we are comparing, right? On the left, you have Chennai, India. And right, you have Europe and North America. Look at the Europe and North America. The risk ratio clearly is defined by BMI. But when you look at Chennai, it's flat, right? So in our population, BMI cutoffs does not really tell us about the risk, right? And this is not just important in India, because a lot of Indians are there in US and in UK, right? And that's the reason why JCC asked that, why don't you do an expert comment on this? So this is extremely important, and that is a huge, big confusion, right? So you would say, what is the way out of this, all this confusion? The way out of treatment is kind of different. So let us look at the anti-diabetic treatment and its effect on weight. If you look at insulin, sulfonylureas, TZDs, what? They increase weight, right? And we know that we have better drugs like DPP-4 inhibitors, alpha-glucosidase inhibitors, they're weight neutral. But if we are talking about an anti-diabetic medication that reduces weight, we have GLP-1 analog, GLP-1RAs and SGLT inhibitors, of course, metformin, right? So let us focus on GLP-RAs, SGLTs and metformin, right? So if we look at metformin, SGLTs and GLP-RAs, we see that the mechanism of action of GLP-RAs are different. They increase insulin secretion, they decrease glucagon, they slow gastric emptying by increasing and increased satiety, right? And if you look at the subsequent effects, A1C reducing efficacy is maximum with GLP-RAs compared to even SGLT inhibitors. If you look at hypoglycemia risk, uniformly low in all three. Look at weight reduction, significantly more with GLP-RAs. And if you look at cardiovascular benefit, GLP-RAs and SGLTs, right? So if you look into all those published CVOT trials and see, you find, right, GLP-RAs, take out GLP-RAs, 14% reduction of cardiovascular, 12% mortality reduction, composite kidney outcome, 21%, and actually what we are focusing on, 11% prevention of new onset heart failure in these trials. Okay, so if we take out the GLP-1s and spread them on a platter, all of them, abiglutide, dulaglutide, exenatide, liraglutide, okay, all of them, and look at the A1C reduction, we see that semaglutide has the maximum of 1.38, significant reduction of A1C, right? Look at weight reduction. Again, all the platter of GLPs, we see that semaglutide has 4.1 kilograms. So because we are talking about diabesity, we are focusing on diabetes and obesity reduction, right? Now, if you look at the over-the-board meta-analysis and look at the semaglutide pool data, you see, 24% reduction of MACE. Why are we talking about MACE here? We are talking about heart failure, right? Because it is this acute coronary syndrome and MACE that subsequently gives rise to a majority of future heart failures, right? Now, you would say, is there a data on established heart failure patient with semaglutide? Yes, there's a very small data of 136 patients. Thank you. I've been asked by Dr. Abraham that can continue for 1.5 more minutes. Yeah, no problem. So, do we have a trial of semaglutide in patients with heart failure? Yeah, we have a small trial of 136 patients, type 2 diabetic, obesity, and heart failure. They are in heart failure, right? Not prevention. And if you see the observational data, will not waste time, go on to that, and we see that what happened in that very small trial is that NYHA class better, in T-proBNP better, and heart failure hospitalization better. Okay, so there is a data that yes, even in heart failure this is good. But we are just focusing on 2 more points before we end, and that is this. Everybody would ask about this, right? So we are talking about GLP-1 analogs, and we are talking RAs, and we are talking about SGLT inhibitors. Do they match up? Yeah, we all use SGLT inhibitors, right? Do they match up? And the question, the answer is here, right? If we look at side by side, GLP-1 RAs and SGLT inhibitor, look at that. Prevention of heart failure hospitalization, both are good, but SGLT looks better than GLP-RAs. But if you look at the entire cohort of MACE or cardiovascular death or MIs, which subsequently would give rise to a new onset heart failure, you see both of them are good. Okay, so once we see both of them are good, the final barrier comes here, right? So can we combine SGLT and GLP-1 analog for their best of their effects combination in a primary prevention of cardiovascular disease? And yes, the data looks very interesting here. So you have 336,000 patient data, type 2 diabetes, no cardiovascular disease. They are nested case control data analysis, 336,000 patients. So they are type 2 diabetic, they have no CVD, right? Nested case control. Let's see what happened. It's just the final conclusion that if we look at the data between top SGLT inhibitors, next green GLP analog, GLP-RS, and the third combination of GLP and SGLT inhibitor, and we are looking at the odds for heart failure. We're not looking at MACE here. So prevention of heart failure in a diabetic looks like the best when they are treated with a GLP-RA and SGLT inhibitor, right? So what are we talking about? We are talking about this, right? We have a huge confusing background when we talk about diabetes and obesity, and none of us clearly know the answer, right? And can we find a way to clarity? I think quite difficult, right? Quite difficult to find a connecting link from transition of confusion to clarity. But in our journey, in our endeavor to treat such a complex situation where you saw on the first slide, the whole milieu is disturbed. I think SGLT and GLP-1 based therapies give us a clue, a direction, and perhaps a bridge to connect confusion to clarity. Thank you for your time and attention. Sorry that I've exceeded by a minute or so.
Quick question, Tiny. How do you now look at tirzepatide with weekly injection? 90% patients achieved a significant weight loss. All cardiometabolic parameters improved. How do you look at that for the future?
I think the future is good. Basically as cardiologists, we are not diabetologists. Like even we, and not just the patient, we are afraid of injections, right? So the moment we listen about injectable GLP, we said, no, why don't you try a little acarbose or voglibose kind? We are scared of injections, right? So the point is, the moment GLP-RAs have crossed that threshold of from injection to oral, I think all of us are ready to accept that and embrace them. Couple of questions still remain. One, of course, the side effect of nausea, but if you follow their proper guideline of giving the drug before food, 30 minutes before food with 100 ml of water, I think a lot of patients do tolerate them, start with a small of 3 milligrams, graduate to 7 and then to 14, the usual standard dose they tolerate. And second, of course, is the cost. So if somebody from Novo is there, we would request that over time, please see that as much as cost you can subside, more and more patients probably would get a benefit of this kind of combination therapy, especially those whom would I choose now? A person who is grossly obese and of course uncontrolled diabetic and has a high risk of cardiovascular disease. Perhaps I would choose this combination.
Thank you, Dr. Tini, for excellent talk. Of the last slide, you mentioned the combination of SGLT2 with the GLP-1. Should we replace SGLT with the GLP-1 in a patient with diabetes and heart failure?
This particular data was derived from people who did not have heart failure, did not have coronary artery disease. They were just diabetic And they tried to see in a pure diabetic who were overweight by combining GLP-RA and SGLT inhibitor, do we benefit by reduction of cardiovascular events and heart failure, and we saw that new heart failure were prevented. Now, today we know with so much of data coming in from both from empagliflozin and dapagliflozin that they're extremely good in established heart failure. Do we have that data from GLP-1? No. Some 136 patients of a very small real world data. That doesn't qualify us to give GLP-1 in a patient who has come with a heart failure for his treatment of heart failure. But even obese patient, uncontrolled diabetic with heart failure comes in, who is already on SGLT inhibitor and other drugs, I have no hesitation in putting him on an addition of GLP-RA. They are safe.
Thank you.
Yeah. Yes. Yeah. So see, there's a reason why Dr. Praful is asking this very important question, because all of us who have read the semaglutide trial, the oral trial, very clearly know that there are quite a few caveats. Okay, right. For example, acute myocardial infarctions didn't come down. Why they didn't come down, we don't know. My take would be that it was a shorter trial. The mean follow-up was about 15 months, when perhaps it was not enough time. Despite that, the cardiovascular death came down, total death came down. Acute myocardial infarction did not. In fact, the acute myocardial infarction was slightly higher in the oral semaglutide group. So the question comes in, does oral semaglutide, is it less effective than injectable? I don't think so. Obviously, the amount of drug that goes into the system is much less, because it's a very complex system. They call it what? Peptide in pill. So I think the amount of the drug that transports into the blood is lesser. And so probably the benefit is lesser and it is taking longer time to kick in. But I have no doubt in our mind that the direction should be same. Any comment, Dr. Praful, your take on that? Outcome data is very, yeah. Yeah. Oral. Once a day tablet. Yeah. Injectable, yeah, correct. 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 Yeah, I suppose so.
Area of this T20, patapat question and answer. The other thing is that also they are bringing 25 and 50 milligrams of oral semaglutide now,
for
considering this fact only, that the bioavailability of semaglutide is much less, and it's possibly not as effective as the injectable.
Dr. J.C.
Just one question. Is somebody envisaging a dedicated heart failure trial with oral semaglutide?
No, I'm not sure.
So till that thing comes up, that means the next 5 to 10 years, we couldn't be prescribing these drugs as a anti-heart failure medication.
No. Anti-heart failure drug, no, but we know that they are safe in heart failure. They have been shown to prevent emergence of heart failure, like what we saw in the initial SGLT trials. The initial SGLT trials showed that if you give it to patients who have cardiovascular risk, diabetes, obesity, they prevent emergence of heart failure. Like Dr. Professor J.C. Mohan Wright clearly said, there's no indication right to give it to a patient of heart failure with diabetes, because it has no heart failure treating ability, this particular drug. Yeah, very clear.
Thank you. Any for a very large.
Not from the government, at taxpayers' cost. Please.
Diabetic patient has got a 32% risk of developing heart failure. Now, you are put a slide saying primary prevention. 32% risk of heart failure is there in any diabetes, whether lean or obese. Now, in diabetes with obesity, you have put a slide putting it as primary prevention, sir. Now, I want to ask how early a primary prevention you would recommend, because when we see an obese patient, most of them are obese and come with first diagnosis, new onset of diabetes. Do we start in these patients for primary prevention?
Absolutely no. Primary prevention should only start from lifestyle, diet, exercise and other things, and then you add up medications. But till now, this is just a data set. There's no indication that GLP-1 should be given as a primary prevention in a patient who is diabetic simply to prevent heart failure. No, there's no data. This is just a network analysis that has been done to show that they are benefit. The other thing we should understand that this is an extremely expensive drug. So your patient might be affordable, but then my patients won't, right?
So thank you, Tiny, for a great talk and not so very tiny discussion that followed after that. And we go to the Abraham.
Dr. Uday, can the chairpersons remain because
Suresh and
Dr. Suresh,
Dr. Ilayaraja.
Dr. Suresh is here.
I can see him.
Dr. Suresh is there. So, and
Ilayaraja is there.
Dr. Ilayaraja.
And Dr. Sanjay Mittal is here. Sanjay, please.
Okay. So Dr. Oni could not make it because he had an intervention. So Dr. Hasra and Dr. Vinod Sharma are there. So we are well on time. Let's little more time for discussion because the greatest complaint was that there was no time for discussion.
Good morning, everybody. So we are going to the next session, GDMT Roadmap to Success. So the first talk is horizontal or vertical approach in starting Fantastic Four, Dr. P.K. Hazra.
Good morning and greetings from Kolkata CSI. It's horizontal or vertical. Many of these presidents, they died due to heart failure. They would have been alive today if they had an access to horizontal therapy or four fabulous foundational therapy, which consists beta blocker, MRA, RD, and these drugs are discovered in a new decade. So newer people are getting benefit out of all these four fabulous drugs. Now there is a confusion whether to go the vertical way or the horizontal way. The heart failure is divided by ejection fraction but united by the mortality. Whether you have 40% or 50%, you die equally. Not because you have a less ejection fraction and higher ejection fraction. Men, women, young and adult, everybody, irrespective of the ethnicity, everybody dies. So these are the trials which are depicted here. Some trials like consensus trial, you do not know the ejection fraction. Even then the SC inhibitor worked there. So there is no doubt that SC inhibitor should be the building block of any heart failure. It has got a historical advantage, is a historical construct. That's why the SC inhibitor always comes in our mind as the first drug of therapy in a vertical approach. This ejection fraction, as I said, is a kind of elephant in the room, and everybody knows that ejection fraction cannot divide heart failure in two groups. But it is still then, I think movie is not playing. Anyway, even then, we are here to discuss the vertical and horizontal approach. There are different varieties of heart failure. Sometimes one form of heart failure can progress into another form of heart failure, or can deteriorate from the HFpEF to MREP to Hfref. So it's a continuous journey. Whatever approach you follow should follow lifelong, and only the diuretic can be taken off. So India is divided by linguistic, united by the heart failure, divided by food habits, united by diabetes, obesity, hypertension, ischemic heart disease, rheumatic heart disease. Only one GLP-1 works in heart failure, that is albiglutide in harmony trial, 21% reduction of heart failure. So that's obesity, a new drug. Definitely will be added on the four pillars plus 2 pillars, that is verisugated and omacaptive. You can take iron and other drugs also into consideration. And there are some form of heart failure where you go for vertical approach, like some heart failure very transient, like Takotsubo cardiomyopathy, tachycardia-induced cardiomyopathy, young cardiomyopathy, drug addicted, cocaine. The certain drugs can be given quickly, and certain drugs can be taken off very quickly. So it's hop in and hop out. So that neither vertical nor horizontal approaches matches there. So it's a kind of science. You apply your mind there. There are a lot of things which has been said to the science has proven wrong. So what are the errors in predicting future? It doesn't matter what he does, he will never amount to anything Einstein teacher to his father in 1895. X-rays will be proved to be hoax, and that is none other than President of the Royal Society of Radiology. Nothing can replace S inhibitor. Frank Ruciska from ESC guideline in 2016 to 2020, he continued to say that nothing can replace S inhibitor. Nothing, even in spite of having paradigm trial. So that is the past. So how the consensus has been transformed into paradigm. The consensus trial, the S inhibitor saves life in mans. See, in a paradigm trial, it saves life in years. So definitely there is a thought process from 2016 onwards, the vertical approach, emphasis on the dosage, at each drug on top of the other drugs at a time, delays in reaching targets and active treatment modalities. In 2016 onwards, the horizontal approach, all 4 fabulous foundational therapy in first 4 weeks can be initiated with starting low, go slow. But sometimes it can be start high, can go low. Somebody is hypertensive, somebody is tachycardic. So one size does not fit all. Perhaps sometimes one size fits all. That is the foundational therapy. In most of the heart failure patients, in the earliest period of time, if you go horizontally, the data came from the strong HF trial. So Fantastic Four can be manipulated to some extent depending on the comorbidities, but all the time you can go for rapid sequencing, you can take beta blocker the first drug, you can take SGLT2 is the first drug. Now there are 32 models available by which you can choose which one is the best model to choose. Now SGLT2 is just like Indian, it's a big host. It can accommodate your beta blocker nicely, it can accommodate ARNI nicely, it can accommodate S inhibitor, it can accommodate MRA, it can accommodate ARBs nicely because it's a hypokalemic drug to some extent and does not produce so much of hypotension. So it adds life to life. So what is the time approach? Time approach, like it should be adequate support, it should be timely support, it should not be too delayed. By the time you are ended up with CKDs, your creatinine is gone, you are actually reaching the end-stage heart failure. So if you follow this model by Muthu Baduganathan, so there are different colors here. Some colors like, on the left, the RAS is, I think, violet. Then the yellow is beta blocker, green is MRA, and some red is ARNI, and blue is SGLT2. So if you look at the heart failure hospitalization, cardiovascular death, if you go to the sequence 2, that is 1 is in blue color, and the 2 is in the green color. So that means SGLT2 and beta blocker should be the first line of therapy. So this model proves that if you follow these drugs and titrate in 1 to 2 weeks, so 1 and 2 means 1 and 2 weeks, 5 means 5 weeks, and 4 means 4 weeks. So beta blocker takes time, and it takes time. So whatever you do in the horizontal method, the time is money, that there is a need for speed. You do it very quickly without producing hypertension and symptomatic. So now we are moving to the circular approach. Now these drugs may not be born equal. They have every right, the democratic right, to be in the heart failure therapy, armamentarium heart failure therapy in 2023. And each and every drug is such a beautiful drug, and it can match the device therapy. Manokar has presented TR therapy, mitral clip. It cannot be compared to TR because it's a mechanical process, and it can be done under local anesthesia. But these drugs can match a surgical benefit. Now there are 2 approaches, again approach, a neurohormonal approach, a non-neurohormonal approaches, but at the end of the day, it's a circular journey. It is a hop, like if you have a city tour on a bus, you can hop in, hop out. If you have hyperkalemia, take the ARNI up, and you can go back to the journey by putting ARNI in a smaller dose. So there are second layer by your transplant, Hfai, etc. And this is personalized approach. For example, low BP, start with MRA, SGLT2, low ARNI, low BP, low beta blocker, and very sugar. So fifth failure will be very sugar. Diabetic kidney disease, after fidelity trial, we know that Fineron also can come as a heart failure therapy, though it is not a dedicated heart failure trial, you have to wait a finance trial. Somebody said, why not smaller dose? Smaller dose is okay, 21%, 21%, and 21%. So should everybody get 21% benefit from 50 milligram? I should not escalate the dose? No. If you look at the confidence interval, full dose is 0.71 to 0.88. So that means you should go for a full dose. And these are the NNTs of each and every drug, and very good number. Anything less than 30 is beautiful. And men and women may not from Mars and women from Venus. You know, the difference between having horizontal or vertical approach may vary from women to men. So women are much more responsive to horizontal therapy and any device therapy. They start having heart failure with a high rejection fraction, they have less ischemic heart disease, they suffer from Takotsubo cardiomyopathy, stress-induced cardiomyopathy, etc. So rapidly reversible heart failure where vertical approach may be appropriate, but most of the people where you have to start this drug very early in the journey and you have to continue throughout, it is better to have a horizontal approach. Unused in other trials is pathetic, like Victoria 15%, but we are improving on that because of these drugs has reduced cardiovascular death. So I have a very low threshold of prescribing SGLT2 in all heart failure. These are the trials which has been stopped prematurely. Only MRA trial is lagging behind. Otherwise, all beta blockers, the beta blocker trial, SGLT2 trial, RD trial has been stopped prematurely. So these four fabulous foundational therapy should be applied in horizontally. Anything can be changed with time. If you do not change with time, time will change you. So SGLT2 or RNA should lead. And you know, this trial, a Danish trial somebody presented, if you look at the red line, the sudden cardiac death still lower with the sudden SCD trial. So that means paradigm trial sudden cardiac is higher than the device trial. So somebody may need a device, but somebody who is not able to afford it, RNA is a kind of cellular ICDs or SGL is kind of cellular ICDs. So come out from the maze, day one thinking, and it's up to you which one you choose, but choose all four drugs on the very first day. There are a lot of rationale why you choose these drugs. So ladies and gentlemen, we are moving towards a path of mortality in the terms of heart failure as concerned. We are moving with SGLT2 beta blocker, ivabradine, IBR, verisugot, and many other senolytic drugs. Your journey, the last bogey can be hydrolyzed in nitrates. Sometimes if you have a body which is defective, you can just dump it and repair it and come back. So this is a beautiful journey of heart failure in 2020. Thank you for your kind attention.
It was elaborate description on the summary of what heart failure medications and treatment is all about. A few questions which I want to have a clarity on for the sake of audience. Once we know these four pillars, if suppose, as you said, we start beta blockers in SGLT2 on day one, and maybe after 5-6 days of stabilization, we start RNAs thereafter, or ACE inhibitors, whatever. Is this still a horizontal approach or is it a vertical approach?
Still a horizontal approach.
Yes. So by definition, the vertical approach, I think, would mean that you start one drug, see for the symptoms variability. If the symptoms stabilize, you don't add the other drug, and then you keep on doing that. But thanks for that message that all four drugs have to be started at the earliest, at the same go, within a week or 2 weeks, as soon as the person is stabilized.
Yeah, then ESC 2016 guideline says use ACE inhibitor first, then wait for some time. The patient is still symptomatic, then you add another drug. If that means in corollary, if patient is not symptomatic anymore, stay on ACE inhibitor. So that concept has changed. So that is a vertical approach. Now it has become a horizontal. You start all these drugs from the very beginning.
Any questions? Thank you, Dr. Hazra. Okay. So may I now invite Dr. Roni Mathur? Afterwards? Third one. Okay. And Dr. Vinod Sharma, please. Is going to talk on will ACE inhibitors be abandoned in the treatment of heart failure with reduced ejection fraction?
Good morning, Chairperson, ladies and gentlemen. At the outset, I would like to thank the organizer for inviting me to speak in this symposium. Now this question, will ACE inhibitor be abandoned in the treatment of heart failure with reduced ejection fraction? It's a very pertinent question, especially when there are too many makers have come in the market and there are a lot of scientific evidences in favor of RNA. It is very pertinent to discuss. We know the magnitude of problem of heart failure in the country and how it is putting a fiscal pressure on the healthcare system. Before we delve into the mechanism and we discuss and come to the conclusion, just delve into the scientific basis of this 4 class of the drug. So-called 4 pillar of the drug is based on tackling those neuroendocrine abnormalities: beta blocker, ACE inhibitors, aldosterone antagonist, and SGLT2. So they are covering each sympathetic system, RAS, aldosterone system, and finally effect on cardiac remodeling. Now we have, despite all these 4 classes of drug, mortality, though it has improved, but it still remains high in the patient with heart failure. So there is need to look for something beyond. And there came the one leftover kind of a limb of the neuroendocrine abnormality or endogenous peptide. That was the ARNI, and that was the neprilysin when it came to block the pathway leading to the hemodynamic improvement, and simultaneously it was combined with the valsartan. The landmark trial based on which things went ahead is the paradigm heart failure trial, and as we all know, this trial had to be interrupted prematurely because the benefit was excellent. Patient in sacubitril group had a 23% fewer hospitalization for worsening heart failure, and risk reduction was evident shortly after initiation of this drug, and within the overall risk reduction was almost 33%. If we look at the data and comparing it with the ACE inhibitors and other drugs, the benefit with the ARNI is beyond what we achieve with the ACE inhibitors. No doubt about it. It is beyond what we achieve with the beta blocker and other drugs. Now, 20%, if we compare it with the ACE inhibitor trial, 20% relative risk reduction in combined primary endpoint of cardiovascular death and hospitalization, as well as in the individual component, was there with the ARNI, while with the ACE inhibitor, reduction was more pronounced in heart failure hospitalization than cardiovascular death. ARNI reduced the risk of death from any cause by 16% and improved the quality of life, and this benefit was consistent among all pre-specified group. Further to this, the Pioneer study came, and Pioneer study in which the patients who were hospitalized with heart failure, they were randomized to this ARNI and compared to the enalapril, and as we can see that after discharge, fewer patients treated with ARNI were readmitted with heart failure, and at 8 weeks compared to enalapril, and relative risk reduction was almost 44%. And this was the first evidence about the tolerability and safety of using ARNI while patient in the hospital. Similarly, the transition study. This also, the initiation of ARNI, a wide range of heart failure with reduced E of patient stabilized after acute heart failure event, either in hospital or shortly after discharge, is feasible with about half of the patient achieving target dose within the 10 weeks. Now, these 2 trials, Pioneer and Transition, if we compare with the paradigm, in both the trial, patients who were included were de novo heart failure, and they were naive for ACE inhibitors. And this was the first time we got this data. And clinical benefit and tolerability were similar or even better in terms of side effect and achieved doses. So this trial also concluded that in-hospital initiation of sacubitril valsartan should be preferred to prevent readmission in early vulnerable period after the discharge. Further to that, there was analysis by Pecker where he found that fewer patients treated with ARNI experienced worsening of heart failure episode not requiring hospitalization. Emergency department visit was reduced, and when hospitalization required, patient receiving ARNI were less likely to require intensive care, less likely to require intravenous inotropes, and need for implantation of device also reduced. Now, this protective effect was supported by, from the pathophysiological point of view, in terms of reduction in biomarker and net clinical benefit in terms of cardiovascular death and death due to the worsening heart failure. We know the natural history of heart failure. There is time when there is a remission and patient gets readmitted. More frequent hospitalization, more likely to be increase in the mortality. ARNI is the one which covers entire spectrum. It reduces the first hospitalization, it reduces the recurrent hospitalization, and it reduces the cardiovascular death. Very recently, there was a meta-analysis, as we can see, the combination drug, where the ARNI was there compared to ACE inhibitor, as we can see, all-cause mortality, cardiovascular mortality or heart failure hospitalization, and pure cardiovascular mortality, the combination of among the 4 drugs which contained ARNI had a better outcome. Further to that, cardiac remodeling. Cardiac remodeling is intrinsically related to the progression of heart failure, and remodeling is something which leads to increase in the cardiovascular morbidity and mortality. A 10% decrease in left ventricular ejection fraction is associated with 73% increased risk of death from the chronic heart failure. And if we look at the outcome of the reverse cardiac mortality, there is a significant drop in mortality. A 15% reduction in left ventricular end systolic volume index is associated with 68% decrease in the mortality. And reverse cardiac modeling is something which is key to the heart failure treatment, where the ARNI stands a better chance. Now, among all these drugs, if we look which is the ABC of reverse cardiac remodeling, it is only ARNI, beta blocker, and CRT. ACE inhibitor, ARB, and MRA, they just slow the progression of cardiac remodeling. There are many mechanisms by which ARNI helps in cardiac remodeling and ventricular dilatation, change in the shape of the ventricle, and reduction in the functional MR. There are multiple studies. Evaluative study was published 3 years ago. There was a significant reduction in left ventricular end systolic volume index, diastolic index, and left atrial index, and compared to enalapril, which was observed at 12 months. There was another study which showed that there was significant improvement in the systolic and diastolic function after 4 months of substituting ACE inhibitor or IRB for ARNI in CHF patient optimally treated. Similarly, the PRIME study, patient with symptomatic heart failure with functional mitral regurgitation, there was significant reduction in mitral regurgitation and ventricular volume without change in the blood pressure at the 12 month in the ARNI group compared to the valsartan. Prove heart failure. There is another landmark study. Patient with de novo heart failure who had not been treated earlier with ACE inhibitors or ARB, they were given the maximum dose of ARNI, and there was a significant improvement in the outcome. Similarly, in patients who were admitted with acute decompensated heart failure, there was an improvement in their GLS compared to ARNI in a significant number of patients. Because of its anti-fibrotic, anti-hypertrophic, anti-proptotic effect, ARNI definitely has a role in reverse cardiac remodeling, which ACE inhibitor do not have. As far as dose-response relationship is concerned, at various quartile of doses, the improvement with ARNI was significant compared to ACE inhibitor. ARNI has a favorable effect on glucose metabolism, so the ARNI is a choice, as we seen with the previous speaker, that ARNI is a choice in patient with diabetes mellitus. Paradigm heart failure post hoc analysis has given a clear idea that there were 29% fewer patients in ARNI group needed to start insulin or drug or other oral drug, and at 1 year follow-up there was a greater reduction in HbA1c in a ARNI group. Similarly, in patients with renal dysfunction, ARNI definitely stands a better chance. Another aspect is the arrhythmia. Whenever there is adverse remodeling, myocardial distension is there is a pro-arrhythmic substrate, and chances of sudden cardiac death increases. ARNI has several mechanisms, especially the effect on enkephalins, endorphin, and bradykinin, and reverse remodeling altogether. They suppress the sympathetic system and they reduce the sudden cardiac death. There are multiple data which says that ARNI has a significant favorable effect on reduction of sudden cardiac death. There are some of the electrocardiographic data where the ARNI was found to have a significant reduction in the QRS duration and QTC interval. Similarly, the left atrial and left ventricular dimensions were reduced. Now, there was some study where patients who were treated for, initially they were treated with the ramipril or valsartan, and they were switched to the ARNI for 9 months, and as we can see, there was significant reduction in arrhythmia.
There
have
are
to summarize,
some of
Dr.
the shorter studies, this effect on arrhythmia, as we can see with the ARNI, the VT-VF burden were dropped. These are the series of studies which has come up, and one of the studies, SAVE ICD. After 6 months of therapy with the ARNI, 1/4 of primary prevention patient with left ventricular failure and implantable ICD had a LVF of 35% or more. For every 100 patient with LVF less than 35% and no previous event for more than 6 months, treatment with ARNI could avoid an ICD implant in 25.
Dr.
Rapid
Vinod, can you
treatment
summarize?
with ARNI could prevent ICD implantation in a good number of patients with significant cost saving. Just quickly running through some of the aspect that the ARNI has come up as a compelling first drug and device therapy, first line drug and device therapy for prevention of sudden cardiac death in patients with heart failure, along with beta adrenergic cardio receptors, mineral corticoid receptor antagonist, and cardiac resynchronization therapy. Now, I'll just skip the quality of life is equal with both, rather with better with the ARNI. The side effect profile is the same between ARNI and ACE inhibitor. Cost effectiveness, it is practically the cost effectiveness, the use of ARNI associated with longer life expectancy and incremental cost effectiveness ratio than ACE inhibitors, especially when it is started in de novo patient. Now, just one concluding slide. ACE inhibitor no doubt form the bedrock of a pharmacological therapy of heart failure. The benefit of ARNI over ACE inhibitors are statistically and clinically compelling, as we have seen the data analysis of Paradigm Heart Failure trial. Neprilysin inhibitor to treat heart failure is not just a tale of science or serendipity, but it is a question of second chances. Majority of the regulatory authority and guideline committee have practically written obituary about ARNI, but if we see the ACC guideline, still the ACE inhibitor is class 1A, and when we come to the ARNI, it is class 1BR. So the benefit risk is still, it has kept to the age, it has not come into the first letter in the treatment of heart failure. Even many of the guidelines have, in sequencing the drug, they have asked for beta blocker SGLT2 to be started, followed by ARNI, and practically they have forgotten ACE inhibitor. But few of the things, quickly I'll finish up. Neprilysin is an enzyme which is ubiquitous in distribution and promiscuous in function. Accumulation of amyloid beta peptide in the brain, no doubt there were no cognitive adverse effect in the Paradigm Heart Failure trial, but we have not completed even 1 decade of data with ARNI. ACE inhibitors have decades of data, so still we need some more data. If we see that prototype drug omeprazole, which inhibit both neprilysin and ACVs, it showed dose-dependent increase in ANP, BNP level with decrease in plasma acid activity, but it was no more effective than ACV monotherapy and a higher incidence of angioedema. And similarly, current recommendation is based on the Paradigm Heart Failure trial, and this trial recruited mainly class 2 and class 3 patients. If we see the old data from the previous trial like consensus, there was in consensus trial group, there was a 30% reduction in mortality. If we look at the solved data, class 2-3 patient, there was survival benefit of 16%. There was 26% reduction in the rate of fatal myocardial infarction in enalapril group. There are wide dose range over which enalapril could be used effectively. Sickest patients benefited most from the enalapril. This was a data from the SALT. ACE inhibitor in secondary prevention, it is a well-established drug. It is independent of benefits seen in patients with reduced EF and includes not only significant mortality benefit, but also decreased rate of stroke, MI, congestive heart failure. ACE inhibitor benefit is most significant in sickest STMI patient, including patient with pump failure and reduced EF, and we save 50 lives is saved per 1,000 patient treated. Ischemic cardiomyopathy, majority of
have to summarize.
1 minute, sir. Ischemic cardiomyopathy, another subset, almost more than 60% patient of heart failure are ischemic cardiomyopathy.
There the data is much more with ACE inhibitor. Replacing ACE inhibitor with ARNI may not be very prudent. Flexibility of dose adjustment by a single agent, especially in patient with borderline blood pressure, is not available with combination of drug of ARNI. It is more relevant as we start using SGLT2 also in patient with the heart failure. So just ladies and gentlemen, to conclude, ARNI has reached closer to the so-called niche drug in management of heart failure, but it hasn't got the position of ACE inhibitor. ACE inhibitor would remain in the scene in many subset of the patient. We need more data with ARNI, especially in terms of its effect on ANP, BNP and its neurological effect over a period of time. So my view is very clear, ACE inhibitors cannot be written off totally. Thank you.
Thank you, Hazar. I think it's already quite late. We'll close the session and the questions may be discussed during the lunch break.
Thank you, moderators, for keeping up the time. And thank you, panelists, for highlighting the different approaches of heart failure treatment. Moving on to our next section on current and future session, may I take this opportunity to welcome Dr. Bahirath, Dr. BKS Shastri, and Dr. Prakash Jain to chair the session. May I request the moderators to start the procedure. I request the speakers and the moderators to stick on to the time, please. General announcement, I request the delegates to keep their mobile phones on silent mode during the session.
Morning, everyone. Without wasting much time, let's get into the pre-lunch power pack session. The first talk, PA pressure monitoring after champion and guide HF. Can we have Dr. Krishna Mohan, please, for the first talk?
Good morning. First of all, I would like to thank the organizers for the opportunity. So, no disclosures related to this particular topic. Just wanted to paint a picture what I'm going to talk about. So we all know the mortality in heart failure is still very high. Is there any other things we can do apart from the drugs which we've been hearing about? And mostly in diastolic heart failure or heart failure with preserved ejection fraction. Survival of the heart failure is still about 50% in 5 years, 10% at 10 years. And the rehospitalization is actually very high at 30% in 1 month, 50% in 6 months in a patients who are admitted. So we need to look for an accurate measure or a monitoring which can actually potentially reduce the hospitalizations and then related complications in this group of patients. So far, majority of us will depend on the clinical signs like weight gain or edema or nocturnal cough, all these things as a sign of worsening heart failure. But we all understand that these have very limited impact on hospitalizations of the heart failure patients. So in search of more sophisticated technique, so invasive hemodynamic monitoring has been proposed. And so this particular slide, we will see that the pressure changes actually occur in majority of the patients almost 4 weeks before the actual index hospitalization event. So if we are able to manage to catch this particular time where, so if we look at the stage where a filling pressure starts increasing or a pre-symptomatic congestion phase, we will be actually saving a lot of trouble to the patient, and economically also we can avoid the hospitalization and related costs. So how are we going to measure these pressures? The historical thing, and we all know, and majority of the hospitals do in a patient who is in the hospital by Swan-Ganz catheter, but this cannot be a long-term thing. So the invasive hemodynamic monitoring has been done for the last 15, 16 years by using the implantable devices. And then some of the devices are the Cardila, Chronicle, which is Medtronic, and CardioMEMS, which is St. Jude's now Abbott. So this idea came from the trials or trials or sub-studies of the device patients, wherein they have noticed, so if you actually look at the intrathoracic impedance in device patients, you could actually make very quick clinical decision so that you can reduce the relative risk of death at 5 years. And these are the trials done by the Medtronic, Boston, and Biotronic, and these all have actually robust data with a lot of patient population. But these are all only sub-studies or just observational things. So parallelly from 2006, there were several invasive hemodynamic monitoring studies have been done. One of them was COMPASS HF, Reduce HF, Homeostasis, Escape, Champion, and Guide HF. So the Guide HF is the latest one, and most of them are done in between 2006 and 2010. So the COMPASS HF was a prospective multicenter randomized trial where there was a small number of patients, it's 274, NYH 3 or 4 patients. These patients were implanted with a chronicle device, which is almost like a pacemaker, but you are actually sensing the pressures inside the heart. So this study, unfortunately, did not show any clinically significant reduction in heart failure events nor in the hospitalization. So then ESCAPE was a trial where invasive hemodynamic monitoring was done as a snapshot. That means not a continuous one, but they have taken intermittently. And this actually again shown that taking a snapshot actually is not going to improve your hospitalization or primary events. So they actually proposed a longer monitoring of the PA pressures. The Champion trial is the largest group which is done in the past. This trial started in 2008, presented in 2010 in a European Society of Heart Failure. These patients had implantable hemodynamic monitors, but the number of the patients were still too small, and because of that, they have used a lot of patients with the heart failure with preserved ejection fraction as well. So the device which they have used is called CardioMEMS, which is a PS sensor. It's about 3 millimeters thickness and about a centimeter long, and this is inserted into the pulmonary arteries, and this can be retrieved at a later data. And these patients, they can have their data sent from the comfort of their own homes. So they have looked at 550 patients with the CardioMEMS implants, and these patients, 270 patients, they were managed based on the pressure changes, whereas the other group of patients, the data was collected, but this data was not given to the clinicians. So they looked at the data at the 6 months, and then after that, all the patients' data was given to the clinicians, and then they looked at what can be done, and they all managed in the similar fashion. So the primary endpoint for this trial was actually rate of hospitalization, and then secondary endpoints are change in the PA pressure at 6 months, number of patients admitted to the hospital for heart failure, days alive outside the hospital, and the quality of life. And all these patients were treated to a targeted pressure of CS systolic, PS systolic of 15 to 35, diastolic of 8 to 20, and a mean of 10 to 25. If you look at it, the patients who have had monitored, their pressures have obviously been down because all these patients, clinicians had the benefit of monitoring the pressure, and they could target the treatment based on the patient's pressures, so they could actually manage the proper one. Then when they looked at the hospitalization, which was the primary endpoint, you could see the benefit started even well before 6 months. By the 6 months, they had a very significant 28% relative risk reduction in the hospitalization, and after 6 months, the benefit actually continued, and the curve started separating, and they became wider and wider. The safety endpoints were met in both the control and treatment group, and there were no adverse events in this group of patients. And based on the hemodynamic monitoring, the medication change was obviously more in the study group with the about one medication, one drug per month change in the patient management. And if you look at this champion clinical trial data, the number needed to treat to avoid one heart failure admission was only 4, and there is a comparative study. You can look at the drug trials and all. And the second trial which was used was the Guide HF. Guide HF was started before the COVID, and this actually started as a sub-study in a group of patients where they just wanted to look at the reduction in the heart failure based on the previous data collected from the champion. It's again from the Abbott. There were 2 types of study in this one, a randomized control trial with a treatment and control arm, and there was a second sub-study with a single arm study with treatment only group of patients. And both the groups, patients were treated based on the PA pressure. If you look at it, with the benefit of hemodynamic monitoring, they were also looking at the pressures going up in the control arm. The pressures start going up in all group of patients with the heart failure with the reduced ejection fraction, heart failure with the mid-range ejection fraction, and heart failure with the preserved ejection fraction. Almost similarly, everybody's pressure started rising, and up to one day before, and then with the treatment, everybody's pressure has come down. This is the basis of this one. And then the Guide HF, it is shown a benefit in almost every group, but only significant benefit in patients with the heart failure with the preserved ejection fraction. Both the primary outcome, which is all-cause mortality, heart failure hospitalization, and urgent heart failure visit, but the heart failure hospitalizations were significantly more. However, the primary endpoint was not met in the Guide HF trial, whereas if you look at the overall heart failure hospitalization in the cohort, there was significant improvement. So this is the summary slide. So the champion summary, basically the clinical stability was better maintained in patients with ejection fraction of more than 40%, and hemodynamic guided heart failure management resulting in the lower hospitalizations. In the Guide HF, hemodynamic guided heart failure management across all spectrums of patients was safe, but did not reduce the composite of the mortality and the heart failure events. And the COVID-19 unfortunately has impacted the outcome of the trial because they could not get to the numbers which they needed. And the pre-COVID impact indicated the trend towards benefit of hemodynamic guided heart failure management on the primary outcome. And however, this is largely driven by the lower heart failure hospitalization rate compared to the control group. To sum up, changes in the pulmonary artery pressure measurements are an early indicator of worsening heart failure. Adjustments to changes in the medication and lifestyle can actually improve the patient's condition and can reduce the heart failure hospitalizations. Other signs of worsening heart failure can appear too late, as we have seen throughout the studies, and which is why a pulmonary artery pressure monitoring can be a beneficial treatment option. However, it shows promise in early detection of clinical decompensation. Perhaps we may have to adapt the invasive hemodynamic monitoring, but trials on a large scale are still pending. Once we get that, I think we'll get more information. Thank you for your attention.
Thanks, Dr. Krishnamohan. I think now this will be standard of care soon. The only thing is CardioMEMS, as of last arrival, when they came to our hospital, we found out it cost 20 lakh rupees. And I think it's out of budget. Admission is probably cheaper than CardioMEMS. Right. And again, the other thing is that there are other ways in which, just for the benefit of the house, other ways in which you can monitor lung impedance to measure early pulmonary edema. We now have this Merlin system of St. Jude. So as standard of care, the ICD and CRT, we have this Merlin system incorporated so that lung impedance is measured and day to day you can advise these patients. So the good news is that not only hypervolemia, hypovolemia also. Sometimes the patient may be over diuresed.
Correct.
And we can down titrate the dose of medicine. So I think this exciting, a new area in the management of heart failure, home monitoring, and combine that with artificial intelligence and a smartphone analysis. And I think we've gone way ahead in our management.
Abbott is the one which is now got the Bluetooth technology, wherein like the care links and other things where you need an additional device. The phone can send all the information through to the patients from the clinicians. Yes.
We get alerts from the patient.
Yes.
So you want to say something? Any questions from the house?
This was purely hemodynamic monitoring. Of course, when the patient actually had any changes, when the clinicians called them for their clinic advice, I think other things were also measured, but this was not taken as a part of the trials.
A handheld device costing less than 2,000, a lot of people have developed already. And of course, if there was no PNDT issue, just put it and find out.
Yes, that is the problem. So this country has draconian PNDT, PCPNDT, so you're not allowed to carry any handheld ultrasound. That sound is actually a criminal if you don't have a license, and it has to be stuck to one place. So you cannot carry it around, unfortunately.
What about the rest of the country? I'm just saying the rest of the world. I mean, if you have, let us say, available for $1,000.
But manpower, we have manpower.
No manpower, the self-monitoring. You just monitor yourself, look for B lungs, change your diuretics accordingly. You just have to look at those vertical lines. It's as simple as that. That could avoid all that critically expensive stuff, actually.
Yeah, I know, but look, if you look at the ultrasound or anything to do with ultrasound, it's all human dependent. So if you don't have a person who is not well trained, you can miss. It can take time, and then obviously there are other logistical issues. So you have to undress the patient, you have to carry your gels, you have to clean up all those things. It will take a bit of time. But as you said, CardioMEMS is not available in India yet. It's absolutely not available because still there is no conclusive evidence. So this actually shows trend towards the collection of the patients much earlier and correcting their issues, but we don't have a robust data.
Mohan sir, if I may add, we went through this in our hospital to check lung ultrasound. And we found out that it picks up the horizontal waves fairly late, sir. Maybe we need more expertise in interpretation of this. So by the time we see these lines, already patient is symptomatic. The whole idea was to catch them 20 days earlier.
4 weeks earlier.
Not at rest and not while they are lying down. Yes. But the guy is walking around and he's using phone through the. You can hold like this. Yes. And really, certainly not at rest, because that will have a very low sensitivity.
Yes.
I am talking about regular
ambulatory
effort.
Patients.
Yeah, that's the point actually.
Maybe, sir. But again, as he rightly pointed out, licensing has become a big issue. The PNDT Act. One device is licensed to one person only. Now,
one person and one place.
One place. So we can't take it and move around to other places. It's very strict now as per the new guidelines.
There might be available, maybe what we have, external loop recorder. There might be some sensor which can have lung impedance measurements also as an external implantation rather than the internal implantation.
Yeah, as you pointed out rightly, the devices now, whoever has got the devices which are capable of picking up impedance, they've been there for the last 20 years nearly. So that probably is the first place. We can try our own patients with the correcting the impedance data. That probably is the first step.
So loudly thinking, as we have now non-invasive glucose monitoring through a patch.
Yes.
Can we have anti-proBNP monitoring through a patch? I put it on my arm, and of course I'm walking around, it tells me in 24 hours, this is my anti-proBNP, I should change my diuretic dose.
Honest answer, I don't know. I don't think anybody knows. So probably we don't know is the correct answer.
Thanks, Dr. Krishnamon. In the interest of time, we'll move to the next lecture. Gene silencing to treat heart failure. Dr. Sajan Ahmad. Welcome, Sajan.
Respected chairpersons, dear teachers, seniors and friends, thanks to Abraham sir and team Hfai. Chennai was where I was born, so it's good to be back in Chennai. I think any session on heart failure and the future therapy should mandatorily include gene-based therapy, and so we'll look at gene silencing and try to see if it has moved from being usual DM cardiology theory exam question to what can be useful in clinical practice. If we look at heart failure and cancer, we all know that despite all the advances in management and all the molecules that we discussed, heart failure remains as malignant as some of the common cancers. This brings to fore two lines of thought. One, of course, highlight and probably even disruptive technologies in therapy. On the other hand, it also proclaims the unprecedented improvement in cancer survival, which has been aided by translational research and the early adoption of newer and revolutionary targeted therapies in routine clinical practice, which has really made a change. In a side story, we know that the discovery of the PCSK9 gene and the identification that loss of function mutation of PCSK9 leads to low LDL led to pharmacological reproduction of this favorable phenotype with the use of the PCSK9 inhibitors. And the next obvious step was to try to genetically reproduce this favorable phenotype, and it was successful with inclisiran, the silencing RNA against PCSK9. So from science fiction, it has come to reality. If we trace the evolution of cardiovascular drug therapy, we cardiologists are always happy to block and inhibit receptors and molecules and proteins and so on and so forth. And now we have moved on to monoclonal antibodies and gene silencing and RNA silencing, but have we reached anywhere in heart failure? The Fourier transform we used to learn in physics splits a function into its constituents. And if we really look at the fundamental thing that makes a living being living is the gene expression. And this is classically described by the central dogma by the great Crick himself in his unpublished report, from DNA to RNA through transcription and from RNA to protein through translation. So gene therapy essentially looks at changing a gene, putting in a new gene in a defective gene's place by the use of cardiotropic vectors. And in the current landscape of heart failure gene therapy, there are exciting potential targets for gene therapy, most of which include the excitation contraction coupling, of which the two most commonly targeted molecules are the SERCA2A, the sarcoplasmic endoplasmic reticulum calcium ATPase, and phospholamban. The CUPID-2 trial was actually the largest gene transfer study done, but unfortunately the results were abysmally negative, and this was tried in heart failure with reduced ejection fraction, so much so that another trial, the agent HF, which was started, was prematurely withdrawn because the funding was withdrawn because of the failure of the previous trial. So with regards to the conventional gene therapy, we have miles to go before we can reap the benefits, and the only positive thing being lack of safety concerns. So this calls for an entirely new strategic change, which brings us to the silencing therapy, which is RNA interference therapy, which is different from classical gene therapy in that it is post-transcriptional gene silencing. That is, it blocks the protein synthesis by the mRNA after the mRNA has actually been formed. And this is done with the use of non-coding RNA agents, including synthetic RNAs and recombinant RNAs. As organisms evolved from being simple organisms to highly complex organisms, newer molecules began to form in our bodies. And now in humans, 99% of the total human genome is composed of non-coding genomes and actually not coding for any useful protein. But that doesn't mean that these molecules are useless. They serve very important purposes. Now there are more than 1,400 separate microRNA genes in human beings. Regulatory RNAs have now been found to be extremely important in heart failure, and they belong to a larger group of RNA family. We know that messenger RNAs or the protein coding RNAs, but there are also non-coding RNAs or non-protein coding RNAs, which can be either regulatory RNAs or housekeeping RNAs. Our area of interest in the silencing RNA belongs to the regulatory non-coding RNA, which are actually small fragments of RNAs. So they regulate gene expression by transcriptional regulation, chromatin modification, translational regulation, and by affecting the signaling, and act at different sites of the cardiomyocyte, including hypertrophy, inflammation, regeneration, and vascular health. In hypertrophy, it can even affect the expression of BNP and ANP levels and sarcomere assembly. In inflammation, the major areas are NF-κ-beta, immunity, and interleukin and TNF expression. In cardiac regeneration, they have important roles in apoptosis and cell cycle reentry. In the vascular system, they have effect on the endothelin-1 expression. Both the small interfering RNA and the microRNA are non-coding RNAs with important roles in gene regulation, and they target the mRNA. The difference is that in the silencing RNA, they are very specific and they have only one target in the mRNA, while in the microRNA, they can be non-specific because they can bind to different parts of the RNA. So in silencing RNA, it is fully complementary, and so it is very specific, while in microRNA, it is not specific. Two interesting terms are DROSHA and DICER. These are actually ribonucleases which help in the synthesis of microRNAs in the nucleus and in the cytoplasm respectively. So this is probably like something like the tagline of Tenet, but basically the mechanism is that we introduce synthetic mature double-stranded silencing RNA, which contains a passenger strand and an antisense strand. It is delivered to the cell by nanocarriers. It escapes from the endosome. It is introduced into something called the RNA-induced silencing complex, which contains a protein called Argonaute. So this leads to activation of the RISC or the silencing complex, and the Argonaute mediates the cleavage of the mRNA and prevents protein synthesis, and this cleaved mRNA is degraded by enzymes. So this is what happens inside the cell. So essentially what happens is we have a delivery system, we give silencing RNA, it binds to the Argonaute protein, there is a silencing complex which is formed, which cleaves the mRNA and prevents protein synthesis. So this is how it will look like. So there are various drug delivery systems which have been used, including lipid-based nanocarriers and drug conjugates, and they have to be optimally designed based on the target that we are trying to achieve. And it should also prevent off-target effects and prevent activation of the immune system. These are some of the challenges. And various chemical modifications are also used for these silencing RNAs. Cardiovascular indications form a very small percentage of the current indications, and as early as in 2009, the phospholamban was targeted in mice models, and it was found that it brought down hypertrophy and heart failure. The NF-κ-beta was also studied in mice model, and it led to regression of hypertrophy. The Hfai has actually come out with a position paper in 2022 on such therapies, and silencing RNAs are included under the oligonucleotide therapies. Hypercholesterolemia and TTR-mediated amyloidosis are the currently approved indications, and we had a session on amyloidosis in the morning. So we know that toxic TTR oligomers impair cardiac structure and function, and two major agents, patisiran and vutrisiran, are now available. Patisiran has been studied in the Apollo study. It inhibits the TTR synthesis, and it is given as IV infusion every 3 weeks for 1.5 years, and it brought down the wall thickness and improved cardiovascular outcomes. Similarly, the vutrisiran is being tried in Helios. It is given subcutaneously once every 3 months. RNA interference or silencing can be used as useful adjuncts in other modes of therapy like heart transplantation, where you can actually inhibit the alloimmune rejection process and improve the tolerance by the transplanted cells, and also in stem cell therapy to improve the efficacy of the stem cells. Now we know that the reactivation of the fetal gene expression happens in the adult failing heart, and this can also be suppressed by post-transcriptional modulation by the microRNAs. Another interesting area is gene editing with a base of CRISPR, that is clustered, regularly interspersed short palindromic repeats. The epigenome, which is actually chemical modification to the DNA and histone proteins, is also being tried to manage heart failure. And finally, telomeres have been found to be useful, and telomere shortening has been linked to aging and many of the processes associated with heart failure. So in a nutshell, we have seen how cardiovascular therapy has evolved and how gene therapy has found challenges, and regulatory RNA by silencing, epigenetics, telomere modification, and the use of drugs in amyloidosis. These revolutionary technologies have already received Nobel Prizes, Dr. Craig Mello and Andrew Fire for RNA silencing, and Emmanuel Charpentier and Jennifer Doudna for the CRISPR. And now it has moved on to various other realms of routine life, as in they have brought out genetically engineered potato by silencing many of the genes, and more CRISPR meat by gene edited meat, and also RNA silencing based pesticides. So hopefully in the near future, probably in our lifetime, we may have some useful therapy for heart failure. Thank you so much. And I have absolutely no clinical experience with these molecules.
Congratulations, Sajan. That was a wonderful talk, very nicely covered in the given time.
Thank you, sir.
Circa, we have data about that. Phospholamban, that's the way the CardioMEMS device works. So this again, these are two promising areas.
Yes, sir.
CRISPR, I think Dr. Abraham Omen already mentioned its role in amyloidosis. So
Correct.
I think these are exciting new developments on the horizon. Of course, RNA is an entire big gamut, and I think a lot of work is being done. We have some tiny experience working with Biocon, wherein we worked with the Circa model. However, I think we have a long way to go before it can translate into human clinical trials. Sir, you want to say something?
I think the thing is, RNA-based therapy looks more promising than the gene and the DNA-based therapies, because the molecules are considered to be more stable and more efficient, and longer-lasting effects are produced. So hopefully,
Hazra sir, you have some.
Yeah, it's a fascinating talk. Gene editing works for life. There is cholesterol. But why your gene silencing works for only 3 months or 6 months, like inclisiran gene silencing works for only few months.
Yes.
It regains its potential of protein synthesis. There are two therapies which can change the gene device therapy. One is CCM technology, cardiac modulations. It can change on, if you keep on pacing on the QRS, after the QRS, it can change your gene. And second, there are 30 cases from Austria presented in TCT 2022. What they have done, they have put a shockwave, like a large shockwave device on the heart during CABG, post-CABG, and it applied for 30 minutes, one shock therapy, then they close the chest. And they have shown that improves ejection fraction by 20% by changing their genetic. So my question is it always you need a carrier or electrical stimulations, mechanical stimulations, or it can be a mutually additive sometimes?
Absolutely, sir. This is new information to me. I think it is going to be additive, because it is not purely the genomics that determine the morphology. There are various environmental modifications that can happen. So such stimuli may actually add to whatever change. The only problem is how to specifically target the cardiomyocyte without producing effects on the other cells. So that is one of the challenges.
Thank you, Mr.
Thank you. Thank you, sir.
Dr. Sajid Ahmed. We'll invite Dr. K. Kannan. He will talk about metabolic modulation in heart failure. Welcome, Dr. Kannan.
Good afternoon, everybody. At the outset, I thank Dr. Abraham Omen and the entire team for the opportunity to present on metabolic modulation in heart failure. This will be the structure of my talk, because this mainly deals with metabolism and how it alters in the healthy heart, and how the challenges in a diseased heart. And how that metabolic modulation, in addition to the metabolic changes, translates into cellular changes, and which may have a favorable effect by modulating that in heart failure, and how it works in therapeutics. And then we just have some brief conclusion. So you look at the cardiac metabolism. See, normally the healthy heart, see, this is what you see in the yellow is the mitochondria, and what you see in the blue is the cytosol. So the heart has got multiple sources of fuel in the form of free fatty acids, glucose, lactate, and ketones, and it adapts to the situation according to what it has at that point of time and what is the clinical situation in which it functions. And basically, most of the energy generation occurs at the mitochondria, and all the ATP formation mostly is formed there. So what is more important is, there are a lot of challenges is day and night, activity and rest and everything. A healthy heart should maintain a stable hemostasis. So normally in a resting condition, the fatty acids constitute the major source of fuel. About 80% is at rest. And the pyruvate, it goes through the oxidation of free fatty acids, and pyruvate oxidation contributes to the rest. It has got a huge reserve of oxidative metabolism too, because now it utilizes only 20%. And even in the exercise, there's a shift from the free fatty acids to glucose and lactate, whereas the FFA fuel, it remains mostly unchanged. So it can utilize the fatty acids, glucose, amino acids, and ketone bodies. All can be used as fuel depending on the situation. But preferentially fatty acids are used due to its efficiency, because one molecule of palmitic yields a net gain of 29 ATP, but it consumes 31 molecules of oxygen, whereas one molecule of glucose yields 38 ATP and consumes 6 molecules of oxygen. So when this oxygen is sufficiently available, then the balance is towards fatty acids as a source of fuel. And ketone bodies are used in only special situations, like in fasting situation and some patients with diabetes. So when the metabolic demand requirement exceeds the metabolic reserve, then the aerobic limits are breached. So it has got a very good potential for ATP hydrolysis. 20 times its mass is its capacity, but the only thing is the reserve is very small. So it has to be replenished fast. And 95% of the ATP that the heart generates is from the mitochondrial oxidative phosphorylation, and only 5% from glycolysis and the Lester cycle, because the mitochondria is a very vital component in ATP generation, and majority of it is used for the contractile proteins, but 30 to 40% is used to activate the ion pumps, especially the calcium ATPase pump and the sodium calcium exchanger pump. So the energy formation mostly from the mitochondria, utilization in contractile proteins, and as well as the two major pumps. So if you compare between glucose and free fatty acid metabolism, FFA produces more ATP but consumes 12% more amount of oxygen to produce a similar molecule of ATP. So that means in a person who is deprived of oxygen, then free fatty acids are sometimes disadvantages. So when oxygen is abundant, the free fatty acid metabolism is efficient. But during ischemia and heart failure, glucose appears to better myocardial substrate because of the deficiency of oxygen. So when you look at a holistic approach, heart failure is a multi-organ disorder with metabolic failure is a basic mechanism. That is one way of looking at it, because it's an engine out of fuel. You don't have the fuel because and it's very important to remember the metabolic derangements in heart failure is not limited to the myocardium, but extends to skeletal muscle. So that's why many patients with heart failure have muscle fatigues and pains and aches, which can contribute also to the symptomatology of heart failure. So the basic concept starts with the mitochondria, as discussed, where the generation is reduced, but both the oxidation of both glucose and fatty acids are reduced during heart failure, but the circulating levels of these are still high. One interesting concept is uncoupling of glycolysis from glucose oxidation leads to accumulation of lactates and protons, which adversely affect the heart failure. So when you have the heart failure, it is better the aim is to convert into a glucose metabolism compared to a free fatty acid metabolism, because free fatty acids is injurious to the cardiac muscle. It reduces arrhythmias and requires more oxygen for ATP production. It also increases the oxygen demand, and byproducts of free fatty acid metabolism cause damage by itself. Uncoupling of proteins is produced, and ATP production is less and is more wasted on non-contractile work, and ROS is also generated. So the aim of any modulation of heart failure therapy in a patient with seems to convert from the free fatty acid to oxygen metabolism, which can be slightly more useful in preserving the oxygen. So whenever the heart comes to heart failure, there are three major changes it undergoes. The substrate uptake selection is one thing which changes, oxidative phosphorylation changes, and energy shuttling that cases. Autopsy studies of hearts have shown that failing hearts have 25% less ATP. So metabolic change from predominantly metal-basing fatty acid to glucose is beneficial, but it is compensatory up to a point. But what happens is, once it reaches a particular point, insulin sensitivity comes down and there's a metabolic flexibility which the heart, normal heart, healthy heart enjoys is lost. So there's also the contribution of the decrease in fatty acid oxidation. It also suppresses of PPAR, which impedes fatty acid oxidation to myocardia. So that way, it may be useful to suppress the fatty acid oxidation. So because of increased lipolysis rates, the fatty acids circulating fatty acids were also increased. So despite the switch from to the carbohydrate metabolism, the failing heart still is deficient because the pyruvate oxidation is changed. Instead of being transported to mitochondria, pyruvate remains in the cytosol and reduced to lactate, which contributes to the cellular damage which happens in heart failure. And also it changes the mitochondria of the failing hearts. And this is the thing which you can see that the pyruvate, which is because of it's converted to lactate and goes to other pathways, and it also contributes to it doesn't really give the benefit that it desires to have. So all this leads to cell acidosis, myocardial damage, contractile dysfunction, calcium overload, and oxygen wastage. And because of the unfavorable effects of the pyruvate, the effects that we desired are not reached by just switching over from the fatty acid to carbohydrate. You don't get a full compensation. So in the late stage of heart failure, the glucose uptake, once the insulin resistance sets in, the glucose uptake decreases. And this induces PPR activation, but excessive PPR activation also results in contractile dysfunction. So this also can be detrimental and the contribution due to insulin insensitivity. So in that situation, ketone bodies and branch amino acids become more relevant. So because of the situation which we run, ketone bodies provide a more efficient ATP to oxygen ratio. But really, is it really useful is another question mark. Basically, a flexible heart becomes an inflexible heart during this. So in addition to ATP, the metabolic pathways involves changes in non-ATP generating cellular process also gets activated. So these modulating cardiac metabolism can also reduce these processes and improve cardiac function beyond ATP production. So what is the link between the metabolic and the mechanical has not been fully understood. It's a simplified overview in healthy heart. The metabolism, mostly there's a generation of ATP leading to contractile function. But once the heart failure sets in, the amount of ATP comes down and the other pathways become more activated. With ROS gets involved, cell growth gets involved, autophagy gets involved. So there is a reduction in the ATP and the other pathways become activated. So when these therapeutic changes which are doing in metabolic modulation, it also affect the cellular structure because the metabolic changes induce cellular changes like mitochondrial crystal comes down, cellular size comes down, myofibril content comes down, and actin-myosin coupling is interfered. Therefore, whenever you treat cardiac remodeling of the metabolism, it affects both the skeletal as well as cardiac vessels, and it may really help in the treatment of heart failure. So if you see the slide on the right side, there's a metabolic modeling, how it translates to structural remodeling. You can see that the fatty acids are used lesser, glucose is used more, but beyond a point of time, there's an increase in oxygen radicals, ATP depletion, inflammation, hypertrophy. The transition occurs from the right to left. The structural remodeling happens, which can be detrimental in heart failure. So the objective of the metabolic remodeling is to prevent them going to structural remodeling and delay it by therapeutic interventions. So the benefits are due to the shift energy from fatty acid to carbohydrate, which leads to increased production of high energy phosphates. And if sparing of fatty acid inhibition, it improves the functional capacity and muscular strength in patients with heart failure, an effect that goes beyond the modulation of cardiac metabolism because the effects on the skeletal muscle parallel that in the cardiac muscle. And they have also shown that inhibition of free fatty acid improves the functional class, exercise tolerance, quality of life, left ventricular ejection fractions, and cardiac volumes in patients both with ischemic and non-ischemic heart failure. So these are the therapeutic options available in heart failure. Though even the commonly used like ACE inhibitors, ARBs, ARNIs, beta blockers, they also have a metabolic mechanism for their action. As you can see that AC and ARB act the PTK4 expression, whereas the ARNI acts the GLP-1 pathway. So these three drugs in the last, mostly the experimental stage, trimetazidine, MCD inhibitors, and fibrates, these are newer drugs which we are looking at for treatment of metabolic modulation of heart failure. There are a lot of therapeutic targets for heart failure at different levels. We start with CPT1 or thiolase, PDH, PDK4. What is common? Only two drugs which are commonly now used are both trimetazidine and ranolazine. And this acts by shifting the metabolism to carbohydrates. So we have the site of these are the very common things which are been exciting now. That is MCD inhibitors, paraxylin, and trimetazidine. But because of the side effects, and more studies are needed to see where we are progressing in this direction. So trimetazidine is the one thing which is available to us, which is the commonly available, which shifts from FFA metabolism to glucose metabolism with favorable hemodynamics. So whenever we treat heart failure, we have been looking at beta blockers, we are looking at ACE inhibitors, aldosterone antagonists. All this relieve wall stress and afterload. But the energy demand is one thing which we are looking at, and that direction, till we don't have a real clear picture. So it's a disease of varied presentation and symptoms, heart failure. The 4-pillar approach has greatly contributed to reducing cardiac morbidity and mortality, but it has not achieved the entire objective in the treatment of heart failure. Shifting from fatty acid to glucose metabolism adversity can be helpful and offers an exciting option. The metabolic modulation approach to heart failure and in the identification of the crucial link between the metabolic and mechanical can revolutionize heart failure management. Thank you.
Thank you, Dr. Kannan. Very elaborate metabolic modulations for the heart failure has been explained. Yeah, we were having earlier also, we were taught that glucose, insulin, potassium infusions also most of the time in acute MI situations wherein you can have metabolic modulations and remodeling of the heart. What's your uptake about this now in this scenario?
So we are looking at we are looking at cellular level. We are looking at actually shifting the metabolism from fatty acids to carbohydrate. When you're using inotropes, when you're using dopamine, we are actually depleting the ATP. That is where we are having more incidents of complications and arrhythmias. Now we are looking at shifting the metabolism to glucose. So because it can be useful because at least you save some oxygen and the aerobic threshold can be prolonged. That is the objective. But till now, all the experimental drugs, they have not given conclusive evidence. And the link between the mechanical and the metabolic, that is what is still not fully defined.
Good. Thanks, Dr. Kannan. We'll move on. So, may I invite now Dr. Uday Jadhav to give his talk on are there pillars of GDMT in heart failure with preserved ejection fraction? Uday sir, over to you.
Thank you, Bhagirath. So, let me at the outset say this, that Dr. Abraham asked me if I can speak for 1 minute less. So the first 2 slides are important. I just rotated them, so we have the answers. I think this is important as Professor Dr. J.C. Mohan will come up with the echo findings in the afternoon with HFpEF. This forms the clinical profile. And I guess this is very important to look at. That these are the sort of patients that you are going to see in clinical practice. If we look at that history, the obesity, those hypertensive patients at times not being in sinus rhythm, mainly elderly. Now, it may all look very naive, but it's extremely important because this is my concluding slide, which I've put first in case you want to skip the whole lecture. That the complex pathophysiology of heart failure with a HFpEF is both a diagnostic and therapeutic challenge as on now, as on today's date. RAS and SGLT2 inhibitors have emerged as promising drug therapies. SGLT2 inhibitors now established drug therapies for reducing primarily the hospitalizations in heart failure. Now, mind you, no medication to date have reduced the CV or all-cause mortality in HfpEF. It's not changed, except probably the early days of beta blockers. We'll talk about it. The under-recognized interventions which can simply improve the prognosis is restriction of calories and exercise. And finally, as the LVEF goes up and you say, look, their LVEF is normal, are these HfpEF? The contribution of the non-cardiac and non-heart failure events to the death or hospitalization will increase. Those are the comorbidities that you need to manage in today's state. And if you undermine these two importance and look at only drugs, that may not make a great impact as on today's date, except the SGLT2 inhibitors. So here are the biomarkers in HfpEF and in Hfref. So these are in acutely decompensated patients, and you can see in Hfref and HfpEF almost on a same behavioral pattern. So if you are going to target the biomarkers by going by clinical trials, then it remains rested at the level of the drugs. That's good to take forward. But that may not necessarily translate into clinical benefits, right? We have seen that with ACE inhibitors, we've seen that with valsartan, sacubitril, valsartan a little here and there, beta blockers, and so on. So it's all started with beta blockers. Now, do beta blockers really have a data in HfpEF? The early two trials were seniors with nebivolol, and then we had the JDHF trial, and these two clinical studies were not really aimed at targeting HfpEF. It was only on the sidebar that these two drugs were looked at, and up to a EF of 37%, let's talk of seniors, it was beneficial. As it reached a higher level and crossed beyond 50, actually there were no benefits, there were harms. So what does this all tell us? That in a sinus rhythm and in a heart failure with atrial fibrillation, the situation is a little different. And there has been, in fact, a feeling that if you withdraw beta blocker in HfpEF, you may actually get better benefits at times. There's a recent evidence that came up. Okay, now all those other trials. It started with iPreserve, right? We had irbesartan, and then we had CHARM, preserved with valsartan, and then we had PEP-CHF and TopCat, and really nothing changed. So amongst the three pillars, beta blockers haven't proved their worth as on now, but it's an interesting drug to study because it's not as well studied, in my opinion, for HfpEF segment. ACE inhibitors and ARFs, mind you, did make one difference. The all-cause mortality did reduce. Now, is this important? Probably if you look at the phenotype of HfpEF, that should have a relevance there, because we need not always singularly target a cardiovascular mortality. You must look at all-cause mortality in these patients because they do have all those more all-cause mortality parameters. TopCat was with the third pillar, spironolactone with and the eplerenone. So this is with spironolactone, and you can see there was no statistically significant difference in morbidity and mortality. But then this trial was a little here and there. In US and Canada, they did find a difference. In the state of Russia and Georgia, nothing. Probably because the placebo events were much higher in those countries in the Russian continent. And also those patients had more hospitalizations over the last 12 months as compared to what you saw in the United States and Argentina. So I think there is a little hope there. You have SPIRIT HF trial, and now you have finerenone, so you have the ART-HF trial. So you can look at, probably they may make some level of difference, but we need to wait and see. Interesting was sacubitril valsartan. It just skipped the p-value, a 13% relative risk reduction at 0.06. And there were places where it turned out to have a benefit. But the 2-3 important points that came up, one was this: the quality of life certainly improved. So that's one. The composite renal endpoint did improve. So that's the second take-home message from that clinical trial, that you have a lesser decline of the eGFR and you see more nephrologists using this drug. And it looked like, and that's how Novartis submitted the second NDA saying, a new NDA saying that in patients who have absolutely normal EF, sacubitril valsartan may not make a difference. And in patients less than 45% were grossly in a overt cardiac failure with reduced CF and clinically seen, it does make a difference. But between that little arm of 45 and 57, there are subsets where it can make a difference, let's say women. So there is a trial that's coming up that is looking specifically at two things: this set of patients and in acute decompensated heart failures in patients who had preserved ejection fraction. And these two trials will tell us what is going to happen over a period of time. All right. There have been changes in the NT-proBNP safety and tolerability. So I just mentioned about this clinical trial. What about in the last couple of minutes on SGLT2 inhibitors? And you have data now with Deliver and with empagliflozin, and we'll talk about it. But interestingly, it was the SGLT1 plus 2 inhibition with sotagliflozin that made a difference. So these are these 739 patients with HfpEF, and you can see a significant difference. And when you put all the EFs together, including the EF more than 50%, the scored and soloist still gave us one message, that urgent heart failure visits, hospitalizations for heart failure, total CV deaths all did improve. Emperor Preserve, of course, set the whole standards of care in HfpEF by saying that there is a relative risk reduction of 21% in the incidence of primary outcome. But mind you, as is true with all SGLT2 inhibitors, it's all driven more by heart failure hospitalizations than a reduction in the rate of the CV death. But then it gave a huge impact in terms of decline in the eGFR. So the renal protection in patients with HfpEF is an important consideration, and that's where SGLT2 inhibitors are going to make a difference. Now, above a percentile of 60 EF, if you are strictly going to talk of LVEF, there has not been a great data with empagliflozin in that subset. That brings us back, as I finish Deliver, I'll talk to you about it in a minute, by Scott Solomon. So these are again patients more than 40 years old with a EF more than 40, and look at the difference. The primary endpoint, 18%, significant relative risk reduction, number needed to treat was 32, and it did not matter whether LVEF was less than 60 or more than 60. Now that's heartening. That if you look at the p-values and then look at clinical practice, if you see a patient who is breathless, short of breath, enzymes are a little high, the echo shows probably reported as just normal, diastology not looked carefully at, even in this subset of patients, the only class of drugs that can make a difference are DAPA, empagliflozin, and SOTA when it comes. Now, DAPA really showed this data very, very well, as did EMPA also. Worsening heart failure changed. Not a great difference in CV death, and this bothers me a little. There is more coming up on this now, how these things will have to be looked at. All the parameters of heart failure changed in these pre-specified groups. Importantly, quality of life significantly improved. And compared with the Emperor Preserved, there were similarities, relative risk reduction almost same, populations almost same. So there was a clear signals of benefit. So now in HF, this is the spectrum. In HFpEF, you have DAPA with EMPA, Hfref, DAPA, EMPA, improved PF, DAPA, reduced EF, EMPA. As I stop here, just on time, I'm saying this again, that it's time now to look at LVEF as a spectrum, not just divide into one with lesser, mid, more, preserved. We need to mingle all this and bring up a clinical spectrum. Heart failure as an entity, treat the comorbidities and the risk, get it down first, treat hypertension well, and SGLT2 inhibitors will be the pillar. I have a strong feeling ARNI works, but that's a matter of discussion. Thank you very much for the patient here.
Thank you, Dr. Jada. As usual, nice presentation. Maybe one question you can take up. Any question from the audience? Otherwise, I have one question, Dr. Jada.
Yes, sir.
See, all these clinical trials, you want to decrease mortality or hospitalization. Are these endpoints same both in Hfref and HfpEF? What is the cause of mortality and cause of hospitalization? Are they same in both Hfref and HfpEF?
They are similar, sir. Both
because
in
the HfpEF has so many comorbidities.
True.
So the mortality and morbidity may be determined by something like COPD or respiratory failure or renal failure.
So there are pre-specified groups in even the Deliver study, and they have looked at, just to look at with associated COPD, whether it makes a difference or no, I don't think that sort of data is there. But the major pre-specified groups in terms of everything, the age, the BMI, everything, those parameters are almost running equal. And if you put those graphs in the pre-specified groups, running equal.
Because if the morbidity and mortality is due to non-cardiac factors, there is no point treating cardiac factors and say that there is no reduction. You have to have a comprehensive approach.
Right. So I think it's important to look at those points of all-cause mortality. Yeah.
Dr. Shastri, the March SENI actually published data on the heart failure and the type of mortality. Obviously, HFpEF 65% mortality is non-cardiac.
Yeah.
And in Hfref, 65% mortality is cardiac. That would tell you why the drugs behave differently.
I guess it changed over time also. So when iPreserve came up, the earlier trial looking at HFpEF, the yearly mortality was 5.6%. That actually brought HFpEF as an entity into action that, look, with a normal EF, 5.6% annual mortality, and that time the cardiovascular death, because they were evaluated a little carefully, attributed 60%. Whereas sir is saying, as these couple of decades have gone and probably metabolic diseases have gone higher and other risk factors are killing patients, we have to look at the patient in total, not just the EF. Thank you.
Thank you very much. We move on to the next topic, heart rate control in heart failure. Influenza vaccine understanding by cardiologists, Dr. Ambuja Rai. As you know, the most common cause in this season for heart failure hospitalization is lower respiratory tract infections, typically a unvaccinated patient. Dr. Ambuja Rai, please.
Thank you, sir. Good afternoon, chairpersons, and my thanks, since you're trying to organize this, for giving me this opportunity to speak here. After very esoteric talks on gene silencing and metabolic modulation, talking about a flu shot may sound very pedestrian, but sometimes the biggest impacts, as we know, comes from the simplest interventions. And I would like to just, over the next 10 minutes, tell you how this simple thing can have such a large impact. And I brought this out today because in the last 2 years, all the hullabaloo of COVID, we've had 2 large trials which have focused on cardiovascular disease, impacts of flu, and I was lucky to be part of one of these trials. So why should cardiologists be interested in flu? Well, after COVID, of course, that interest has gone up, but even if you remove COVID, we know there's a very strong association, and these are the 3 things I will talk about. Bring out the associations of influenza and cardiovascular disease, what the recent evidence of benefit in influenza vaccine in cardiovascular disease is, and the current status of use of the influenza vaccine, particularly in our country. So long before COVID, if this is a very elegantly done study through 35 large cities in the United States, including the Spanish flu. And if you see, during each of the epidemics of influenza, there is a spike in mortality, which is understood. But if you carefully see the impact of death due to causes other than influenza and pneumonia are very large, and that's seen by those dark lines, and largest of it is cardiovascular disease. So that association is well known after every peak of influenza, that there is increase in cardiovascular deaths. And this very elegantly done study, again published in New England Journal by Wong et al., clearly showed that after an index flu, during the next 7 days, there's almost a 6 times higher susceptibility to having an acute coronary syndrome. So again, a very strong association of cardiovascular disease, of myocardial infarction after a flu. And these are 2 studies studying impact of LRTIs, lower respiratory tract infections, on myocardial infarction and stroke, and the risk of heart failure after an episode of severe pneumonia. And there was a 2 to 4 times higher risk of ACS and 8 times increase in heart failure post-respiratory infection. And thus, it leaves a legacy effect even up to 1 to 5 years after this episode. So there is clearly an association of flu and heart diseases. But the purists would say these are associations, show me the trials. And here is what I'll highlight, the two recent trials published on flu and its impact on cardiovascular disease. One of them is the IAMI's trial, the influenza vaccine after a myocardial infarction trial. It was a randomized controlled trial, primary PCI in most centers, and in Bangladesh it was post-thrombolysis, where they gave the patients the flu vaccine versus placebo, and there was a reduction in MACE rates of as much as 28% and of cardiovascular deaths of 41% by just giving a simple flu shot. And the number needed to treat to reduce one major cardiovascular, to reduce one all-cause death and cardiovascular death was just 53. So huge impact of this simple flu shot in patients post-MI. You know, many a times you don't want to do that in an acute unstable condition, but this trial clearly showed that, you know, there was a huge impact and 41% reduction. And in the same study, they did a meta-analysis of all the randomized trials of influenza vaccine in cardiovascular disease, and they showed an overall 49% reduction in the meta-analysis of cardiovascular death. I'm not aware of any secondary prevention strategy, whether it be statins, ACE inhibitors, beta blockers, having that level of protection for cardiovascular death in patients post-myocardial infarction. So obviously a major impact that needs to be implemented. What about heart failure? And here is the data which was present earlier, but these are all observational studies. No randomized trials were available, but this review from 2019 shows a 24% reduction in mortality at 1 year and a 48% reduction in mortality during the flu season by giving the flu shot in patients with heart failure. But there were no randomized controlled trial until this IVV trial that we published in the Lancet Global Health just last year. And we have 7 centers from India, 2 from the north, and others from more of central and southern India, because that decided the vaccine which you would give. The NH vaccines were given north of the 30-degree latitude, and the SH vaccine was used south of 30-degree latitude, because the seasonality of influenza is such in different parts of India. So you need to have that in mind when you're randomizing patients in such trials. The eligibility was standard. Adults with clinical diagnosis of heart failure in class 2, 3, and 4 were included in the trial. It was the trivalent vaccine in the first 2 years, and when the quadrivalent came, and it's now mandatory to have quadrivalent, we gave the quadrivalent vaccine in the third year of the trial. Our first major primary outcome was composite of CV death, non-fatal MI, and non-fatal stroke, and the second co-primary outcome was added heart failure hospitalizations, and of course we had the secondary outcomes. This were the baseline characteristics, and more than 1 in 5 patients were from India, and most of these patients were from tropical countries, non-Western countries, because it really would seem unethical to do them in those countries, because the penetration of influenza vaccine was very high, and it just not be possible to do in a Western country. So we did this in countries where the penetration of flu vaccine was otherwise very low, because there were ethical issues. And what we found, to our surprise, was the trial was negative. Both the 2 co-primary endpoints were not significant. But we had decided, of course, all all-cause hospitalization did reduce in the trial by 16%, and the incidence of pneumonia came down significantly, which were the secondary endpoints. And the recurrent events, when we analyzed the recurrent events, there was again a 17% reduction in all-cause hospitalization in patients who received the flu shot. But when you learn as you do trials, and I don't know whether there will be another one, but many a times the trials, especially for flu, are analyzed by the flu season versus non-flu season. And this was a pre-specified analysis which we had done. And during the flu season, we clearly saw that the primary endpoints were reduced. So death, MI, non-strokes were clearly reduced during the flu season within the trial. And this is from the updated meta-analysis after the publication, just has come last year, after the publication of IMI trial and the IVV trial, and have shown 25% reduction in major adverse cardiovascular events in patients of heart disease when they receive the flu shot versus when they do not. And these are all randomized controlled trials. So we have answered that question on giving evidence for use of the flu vaccine in a randomized trial. But what is the real world use in India? And this is from the very landmark ACS registry from Kerala, and they've looked at the established therapies given, but we are not even asking the question whether a flu shot was given or not. So that is the priority for flu shot. This is again the largest ACS registry being done by ICMR. Again, we're not even asking the question on the flu shot. Again, another registry on heart failure. Again, we clearly know that GDMT reduces mortalities, but again, we are even not asking the question on flu. So, that just shows where it lies in our priority. And this is the one study from the paradigm where they looked at flu, and it was just an appalling 0.2% use in patients with heart failure. So, ladies and gentlemen, my take-home message is that there is a clear association between the common flu and acute coronary syndromes and heart failure hospitalization. For the first time, the large IAMI trial has shown reduction in MACE and mortality far greater than any other secondary intervention therapies that are available. IVV trial, the first such trial in heart failure patients, has shown reduction in hospitalizations and also reduction in combined endpoints during the peak flu season. And of course, we would like to bring greater awareness of the efficacy of the vaccine so that we can really translate knowledge to action. Thank you so much.
Thank you, Ambuj sir. With the permission of the House, I have 5 rapid-fire questions for you because I think this is a very important topic for all of us. Most of the time you have patients who've been vaccinated with COVID, either the second dose or the booster. How much time will you wait till you give the influenza vaccine? We arbitrarily assume 2 weeks. What is your protocol, sir?
So I agree there is no data available on this, but generally people have done it 2 to 4 weeks. But remember, there is a seasonality for the flu shot. You can only give it, we tend to give it around the year, which is not the way to go.
We ideally choose September because these strains are, the new strains come into the vaccine.
No, so WHO and India typically gets 2 vaccines. One is the SH and one is the NH. The NH is released in November, but the SH gets released around March, April. Unlike what our usual practice is, NH should be restricted to the very northern states. SH should go to all states. I mean, that's the recommendation south of the 30-degree latitude, which is most part of India. Chennai is an exception because it gets the winter rains and the flu season peaks in the winters. So there may be reason to give it here the NH vaccine, but most of India should get the SH vaccine, which comes in April. So that is something which we don't practice. But if you are getting a patient in April, in October, you might as well give the NH. But if you have a choice of the annual, we should follow the SH for most part of India, except Punjab, Kashmir, where you use the NH vaccine.
So then another quick question is, I think the same applies for the pneumovac also. You would wait for 2 to 4 weeks.
Yeah.
The next question is regarding the dose of antigen. You have three dosages, 30, 45 and 60 microgram per deciliter of virus. So in immunocompromised patients, transplant patients, would you prefer a different dose or go with standard dose?
This is a very valid question. You know, the InvesTED trial looked at this. The InvesTED trial was a trial for influenza vaccine, and they gave 2 shots versus 1 shot. As I said, they can't do a randomized trial in the West because it is an established therapy. And they looked at whether 2 shots would be better than 1. Unfortunately, the trial was negative. The benefit was similar. But I think where we missed out in the heart failure is maybe these patients are immunocompromised, and 2 shots would work better than 1 shot. So those are the patients where 2 shots would be better. So any patients probably where you are looking at an immunocompromised patient, 2 shot may be better, although we don't have evidence or data to support.
And last question, sir. Many times a patient is done with the influenza vaccine and then the new strain comes up. You have this antigenic shift and antigenic drift. So at any time, did you consider giving one more shot within the same calendar year, or you will wait till 1 year is over?
So the best next vaccine you'll get in the next season, which is if you're given the NH, you will have to wait till October for that to change. And the NH-SH, you know, that's the cycle which happens. So the next would come only in October. So if there is a shift, you think there has been a change, and it comes out with all the list of the antigens in those vaccines. So you could then potentially use the next vaccine which is released, which is the next season vaccine.
Because this also protects against H1N1. So
Yeah.
supposing you have an outbreak after you have given the flu vaccine, would you consider a booster dose or something like that?
Only if your next vaccine has that.
I think a very good discussion, and for the sake of the house, many people may not follow all the discussion. I take the liberty of explaining. Influenza occurs in different seasons in India. In Madras, Tamil Nadu, where we are sitting now, it probably occurs in November, December. Whereas in northern India, typically Jammu Kashmir, it occurs in January. Whereas most of the other parts, it tends to occur in July, August. So you have got 2 vaccines, Southern Hemisphere vaccine and Northern Hemisphere vaccine. The WHO or whatever the reference laboratories, they give recommendations in the month of September and in the month of March. In the month of September, they give recommendations for the Southern Hemisphere vaccine. The vaccine manufacturers come out with the vaccine in the month of March, and typically that has to be given in the month of April, May. So the patients are protected from the epidemic of influenza in the month of July, August. Whereas the recommendation made in the March are for the Northern Hemisphere vaccine. It is marketed in the month of September, and it is typically given in October, November to prevent the peak influenza epidemic in the December, January. So these things are there, but generally the strains are not so different. They tend to be common. So most of the time patients, at least one vaccine you take. Typically in most of the country, most parts of the country, we gave it in May, June ideally. And in the northern parts, typically Punjab, Haryana, Punjab and Srinagar probably, you give it in the month of November. That is one important aspect. And another aspect is the following acute coronary syndromes. If you get, this is a different ball game, different subset, not heart failure, but if you give following acute coronary syndrome, the 1 year event rates are less after the acute. That is 2 different things. One comment from there and then Jada, please.
So, you might have missed my slides. The randomized trial is showing a 45% reduction in CV deaths. So, I mean, so even if you look at the 95% spread, the minimum is 25%. So there is clear reduction in CV deaths, and this is not one trial. It's now 7, 8 trials and the meta-analysis. So, and the pathophysiology is not difficult. We know, influenza, inflammatory state, atherosclerosis is an inflammatory state, and this can clearly be a trigger for heart attacks. So, I mean, I don't
Can we
know
give
whether I can answer.
twice a year this vaccine or 6 monthly? Actually, some say 6
I
monthly.
don't think there are any recommendations for 6 monthly. We don't need to overdo things.
Okay.
It's an annual vaccine, and as Sir explained,
Yeah.
most of India, the flu season is post-monsoon. So you should cover that by giving it in April. Extreme north, maybe you're from Kashmir,
Yeah.
you should be doing it in January this year.
Thanks.
November,
Dr. Jaja?
December.
Professor Dr. Any difference you, if at all, noted from the Indian data which you generated as compared to the rest of the globe in this study 1 and 2? Has then, because it's a large data, has there been any link related to a demyelinating polyneuropathy or a Guillain-Barré syndrome situation after these vaccinations?
Yeah, so Indian data we have not analyzed. Unfortunately, the entire trouble study is negative, so doing a sub, it doesn't make sense. But we've done, with NIV, we've looked at the immunology response, and we'll be publishing that, because there is always this doubt whether the temperate and tropical countries will behave similarly or not. And maybe that's reflecting in the trial being negative. So we're not sure about that. But when we went by season, the trial analysis showed clear benefits. GBS incident, we didn't get any in the trial, none in the trial, and that's extremely rare.
Thank you, Dr. Ambujarai. Is there anything like antibody measurement? Because most of us will be infected with some sort of viral infections, and most of the patients will have recent infections. Should we measure antibody before going for any vaccinations, or we can just go ahead with it?
I don't think that's recommended, but for the study purposes, we've done the serology for all patients to look to see whether how was the response, and was the protection, which is next level of understanding, was the protection related to the serology response or not? We are yet to publish that data, but for clinical practices, I don't think that's recommended. It's a simple treatment, and even if during the trial, we had provision of people getting, because they were blinded, and if the physician wanted to give it, they could still go ahead, and it's well known that people have got 2 shots, and it doesn't have any harmful effect.
Attain the infection, like vaccine was not given because they had infection that time. So what is the protocol for them?
Are you talking about COVID or the flu?
Post-COVID, and those who are not vaccinated. So the same protocol applies, or?
Yeah, so the flu, actually there is some data that flu was protecting even against, flu shots were protecting in COVID.
Yeah.
So as Dr. Bhagirath asked, you can do the flu shot 2 to 4 weeks after the COVID.
Thank you, Dr. Ambujarai. I invite Dr. A. Suresh to talk upon heart rate control in heart failure. Welcome, Dr. Suresh.
One housekeeping announcement, because very extraordinary situation has happened. A lot of people are waiting outside to get a chair in the conference. So this has never happened. So we may take a 15 minutes break to reassign the chair. So thank you very much for that. So, and we are absolutely on time. So I request the speakers to reduce that talk by 1 minute each, so that we'll have that extra 15 minutes. So this is unprecedented, because generally we take, we don't have people. So now we have no chairs for people. Thank you very much.
Respected chairpersons, moderators, seniors, and dear colleagues. At the onset, I would thank the organizers for giving me an opportunity to present this topic, heart rate control in heart failure, in front of august audience. As you all know, heart failure is a clinical syndrome consisting of cardinal symptoms as shown, which is due to structural or functional abnormality of the heart that results in elevated intracardiac pressures and inadequate cardiac output at rest or after exercise. So main culprit is the sympathetic nervous system activation. It has a complex role in heart failure. Initial part, it has some benefit for maintaining the cardiac output, there is, because of the inotropy and chronotropy, cardiac output is maintained in the initial phase. But as the time goes on, because of the increase in norepinephrine and angiotensin, that leads to sodium and water retention, that leads to all the cascade of the heart failure pathophysiology. It also leads to disruption of beta-adrenergic signaling, downregulation of beta receptors, impaired mobilization of intracellular calcium, cardiomyocyte hypertrophy, necrosis, apoptosis, and fibrosis. It leads to renin-angiotensin-aldosterone system activation, leads to decreased response of natriuretic factors. Coming to the topic per se, what is the optimal heart rate? Consensus opinion in patient with sinus rhythm, there is no ambiguity. The heart rate should be less than 70 beats per minute. But in case I restrict my talk to heart failure with reduced ejection fraction because PEF was dealt with the previous speaker. So in heart failure with heart rate, reduced ejection fraction, when AF is there, it's like, it's a Goldilocks zone, like you should not be too low, should not be too high. If the heart rate is very high, as you see here, you can have pulmonary edema or tachycardiomyopathy. If the heart rate is low in a long-standing DCM patient who is elderly, they can have sick sinus syndrome in the form of tachybrady syndrome leading to high degree AV block or even complete heart block. So the heart rate should be optimal. So it has been suggested that the heart rate should be less than 80 per minute at rest and it should be less than 110 beats per minute at exercise. But ESC recommends a lenient heart rate control of less than 110 beats per minute in AF patients. The reason what they advocate is that as the atrial kick is lost, you need more heart rate to increase the cardiac output. But then you should not have a strict heart rate control for each and every patient. Like you should everything should be customized. If the patient is young, has a heart failure which is of recent origin, LV is not dilated, this subset of the patient should be having stringent heart rate control. If the patient is elderly, as the LV is very much dilated, then you can have a lenient control. So coming to the cornerstone of therapy of rate control in heart failure is beta blockers. How does it work? It decreases myocyte death, upregulation of beta-1 receptors, inhibition of renin secretion, decreased myocardial oxygen consumption, and prevents pro-apoptotic and cardiotoxic effects of cyclic AMP-mediated calcium overload. The recommendations for beta blocker in HFrEF is the bisoprolol, metoprolol, and carvedilol. It's a class 1 recommendation. Coming to the drugs per se, carvedilol is a third generation non-selective beta blocker. It blocks beta-1, beta-2, and alpha receptors, and it has antioxidant properties also. It causes vasodilatation of aorta, pulmonary arteries, and coronary arteries. The reason, one of the reason its side effect is hypotension is because of this reason. And the trials which I have seen is Copernicus and Capricorn, which decrease the annual mortality by 34% and 23% respectively. Coming to bisoprolol, it's a second generation agent. It has 120-fold higher affinity for human beta-1 compared to beta-2 receptors. CBS2 trial has shown 34% risk reduction, and it also reduces the sudden cardiac death and heart failure hospitalizations. Metoprolol is again a second generation agent which has 75-fold selective affinity. The trial which has shown is MERIT-HF, 34% relative risk reduction in annual mortality. It also reduces sudden cardiac death and progressive pump failure. Vabradine has been advocated as a class 2A recommendation in patients with sinus rhythm. As we all know, it acts on IF current, prolongs the SA node depolarization. So if the heart rate is more than 70 beats per minute and patient is on beta blockers or is not tolerating beta blockers, vabradine can be added on. And SHIFT is a trial which showed mortality reduced by 18%. Coming to the age-old drug, digoxin, it inhibits the sodium-potassium ATPase, but the role in heart failure is because of its vagomimetic action, which indirectly reduces sympathetic outflow by improving carotid baroreflex responsiveness. In low doses, it's a neurohormonal modulator. The rate AF trial, digoxin was compared to bisoprolol, and it showed that it had a better NVHA class, and the effect of quality of life was similar. DIC trial showed reduced HF hospitalizations. It's a class 2A recommendation in patients with AF with HFrEF. Amidron is the only antiarrhythmic drug with neutral effects in patients with reduced ejection fraction. IV amidron is a class 1, predominant class 1 and non-selective class 2 effect, whereas oral has class 3 effect. It's well suited for atrial and ventricular arrhythmias, and it's a class 2A recommendation for rate control in heart failure. The trials which I have studied are RS study and CTAF trial. It takes around 6 to 24 hours for conversion from AF to sinus rhythm. So coming to the pathophysiology shortly. So as we all know, in non-valvular AF, pulmonary vein trigger accounts for 60% and remaining are non-pulmonary venous trigger. That leads to increased tachycardia and then irregular conduction, loss of atrial kick, and decreased diastolic filling time, mitral valvular dilatation, mitral regurgitation, leading to decreased cardiac output and heart failure. When heart failure ensues, that leads to increase in RAS, increased sympathetic activity, and that leads to atrial stretch and left atrial pressure, that leads to further atrial fibrosis, and then AF is occurring. Around 40% of the heart failure patients have atrial fibrillation. So AF begets AF, and again heart failure is ensured. So what are the therapeutic modalities? As we all seen, the drugs have already been discussed. What I would like to discuss in the coming slides is the rate control by catheter ablation and by AV nodal ablation and with CRT in patients where there is permanent AF and you cannot go for a rhythm control. So I'll run through my clinical cases of arrhythmia-induced heart failure. So as we have said, it's a pulmonary venous trigger which accounts for 60% of the atrial fibrillation in non-valvular AF. And 40% could be SVC, IVC, or it could be cavity isthmus, any atria, anterior part of atria, or posterior atria, or roof of atria. So he's a 45 years old gentleman, presented with recurrent palpitations since 3 months, and he had shortness of breath class 3 to 4 since 10 days. This is the ECG. As you can see, he had atrial fibrillation with fast ventricular rate. Echo had a severe LV dysfunction. He was not responding to any of the antiarrhythmics. I had taken it for 3D mapping, radio frequency ablation. This is the left atrial geometry, as you can see here. So these are pulmonary veins. The violet color is the normal voltage, and then there's a low voltage in the anterior part of the atria. Pulmonary vein isolation was done, and after isolation, this is where, if you can see the end, the AF is being converted to sinus rhythm during ablation. So post RFA, patient was in sinus rhythm, and is 5 years on follow-up, is not on anticoagulants, not on antiarrhythmic drugs because Statsworth score was 0. So it's a tachycardiomyopathy due to left atrial tachycardia and paroxysmal AF. So coming to recommendation, it's a class 2A recommendation when you think arrhythmia is causing that tachycardiomyopathy. This is another case, 63 years old male, known case of dilated cardiomyopathy post CRTD presented with heart failure. If you can see here, he had AF with fast ventricular rate, and BIV pacing is not that much. And in fact, the BIV pacing was only 74 to 75%. As we all know, when we implant a CRT, you should have more than 99% BIV pacing. So the CRT is not functioning well, so we have to do something to block the AV node. So I subjected him to AV nodal ablation, and after AV nodal ablation, he had 100% BIV pacing. And this is the ECG, and he significantly improved, and his heart failure symptoms have decreased. The other way around, what ESC recommends is that in a patient who has permanent AF, and you cannot convert him to sinus rhythm, then, and he has LV dysfunction, you can do the AV nodal ablation and put a CRT. So this atrial flutter, as we all know, atrial flutter is because of the re-entry around the cavity tricuspid isthmus. So he's a gentleman who presented to me. He had palpitations since 6 months, but breathlessness since 1 month. He was diabetic and obese. This was the ECG 6 months back. You can see it's a typical atrial flutter. When he presented to me, it was a 1-to-1 atrial flutter. So he had severe LV dysfunction. EF was around 32%, and RV TAPC was 1.3 centimeters, which means he had a significant RV dysfunction also. So this you can see here, LV is hardly contracting. TE was done. There was a left atrial appendage clot. So cardioversion is the treatment of choice in atrial flutter, but then as LA clot was there, to take him up for ablation, and this is the right atrial geometry, and this is the cavity tricuspid isthmus. Ablation has been done. He was in sinus rhythm after ablation, and his ejection fraction improved to 64%, and TAPC also improved to 1.65 centimeter. And it was a tachycardiomyopathy due to incessant typical atrial flutter, and successful cavity tricuspid isthmus ablation was done. This is a patient, 60 years old, presented with palpitation, breathlessness since 1 month, diabetic and hypertensive. I have some more 3-4 clinical cases. Can I go ahead? So this is a SVT ECG. He was not responding to any of the antiarrhythmics. Adenosine was tried, beta blockers, calcium channel blockers, amiodarone was given. He was persistently in this rhythm. So took him up for 3D mapping. So you can see here, patient had origin in the right atrial appendage, and during ablation, the tachycardia terminated to sinus rhythm. So this you can see here in the sparkling, the white color one is the where the focus of origin of the atrial tachycardia. So this is during ablation, atrial tachycardia converted to sinus rhythm. This is a sinus rhythm. So post RFA ECG, and after ablation, post 1 month echo showed a normal LV function. This is a very interesting case. 61 years old female presented shortness of breath class 4, and she was in heart failure. In fact, she was treated somewhere, and the cardiologist told her that your heart pumping is very weak, and the patient attendance, he was paramedical staff. So he searched to the Google, the treatment of heart failure, and this treatment is cardiac transplantation, he thought. And he came to me because he thought I knew a transplant surgeon, came to me that this patient wants transplantation, you refer to me a transplant surgeon. I saw this ECG, I said you don't need a transplant surgeon, he needs a EP study, because all the antiarrhythmics were tried, but the patient was in this rhythm. If you can see here, the heart rate is around 120 beats per minute, and the P waves are inverted in the 2-3 AVF, and he was in this rhythm. Even after giving antiarrhythmics, the rate was 105, but still the rhythm was a low atrial rhythm. So took up for EPS and RFA, and was, you can see the ablation catheter here. It is in the posterior septum, it was septal AT, and after ablation, this is the ECG, was in sinus rhythm. Ejection from severe LV dysfunction, it improved to moderate LV dysfunction, and after 1 month, repeat echo was done, totally asymptomatic. So this patient didn't need transplant. So this is another patient, 54 years old male, female, presented with shortness of breath, palpitations. This is a short RP tachycardia. I just want to show the ECGs because even if you can see it's a short RP tachycardia, most likely AVRT, this itself can cause a tachycardiomyopathy. So severe LV dysfunction. This patient had a concealed left anterolateral axillary pathway, and after ablation, patient was in sinus rhythm, and 15 days after the procedure, she had near normal LV function. This is a very interesting case. 40 years old male presented shortness of breath since 3 months. Echo showed severe LV dysfunction. This is a ECG. If you can see, it's a left bundle branch block. He was suggested CRTP implantation. But then if you carefully see this ECG, it's a pseudo LBB. The PR interval is short, delta wave is there, so it could be a pre-excitation. Holter was done, there was runs of tachycardia. So I told him you don't need a CRTP, ablation would cure the thing. And post RFA, this was the ECG, and 1 month after the RFA, he had normal LV function. So this is a 48 years old male. I'll just show the ECG. He had a SVT, he had a severe LV dysfunction, adenosine was given. The SVT terminated, but the VPCs, you can see outflow tract VPCs were there. If the tachycardia persisted, you could attribute SVT is causing the tachycardiomyopathy. But even after the termination of the tachycardia, if the LV dysfunction is there, then you must think of other things. So this patient had a VPC, and EF was 30%, and the burden was 26.4%. So severe LV dysfunction could be because of idiopathic VPCs. MRI showed no scar and severe LV dysfunction. I took the patient for ablation. This you can see the ablation catheter is below the left coronary artery. The VPC was arising from left coronary cusp, and the SVT was typical AVNRT. So after ablation is a 3D mapping. He had a normal ECG, and 1 month after the procedure, he had near normal LV function. So this is a 17 years old male. He had 4 rhythms. This is the first one is a AVNRT. Second one is a orthodromic AVRT. This is a atrial fibrillation. Then this is orthodromic AVRT, and this is a VPC. So he had a quadruple rhythm. Tachycardiomyopathy was because of 4 rhythms. Successful ablation was done, and post ablation he had a normal LV function. This is the last case. Is a very interesting case. 53 years old male presented with sudden onset of breathlessness, palpitations, and episodes of pre-syncope. BP was 80/60, coronaries, mild LED disease. This is the presenting ECG. He was in VT throughout the hospital stay. IABP was put, nothing happened. There was another arrhythmia we could see. He had atrial fibrillation and left atrial flutter. and echo showed 17% ejection fraction. As I had no other option, I had to take him up for ablation, and you can see VT ablation was done, and I had a right atrial flutter cavotracheostomy ablation was also done. And post ablation, he had sinus rhythm, the LV functions slightly improved. Then I wanted to know what is the cause behind this, both the arrhythmias. And if you see cardiac MRI was done, the septal scar is there. When you see a septal scar, then you must think of a sarcoidosis or a tuberculous granulomatous myocarditis. Did the cardiac PET scan, and there was uptake in the LV, and you can see the hot spot in the left supraclavicular lymph node. Did the supraclavicular lymph node biopsy, and patient had a granulomatous myocarditis, tuberculosis. So he had a tuberculous granulomatous myocarditis presented with a VT storm. So this is after ablation, and he's doing well, 5 years on follow-up. Though LV is, EF is around 40%, but it's totally asymptomatic on ICD. So this coming to the take-home message for drug therapy. As we all know, beta blockers is the first line for rate control in heart failure. Ivabradine is a reasonable choice for heart failure, reduce ejection fraction when there is sinus rhythm, and when there is AF, you can give digoxin when beta blockers are not tolerated. And amiodarone is the drug of choice in patients with structural heart disease with heart failure. So summarizing, arrhythmic etiology in patients with cardiac dysfunction should be sought. A early rhythm control strategy, be it SVT, atrial fibrillation, or atrial flutter with tachycardiomyopathy should be done. AV nodal ablation is a class 2A recommendation in patient who has permanent AF with heart failure with reduced ejection fraction. And the VPC burden should be reviewed for timely prevention of cardiomyopathy. And VT ablation is also useful in dilated as well as ischemic cardiomyopathy. So concluding, imaging techniques may be useful in providing the insight about the mechanism of arrhythmia. High index of suspicion is required given the potential LV recovery in cardiomyopathy with arrhythmia. An aggressive proactive approach is required for the treatment of arrhythmia for a better quality of life and not giving the adverse effects of the antiarrhythmic drugs, and last but not the least, giving the mortality benefit. Thank you.
Thanks, Dr. Suresh. Just one comment that when you put in a CRTD, many times we find that if the patient already has pre-existing atrial fibrillation, then we go ahead with AV nodal ablation and then place the CRTD. That's what you showed. But also want to emphasize that couple of our patients who've been on CRTD subsequently developed atrial fibrillation.
This patient, what I showed is he already had
subsequently,
CRT.
yes.
I did the AV nodal ablation.
So when we monitor it, we need to keep seeing whether they have gone into atrial
fibrillation. Pacing is more than 99% or not.
Yes.
It is because of AF. If even you have VPCs also, then you need to ablate the VPCs.
That's my next
also.
question. Many times you have patients with LV dysfunction with frequent VPCs. So at what stage would you consider ablation? That's my last question.
So VPC burden, if it's more than 15%, then it has been shown that it causes LV dysfunction. So we go for ablation when the antiarrhythmic drugs fail, of course.
Thank you, Dr. Suresh. Just want to add a couple of points. Coming to the last point, as much as VPC burden, the morphology of VPCs also matters. If you have got a wider QRS, epicardial origin, with initial wide, slow fast VPCs, they tend to produce more, and also polymorphic VPCs, they tend to be associated more with tachycardiomyopathy. And another quick comment before we close is the atrial fibrillation. Though most of the time what happens typically atrial fibrillation, heart failure patient have borderline low blood pressure. We cannot give any of these beta blockers or calcium channel blockers. We tend to give amiodarone, but we should know that amiodarone though doesn't generally produce LV worsening of LV failure, but it can do so in class 3, class 4 patients, especially if you have got a widening of QRS. So I think we should have a low suspicion, low threshold to do a AV nodal ablation. And sometimes I think maybe in short future we may have a paper from another institute. There may be reverse remodeling and patient may get sinus rhythm later. So we should have a AV nodal ablation preferentially than continuing on amiodarone, especially if the patient is worsening.
Sir, I would like to add two things, sir. The ventricular premature complexes, be it outflow tract, be it LVOT, RVOT, fascicular VT, and single morphology, even from RV idiopathic sites are there from the annular, tricuspid annular. So these are whenever we see a monomorphic or two morphology of VPC and patient has LV dysfunction, better to go for an aggressive approach. And second thing is coming to atrial fibrillation. I feel rather than going for AV nodal ablation should be done when permanent AF is decided. That is either the patient feels or the doctor feels. But I feel if it is the initial stage, why don't we go for a pulmonary vein isolation? And even we can do 2-3.
Talking about a situation where you can't do a paroxysmal atrial fibrillation. See, to treat the PV nodal pulmonary vein isolation.
No, you can even do for persistent and long persistent AF also.
Sure. The availability I'm talking. See, we are talking about a general audience. See, many times, many places, it's not easy to do a pulmonary vein ablation or cryo ablation, and what are the results?
Sir, cryo is just now it has come, but then pulmonary vein isolation can be done. Actually, once we get the referrals, we can do it.
Yeah,
That's what I
results.
said.
Results. What is the success rate? Even the international studies, success rate is about 70%.
You're right, sir. You're right.
I'm talking about a situation, you have got a LA of 5.5, 6. How often you are successful is the pulmonary vein isolation?
Sir, if left atrial dilatation should not be very high, so around 4 to 4.5 centimeters, I think we can have a try, sir.
I think if there are no questions from the floor, we close this session. Thank you very much.
Thank you, moderators and the panel members for that immense knowledge. Moving on to the next section of the day, I take this opportunity to welcome Dr. Ambuj Roy, Dr. Jayagopal and Dr. Dinesh Chowdhury to chair the session. May I request the moderators to start the proceeding. I request the speakers and the moderators to stick on to the time, please.
How much time I have got? 20 minutes? 2 topics in 1 hour, no? No, seriously, I made a miscalculation. I thought it is 3 speakers in 1 hour. So I prepared for 20 minutes talk. Is it 10 minutes? Where is Abraham?
10 minutes.
10 minutes? No, because I have to really jump through the slides. Because I saw 1 hour and 3 topics, I assumed it will be 20 minutes.
Good afternoon, everyone. I think we have a fantastic session now. I think they already began schedule, so I request Dr. Sandeep Seth to start the proceedings on. Dr. Shastri, I think, sorry. Pulmonary hypertension, heart failure, both preserved ejection fraction and reduced ejection fraction, how to manage. Dr. Shastri, please.
It was there before. It is about to be shown. No? This one.
So I'm told that Dr. Sandeep Seth gave his talk yesterday, so we have only 2 talks in this session. Dr. Sandeep Mishra is there.
Yeah, good afternoon, everyone. As I mentioned, probably I'll have to jump through the slides. The topic assigned to me is pulmonary hypertension. This is the pointer. This is the slide. Okay. So the topic assigned to me is management of pulmonary hypertension in heart failure, both Hfref and HfpEF. Now, if you see here, the prevalence of pulmonary hypertension in heart failure varies widely based on the definition used and methods of measurement of pulmonary hypertension, whether it is echocardiographic or invasive, whether you are measuring it in an echo room or in the cath lab or in a outpatient center or in the inpatient. This probably everybody knows. The left heart disease, left ventricular end-diastolic pressure increases the left atrial pressure, backward transmission to the pulmonary veins, capillaries, and this leads to the pulmonary wedge pressure increase, and this is isolated post-capillary pulmonary hypertension. The pulmonary vascular resistance typically in this group is less than 3 wood units, and the difference between the pulmonary artery diastolic pressure and the pulmonary artery wedge pressure is less than 7 millimeters. If this post-capillary pulmonary hypertension is persisting and long-standing, there will be arterial vascular remodeling, both sclerosis and hypertrophy, that leads to fixed pulmonary arterial pressure, pulmonary vascular disease develops. That is the combined pre and post capillary pulmonary hypertension. Here pulmonary vascular resistance is more than 3 compared to isolated post capillary, which is less than 3, because the arterial component has remodeled, and because of this the pulmonary artery diastolic pressure increases and the diastolic pressure gradient will be more than 7. And now, as I mentioned, in the isolated post capillary pulmonary hypertension, only passive transmission, not much of structural changes, but in combined pre-capillary and post-capillary pulmonary hypertension, there is a medial hypertrophy and sclerosis in the arterioles, and that leads to increased pulmonary vascular resistance here. Here the pulmonary vascular resistance typically will be more than 3 wood units. All other parameters will be okay. Now, these are the definitions, the fifth World Congress and 6th World Congress. You can see the mean pulmonary artery pressure, previously the definition was more than 25 millimeters to define pulmonary hypertension. Now it is reduced to 20 millimeters of mercury. The diastolic pressure gradient has been taken away because the prognostic certainty is not there. So this has been removed. So other things remain the same. And why this change occurred? Because in the epidemiological studies, when the pulmonary vascular resistance, when the pulmonary artery mean pressure is normally up to 20, even 20 to 25 pulmonary artery mean pressure increase has been associated with adverse prognosis. So now the pulmonary hypertension definition is pulmonary artery mean pressure more than 20 millimeters. You see what is the difference between Hfref and HfpEF? The HfpEF patients tend to have a higher pulmonary vascular resistance. Here you can see the median, you see median remains almost same, but the graph is shifted more to the right, leading to the higher incidence of increased pulmonary vascular resistance in these patients. These phenotypes, in the HfpEF population, based on the pulmonary hypertension, one of the criteria here you see, in the phenotype A with HfpEF, pulmonary artery pressure, systolic pressure is 10 to 25, which is almost normal. As the patient advances, the disease advances, the pulmonary artery pressure increases to 45 millimeters at rest, and even further, the patient develops the vascular remodeling and pulmonary arterial hypertension becomes 60 millimeters of mercury. And irrespective of the underlying disease, in general population, with people with or without cardiopulmonary disease, with or without the LV systolic dysfunction, whether both HfpEF and Hfref, each increase in the 1 millimeter mercury of the pulmonary artery systolic pressure is associated with poorer prognosis. Not only that, the ventricular arterial coupling matters. So, for example, patient with less than pulmonary artery systolic pressure of 47 millimeters also has RV dysfunction. That patient fares worse. So, both pulmonary artery systolic pressure as well as the RV systolic function, both are important. It is becoming increasingly difficult in elderly patient population with pulmonary hypertension, whether is it a HfpEF with pulmonary hypertension or is it a idiopathic pulmonary arterial hypertension, group 1 pulmonary arterial hypertension. There are some clinical markers to tell you the probability that it is if the patient has got more atherosclerotic risk factors, older in age group, previous coronary interventions, atrial fibrillation, structural heart disease, ECG with left bundle branch block, LA dilatation, all these indicate probably this is a group 2 pulmonary hypertension and not group 1 pulmonary hypertension. But if the elderly patient doesn't have these factors, probably you are dealing with a pulmonary arterial hypertension. Invasive cardiac catheterization and measurement of the pulmonary artery wedge pressure and PVR are important in these patients. And it is important, as I mentioned in this group, to differentiate the pulmonary group 2 pulmonary hypertension and pulmonary arterial hypertension. Sometimes it may be difficult. The criteria is what is the pulmonary artery wedge pressure. In well compensated patient, pulmonary artery wedge pressure may be normal or less than normal, but if you challenge the patient with exercise or with volume overload, the pulmonary artery wedge pressure increases, which is not the case in group 1 pulmonary arterial hypertension. So it's not only important to do a cardiac catheterization very carefully, but if you have got a doubt, you have to give a volume infusion or appropriate exercise in the cath lab and demonstrate what is the behavior of the pulmonary arterial wedge pressure before characterizing whether it is a group 1 pulmonary hypertension or group 2 pulmonary hypertension. So what is the treatment of pulmonary hypertension in LHD? Treat the underlying heart failure based on the phenotype, whether it is Hfref or HfpEF, and guideline directed medical therapy for the Hfref, and standard of care for HfpEF, which has been discussed. And the most important thing is whether to use pulmonary vasodilators or not. I suppose that is the reason for my talk. Looking at among the available pulmonary vasodilators, endothelin receptor antagonists have consistently shown disappointing results. They increase the mortality, they increase the heart failure hospitalizations. So endothelin receptor antagonists, namely bosentan, ambrisentan and macitentan, are not indicated in pulmonary hypertension due to left heart failure, whether it is reduced or preserved. And what about pulmonary PDE5 inhibitors, sildenafil, tadalafil? The studies are most often single center, small number, and short-term duration. The results are inconsistent, variable. Probably they increase the exercise capacity, ventilatory efficiency, quality of life, and
there is another subset of patients probably where these PDE5 inhibitors are beneficial. That is the heart failure with reduced ejection fraction patient waiting for transplant and on LVAD. Probably that is a different subset which I'll deal again, that where the PDE5 inhibitors are shown to be beneficial. But looking at the sildenafil and Hfref trials, a meta-analysis of sildenafil and Hfref trials on 6 trials has shown some benefit in the heart failure hospitalizations. Now, in combined pre and post capillary pulmonary hypertension, very well predefined group, the sildenafil has been shown to be improving the 6-minute walk test, decreasing the NT-proBNP, improving the RV function as well as the functional class. But in another trial, RELAX trial, the primary endpoint of peak oxygen consumption has not been shown to be altered by sildenafil therapy. So as I mentioned, sildenafil has been showing inconsistent results in management of heart failure with pulmonary hypertension patients. This is another trial in which the valve repair or valve replaced patients with pulmonary hypertension, they have been given sildenafil and it worsened. Probably this is a very, the patient population is non-homogeneous and the average pulmonary artery wedge pressure is 20 after the valve repair or replacement, mitral valve replacement or aortic valve replacement, which is not acceptable. Probably but the study shows that sildenafil is not particularly beneficial in these patients. So this is a summary of many clinical trials. Here you see the epoprostenol in the first trial studied in 471 patients has shown strong tendency for increased mortality. So prostaglandins are not indicated in patients with pulmonary hypertension due to heart failure. Similarly, endothelin receptor antagonist, as I mentioned, they neither improve survival nor hospitalizations. In a meta-analysis of multiple trials, there seems to be some beneficial effect, but it is not consistent. Now, if you look at the mortality, here you see in the last column, the active drug versus placebo, the mortality with most of the agents which are used to treat the pulmonary hypertension, epoprostenol, endothelin receptor antagonists, vericiguat in this study, and also endothelin receptor antagonists, there is increased mortality if you can see in the last 2 columns in the active drug. Now, what are the conclusions? Endothelin receptor antagonists and parenteral prostacyclin therapy have been shown to either neutral or increase mortality in patients with LV systolic dysfunction. pH targeted therapies and especially phosphodiesterase 5 inhibitors may improve exercise capacity in patients with heart failure. However, an increase in adverse events is likely. Moreover, most studies are at high unknown risk of bias, precluding confident conclusion about the effect of pH targeted therapies. pH specific therapies are currently not approved for management of pulmonary hypertension due to Hfref or HfpEF. The people have tried atrial shunt in observation study has shown good results in improvement of NYHA class, heart failure scores and 6-minute walk test, but a randomized controlled trial is negative. As on today, atrial shunt is not recommended or approved in the management of pulmonary hypertension due to heart failure. Other effective therapies include left ventricular assist device if the patient has pulmonary hypertension is waiting for transplant. Mitral clip has been shown to decrease PA systolic pressure, and CardioMEMS also is beneficial in monitoring pulmonary hypertension treating the patients. Last few slides, we have got a patient with heart failure with reduced ejection fraction waiting for transplant. It is very mandatory to understand the mechanism of pulmonary hypertension if it is there and what is the mechanism, whether it is reversible or not. Because what happens, patients with heart failure, left ventricular dysfunction or valvular heart disease initially have post-capillary pulmonary hypertension, but over a period of time they develop combined pre and post-capillary hypertension. The pre-capillary component of pulmonary hypertension is fixed and not reversible. Such patients, when submitted for heart transplantation, will have worse outcomes. In the immediate perioperative period, they will have right ventricular dysfunction and increased morbidity mortality. So it is very important that whenever you consider a patient for heart transplant, initially you do a right heart cath and repeat every 6 months till the time you do a transplant. This is specially indicated if systolic pulmonary artery pressure is more than 50 millimeters, transpulmonary gradient 15 and PVR more than 3, you have to do a acute vasodilator challenge and demonstrate in the cath lab whether the pulmonary hypertension comes down or not. If you can bring down the pulmonary vascular resistance to less than 3 Wood units in the cath lab with acute vasodilators, such a patient may be submitted for heart transplantation. If pulmonary hypertension is fixed, pulmonary vascular resistance cannot be decreased with acute vasodilator challenge, such a patient will have problem after heart transplant. Such a patient has to be treated aggressively before transplantation to decrease the morbidity mortality. Among the vasodilators, one can use milrinone or prostacyclin or inotropes, inodilators, inhaled nitric oxide, or even sildenafil to assess the acute vasodilator response. In patients who are waiting for transplant at high PVR, one can use LVAD. Irrespective of the baseline pulmonary vascular resistance, LVAD decreases the mean pulmonary arterial pressure, pulmonary vascular resistance, transpulmonary gradient, and also pulmonary artery wedge pressure. Last slide, sir. This is in addition, in places where you can't give LVAD, one can give continuous intravenous milrinone infusion to decrease the pulmonary vascular resistance in a patient waiting for heart transplant. This is one of my patients, actually only one patient. The patient had high PVR, you can see 5.65, and not a candidate for transplant. We have given him continuous intravenous infusion of milrinone for 2 weeks, then repeated cath. Surprising, the pulmonary artery mean pressure has increased, so is the cardiac output. That means the patient is volume loaded. We aggressively treated with diuretics, then repeated cath after a few days, then you can see patient became eligible for transplant. This particular patient has undergone transplant and is doing well after 3 years without any problems. Now, in an observational study published recently, not recently, little older, there is not much of difference between inotropic management that as I have shown or LVAD in managing these patients waiting for transplant. But as you know, this is an observational study with all its problems. So in conclusion, pulmonary hypertension is common in both in patients with both systolic and diastolic heart failure, and pulmonary hypertension with high PVR, irrespective of etiology, is a marker of poor prognosis. This has to be differentiated from group 1 pulmonary arterial hypertension, which I mentioned in the earlier slides. Effective treatment of left heart disease is the cornerstone of therapy. Specific pulmonary vasodilators have not been shown to be beneficial. Presence of pulmonary hypertension becomes an important consideration in heart transplant patients, and vasodilator testing is indicated in this subset of patients. Thank you very much.
Thank you. Thank you, Dr. Shastri. I think you've summarized a very difficult to treat situation, and pulmonary hypertension, from what you've summarized, remains a very important prognostic marker, but as an intervention, there is very little other than managing conventional therapy, optimizing conventional that you can do. Is there any comments from my co-chairs or from the audience? We can take one question and then move on.
The oral drugs that can be given to decrease the PA pressures. We are talking for group 2 pulmonary hypertension, that is left heart disease. The main treatment is management of heart failure. If you want to specifically bring down the pulmonary artery pressures, if it is very high, if the RV dysfunction is there, very cautiously you may attempt to give PDE5 inhibitors. That is the only probable this one. But you should be very careful, closely monitoring.
Because we usually face this problem in our valve patients. When we find the patient of MVR, AVR or DVR, the patient already came with the high PA pressures. So pulmonary hypertension has been already set in. So to decrease that...
in the presence of valvular heart disease, you don't give pulmonary vasodilators.
Okay.
Treat heart failure as much as you can with diuretics, prepare the patient well for surgery, do the valve replacement therapy. Most of the times, unless there is a pre-existing or concomitant systolic or diastolic dysfunction of left ventricle, or there is a patient prosthetic valve mismatch, your surgery should be curative and blood pressure should come down. In such a patient, as shown in the CO study, post-operatively, if the pulmonary hypertension persists, if it cannot be controlled with diuretics, you don't have any other specific therapy.
So even after surgery, there is no role of oral drugs per se.
After surgery, if the surgery is done well, patient should not have pulmonary hypertension. If he has pulmonary hypertension, You see whether pulmonary artery wedge pressure is elevated or normal. If the pulmonary artery wedge pressure is elevated, treat with diuretics. If the pulmonary artery wedge pressure is not elevated, you can try PDE5 inhibitors.
Thank you, sir.
Both were there, and with the BP control, and pulmonary artery hypertension is still not under control. Means they are using this phosphodiesterase inhibitors for the past 2-3 years, along with antihypertensive drugs. But EF is about 56%. So what is the...
See, you have to be very clear whether you are dealing with a group 1 pulmonary hypertension or group 2 pulmonary hypertension.
Yeah, it's not valvular.
Group 1 pulmonary arterial hypertension, even if the pressures are normal or low, you can give standard pulmonary vasodilator therapy like PDE5 inhibitors, ERAs, etc. Standard PAH management. Only group 1 pulmonary hypertension is called pulmonary arterial hypertension.
Arterial hypertension, yeah.
Other group of pulmonary hypertension are not group pulmonary arterial hypertension, they are simply pulmonary hypertension.
Yes.
So if the pulmonary hypertension is due to heart failure, in your case with preserved ejection fraction, if you have controlled everything, then as I mentioned, very cautiously, you may give sildenafil, but be very careful. Monitor the patients closely, because what happens, if you decrease the pulmonary arterial pressure, the pulmonary blood flow increases, QP increases. The flow across the pulmonary circulation increases because of the decrease in the pulmonary vascular resistance. Such a patient very often goes into increased breathing difficulty, pulmonary edema-like situation. So if you give PDE5 inhibitors in a patient with HfpEF and PAH, you have to increase the dose of diuretics. You understand? So without doing that, if you give, there can be problems. So you have to give very cautiously with close monitoring.
So for the last talk of the session, I invite Mr. Dr. Sandeep Misraji, a sudden cardiac death in heart failure.
Good afternoon, everybody. First of all, I have to thank Heart Failure Association for calling me here to make my presentation. So what I'm going to talk about is sudden cardiac arrest in heart failure. So I think previously we used to call sudden cardiac death, but many patients don't die. So it's better to call it sudden cardiac arrest. So what are the key heart failure features? So I think all of us know a lot about heart failure. So what I will do is I'll just talk about sudden cardiac arrest in heart failure. So sudden cardiac arrest has an incidence in patients with heart failure of about 5% per year. In US, just to give an estimate, about 2.5 lakh, more than 2.5 lakhs die annually. Interesting thing is that the incidence and prevalence of this arrest keeps increasing with the age, probably because more and more heart failure patients keep coming in. About 50% of all deaths in heart failure are supposed to be, out of the total deaths, about 50% are thought to be because of sudden cardiac deaths, which are totally unexpected. Patients with heart failure have about 6 to 9 times more chance of having sudden cardiac death than general population. The risk of sudden cardiac arrest is increased in both those with reduced ejection fraction as well as preserved ejection fraction. Also, the risk is irrespective of the type of heart failure with reduced ejection fraction, whether it is ischemic, non-ischemic or any other type, the risk still remains. Now, this is just the annual rates from all these studies, and you can see that during the time the risk has been persistent in as many trials as you can see. Now, the sudden cardiac arrest is not of one type, and especially in heart failure, we find that there could be 4 causes for sudden cardiac arrest. Of course, the commonest is the lethal tachyarrhythmias, VTs or VFs. Then bradyarrhythmias can also happen. And then there is pulseless electrical activity, which we call electromechanical dissociation. And then there could be sudden hemodynamic deterioration as well, that we can think of as, which can lead to sudden cardiac arrest in heart failure. Now, some important things, I think, which is of interest. The risk of sudden cardiac arrest is more in those patients with mild heart failure. Or in other words, if you look at people of mild heart failure, and if you look at people dying of mild heart failure, then chances of dying of sudden cardiac arrest is much more than hemodynamic compromise. But as the severity of disease goes on increasing, then people with who are sicker with more progressive heart failure die of more of hemodynamic compromise than sudden cardiac arrest. So an interesting thing has been that there has been a declining risk of sudden cardiac arrest over the years. And I think that is rather interesting, because we know that overall mortality with heart failure has practically remained static, but mortality related to sudden cardiac arrest has decreased, and that due to progressive heart failure has probably increased. And you can see the trials, the early trials, the deaths due to sudden cardiac arrest were higher, and in the later ones we see that the proportion or percentage of death due to sudden cardiac arrest has come down somewhat. So what are the mechanisms of sudden cardiac arrest in heart failure? And as you can see, there is an interplay of many factors. Number one is the basic thing is that there is an adverse electrophysiologic remodeling. So that is, I think, the molecular basis for sudden cardiac arrest. And that can happen because of several things. It could be because of sympathetic activation. It could be because of activation of renin-angiotensin-aldosterone system. It could be because of structural or mechanical things like interstitial fibrosis and altered structural support. And also it could be because of myocardial injury. All this leads to development of this specific adverse electrophysiologic substrate, and that leads to arrhythmia and development of sudden cardiac arrest. So some things that I have summarized, there is an action potential prolongation, there is alteration in calcium homeostasis, there is abnormal conduction in the myocardium, there is also contribution by myocardial ischemia in at least those with ischemic cardiomyopathy, then altered neurohormonal signaling and electrolyte imbalance. But I think one important thing is a genetic substrate, and I think that remains key in many people, because we may say that a lot of people with heart failure die of sudden cardiac arrest, but some don't die. So who are the people who are dying if they have the same environmental factors? And there are certain genetic predisposition to development of all these abnormalities, especially this development of adverse electrophysiologic remodeling, and that is compounded by other environmental factors. So let us look at some of the electrophysiological abnormalities. As I said, cellular hypertrophy and interstitial fibrosis leads to changes in expression of the ion channels, and that leads to increased propensity of development of this electrophysiological substrate. Mechanical stress and abnormal repolarization also contribute to this particular problem. Obviously, most of us know that there is a neurohormonal interaction or activation, and I think many of our therapies are directed towards these neurohormonal agents to try to address this problem, because this is one of the most important triggers that leads to development of that works on this changed or altered electrophysiological substrate, and then that leads to arrhythmia. And adrenergic stimulation is one of the very important things among it. Also, you know, if you think of why some people suddenly develop, it is many of them, the precipitating factor is electrolyte disturbance, especially potassium hypokalemia is one important substrate, and obviously in these heart failure patients already on diuretic therapy, this can happen in between, and therefore it is one of the most commonest triggers of developing sudden cardiac arrest. But in serious cases, there is also this cardiorenal interactions that can lead to this development of sudden cardiac arrest. But as I said before as well, I think the first thing, and this may be called the first hit, is the basic genetic predisposition to development of the arrhythmia, which gets acted upon by the other things, and then finally environmental factors provide the final trigger for development of sudden cardiac arrest. And this was for those with reduced ejection fraction. For preserved ejection fraction, it is a bit more complex. It could be because of structural remodeling, electrical remodeling, genetic characteristics, and autonomic dysfunction, and it can lead to these kind of problems. Now, coming to the treatment of, or basically we can't treat, or we have to treat it symptomatically, but prevention of sudden cardiac arrest, the way to do it is the electrical way, and ICDs remain the first choice. And in some select cases, we may even go for CRT-D devices. But there is a lot of now data coming from that if you do guideline-directed medical therapy, you can significantly bring down the risk of sudden cardiac arrest as well. And this particular shows the mechanisms of how these guideline-directed medical therapy can bring down the risk of sudden cardiac arrest. Many of them are, as you can see, anti-fibrotic. Some of them are anti-adrenergic and anti-apoptotic as well. Especially beta blockers, you can see, have got 4 mechanisms of reduction of sudden cardiac arrest: anti-adrenergic, anti-fibrotic, decreasing in hypertrophy, and anti-apoptotic. And that is why it is not surprising that beta blockers are some of the most effective agents in prevention of sudden cardiac death. Nearly 40% reduction in sudden cardiac, or more than 40% reduction with beta blockers. In HF, preserved ejection fraction, also remember that the risk, though lower, of sudden cardiac arrest still is there. About 25% die of sudden cardiac arrest. And in these cases, I would say that electrophysiological study can help identify some of the people who would have this and can benefit. Now, I think these were some of the complex issues. Very sick patients where ICDs are contraindicated. Still, in those cases, if they remain, they are candidates for transplantations, they can be considered for ICD. If we are thinking of discharging them, if they remain in hospital, obviously, we have other modes. But if we are planning discharge, then ICD can still be given. Also, people on LVADs, they are at particularly higher risk of developing sudden cardiac arrest. While we would take care of their hemodynamic worsening, but sudden cardiac death risk increases for several reasons. And now the time is up, so I will not go into details. But here again, there is need for thing. And also, even after transplantation, in many cases, there could be a risk of sudden cardiac death because of these things: severe allograft vasculopathy and unexplained syncope. So these are some of the indications of ICD even in these patients. Some data with some newer implantable electronic devices, and we have to wait for their final confirmation whether they can be used. So I think I will just go to conclusions, and I would like to conclude that patients with heart failure have about 6 to 9 times the risk of developing sudden cardiac arrest. Out of all the deaths in heart failure, about 50% are because of sudden cardiac death. The risk is present both in those with reduced ejection fraction and preserved ejection fraction, and the risk happens irrespective of the etiology of heart failure. Interestingly, the risk of sudden cardiac arrest declines with the passing year. So if you come across a person who has already survived, let us say 5 years, 6 years after developing heart failure, and he is now asking whether I should go for ICD, maybe you have to think twice, and maybe he can be managed well with just guideline-directed medical therapy. This is just a suggestion, but of course, in the interest of patient, anything can be decided. But as I said, they can be of 4 types. And finally, as I said, genetic predisposition is some of the important things. guideline-directed medical therapy, especially beta blockers, ACE inhibitors, ARBs, ARNI, and mineralocorticoid receptors, not only improve the heart failure hemodynamics, but they also decrease the risk of sudden cardiac arrest. ICD is of course treatment of choice, especially if there are high risk for developing sudden cardiac arrest, those waiting for cardiac transplant outside hospital, those on ventricular assist devices, and select cases of post-cardiac transplantation as well. And CRT may be considered as and when appropriate. Thank you so much for your kind attention.
Thank you, Dr. Sandeep, for a very elegant overview of sudden cardiac death in heart failure. You brought about a very important message. I think if you look at the scenario of heart failure, it's actually the milder forms of heart failure which have more propensity for sudden cardiac arrest.
Because they are unlikely to develop progressive heart failure.
And quite paradoxically, when you, if you look at your clinical practice, as the LV function goes down, and particularly reduced ejection fraction, majority of the patients who receive an ICD are fairly very late in the stage of the disease. And it's really questionable whether it really prevents a sudden cardiac arrest, because ultimately they all end up die of systole. They're not purely an arrhythmia. So do you think there is a paradox there? And so in a secondary prophylaxis, let's say a preventive measure, it's understandable that you put in an ICD. But as a primary preventive strategy, is it worthwhile spending so much money for these patients, or the therapy of beta blockers and all these guideline directed would really suffice there? Your comments?
I think you're right, Dr. Jayagopal, and there is now a lot of papers actually rethinking on the need for ICD, especially people who are down the, many years down the line having heart failure. And people are indeed recommending that some of these people might be managed very well with just guideline-directed medical therapy. Because the most important cause of death in them is progressive heart failure and hemodynamic collapse rather than sudden cardiac arrest. Sudden cardiac arrest is more common when mild heart failure, where risk of hemodynamic collapse is not that much. So there obviously, sudden cardiac arrest becomes the more important contributor, and there for those fitter people and healthier people, the ICD may be a good idea. But those down the course, probably, unless they are going for cardiac transplantation and they are out of hospital, so those cases you might consider ICD. Otherwise, very sick people, ICDs are not. Dr. Ambuj, I think.
Thank you, Dr. Mishra. As always, an excellent explanatory talk. As you said, we often forget that guideline-directed medical therapy has clearly shown to reduce 44% chances of SCD over the years from rails.
Just beta blocker shows 40% or more.
From rails to paradigm, if you see. And probably that was the reason why Danish was negative when you did ICD and non-ischemic heart. But my question is a little different. We've pegged ICD indications on heart ejection fraction alone. Do you think that there are other evolving markers which could determine SCD in the future, the risks of SCD beyond ejection fraction?
This is a very interesting area, as you rightly mentioned, and that is why I also brought out the other point, the genetic abnormalities. So, same patient, same kind of patient, somebody develops sudden cardiac arrest, somebody does not develop. So what are the things, what are the markers that decide which one is going to develop? And this is especially relevant even more in cases of preserved ejection fraction. Fortunately, there some electrophysiological markers are existent, which if present, you can predict that these people with preserved ejection fraction are more likely to develop sudden cardiac arrest. But I think this is a very important work that requires to be done, and identifying those genetic abnormalities, identifying those electrophysiological substrates that can predict that, okay, this person, although down the line can still develop sudden cardiac arrest and may still benefit a huge way from ICD therapy.
Something like imaging fibrosis on cardiac MRI is coming up. So
myocardial fibrosis.
Any other question from the audience? We have about 5 minutes.
If there are no, I think we're getting signal from the organizers that its time is up. So thank you very much, Dr. Sandeep Mishra. I think let me take this opportunity to thank the organizers for having us.
Housekeeping is that we are absolutely on time. Actually, 15 minutes we are ahead of time.
Yeah, I
But
think that time is till 2
yeah,
p.m.
So this 15 minutes, we would like to have some time for the rearrangement of the hall. So you can continue your discussion, and the hotel people will inconvenience you a little bit by rearranging the hall. So you had food, so rather than loitering outside, it's better to have scientific food along with the Taj food. Thank you very much. So if you can continue discussion, they're all eminent people here.
So I think there's one final question to you.
I think, yeah, sorry?
Yeah, one more question to you.
Okay.
See, time and again, we see patients with a very low ejection fraction who are ideal candidates for a CRT. And since the EF is low, many people are recommended a CRT D in addition. But over the period of time, when in these patients, their ejection fraction improves, the same question which was from 30, it becomes 40, 45, they're good responders, real responders. And then the question comes whether a defibrillator was really indicated in this patient. So I think, is there any way that you can make out? I mean, you're wiser after your therapy, but then, but these are important things, thinking of the cost constraints in the country, and I think, is it a fair trial of beta blockers the right way to go about?
Yeah, I think, Dr. Jay Gopal, there are a couple of some related issues to this as well. The cutoff point is 35% ejection fraction or lower. And most of the people who get ICD, you would say, are exactly like 34, 35. So we really have a question, because this is a subjective, most of the cases. Whether it's really 35% is, I think, something people can think about. And, so I think we need to have specific kind of things or objective assessment of the ejection fraction, because at this particular thing, if it is 40, then people can read as 35 as well, some people. But so that is another issue I wanted to bring. But otherwise, I think this is a well-known fact, and we really need to know markers of sudden cardiac arrest, so irrespective of ejection fraction. So if we have those markers on board, and we have clear-cut markers, then we can come out with some kind of score, like major criteria, minor criteria, score kind of thing, where we can actually put in those things, and then we can come out with a score. So I think this is some work in progress.
Thank you so much. I think really appreciate your talk. Thank you once again. Thank you.
Thank you, moderators and the panel members, for emphasizing the management of heart failure. Thank you, sir. There will be a short break to rearrange the hall. We will resume here by 2 o'clock. Thank you. We all can resume here in 10 minutes. Thank you.
Good afternoon, everybody. I think we had a small break, and usual thing has happened. After the break, it's difficult for people to come back in. So I invite the moderators, Dr. Amudan, Dr. Sanjay Mittal, Dr. Prakash Jain, to start the session and take it forward. Thank you very much.
Good afternoon to you all. So after a short break, we are back here, and we are going to discuss a very important topics in this session on markers, biomarkers on heart failure. And we have three eminent speakers here. Dr. D. Prabhakar, is he here? Yeah. So he is going to initiate the meeting on natriuretic peptides in heart failure.
Thank you, sir. At the outset, let me thank Dr. Abraham Uman and the organizing committee for giving me an opportunity to be here. Like Uman said, a break gives a break. A lot of people have taken the break and left. But let's get on with people who are interested. I shall be occupying you over the next 10 minutes over natriuretic peptides, the current scenario, and what's the future hold. And the story of natriuretic peptides started in 1983 when ANP was detected, and ANP secretion was found to be in very negligible amounts, but elevated in LVH. Then BNP came because brain came in because the original source was the pig's brain. And then they found out that it was in a very large amount in the ventricles, and then the CNP and the DNP were also detected, which act on the peripheral vasculature and the atria. The mechanism of action, I just want to tell you 2 points in this. That is going to be, give me 1 second on this. Yeah. So there are only 2 points in this. We are more interested in BNP and anti-pro-BNP. The pro-BNP is secreted with wall stretch whenever there is increased filling pressure. That is cleaved into the inactive anti-pro-BNP and the active circulating BNP. Now the anti-pro-BNP stays for a longer time, it's inactive, and the circulating BNP is cleared either by the NPR, the natriuretic peptide receptor C, or it can be removed by the endopeptidase. All of us know the neprilysin and the neprilysin inhibition that happens. Renal filtration can also remove it. So this is how the clearance happens. What do the receptors do? The basic NPRA is where the ANP and the BNP get bound to. The B actually binds only to the C-reactive, C-N natriuretic peptide, and the type C is mainly meant for clearance. So in clinical parlance, what happens? So when these are secreted in response to elevated filling pressures, the atrial natriuretic peptide has the shortest half-life, stays for about 2 minutes. The BNP stays for about 20 minutes, but the anti-pro-BNP stays longer, up to 120 minutes. I will not go much into the genesis of this particular slide, but I'll just tell you the CNS actions and the renal actions are by NPRA receptors, and the rest of the actions are very complex. If I go into this, I won't be able to tell you anything else for the next 10 minutes. So I will just skip this particular slide and then go ahead and tell you where do we stand in clinical practice today. Today what we see is that the entire scenario of management of heart failure, the diagnosis of heart failure is based on the natriuretic peptide. Look, say once you assess clinically, you try to do a natriuretic peptide which could be the anti-pro-BNP or a BNP, and everything else seems to be going after. This is the American version. In India, we don't do much of this because echo seems to be cheaper than doing an anti-pro-BNP or a BNP. That's one reason why we don't see. But according to the literature, this is what happens. So it seems to be fairly simple molecule, simple test to be done for everybody with heart failure. But in a day when you are not having any problems, be sure that you're traveling the wrong path. This is what Dr. Swami Vivekananda said. And the same problem is cropping up with the BNP system also. But the first question that asks is, every hospital wants to know whether to do the BNP or the anti-pro-BNP. What is the difference? the NT-proBNP is more stable and it stays for a longer time at room temperature. The NT-proBNP is stable for about 72 hours, but the BNP has to be done within 4 hours. So if you're going to look at a test where the lab reports are going to be delayed, NT-proBNP gives you better results. And there are several non-cardiac causes for elevation of the NT-proBNP and the BNP system. You have to remember that advancing age, anemia, renal failure, pulmonary disorders, pulmonary embolism, critical illness, sepsis, because most common references, they see a patient with breathlessness in the ICU with sepsis, they tell you BNP is elevated. That's a very common thing, but sepsis itself can increase your levels. But what we should be aware of is, if there is heart failure, there is an entity wherein you have lower than expected levels. Now, which condition is that? The obesity, flash pulmonary edema, burnt out heart failure, upstream heart failure like mitral stenosis or an acute MR, where the ventricle is all right, the cardiac tamponade and constriction, you have to remember that. What is the reference value? In an ambulatory setting, it is very clear, 50 and 125. But in an acute setting, you have to look at confounders, especially the age. As age advances, your cutoff values are different for NT-proBNP, but not for BNP. BNP is the same at 400. And we have been talking so much about the 4 pillars of management of heart failure. Ujay Jadhav made a Dr. Jadhav made a case for the 4 pillars of management also. And what do these 4 pillars do to the natriuretic peptides? When you give beta blockers, initially there is an increase in the level of the NT-proBNP or the BNP. You must remember, if you start beta blockers and check the BNP levels, it is going to get elevated. You must remember it in clinical practice. It doesn't mean that the patient is behaving adversely. It is unrelated to the clinical status, but it can go transiently. Remember it when you interpret these patients. The next question is about ARNI and the neuropeptide axis. When you start giving the ARNI, there is a decrease in the NT-proBNP levels, but increase in BNP because the BNP clearance is reduced. We already saw that the endopeptidase neprilysin is responsible for removal of the BNP. So that is also important, but clinically, it does not affect the diagnostic accuracy and it is independent of that. So it seems to be having equal efficacy in prognosticating these patients. And whenever there is an alteration, it also correlates with the echocardiographic parameters. And for the record, ANP levels also increase with ARNI therapy. That also is seen in clinical practice. Now, there have been several studies showing prognostic and different times what happens to these levels. This is the original paradigm trial, wherein initially there is a reduction when you give sacubitril valsartan and subsequently it stays put, whereas there is an increase when you start giving enalapril. There is not much of a change in these group of patients, and even the transition trials showed that there is a significant reduction. Whenever there is a significant reduction on treatment, then the BNP levels are coming down. It seems to be translating into good overall efficacy. The favorable response, they defined a little differently there. They said that if your NT-proBNP is defined as reduction less than 1000, or if it is going to be a more than 30% reduction, it was significantly reduced. Now, what happens if you do serial NT-proBNPs? Now, serial natriuretic peptides, if you do, the one good point that seems to be happening is you seem to be titrating your drugs better. Your patients seem to be getting much higher dosage of drugs. And the longer the duration of lower levels of BNP, the patients seem to be faring better. So there is some advantage in that. But when you looked at mortality, it didn't show significant benefits. And there is a big mixture of negative trials and positive trials with BNP serially being measured. So then the last word is not yet said. So we go back and start looking at, can we predict heart failure with these trials? Now, 2 significant trials came up. One is the STOP Heart Failure trial. This is a very interesting trial. Patients more than 40 years of age and having any of the risk factors, common risk factors, and known LV dysfunction was excluded. So when they tried looking at a BNP level more than 50, those patients, they put them on aggressive treatment and they found out that subsequent onset of heart failure was less. Similar result they also found with serial measurements in patients with diabetes. They found out that if you look at NT-proBNP, the increase seems to precede the onset of clinical heart failure. So in clinical practice, the risk factors of heart failure, if you look at 50 and 125 for NT-proBNP. Ambulatory, 30% rise or a 30% fall seems to be showing that there is a significant problem. I think this is a simpler way of doing it. When it comes to heart failure with preserved ejection fraction, there's a lot of confusion and mixture there. Though it goes up in an acute episode of heart failure with preserved ejection fraction, it is only classified as additional diagnostic criteria. You don't need to have elevated NT-proBNP or a BNP to diagnose heart failure with preserved ejection fraction. It's very important. But higher the value, poorer the prognosis. Even 4 times more worse prognosis has been mentioned. And if you look at an NT-proBNP based criteria, TopCat trial was discussed, they said it's not useful. But if you look at NT-proBNP as an enrollment criteria, those with an enrolled value of more than significant 1000 value, they found out that these patients benefited. So if you look at NT-proBNP elevation, MRAs are going to be beneficial. Now, similar reductions in NT-proBNP have been found out in the Paragon trial also. And if you look at the H2FpEF score, you will see that several parameters were studied, and in the final write-up, the NT-proBNP doesn't figure. Most of the patients had NT-proBNP levels that are not very high in heart failure with preserved ejection fraction. If you look at why this happens, because most of these patients were also obese. In obesity, there is a paradoxical reduction, and this paradoxical reduction has been studied, and a putative mechanism has also been mentioned, wherein they say with obesity, there is an increase in pro-inflammatory cytokines, there is a reduction in the NPRA receptor, and there is an increase in the C receptor, which removes the BNP. So the BNP levels are falsely low in these patients. So this is one proposed mechanism. But it is also included in the HFpEF score, where you have values of more than 80 of BNP or a 240 in the presence of atrial fibrillation, or NT-proBNP of 125 and 660 for diagnosis of major and minor criteria are all mentioned. I will not go into this, I still have only about half a minute left. Now, the newer thing that is happening is, using NT-proBNP and BNP concentration, you also find out that there is an increased event rate. So all the studies that they did with NT-proBNP as inclusion criteria had better results. So if you are planning to do a study, probably you should do this. So what is new, what is coming up in future? Three things are coming up. The C-type natriuretic peptide is coming in. It is not very, very specific, but if it is high, it seems to be really showing that there is going to be an adverse outcome. It is not elevated always. Only 23% have elevated CNP levels. 24% despite acute decompensated heart failure at normal levels, but it predicted adverse outcome whenever the values are high. The next thing that happens is, when you have a summary of patients, the new treatment that is coming up is a combined inhibition of neprilysin and phosphodiesterase inhibitors. I will not go much into this, but phosphodiesterase inhibitors, the common thing that we all know is the sildenafil or the Viagra. These are some of the drugs that can be combined. And the newer thing about, the other thing about ANP is the mid-range pro-ANP. Now, this is found to be a marker for AF-related stroke. So in stroke patients, instead of doing an extended monitoring, this probably will take over, and we will be seeing more of this in the future. So final conclusion, in an ambulatory setting, dyspnea of unknown origin, it has incremental diagnostic value, we know the values. In known heart failure, higher value, higher short and long-term outcomes, incremental prognosis value. And in STOP heart failure trial, there is a case for checking all patients at high risk for heart failure. You look at the BNP levels. If it's more than 50, aggressively treat them. You're going to postpone heart failure. This is probably applicable to most of the diabetic patients. Pre-discharge BNP and NT-proBNP probably has the most prognostic value rather than diagnostic. So at that, I'll say thank you to the organizers, and I will close my talk. Thank you so much.
Thank you, Dr. Prabhakar. My only question is, very frequently we see in elderly false negative results. How do you manage that cases? And what is the mechanism involved?
Sir, false negative, you mean low values?
Low values, especially in the elderly.
So I gave you a slide about
values.
I gave you a slide about 4 causes. One is these burnt out heart failures. 2 is these backstream heart failures, where you have an acute MR. 3 is the obesity. The most common thing is obesity. In obese patients, it is very unreliable factor, and you really don't have to rely on NT-proBNP or a BNP for diagnosis of heart failure. Heart failure is a clinical diagnosis, and you can also make a diagnosis of heart failure with your echocardiography, elevated pressures also. I shouldn't tell you about this, you have to tell me about the echocardiograph.
One question which I have is that what is the prognostic value of sequential NT-proBNP measurements, and do you recommend in follow-ups to be checked?
So there is 2 conflicting data. There are good negative results and good positive results. But as of now, if your values are coming down, those patients seem to be doing better. But there are some trials which have clearly shown that it is not beneficial in terms of long-term outcome. But in clinical practice, there was one trial which I had shown, wherein it has clearly shown, if you follow up serially and the NT-proBNP values are high, you tend to put patients on better drugs. The treatment seems to be better. The dose escalation seems to be better. So in that way, it is beneficial. But long term, to look at the value serially, 30% elevation or 30% reduction seem to be good. But I think the last word on that is not yet out.
Dr. Hazra.
Yeah, a nice talk. In the Verisugar trial, the BNP benefit, the benefit of Verisugar stops exactly at 8,000. The mean was 5,400. If you have more pro-BNP rise, that means you need some more drugs. But why the Verisugar, the benefit stops at 8,000 pro-BNP level?
You have to answer that. I don't know, sir. Dr. Hazra is the boss for that.
So, I think why this 8,000 was that, Dr. Hazra, I think what happened was that these people who had BNP more than 8,000, despite optical medical treatment, they were too far gone. So there has to be a limit, beyond a limit, nothing is going to work. So that was a marker. As far as NT-proBNP in hospitalized patients is concerned, if you have reduced it by 30% at the time of discharge, you have done a good job. If despite your optimal medical treatment, NT-proBNP still continue to be high, when you are following up these patients and you have done everything that you can, it basically indicates that these people have a poorer prognosis.
Persistently elevated levels, they have poorer prognosis.
Yes.
But serial follow-up, they're still not. This is the slide about the last 4 points that I gave is actually from the 2022 European, the American guidelines. So they still do not recommend it on a routine basis. But what you say on prognosis is accepted, sir.
Thank you, Dr. Prabhakar. I think we'll go on to the second talk. The second biomarker we are going to hear from Dr. Jayagopal is troponins in heart failure.
Good afternoon, everyone. You just heard about the use of the BNP and pro-BNP in heart failure. So my job here is to discuss about the troponins in heart failure. Now, all of us know that this is a robust prognostic marker in various cardiovascular diseases, more so in the acute coronary syndrome. It's released by the myocytes during an ischemia or hypoxemia, and even in microvascular dysfunction. Sometimes, you find normal coronaries, but the troponins go up. And the prognostic values, there's been known over a period of time, even in heart failure, that even a low rise has been as early as the 2007. And then people have tried to correlate with a lot of structural abnormalities as well as the diastolic dysfunction. Now, I would like to discuss this in two settings. One is in an acute heart failure scenario, and the second is chronic, because these are totally different pictures altogether. Now, when you have this is actually a real life patient. When you have a patient like this, for example, a 75-year-old man, hypertensive, comes to you with an acute heart failure, you find an EKG evidence of an anterior myocardial infarction, and you find the troponin is very elevated, 1.68. This is a high sensitivity where the normal cutoff in the population is 0.014. Anything more than 0.030 is high. You're fairly certain that this man has an acute myocardial infarction. I think the importance is when you have a very highly elevated troponin, the message is it's an acute coronary syndrome, and you need to treat them the same way. You find this guy has a left main with 3 vessel disease. Now, it's also important that you recognize this high troponin because the therapy is different. You were talking about guideline-directed medical therapy. RNA is beneficial in all forms of heart failure, but not in the setting of an acute myocardial infarction. The Paradise trial. So the troponins in acute heart failure, I would say the data, if you look at it, you can have the reduced ejection fraction where we have probably more data. But in the context of a preserved ejection fraction or mid-range, there's actually not much of data. Now it tells you, for example, the scenario which I showed you, the short-term outcomes. Question is, do they need aggressive treatment and follow-up? And maybe whether they're useful as a trial. For example, very highly elevated, it's an MI, you need to really treat them accordingly, and also about the cutoff values. Now, we all talk about in acute heart failure, if it's due to an AMI, it's a type 1 MI, this typical scenario, but sometimes there is a supply-demand mismatch, what you say the type 2. Apart from that, there are a variety of other reasons which could also account for the troponin rise, like the direct toxicity of neurohormones, anemia, and so many other causes which one must be really be considering. And when you look at the studies in acute heart failure, you can see as you go down the graph, you can see the studies which are in the earlier era, before the high sensitivity troponins came in, the pickup of high elevated troponin was very limited. Whereas down below, you find that the high sensitivity, where I was talking to you, referring to the figure of more than 0.014, you see as high as 99% had an elevated troponin troponin level. So this is all based on a very low cutoff values, 0.023 and 0.013. So this is what really matters, a marginal elevation of troponin T, whether it's really a problem. Now let's go back to the data that we have. The ATTR registry, which is one of the largest data on acute decompensated heart failure, more than 100,000 patients, and out of which the troponins were measured in about 80.5%. And they had what is very clear in this, most of these studies had a troponin T. It was not the troponin I which was measured. 90% had a troponin T, and the positivity was very low, in about 13%. And when both markers were used, troponin T and I, it was found to be elevated in about 2%. And what came out of it? There's actually a printing error. The one in the top is the trop I, the cortical. As you see that the levels keep on rising, the pickup of the troponin levels, there's a significant increase in mortality. Like the same thing with the troponin T as well. And not only that, when they combined this with the use of inotropes in the ICU, those patients who had a high troponin T and the usage of inotropes, they had a much higher mortality. So essentially what I'm trying to convey is that any amount of trop T in the context of an acute decompensated heart failure can tell you that these patients have a significantly higher mortality. Not only that, a subset of these patients, they were also followed up the serial troponin levels. And you find that when there is a serial increase in the troponin levels, that actually translated in increased mortality. Well, this is almost the same which came out of the GISI and the Valsartan heart failure trial, where the one which is decreasing level down below, the one which is increasing on the top, and the stable S is in the middle. You find that when there is an increasing level of troponins, this actually translated into increased mortality. Now the question is, do we have data in the preserved ejection fraction? Now there's a paper which has come out, prognostic impact based on the ejection fraction. This was about 847 patients. Well, acute AMI was totally excluded in this group. They looked at the 30-day mortality prediction of the outcome of these patients. And what they found was very interesting. Now what you see in red is a dead patient. So the moment you had a high sensitivity troponin T, there was an excess mortality, and that was mostly in the mid-range and the reduced ejection fraction. In other words, this did not convey any information to the preserved ejection fraction. But the more important than that is, you try to combine this with other markers like the NT-proBNP, which you had talked about in the soluble STs and things like that. This actually would tell you that these patients are prone for excess mortality. Now the question is about the other group. What about chronic heart failure, which has really not been tested well, though you have a variety of data available. Again, the same thing, mostly the troponin T has been measured here. And as you see in the latest reports, where the high sensitivity has been studied, about high sensitivity, 92% had an elevated trop T. And there's actually, we have to pull up, derive the data from some studies. For example, Evaluate trial with the usage of RNA basically wanted to look at the aortic stiffness. And these patients have subset of this when they were followed up for 12 weeks. They primarily looked at the aortic stiffness and also the three markers, NT-proBNP and the trop T. And what they found is there was a reduction in the LV mass. As you see in the picture below, the reduction in trop T over 24 weeks correlated with the reduction in LV mass and aortic stiffness. And the subset from the heart failure with Emperor reduced trial, this is again a fairly larger data, 3,636 patients. The increased trop T was associated with increase of diabetes, atrial fibrillation, class 3 symptoms, previous heart failure, and again worse renal and cardiac outcomes. So again, and the values here tested was only very, very small values, like more than 14. When you talk about the preserved data, the Emperor preserved, again, mostly the same thing. They had about 90% had a trop T, 97% had a trop T tested in this group out of the 5,986 patients. And they found a 2 to 5-fold increase in mortality, heart failure for hospitalization, as well as events. And these patients were actually, being a preserved ejection fraction, had more comorbidities. So the final meta-analysis on this group in chronic heart failure, there are about 10 studies on more than 9,289 patients, out of which the ischemic variety was only about 60%, the LV ejection was less than 40. And what they found was interesting here. Here they were able to come out with the data that if you look at the troponin levels and have 18 nanogram, 0.018, which would pass it as a normal variant up to 0.030, whether it's the ischemic group or the non-ischemic group, in both groups, a higher than more than 18 nanogram had excess mortality. So that is a kind of prognostic impact that troponin T could give you even in the chronic heart failure group. And not only that, if you try to combine this with other variables, for example, the sex, the age, the ejection fraction, lower the ejection fraction, the type of heart failure, and also the EGFR and BNP, and if you're able to correlate with all these things, and then this has got an additional incremental value. Again,
a value of more than 18 nanograms seem to be telling you that these people have worse outcomes. So I think the message is very clear. Any amount of elevation more than 18 nanogram in a chronic heart failure is perhaps to be really worried about. So I think, is it the future? So, I mean, is it mandatory for you to, I think it will be an add-on in terms of getting additional data. I just wanted to bring in one of our own colleagues' publication. This is actually something thought-provoking, the troponin assay just by a dermal, just do a scan, just like you have your temperature recorded. If you are able to do it in the years to come, or maybe in the days to come, it may not be far away that we get to see this. You find the troponin assay. Well, this has been studied in acute coronary syndrome, seem to correlate very well with the blood levels. So I think a non-invasive method of measuring the troponin might be the future. We don't know. I think I must really congratulate Dr. Sengupta. I'm sure he is here in the audience for this wonderful work. Just got published. And I would also like to tell you that what are the recommendations used. So to sum it up, I would say interpretation of a troponin T first and foremost is in the context of a clinical condition. Dr. Prabhava was telling you that the NT-proBNP can be elevated in many conditions. Likewise, troponins can also be elevated in many conditions. In fact, the medical office these days, they come to you, somebody has chest pain, they have some vague discomfort, the troponin is elevated, shall I lift to the cath lab? It's not that. I think in heart failure also, there are a variety of conditions, uremia, infection, sepsis, so many other things which can also increase. It's encouraging that it should be encouraged when there is a need for additional risk stratification. The patient has a high BNP, even in chronic heart failure. An incremental contribution risk assessment along with the biomarkers, I think that's where it stands today. Persistent elevation of troponin, even in stage B. In fact, this is supposed to be one of the forerunners for developing heart failure. So I think it's maybe a good thing to look at it. But then it being an expensive test, I don't know whether it can be really routinely used in general population. In acute heart failure, I told you, most important thing is rule out an acute MI because the treatment is different. Again, RNA is not the treatment to be given in heart failure due to AMI, at least the initial few months. And it's again a wide range of EF, just as I showed you, whether it's reduced ejection fraction, mid-range or elevated, troponin elevation tells you that these are patients who are prone for adverse outcomes. Thank you all for the kind attention.
Thank you, sir, for your great talk. My only question is, when the patient comes, which test do you order, TROP-I or TROP-T or high sensitivity TROP-I?
Yeah, see, in an acute coronary syndrome, I think both are equally effective. The only advantage with troponin, most of the studies have done with troponin T, I don't know for what reason, but the moment you have a chronic kidney disease, the troponin T may not be the test, TROP-I will be the preferable one. But otherwise, both are, today we have the high sensitivity troponin T and there's nothing to choose between the two. Whatever is available in a hospital, high sensitivity troponin T, anything more than 0.014 is supposed to be very sensitive, but they're not very specific. That's the answer. But then troponin I, in both scenarios, even if you have a chronic kidney disease, could be. Now that we have the 4th generation TROP-I as well, so both could be used.
Yeah, so it's very easy to basically discuss about when we have acute coronary syndromes and what is the role of troponin T. But when a person presents in acute emergencies and all, how to actually go ahead with the rising trends or decreasing trends, that's something which you could clarify upon the diagnosis part of it.
Yeah, I think so. Somebody comes to you with an acute decompensated heart failure, again, the clinical suspicion that this guy has an acute coronary syndrome as a major issue there. I think a very highly elevated troponin T, anything more than 1, I would say more than 1.2 TROP-T, high sensitivity is supposed to tell you it's a huge MI. So I think that's the first message. If you have a very highly elevated troponin, that's often an indication for ACS. You need to stabilize and study this patient. Even in a country like US, 30% of heart failure patients do not get a coronary angiogram. So I think it's important that you don't miss because these are treatable causes. Whereas if you find a marginally elevated, let's say the general population 0.014, you up to 0.030 is acceptable, but you find something like a 0.023 in a heart failure. Well, these tells you along with the additional markers that the adverse events may be more. You don't have to be in a hurry to really search for the coronary angios and look for any lesions there. Treat the heart failure with a guideline-directed therapy, and that's the way to go about.
And sequential. The other thing is, when a person is presenting to the acute emergency, we do not know the previous history. In my opinion, I use troponin I much more frequently because later on, if you recognize that the person was carrying a diagnosis of CKD, which the person may not be knowing, that's a dilemma which we can avoid by using troponin I.
Yeah, that's an advantage. CKD troponin I is the preferred biomarker.
Yes, please.
Yeah, the biomarker is a D-dimer. So if you have so in fact, it's a standard practice. Sometimes, you tend to miss it, and sometimes you mistake it for a coronary artery disease and acute MI. So the only troponin may not be elevated. The one marker which could go up is a D-dimer there. So all the aortic syndromes, in fact, even for the venous as well. So this is sort of a screening test which you could use. But the other problem is that if you have in addition, sometimes the NT-proBNP can also go up, because these people develop torrential AR also. So it's also likely that it could go up. But the troponins are generally normal in this scenario. In fact, I had recently a lady, 44-year-old, exactly the same picture, came with 5 millimeter ST depression in the EKG all over. In fact, my cardiologist, my colleague, took him to the cath lab. And then, this lady was unable to lie down. Troponin was negative. And then he called me because he could not take the left shoot. The right he could manage, left could not be taken. He did a dissection, cross aortic, ascending aortic dissection, and then the whole family, they had 4 brothers, all 4 had aortic dissection. So I think the D-dimer is very high. So I think the message is always a D-dimer if you want really from a blood sample.
Sir. Patients coming with acute heart failure and a certain level of troponin, whatever you want, and now you say that this is acute heart failure because of acute coronary syndrome. Most people means not all learned people who think that this is all because of acute heart. We usually in a day or two do an angiogram, find a borderline lesion and put a stent actually, and think that ischemic heart disease was the cause of acute decompensated heart failure, which of course usually it is wrong. So we need to have some stronger kind of information other than a troponin rise or fall or whatever level you want to say, or something else to decide that in a patient who comes with acute heart failure or acute decompensated heart failure, we should be clear that this is acute coronary syndrome as the cause, and not this there is hypertroponemia because of heart failure itself.
Yeah, I get your point very clear, sir. I think it's not justifiable to, in a patient who comes to you with a heart failure, you have a global LV dysfunction, you find a 50 or 60%. It's not really. So I think it's a total clinical picture is very important. And I would also think that these are candidates. I would be aggressive in getting probably an imaging done, an MRI or things like that, to even to look for other causes. So I think the issue that, whether that single lesion is a prime cause for doesn't really come out. The kind of scenario that you were talking about, I would be hesitant in doing any intervention for this.
I end up seeing actually every month a score of such patients who turn up, and I think we are doing a big disservice to these patients.
100%, sir.
Many of the people develop AKI because of our foolishness, and they don't benefit from putting a stent in a borderline lesion, which you think is the cause, which actually is not a cause, unless of course it is a thrombus containing lesion, which may have been the cause.
Well, I fully agree with you. I think we need to be more prudent and then take a decision based on the entire clinical picture.
But the counter side of that is that if a person presents in emergency with acute heart failure and the troponin I is elevated, what to do at that moment? Because if the tropa is elevated, the first diagnosis could be ischemic heart disease, which could be reversible, and the person may be landing up in an MI. So doing an angiogram is that much more important, that thing. And not doing an angiogram may actually eventually land up the person having majority of times having a major MI, which was not timely acted upon.
No, but I think the answer to that is it will also be related to the level of troponin rise. If that is a reason for the heart failure, if that coronary lesion, it should reach a significant increase, like the case I showed you. It should have a significant rise of troponin. Otherwise, I don't think it's justifiable to probably.
But I think any level of troponin does not differentiate the two. Let me be very clear. I'm a clinician. I see this patient every single day. You have to combine everything: troponin, the history part, the echo part,
yeah,
the ECG part, and then come to some kind of conclusion. Unfortunate thing is that we are relying only on troponin to decide.
Sir, can I add a point to that? Actually, in an ACS, when the troponin is elevated and the BNP levels, natriuretic peptide are elevated, it clearly means a poor prognosis. And interpretation of the troponins is very, very tricky in an ACS. HS troponin is being used. HS troponin has a cutoff value. Basically, what is HS troponin? Highly sensitive below the conventional levels. So if it is more than 0.5 with a single value, it is significant. It is not 0.014, 0.14. And if you have a kit in your hospital, please check the kit in the hospital for what is detectable range. Once it is detectable, even in normal people, it can be detectable, and it is now being used as a risk factor for assessment of risk for coronary artery disease. So significant change is going to be 5 between 0 and 1 hour. The biggest advantage of HS troponin has been you can send out the patients, you don't have to wait for 6 hours. So I think the interpretation what Dr.
No, but you're talking about ACS.
ACS, correct.
No,
I'm
but
coming to that.
we are talking about heart failure.
Exactly, sir.
That cutoff is 18, which has come out with the data. And
no, that I agree, sir.
Yeah,
that's what I'm telling. So 18 cutoff for what Dr. Jayagopal says, that's what I'm coming to. 18 cutoff does not apply for ACS.
No,
that is different.
There are studies even in the general population, as you said, the 99 percentile is 0.014 for a healthy individual. It can go up to 0.030. But then even in general population, we have data to suggest that anything which goes up carries a future, chance of having higher future events. So I think these are all in the gray zones. But I think the message I wanted to convey is any level of troponin T has a significance in terms of outcomes.
Thank you, Dr. Grover. I think this discussion can go on and on because 100% surety could never have, but I agree that clinical judgment is the most important thing for a final decision. So let's go on to the final talk. Dr. Dinesh Chaudhary, and he's going to talk on newer biomarkers in heart failure.
Thanks to organizers to give me opportunity for that talk. So thanks to my previous speakers, which have discussed pro-BNP and troponins, which are very well established markers in heart failures. The newer biomarkers are more of theoretical values. There are so many data, so many biomarkers for which in present scenarios, no validated tests are available, and in various studies they are discussed, but because they are not cardiac specific, most of them are not cardiac specific, so they are not used as diagnostic purpose. But in addition to these two biomarkers, they can be used for the prognosis and risk stratifications. So for ideal biomarkers, results should be reliable, readily available, and easy to interpret. Established biomarkers, as I told, are BNP and highly sensitive cardiac troponins, which are very useful to exclude the heart failure, but may not necessarily improve the diagnosis or treatment. I will be discussing these few biomarkers, which I could understand that these can be useful in future. One, BNP and anti-pro-BNP are mainly released with myocardial stress. Troponins are suggestive of myocyte injuries. Some of them are causing myocardial fibrosis and remodeling, and some of them are increased in inflammations. Some are increased in renal dysfunctions, and pro-adrenomedulin are vascular because of vascular activations, and some of them are due to oxidative stress. So cardiac specific is highly sensitive troponins, which is very well discussed in the last talk. I will not go into the details. We will be discussing non-cardiac specific now, that procalcitonin. Procalcitonin is a biomarker for bacterial infections, which is having additional value for the evaluation and management of acutely distinct patient, which we have to rule out whether some superimposed bacterial infection is there or not, or it is merely a heart failure. It is released directly by endotoxins or indirectly by cytokines like IL-6. Relative change are more important than single value. It can be used for monitoring the effects. European guidelines recently published, which showed that procalcitonin may be used for the diagnosis of pneumonia, and antibiotic therapy may have an indication when plasma levels are more than 0.2 microgram per liter. There are few trials for diagnostic and prognostic importance of the procalcitonin. Beck and Pride studies were showed that it can be used for diagnosis of pneumonia in heart failure patients, but European impact trial showed that there is no improvement in PCT guided treatment. So the concept of using a combination of cardiac marker with an inflammatory markers for the very early discrimination of acute heart failure versus pneumonia would be in theory of additional value only. Cost of procalcitonin is higher than CRP and IL-6, and further studies in this scenario are still going on. There are so many kidney markers, as we know that acute heart failure is having very high incidence, around 25% of worsening renal failure, and nearly 50% of patients with chronic heart failure having GFR of less than 60. Both background kidney dysfunction and acute decrements causes a worse prognosis in heart failure. AKI is associated with the doubling of mortality at 1 year. There are many markers, mainly kidney cellular damage markers like kidney injury molecule 1, NGAL, IL-18. They might facilitate earlier detection of AKI following ischemic and nephrotoxic kidney injury. But a kinesis study, very large study, showed that NGAL offered no advantage over serum creatinine. Then some few markers are cell cycle markers, insulin growth factor binding proteins, and tissue inhibitors of metalloproteinase type 2, TIM2, and proenkephalin along with microRNAs are the emerging markers for kidney injuries, for which there are no established tests yet. And ideally these biomarkers should reflect the cause, the mechanism, context and duration of the renal insult. Rigorous assessment of novel candidate marker is still awaited. It is critical to detect the development of kidney injury very early and to implement renoprotective measures as early as possible. Then cystatin C, it is a cystatin C is a cysteine protease inhibitor that functions within the human vascular system. It mostly regulates cathepsins and serves as a marker of renal function. There are good validated tests available for the cystatin C. Prospective epidemiological studies shows a strong association with risk of future cardiovascular events and heart failure. But Mendelian randomization analysis showed that there is no evidence for any causal role for cardiovascular disease. But in acute heart failure, if its value is more than 1.3 milligram per liter, there is associated high mortality with this cystatin C levels. Currently, only trials devoted to this cystatin Cs are in hypertensive patients. In heart failure patients, trials are still awaited. Then there are markers for cardiac remodeling, soluble ST2, galectin-3 and growth differentiation factor 15. These are mainly associated with inflammatory disease and cardiac fibrosis. All three are useful for prognosis, but as these are not cardiac specifics, there are many sources in the blood for these markers. ST2 ligand is a membrane bound receptor for which IL-33 is the functional ligand, and both work as cardioprotective. Once soluble ST2 is released, it acts as antagonist of this signaling, and it is causes anti-hypertrophic and anti-fibrinotic mechanism which was started by IL-33. It is antagonist to this. This is very well depicted in this slide. ST2 soluble in the soluble form is causing hypertrophy, fibrosis and apoptosis. Galectin-3 is known to specifically bind beta-galactosidase, very important role in cancer and inflammations. It is a regulatory protein acting at various levels from acute to chronic inflammation and tissue fibrinogenesis. GDF15 is a protein belonging to TGF beta superfamily. It also regulates inflammatory and apoptotic pathways in acute and chronic tissue injuries in various diseases. High plasma concentration of GDF15 are correlated with disease progression and prognosis. All these three are having very good roles in prognosis, and there are many immunoassays developed in various trials. There is no value for diagnosis as source of origin is not clear, but there is good prognostic information in various trials. It was used, SST2 and galectin-3 were used as a prognostic markers as a additive role in 2017 guidelines. There are many trials. One of these trials showing soluble ST2 in acute decompensated heart failure, it predicted the death and risk restriction in comparison to other markers. These are the various trials showing biomarkers involving ST2, including heart failure with preserved ejection fractions also. It also prognosticate death risk in heart failure with preserved ejection fraction. These are the meta-analysis for these three biomarkers, which shows prognostic value in all cause cardiovascular mortality and heart failure rehospitalization. Then these comes CD146, soluble neprilysin and adrenomedulin. Neprilysin is responsible for the degradation of natriuretic peptides and angiotensin 1, 2 and bradykinins, endothelin and so many. And the heart is a likely source of this, and so many trials are there which are showing that ARNIs are causing survival benefits in the heart failure with reduced ejection fractions, but there is no survival benefit was seen in heart failure with preserved ejection fractions. This is a slide which is showing beautifully ARNI aldosterone mechanism and ARNI inhibition by this neprilysin inhibition by ARNIs. Adrenomedulin, nowadays bioactive adrenomedulin is very well target of therapy. This adresizumab as an anti-adrenomedulin antibodies for acute heart failure. This trial has been completed and there are safety data that there is no harm and it can be evaluated on further on. Then there are metabolic markers, iron deficiency, anemia, thyroid disease and thiamine deficiencies. Trials still did not support routine thiamine supplementation in the treatment of heart failure with reduced ejection fraction. Then coming to the omics, proteomics. Proteomics approach may add substantially greater informations. Mass spectrometry is the gold standard for experimental proteomics. Multiple reaction monitoring, mass spectrometry assays for several markers have been identified. So far, more than 70. One genome-wide associated study showing meta-analysis of heart failure demonstrated that 12 independent variants at 11 genomic loci are associated with the heart failure. Polygenic risk score is based on variation in multiple genetic loci and their associated weights. PRS is more data informing than the single genome associated studies, and in future this will be a very good diagnostic tool and prognostic tool in the heart failure onset and mortality. Conclusion, several biomarkers have been developed. The gold standards are natriuretic peptides and highly sensitive cardiac troponins. In order for a heart failure biomarkers to be useful, it should possess certain qualities. The method by which a novel biomarker is judged should be thorough. Assays for these novel biomarkers should be robust. The biomarker should reflect an important pathophysiological pathway. Biomarkers should give information additive to already available clinical data and lab values and should add to clinical judgment for diagnosis, prognosis and management of heart failure. So these are the few blood levels which were used in the various trials for these biomarkers. This is our newer guidelines 2022, which is giving role of only pro-BNP or BNP in the diagnosis, prognosis and risk stratifications. In 2017, troponin T or SST galectin-3 were having some recommendations, but in 2022, they have been removed. Most likely because they are not having good diagnostic assays and consistent results in the all various trials. Thank you.
What is your forecast, sir? Will any of these newer biomarkers be useful as
Sir,
that of NT-proBNP?
Actually, this soluble SST2 and galactins, which are mainly involving fibrosis and hypertrophy markers. Various trials have now detected their standardized assays also, and a few trials are going on which will be showing whether these can be used in diagnosis. All of them are in can be used in prognosis additive to these natriuretic peptides or troponins, what they are calling as a triad of biomarkers. So if they can be used, they can have good assay tests which are very cheap and can be used in general populations. These can be having very good additive value in the diagnosis.
Is there any other question from the floor?
I think what you mentioned about the metabolic and the proteomic markers, that could be a way for the future.
Yes,
We heard Sajan also mentioning about the new targets of therapy, so possibly we have to wait patiently to get a better idea about those markers. Thank you.
There are no more questions. I think this post-lunch session was very good, and let us give a big hand to all the three speakers.
Thank you, moderators and panel members, for highlighting the newer biomarkers in heart failure. Moving on to our next section on Seeing is Believing. Now we would like to call upon Dr. I. Satyamurthy, Dr. Rajeshwari Nayak, and Dr. Prabhakar to chair the session. May I request the moderators to start the proceeding? I request the speakers and the moderators to stick on to the time, please.
You really want to cover the entire HfpEF echo spectrum 10 minutes? You know, I flew down to this place, wasted my 3 days and 6 figures practice for 10 minutes.
Okay.
Please go ahead.
There seems to be 3 talks related to echocardiography. The first speaker is Dr. J.C. Mohan, who is going to speak on echo diagnosis in PEF.
Thank you, Dr. Satyamurthy. Heart failure is a neurohumorally mediated clinical syndrome of effort intolerance, reduced aerobic capacity, organ hypoperfusion, and systemic or pulmonary congestion. Failing heart has inappropriate cardiac output, elevated filling pressures, both of which can be picked up by echo Doppler, and eventually, of course, we have symptoms of dyspnea or fatigue of cardiac origin. So first thing in echo, when you talk of echo in HFpEF, you need a threshold for making a diagnosis of HFpEF, and the ejection fraction, whether estimated or by eyeballing, provides you the diagnosis to start with. So you can only diagnose HFpEF if the ejection fraction is 50% or more. But HFpEF is a heterogeneously clinical syndrome with stiffness in multiple domains of cardiovascular system. The proposed gold standard by the Mayo Clinic is in case a patient has dyspnea, ejection fraction 50% or more, structural heart disease, and has a pulmonary capillary wedge pressure of 15 millimeter or more at rest, and or a peak exercise pulmonary capillary pressure of 25 millimeter or more, that is what is heart failure with preserved ejection fraction. But the current guidelines based on echocardiography, whether Europeans or Americans, will detect only 60% of all patients with heart failure with preserved ejection fraction. So here are 2 studies from Mayo Clinic looking at the European Society of Cardiology 2019 HFpEF criteria guidelines, which have been already shown to you. And both studies have a sensitivity which is about 60%, although the later study of a larger number of 300 78 patients did show an acceptable specificity of 89%. We also would actually listen from Samir Srivastava about the role of stress diastology. The Mayo data suggests that stress diastology improves the sensitivity of diagnosing HFpEF by echo to 90%. However, the specificity comes down. So you will see many patients where the TR velocity increases, E to E prime increases, and still they are not heart failure. A 29% false positive rate on stress echo is currently unacceptable. So heart failure with preserved ejection, the cardiovascular system is a high gain system. In HFpEF, elevated filling pressures at rest are present in 50 to 60%, and rest of the patients, you can only show elevated filling pressures by stress. So the hemodynamic, first thing is you have to learn that hemodynamic phenotypes of HFpEF are those with normal resting filling pressure 40%, you would not diagnose by resting echo, okay? And you have 60% patient where filling pressure is elevated, and of these, most of them you will be diagnosed by a comprehensive echocardiographic examination. So the diagnostic algorithm does include in step 2 and step 3 echo, either at rest or during what is called stress diastology. And we did talk about these two scoring systems, and which have been discussed since morning ad nauseum, and I wouldn't be discussing them. But nevertheless, in both these scoring systems, stress diastole is needed in case scores are between 2 and 4. This is the most commonly used European Society of Cardiology algorithm, which has functional, morphological, biomarker criteria. But and this is of course the Mayo algorithm, which has only 2 echo criteria, E to E prime, and of course estimated pulmonary artery pressure, rest being clinical criteria. But whichever way you look at it, we mostly use ESC 2019 guidelines, which says that a score of 5 or more means definite HFpEF based on echo and natriuretic peptides. Pickup rate is just 60%, not more than that. And a score of 2 to 4 needs diastolic stress test or invasive testing. Regardless of whatever is the type of phenotype of heart failure, the heart failure is characterized by enlarged left atrium, changed mitral and pulmonary flow patterns, and raised pulmonary artery pressures. This is actually the American Society of Echo filling pressure guidelines, and the current data suggests that this particular algorithm has a sensitivity of only 28%. Just try to digest that thing. 28% sensitivity. So coming back to the Mayo data, and this is again looking at the ASC ESAVA criteria 2016, sensitivity is 34%, specificity 83%. The European data is better. It has a sensitivity of 60% and specificity of 75%. You are missing still a large number of patients, both sensitivity-wise and specificity-wise. The Europeans actually said, oh, we probably have a different kind of patient population. They had a Eurofilling study of 159 patients of HFpEF, simultaneous cath Doppler study, and they found a 75% sensitivity specificity. But remember, pre-test probability underlines the difference. And that is the reason why the sensitivity and specificity are all around. But in no case they are reaching above 80%. So the point number 1, a diagnosis of HFpEF is suggested if there is non-dilated LV with normal ejection fraction, concentric remodeling of left ventricle, or left ventricle hypertrophy and left atrial enlargement. That number would be present in 50% of all HFpEF which you will get. The last bulwark of heart failure is left atrium. Atrial dilatation or atrial mechanical dysfunction both are present in heart failure, and atrial dysfunction precedes atrial dilatation. So you should look for atrial dilatation. It has a sensitivity of close to 70% in a given case of heart failure, and in ESC criteria it gets 2 points in case it is more than 34 ml and 1 point if it is more 29 to 34 ml. But here is a classic example of a patient with HFpEF who has a normal left atrial volume, but the reservoir strain is 21%. Remember, the LA reservoir strain is 40%. So 40% of the patients of HFpEF will have no dilatation of the left atrium, but evidence of reduced left atrial reservoir function. Here is a classic example. The normal reservoir strain is about 40%, and here is a classic example of a patient with left atrial reservoir strain of 14%. And what is the significance? The significance is it will increase the sensitivity and specificity. If the peak atrial longitudinal strain is added to this algorithm, it will increase sensitivity and specificity by about 20%, and negative predictive value will cross 90%. Point number 3, presence of structural alteration on echocardiography supports, but absent does not exclude HFpEF. So normal looking left ventricle, left atrium, don't think it can't be HFpEF. The point number 4, always measure volumes and ejection fraction. Just don't eyeball it. Even experienced people make a mistake. So we will quickly go through. I have just 2 minutes. I don't know. The other thing is, of course, look at the left ventricle wall and the mass and the relative wall thickness. This is one of the points. The ESC criteria gives you 2 points, and in case only wall thickness of 12 millimeter more, it gives 1 point. So the other point is, of course, left ventricle global longitudinal strain. The Americans don't give it any significance, but the Europeans have given it 1 point in case the left ventricle global strain is less than 1. Obviously, it doesn't differentiate any types of heart failure. Even doesn't differentiate normal from abnormal. So for all practical purposes, you can just skip it. But keep in mind one thing, that diastolic dysfunction present only in 60% cases of HFpEF. It is a pathophysiologic puzzle, and if you are going to look at mitral valve E to E prime ratio of more than 15, that has a sensitivity of 28%. So here is an example, E to E prime ratio 27. You can be happy that the filling pressures are elevated. And of course, TR velocity, the sensitivity is abysmal. If you take 2.8, 37 to 46%, but specificity is good, so you should measure it. But the peak pulmonary artery systolic pressure is a lot of significance. The unfortunate thing is, on exercise, the good sensitivity specificity. This is all invasive. This is not echo. By echo, you wouldn't be able to get TR velocity in almost 50%, and on exercise, the TR spectrum would be incomplete in large majority of patients. So diastolic stress echo is most useful in patients with an intermediate pretest probability HFpEF, and this we are not doing it that commonly. We should be doing far more commonly than we are doing. But I want to actually, these are the last 2 slides, so give me 10 seconds extra. These are the echo parameters, sensitivity and specificity. Work from Mayo Clinic, 378 patients of HFpEF, everybody catheterized, everybody put to CPAT, everybody had an exercise test. Your E to E prime of 15 has a sensitivity of 28%, high specificity, left atrial volume sensitivity 34%, TR velocity 37%. What is surprising is, if you can do just the left atrial reservoir strain, you are not able to see it. Left atrial reservoir strain less than 24%. This meets all the criteria. This is all we can get by echo. 94% specificity and 56% sensitivity. As good as putting everything combined, including natriuretic peptide. So if you have to say one criteria, look at left atrial reservoir strain. So ladies and gentlemen, to summarize, and I hope I finish in 10 minutes, HFpEF is elephant in the room, is a pleomorphic condition. Echo Doppler techniques have modest sensitivity and specificity, but with a high negative predictive value if you include left atrial reservoir strain. Stress diastology improves sensitivity, but it lowers the specificity. And LA reservoir strain alone equals all other parameters. Thank you very much.
What kind of echo machines do you need for reservoir strain? Is it going to be applicable?
Any machine, any machine.
Aam Janta will do it?
Yeah, everybody can do it. Actually, for us, we have a portable machine, T8, it costs 12 lakh rupees only, it does LA strain very well.
The Aam Aadmi echo machine is enough.
Sir. Aam Aadmi echo machine is
That is, T8 is Aam Aadmi, 12 lakh rupees. The cost is 12 lakh rupees. It does LA strain very regular. Of course, I have all the high ends, both at home, in hospital, you name it and I have it. I get it free of cost.
So
Name it anything.
Any false positives, any false,
So
does the technique operator dependent?
The left atrial reservoir strain, actually you should do ideally, the Americans say one view is good enough, 4-chamber view. The Europeans say do it in 2 views, 2-chamber and 4-chamber. You do it 2-3 times, you will get a good idea. If you are tracing it correctly, you are there. You will get maybe 21 will become 22, nothing more than that. It won't change too much.
How is the reproducibility?
Pretty good actually. If you have a good image, if the image is not good, garbage in, garbage out.
If the patient has AF, which indices of diastolic dysfunction you usually measure or prefer to measure?
Atrial fibrillation itself, actually, if a patient has distant atrial fibrillation, it is HfpEF. You don't need an echo for that. You don't need an echo.
But you need to assess the severity of diastolic dysfunction in the form of maybe filling pressures and atrial strain, all that. So is there any parameter you would like to, consider or do not do?
There are 2 criteria which you can use: average of 5 to 10 beats E to E prime and deceleration time. Those provide a reasonably good estimate. But remember, as I said, more and more we are trying to correlate these with invasive parameters. We are realizing one thing. We created actually a utopian world about these being very accurate. They are not, they have modest sensitivity and specificity.
Thank you.
One question about your T8 machine, sir. Your T8, how do you measure your LA strain? It is only programmed to do the ventricular strain.
Just fool it.
So you just put, but will it work ulta? But it comes upside down.
Same way. Just tell you are doing LV. You actually start doing the LA.
And what about
3-point click?
What reference values does it calculate, sir? T8?
Pardon?
Reference values?
Or reference values for LA strain? They're absolutely same.
Extrapolated to people who are suffering from heart failure, really walking, they won't feel out of breath when they lie down.
So, Dr. Hajra, if you have been sent a patient with to make a diagnosis of HfpEF based on echo, if the criteria are fitting, the specificity is pretty high that this patient has HfpEF. The issue is when E to E prime is 8-9, LA volume is borderline, the other, so here if you don't want to exercise these patients, the LA strain is a pretty good idea to tell that definitely this is HfpEF. But passive leg raising, as somebody was discussing actually some time back, which increases the pulmonary volume by about 500 ml, is a pretty good way of passive diastolic stress diastology. You could also do cycling, you can also do treadmill. What we normally do is, in these patients, remember it's all also a matter of pre-test probability. If the pre-test probability is high, simple leg cycling on table itself would provide you all the information you need.
Just a small comment on the AF question, ma'am. Of all the parameters that have been, the ACCHA suggests E prime, not the E by E prime, and E prime, which is the least load dependent. So in AF patients, if you really are looking for one parameter, it's E prime. And also there are dual probes, I'm forgetting the dual terms, in which the same beat of AF, in that you can calculate the E prime and the E. So it's out of all these measures, none of them is sensitive or specific enough. But if you look for one, it's E prime.
I would join issues, will say the E prime in atrial fibrillation is completely unreliable.
So can we request delegates to postpone the discussion to later stage? Sorry for want of time. Thank you, sir. Thank you very much. we request Dr. Amudan to come over for the next talk, assessing MR in heart failure.
Good evening, my dear friends. I first of all thank Dr. Abraham Wong for inviting me to give this talk. As you know, mitral regurgitation is one of the very important factor. I first pay homage to my beloved teachers, Professor T.S. and Professor M.S. Both are not with us today. The outline shall be the causes and anatomy, mitral valve, assessment of mitral regurgitation, and how to prognosticate mitral regurgitation, and two cases. Now, the definition all of us know, the mitral regurgitation is defined as abnormal reversal of blood flow from the left ventricle to the left atrium. Now, it can be primary MR, where there is structural abnormality of the leaflets, or secondary MR, most commonly caused by LV dysfunction, which in turn causes reduced closing factor in leaflets and combined with the systolic tethering of the leaflets into the LV, either by global LV dilatation or dysfunction. So this is what we are concerned. The second is the focal wall motion abnormalities with preserved global LV function, and then LV dysynchrony. And the latest one which is coming up is the atrial functional MR. Here you see pure mitral annular dilatation due to left atrial dilatation in chronic atrial fibrillation or restrictive cardiomyopathy, and this is known as atrial functional MR. Now, mitral regurgitation can be caused by any one of these in this mitral valve apparatus, but what we are concerned is the mitral regurgitation in heart failure. It's a classical long axis view of the mitral regurgitation. This is a short axis. Now we have advantages of using a 3D machine, which Floor was concerned about some time back. Simultaneously, you can view the long axis as well as short axis, and you can have triplane view, having all the views from the apex, the 4-chamber, 2-chamber, and the 3-chamber. And this is the advantage of the 3D evaluation of the mitral valve. You can see this is a transthoracic examination. Just viewing from the left ventricle, this is viewing from the left atrium. This is simultaneously possible with the currently available machines. It's called as dual crop. And you can see from the lateral side to the medial side. And this is the transesophageal echo, where again triplane view will be very useful to see all the 4 views which is required to look at the mitral valve. And this is the classical zoomed up view. You can see from this is the left atrial appendage, this is the aorta, from the lateral aspect to the medial aspect, A1, A2 and A3, the P1, P2 and P3. So you can look at this. Now coming to the secondary MR, moderate or severe secondary MR accompanies heart failure in about 1/3 of the patients and contributes to the clinical deterioration, this syndrome. And that is why it is very important. Coming to the pathophysiology, you can see here, this is the closing force and this is the tethering force. This is a normal myocardium, whereas in heart failure, the tethering forces are more and there is less amount of closing force. Both damage the mitral valve. You can see here the TGF beta factor is increased, resulting in fibrosis of the mitral valve, which results in this. So in all these stages, you should look for the mitral regurgitation. This is stage A is at risk for heart failure, stage B is pre-heart failure, and stage C is symptomatic heart failure, and stage D is advanced heart failure. And as you can see in stage A, the patient is at risk of mitral regurgitation. There is no MR jet, or there is a small trivial jet area, less than 20%. and seen only in Doppler, something like that. Has vena contracta width less than 0.3. And then in stage B, you have progressive MR. The effective regurgitant orifice area is less than 0.4. Regurgitant volume is less than 60 and regurgitant fraction less than 50. And in stage C, you have asymptomatic severe MR, ERO more than 0.4 and regurgitant volume more than 60 ml and regurgitant fraction more than 50. And in symptomatic severe MR, even after intervention, the MR persists. So secondary MR due to ischemic as well as the DCM can be seen, and this is the prognosis in relation to the severe presence of severe secondary MR. You can see here in patients with heart failure, when the MR grade is more, the mortality rate is more. That you have to remember. And the mortality rate is more even in patients with ischemic cardiomyopathy compared to non-ischemic cardiomyopathy. The main questions to be answered in assessing mitral regurgitation is what is the mechanism of MR, or what is the severity of the MR, and what are the consequences of MR on LA, LV, and the other things. So qualitatively you have to assess, and then semi-quantitatively, and finally the quantitative assessment is more important. According to the ESC criteria, compared to primary versus secondary MR, which happens in heart failure, ERA, when it is more than 20, it is significant. Similarly, regurgitant volume, when it is more than 30, it is significant. This is the comparison of the EAC guidelines versus AAC guidelines. AAC guidelines don't hair split this primary versus secondary, whereas this splitting is useful in clinical setting. In addition to the other things, the left atrial size and the size of the CFM jet, you can see is very important in quantification of whether it is mild, moderate, or severe. When it is severe, it is more than 40% of the left atrial volume. So this is mild, moderate, and severe. This classification you can see, and it can be early systole, mid systole, or late systole. And the advantages of three-dimensional echocardiography in this is assessment of the vena contracta can be more accurate, and effective ERO can be assessed more accurately, and this is the most important thing. It is very easy to assess the mitral regurgitation severity by anatomic regurgitant orifice area. It's very easy. So these are the stages. This is the vena contracta width, which is assessed by 3D echocardiography. You can see here measuring the vena contracta by 3D echocardiography is very easy, and you can see the assessment is very easy. The width can be measured in two planes, and it can compare with the zoomed up view. Now this is AROA, is still more easier. As you can see here, you can choose the flow convergence area and then measure the, it's only a planimetry. It's a planimetry. It's very easy to do at the bedside of the patient. So this is the PISA method which is there. Now the objection to the PISA method is that it is not a hemisphere. You can see here, this is a 3D of the hemisphere, which is not a true hemisphere. There are multiple projections. So this is the objection to the PISA. Now another multimodality imaging is required. And another important point is the left ventricular mechanical dispersion, which may be useful when it is more than 61 milliseconds. You can see here, this is the ejection fraction is 30, and here it is 62 milliseconds, whereas here it is 138 milliseconds. So this is the typical LBB where you can see the early septal contractions. So these strain methods can be helpful. This is the pressure strain loop from the septal area in LBB, and you can see here this is the lateral wall. These measures are, this is a normal activation map in patients with LBB, and I will show very shortly two cases. This is a case of dilated cardiomyopathy with LBB. This patient, this lady developed LBB after a COVID, incidence of COVID. You can see here, this patient had only mild MR, whereas ejection fraction was 33, and you can see here the JLS was reduced. and GLS was -6, and the left ventricular dispersion was 78 milliseconds. The lady was advised drugs, ARNI, but discontinued and came back after 1 year. Again, you can see here now it has increased to 89, and this is the septal force, pressure strain loop, and this is the lateral wall pressure strain loop. And you can see here, this is the 3D strain which shows the septal flash. You can see here the septal flash, which is very easily, and she had a left gadolinium enhancement, and the patient was suggested CRT. And this is another case. This is a 67-year-old businessman who came after 25 years of post-PCI for interval infarction. See, he had a severe MR, and EBA prime is 49, and you can see here the A over EA is 110. See, and GLS was only -5. And you can see here the left ventricular myocardial dispersion was 207. Yeah. And clearly the patient is a candidate for mitral valve intervention by catheter. Unfortunately, the patient died suddenly. This is the left atrial strain. You can see here the left atrial strain is only 7%, and the LA volume is 104, this patient. So, to conclude, the development of secondary MR is strongly associated with the worsened prognosis in patients with heart failure, regardless of its etiology. Accurate assessment of MR severity in such patients can be challenging, but it's essential. Guideline-directed medical therapy for heart failure is foundation therapy for moderate and severe secondary MR. When effectively applied, these measures will often reduce secondary MR and improve patient prognosis. Thank you for your attention.
Thank you, sir, for that extensive talk, and this is open for floor discussion now.
Atrial functional MR is mainly due to the atrial fibrillation. This is mainly atrial pathology, as happens in restrictive cardiomyopathy. You have to take the whole. Whereas secondary MR is primarily due to problem in the left ventricle. It's a left ventricular dysfunction which results in mitral regurgitation.
So what is the prognostic differences, like if you have coming from the same thing, it's a ischemic cardiomyopathy?
No, we are dealing with secondary MR in heart failure due to LV dysfunction that has a very bad prognosis. Significance of diastolic MR in heart failure, we don't see that often.
We can, sir, practically can't measure effective regurgitant orifice area and day in, day out as a region.
That's what this 3D is very easy, just planimetry, anatomic regurgitant orifice area, planimeter, then vena contracta is easy.
Yeah, just we visually eyeball and then institute the GDMT. Of course, they do reverse remodel, the MR severities go down, the LA volumes go down, LV goes back in. Then for research purposes or in some outlier, you do require the regurgitant volume estimation, which is a very tedious study. In 3D, if I try to attempt, every time I do it, the different readings that come because it requires a learning curve. In fact, technicians of the machine, they do, and the machine related, the personnel, they do it better than me.
So that is why the current ESC guidelines, they say at this point you have to refer it to the imaging specialists.
Yeah.
So that the person who does lot,
and that's why
inter-observer and intra-observer variation will be less.
Yeah. That's why the differences came in MITRA FR and the COAP trial in the patient selection, where this MITRA clip, this eligibility because of the assessment differences.
Because EROA, you have to reduce the aliasing velocity, that gives you the clue. When you reduce it too much, it will become less. So you have to be very careful. It has to be kept at between 30 and 40%.
Thank you,
thank you, sir. Thank you.
Thank you for your excellent exposition of mitral regurgitation, specifically related to heart failure. I think we should all give a big hand to Dr. Amudan for his excellent talk. And Next, I think we go on to a question that was asked during Dr. Mohan's talk. What happens in stress? So we have always been talking about the pressures in heart failure with preserved ejection fraction lying down, and I think what does stress imaging do? Because we keep saying that heart failure with preserved ejection fraction you have to diagnose only during stress. And to talk about this, we have Dr. Srami Srivatsava. Sir, over to you.
Thank you very much for the invite, sir. And can I have my slides, please? Correct. So the deliberation is on stress imaging in heart failure with preserved ejection fraction. I have a disclaimer that for purists who are looking for outcome data, please you may get busy with your phones on silent mode, because this is something where outcome data is lacking. So stages of heart failure, thanks to Professor J.C. Mohan. He has covered a lot of what I wanted to speak. That is how you always have to say if somebody preceding you has already spoken half the things. Anyway, so this is where we are. If you look at the guidelines of 2016, we know that stress testing for preserved ejection fraction was never ever mentioned. And even in the diagnostic algorithms, which was based on classification, again, the issues were that nothing was mentioned. Everything else was given E prime, EA ratios, LA volumes, TR jet velocity, EA, everything was except stress. Now, we know that there are not very many treatments that improve the outcomes of heart failure with preserved ejection fraction. There are diagnostic challenges of heart failure with preserved ejection fraction, and its frequent diagnosis is made only at a very late stage. So exercise intolerance and shortness of breath are not specific. So it is imperative that we diagnose heart failure quickly, early, and should differentiate it from other causes of shortness of breath. So the rationale for stress testing to diagnose HFpEF has already been discussed as per Dr. J.C. Mohan. But to talk about a few alternative complementary mechanisms which have some reasoning to be discussed this evening is that there's something known as longitudinal LV systolic dysfunction. Pulmonary artery hypertension is something very important, because if you have left ventricular end diastolic pressure which is normal and pulmonary artery pressures which are raised, you are pretty much sure that you are not looking at a HFpEF, because in a heart failure with preserved ejection fraction on exercise, it is expected that the E prime should fall and the EA ratios, which are a surrogate marker of increased LVDP or LA pressures, should go up. So in a setting where E to E prime is normal and pulmonary artery pressures are rising, this is something which you have to be very careful about. Plus, there are ventricular vascular coupling, exercise-induced vasodilatation, and chronotropic incompetence. There have been many classifications. Again, they have been already discussed in past. But to give you an example here, there are two patients with the same kind of E velocities and E to E prime ratios. You put both the patients on exercise. One person's E to E prime increases, another person's E to E prime remains stable or increases only marginally somewhat. Now, there is a huge big difference between the two patients. If not therapeutically, at least philosophically and prognostically, we can assume that intuitively, the one who's not increasing too much of his E to E prime will live longer or will have lesser of symptoms. Now, these are diverse etiologies of exertional dyspnea, which are requiring differentiation from heart failure with preserved ejection fraction. Again, things have been discussed in past extensively, and I'm just going to skip over just to tell you that how it should be done. So most of the times we do stress or treadmill tests very casually, but knowing the etiologies of HFpEF, if you are dealing with a hypertrophic obstructive cardiomyopathy where you are expected to increase the LV gradients, this is not the kind of scenario where you should be lax and be doing it very casually. Now, what are the different stressors that you do? Supine bicycle exercise has been tested the most, with its own advantages that it does not increase the heart rate so much, so the E to A ratios do not fuse. And that's the reason why it is preferred that you go on and you can continuously monitor. Unfortunately, what happens in a treadmill is that the moment you are having the treadmill, you can't monitor every 1 minute or 2 minutes, but here you can. So every 25 watts, as they say, 25 watts, 50 watts, you keep increasing, and supine bicycle exercise is a good one. Alternative methods to supine bicycle stress is passive leg raising. So there are patients who will have difficulty in bicycle exercise, and you elderly population, obese people, all you have to do is lift their legs up, ask somebody else to do it because it's passive. Ask somebody to raise the legs up by about 60 degrees, wait for 30 seconds and image. So there's a sudden increase of preload. There is a venous return because of which there is an increase of preload, which can worsen the preserved ejection fraction, heart failure, and that can precipitate worsening of certain of the parameters. So this is what the algorithm is, that from normal to abnormal to pseudo-normal, reversible restrictive, irreversible restrictive, these are the patterns you have to see, and you have to calculate. So just to give my little 2 pennies of how to remember the various numbers of diastolic parameters, E prime should be less than 7, E2 E prime should be more than 14, 21, forget about it, TR jet velocities 28, and LA volume 34. So this is basically a table of 7. 7 E prime less, 14 E2 E prime more, 21, forget about it, TR jet velocity 2.8, and 34 is LA volume index. So this is how I have remembered it. And now another thing is that what about exercise stress echocardiography, which we do commonly in India. We don't have too many supine bicycle. There is some comparison, there is some validity, but unfortunately this is not one of the best ways to do it. But here is a comparative chart that exercise workloads of about 9 to 10 METs is equivalent to 5 to 7 METs on supine bicycle ergometric exercise. Myocardial ischemia is more frequent and more extensive with treadmill, less frequent with supine bicycle. Diastolic function is better for supine bicycle, and effective position is better because you increase your wall tension when the person is supine and increase oxygen demand, precipitating the diastolic failure. Now these are different methods. So we have exercise, we have dobutamine, we have got passive leg raising, physiological, pharmacological, name the things. They have tried just about everything, but probably what they have not tested is showing their wives' pictures. Now we have some consensus recommendations, and these are the consensus recommendations. They have been showed in the earlier talk, and when we have lot of confusion, then it is this left corner that considers CAD or proceed to diastolic stress testing. Now, when you do this, you have to calculate the same parameters what you do in the resting stage and see for the worsening. Again, this has been talked about several times. This is the pre-test assessment, echocardiographic and natriuretic peptide score, functional testing, and final etiology. Not going into the details of this. The interpretation of main parameters from diastolic stress echocardiography are what? So the thing which matters most is E2 E prime, and it can be used reliably for the diagnosis of heart failure in patients with normal or mildly abnormal diastolic parameters at rest. If there is worsening, trust me, the specificity is high, positive predictive value is high. But if it does not increase, it does not mean that you're not dealing with HfpEF. Enough and more data is there, maximum number of papers have come from Mayo, but you have several people who have proven it endlessly. And what is most important is that exercise and pulmonary artery systolic pressure, how does it matter? You increase the pulmonary artery pressures on exercise, but if your E2 E prime, like I said earlier, does not increase significantly, you are in good shape because you know that there is some other cause, probably pulmonary cause, which increases the pulmonary artery pressures. Now there is something known as a diastolic functional reserve. Very interesting concept, that this is the ability of LV to augment diastolic function with exercise. And it may be impaired in patients with risk factors for heart failure with preserved ejection fraction. And the most important is diabetic. So if you have lower diastolic functions reserve, this was associated with reduced exercise capacity. Number two, Diabetes turned out to be the worst to compromise the diastolic functional reserve. And when patients were divided into two groups, the velocity of E prime is the thing which can be calculated very easily. So SGLT2 inhibitors have been there and people have talked about for usage in HfpEF. So there is this recent randomized placebo-controlled trial proved the effect of SGLT2 inhibitor on LV diastolic function with diabetes, and this assessed the improvement in 24 weeks. This is what it is there. All you have to do is keep checking out the E prime at different levels of exercise and see if there is increasing. You are in good shape, because fall of E prime is something which is bad. Now, I am an echocardiographer, so there is a natural bias, but it is not that other people are not trying this. MRI people are also trying it. Now, don't ask me how they did it, but this is a recent paper in 2021 published from Germany, where they did MRI and they must have got some non-ferromagnetic exercise, etc., and they did a simultaneous catheterization. Very interesting. It proves that it is also useful, but for clinical utility, there is a lot of issues which have to be sorted out, because MRI has its own innate negativities. To summarize, we have E to E prime, which we have to trust, exercise, pulmonary artery systolic pressures, which we have to trust, E prime, which we have to trust. But let me tell that please don't have a tubular vision for HfpEF. HfpEF is an enigma. Don't try to look at only one parameter and make assessments, because looking at only one parameter, you can miss the beast. Thank you very much for a patient listening.
Thank you, sir. Very nice talk. I would like to ask you, how often are you doing exercise testing in your practice?
We don't deliberately do it.
No, when needed.
When needed,
how often?
when needed, we do it. Unfortunately, we do it only on treadmill. That's the problem.
On treadmill. And is it for patients where you are clinically suspecting heart failure with preserved ejection fraction, and you do not have a echo parameters to suggest, to conclude a diagnosis of heart failure with preserved ejection fraction, like normal LV filling pressure, something like that?
We do it to find out for an alternative cause. Most of the times we want to induce ischemia and see wall motion, or we want to rule out a pulmonary cause for shortness of breath. So we look at TR velocities more often than not.
Sir, wouldn't the ones who have high metabolic stress have, in the ones who are dicey, they are HfpEF score 2 to 4, and you are doing now diastolic stress test, or you are provoking the diastolic reserve. But the presence of mitral annular calcification or mild to moderate MR at rest, and when you exercise, the dynamic MR that increases, or presence of annular calcification hinders with the interpretation that you have on exercise?
So once you have a MAC, your estimations of E prime are fallacious. So those are the patients you just can't do.
And if you have atrial fibrillation, then you had it.
Atrial fibrillation, you see, you can do this test only where you can do. It is not necessary that you have to do it for everybody.
Dr. Mohan, sir, you wanted to say something?
No, I just want to say that one of the things which can be easily done, which doesn't require all these things, in patients with dyspnea, you should also look at lung B lines. That helps you a lot to sort out the issue. You know, if the other things are not helping you, E to E prime, TR velocity, and things like that, just look at the peripheral field for the comet lines, the B lines, and that might tell you that this patient is developing pulmonary congestion, that is most likely heart failure, preserved ejection fraction, if the ejection fraction normal. We use this thing quite often, and we find that it has an additive value.
Sir, LA reservoir strain on exercise monster that you enumerated?
No, the exercise strain actually is not a very reliable parameter, because strain is also preload dependent. When you do exercise, depending upon which exercise is reducing how much preload, whether it is dobutamine, standing exercise, or bicycle, the preload changes and hence the reservoir strain would change. So there is no conclusive evidence that the exercise related strain has a better positive or negative predictive value. The rest strain is useful. People have gone after the exercise strain, but the data is quite conflicting.
Thank you so much, sir. I think it was an excellent session with seeing is believing, listening is, and we think we should all go and try to practice all that we have done. Try to do LA strain a little more, try to raise your passive leg raising, stress, PF measurement, and assessing MR more conclusively. Thank you so much, all the three speakers, Dr. Mohan, Dr. Amudan, and Dr. Samir, and we'll call this session to a close. Thank you.
Thank you, panel members and moderators, for that immense knowledge. Moving on to our next section on complex engineering to the fore. Now we would like to call upon Dr. Hfai Sahotali, Dr. Damodaran, and Dr. P.K. Hazar to chair this session. May I request the moderators to start the proceeding? I request the speakers and moderators to kindly stick on to the time, please.
Good evening, everyone. Thank you. So the next session, we are going to move towards complex engineering to the fore. So we got fantastic 5 speakers ready to give their views on different aspects of complex engineering in patients with heart failure. So to start off with, we'll call Dr. Y.V.C. Reddy to give a talk on CHIP in heart failure, to do or send for transplant. So let's listen to his views on, particularly after the REVIVE Basis 2 trial, to find out how we deal with these kind of CHIP patients in heart failure.
In a lighter vein, let us see whether he is for the interventional cardiology side or the surgeon side.
Thank you and good evening. To chip or not to chip, that's the question. And the common dilemma we do when we tackle these patients with ischemic cardiomyopathy is exactly this. Whether it is nobler in the mind to suffer the slings and arrows of outrageous fortune, what Hamlet thought is what we keep getting in our minds. A prototypical case 2018, burnt out ischemic cardiomyopathy, referred from elsewhere, a different country for heart transplant. This story starts way back, 15 years back, 2008. A 56-year-old, that time was 41, hypertensive, diabetic, dyslipidemic, OSA, obesity, all the works, anterior MI, LED stented, diagonal plane, but bad LV. The LV keeps ballooning to almost 80 mm, 25% EF gradually over the next 5 years, full heart failure, guideline-directed medical therapy. 5 years later, so 10 years after the original plasty, some angina, heart failure worsens, and now he's not able to do anything. Recurrent heart failure admissions, EF 15%, MR, they've done everything there, so they are downhill course, heart transplant referral. How do you approach? First, GDMT with the 8 proven therapies, that time there were not 8 of course, is not the be-all and end-all of the management. Whatever was GDMT at that time was on board. The complete map of the nuts and bolts is needed. We have to look at the pump, the valves, the electrical supply, the blood supply and the covering, the pump issues, is it infarcted, is it hibernating, is it ischemic, viable, non-viable. This is the most challenging conundrum the clinicians face, the 3C. Is the coronary disease a contributory thing to the problem partially, or is it really the causative thing, or is it just a coincidental? This conundrum is the one which always gives us the biggest dilemma. And of course, we shouldn't miss the pump steal by the aneurysm. This gentleman didn't have much of the issues there. The valves, of course, all of us know that we should not miss mitral regurgitation, which can be tackled, because now we have even issues like mitral clip available easily with us. We should never miss aortic stenosis, especially LFLG. And of course, combo treatments can be done in this era very easily and simply. Electrical issues, don't forget about the contribution with the loss of atrial kick. Do something for the atrial fibrillation if you can. Make it normal sinus. Bradyarrhythmias, easily diagnosable. You can do the CRTs, whatever is needed. Tachy, paroxysmals, we should not miss, and then correct it. Do the ELRs, get it sorted out. This gentleman had all these done. He was having a CRTD as well. And angiographic, of course, the golden test in all these cases. A good angiogram is a one which allows you to do a virtual PCI. You know whether this gentleman is going to benefit by a chip PCI. That is the angiogram we need to be done here. This gentleman had an angiogram done, 50% ISR, borderline, the definition, and non-viable territory in LAD, nothing else was there. Tried everything, 1 year down the line, they said, go ahead, get a transplant done. We always, when we have to decide whether to ship or not, we know why is it that one LAD territory MI is pushing him into a severe global LV, going on to a 80 mm, 15% LV, and then causing us so much of problem. We know that this is all because the heart muscle is only a single band of muscle. Thanks to Francisco Torren-Goss, we now know that it is one muscle bundle which is all made into a double helix, twisted spiral. So this is the culprit. So this is the biggest clinical conundrum and challenge that I was alluding to. It could be one simple thing which could have caused all this. There, incidental coronary, you go and do a stent, it is of no use at all. What is the essence of this slide? Every viable myocardium does not mean it is ischemic viable myocardium. Every ischemic viable myocardium does not mean it is epicardial ischemic vessel myocardium. There could be small vessel disease as well. And only the epicardial ischemic viable myocardium is the one which benefits from revascularization. If you just understand this, a PCIR can get excellent results for his patients. This gentleman, we did everything. We also, of course, have to keep in mind that we should not miss the rare case of constriction, which can develop post-MI down the line and then push him into heart failure like this. He didn't have that. So the full picture of the surroundings are needed. We have to treat all his pressures, the volumes, the ferritins, creatinines, we all know that. He was getting all the treatment and the full strategy now. Once you get everything done, the full strategy is important. Revascularization, you know what to do now. You have to look at the pump if something has to be done. For the valves, there are so many possibilities. The next talks will be on that, the device therapies, and of course the arrhythmias, and even cardiorenal stenting for the cardiac disturbance syndrome, which seems to be there in some of these patients. Remember, God resides in the order of implementation. You should know all the nuts and bolts, and you decide in the correct order in which you can treat the patients, and that is where a chip PCI, the chip PCIR has to be very clear about. And everything revolves around the chip PCI in such a scenario where you think it's going to be useful. The first and foremost, make sure that it is an epicardial ischemic viable myocardium. How do you do that? You have your clinical access, if you need, do the physiology, and if at all you're going in, you decide whether it is a single stage chip PCI or a completed chip PCI, whether you want to support it, impella, whatever you want. And then of course, hybrids are also possible with a mid-cab LED, and then the rest of it is a chip PCI. Whatever it is, do a good job, do an optimized PCI job. So back to our patient, 2018, he's come for heart transplant evaluation, 15%, 80 millimeters bag LV, critical RC and LC stenosis on a repeat angiogram. LAD looks 50% ISR, FD chip at viable. Its viability is not the one which is pushing us into doing the chipping. The chipping is being done only because it is an epicardial ischemic viable myocardium, and we take him up for a double vessel chip PCI. What happens? Does it help? Yes, tremendous improvement in symptoms. 15 becomes gradually over 6 weeks, 35%, mild MR, heart transplant kept in abeyance, and he goes back home, he's doing his business, everything well. Is it enough? No. The seventh sutra, beyond revascularization, continue good GDMT, prophylactic vaccines, rehabilitation, therapeutic lifestyle changes, and beyond the works, very important, close follow-up, because it is a dynamic disease. Things keep changing, periodic reassessments are needed, and the dynamicity of the disease puts you in a bigger role. And dynamic it is. Back to the story again. 5 years pass, and it's now. 2023, recurrent episodes of giddiness now for the last 3 months, admitted multiple times to the hospital, comes, goes. He was on the flight, and the flight has to be returned back mid-air because he again collapsed there. EF 15%, the heart is 90 millimeters back, thin, paper-like, and we had to stop all the medication. And this is the status now. And that's it. Back like LVs. And the vessel seems to be okay. The stents are good, the circumflex is good, the LAD is not bad. So the inexorable downslide continues despite whatever you do, and then the final sutra. This is the time for yes, either an LVAD or a TAH or a heart transplant, and now we get in our team and say, yeah, hand over, yeah, you take over, and we'll try to continue supporting you. There are other scenarios where we might jump in and refer to the heart transplant specialist quite earlier. What is that? If someone has got intractable ventricular arrhythmias, the CRTD is not good enough, it is discharging all the while. Large LV clot, large LV aneurysm, very severe dysfunction of RV, and of course, no meaningful benefit expected from revasc by whatever option because of the poor target vessels. Yes, we'll do this job quite earlier on itself. We do chips in several other types of cases as well, like in this patient, left main and multi-vessels, surgical turndowns, heart team discussions, and chips can be done, protected PCI. I will not go into all that, but I think I will like to stop the session earlier so that we can come to any meaningful discussion of the issues involved. And I will end with this case where an extensive antival MI, no viability, 0, 48% scar, bad LV, referred for heart transplant because of 22% EF. But then there's a left main and a viable territory ischemic in the circumflex. We proceed to go for a chip PCI, a DK nano crush, and that's it. And what happens? 3 months later, EF 40%, a non-LED, a viable scenario, but still he improves well. In a nutshell, coronary and heart failure. It is a potpourri of presentations. It's not one single entity. Your big job is to know the 3 C's: contribution, causation, or just a coincidental CAD. Every wisdom lies there. Revascularization is one important part of the solution, but keep it in the right perspective. And a comprehensive assessment is very vital for the best outcomes. A chip PCI has really revolutionized this management of this complex subset of patients. With the availability of new technologies, new gadgets, imaging, of course, supported PCI, this has become a safer reality as well. And of course, heart transplantation usually is the last resort. Thank you.
Thanks for the wonderful talk and the sutras. But my question here is on the background of the REVIVE trial. What is your current daily practice whenever we are seeing a chip subset? How do you choose based on the clinical?
I think for the sake of the audience, I think let me put that question in perspective. REVIVE BCIS2 trial was a trial done on about 700 patients. Heart failure, not even heart failure, ischemic cardiomyopathy, EF 35% and less, severe CAD based on the angiography. And they didn't do the ischemic evaluation. They just did the viability and said viable territories are there. This is what the conundrum I am saying. Viability does not mean ischemia. So, and 77% of the patients in the trial were in class 2 and class 1. And they went and did the PCIs in 300 odd patients each, 600 patients. What was shown was at 3.4 years of follow-up, the PCI group also was doing the same in terms of mortality and heart failure hospitalization at 3.4 years. Was there a hazard because of intervention like STITCH trial? STITCH trial, CABG versus medical, at 1 month, 3 times more people died in the CABG trial, CABG arm. Here, PCI, no mortality. Second, was there any benefit? Was the quality of life worse for the patients undergoing PCI? At 6 months, the quality of life in the PCI group was excellent. The KCQQ score was better in them. Were there more MIs in the PCI group? The spontaneous MIs were lesser in the PCI group. Was there any downside in terms of unplanned emergency revascularizations because of PCI? There was a 362% increase in unplanned revascularizations in the guideline-directed medical therapy group. All this is part of the trial, where there were errors in the trial design, but still if you see the data, that is it. The final one line, whether mortality had reduced and heart failure hospitalization is reduced over 3.4 years, no. All other benefits are there, with absolutely no safety issues. And then we know from STITCH trial, or the STITCHES trial, the extension, that mortality benefits in revascularization accrue only at the end of 10 years. So this is the icing. Once you know that the MIs were lesser, definitely at the end of 10 years, the mortalities are going to translate. So actually, BC's REVIVE 2 should add more strength to the chip PCI.
That's a very valid point. I think in terms of symptoms, I think even though at 6 months there is an improvement, but at 2 years it's equalized between PCI and medical arm. Now coming to this interesting point of ischemia in poor LV, what are your testing, what are your assessment of ischemia? What are your personal tests, particularly the ejection fraction of 30%? Would you put them on a stress echo, or what kind of stress you want to do for ischemia?
See, in a multi-vessel CAD, where viability is established in the setting of an critical coronary, epicardial coronary. Of course, it is almost assumptionary. But if it is a borderline lesion, a 60 or 70 or 75, and you want to make sure that it is, I think I would go in for a non-hyperemic flow ratio on the table and then do it. I think that would be my best bet.
Thank you so much. I think for interest of time, let's move to the next topic.
Thank you.
We'll invite Dr. Sengotuelu to give a talk on TAVR in heart failure. So thank you. Welcome.
Good afternoon, everyone. Thank you, Dr. Woman and the organizing committee. So, can I have my slides here? Okay, TAVI in heart failure. We know that heart failure is a frequent comorbidity with severe aortic stenosis and actually becomes a very challenging in both diagnosis and management. So ejection fraction is considered as a major predictor for survival in patients with aortic stenosis. And improvement of ejection fraction is seen after TAVI in patients who had heart failure with reduced ejection fraction. And TAVI is now a very promising treatment for and a very low risk approach in these high risk subsets. Okay, so I'd like to classify aortic stenosis can be classified under 4 broad categories. I think we all know about high gradient aortic stenosis, a typical gradient mean gradient more than 40 with a velocity more than 4 meters per second and valve area less than 1. So this is a typical high gradient aortic stenosis. But the entirety of low flow, low gradient aortic stenosis is very important to know. I think many of you know this, but low flow, low gradient aortic stenosis is aortic valve area less than 1 with a mean gradient less than 40 and the ejection fraction less than 50%. So when you have an ejection fraction less than 50%, then this is classical low flow, low gradient aortic stenosis. But there can be, with preserved ejection fraction, still there can be low flow. When you have low flow with low gradient and a preserved ejection fraction, it is paradoxical low flow, low gradient aortic stenosis. And finally, we have one difficult subset which is difficult to diagnose, which is normal flow, low gradient aortic stenosis. So the topic of today, the low flow, low gradient aortic stenosis, low gradient aortic stenosis, again is very important to further categorize under which category they belong. And when you have an aortic valve area less than 1 and a mean gradient less than 40, we need to, particularly when you have a low ejection fraction, we need to look at doing a dobutamine echo. I'll come to that. So there's a classical low flow, low gradient aortic stenosis. When the ejection fraction is normal, again we need to flow. The estimation of stroke volume is again very important to clearly differentiate between paradoxical low flow, low gradient and normal flow, low gradient aortic stenosis. So in this subset, which is very difficult, this normal flow, low gradient aortic stenosis, they may still have low gradient, ejection fraction may be normal. So the identification, we need to look at other parameters like using the other like calcium score, which is if there is a very high calcium score or a high BNP, they are again markers of presence of severe aortic stenosis. The other important test for low flow, low gradient aortic stenosis is using a dobutamine stress echo. So dobutamine stress echo will let us know if there is an increase in the mean gradient of more than 10, or if the peak velocity of increase in more than 0.6 meters per second, or if the aortic valve area decreases by less than 0.3, and also or any condition if the mean gradient is more than 40 and the aortic valve area is less than 1, it is again diagnostic of severe aortic stenosis. So the importance of contractile reserve, again with dobutamine one can know the ejection fraction improves, again that we know that it's got a better contractile reserve. So failure of stroke volume to increase by more than 20% is defined as a reduction in contractile reserve. So again, these are some of the studies which we have seen that the meta-analysis almost in 7,000 patients, there was significant improvement in ejection fraction after TAVI in patients who had LVEF less than 40%. So a study again showed TAVI patients with different types of heart failure, again preserved, whereas moderate or to reduce ejection fraction, all of them showed a improvement in ejection fraction after TAVI. Again, there's another study showed that ejection fraction improved 3 months after TAVI, much more than the surgical aortic valve replacement. And the ejection fraction improvement was quite occurring very early and also persisted over 1 year follow-up. So I was mentioning about the importance of assessing the flow. So in every patient with aortic stenosis, it's very critically important to assess the flow, and aortic flow represents major parameter, and based on that, the classification system exists. So based on the partner trial, it was shown that if there's a transaortic flow is low, then the 2-year mortality is significantly higher. And also in inoperable cohort, whoever had low flow AS had a higher mortality than patients who had normal flow. So flow is again an important predictor of mortality. So all subsets of aortic stenosis, whether it is low flow, low gradient, all of them benefited by transcatheter aortic valve replacement, whether it's a low ejection fraction, low flow, and low gradient, were all benefited from TAVI, but those subsets who had low flow and low ejection fraction had a higher mortality compared to those patients who had a normal LV function and a normal higher gradient. So mortality was lowest in patients who had preserved ejection fraction with a high gradient. So again, the highest, the best was seen in the patients who had reduced ejection fraction. Patients who had already reduced ejection fraction and a low gradient had the worst outcome with a high mortality. So clearly in this graph, you can see that patients who had, if you have good contractile reserve, definitely they do better than those who do not have contractile reserve. Whereas low flow, low gradient aortic stenosis again have a poor prognosis compared to those with better flow. On the whole, every patient who has, even regardless of the contractile reserve, regardless of the low flow, low gradient aortic stenosis, they benefit from from TAVI. So I'll show you one case example. One of our patients is a 75 years old gentleman, diabetic, asthmatic, multiple comorbidities. He had bypass surgery earlier, and he actually a sudden cardiac arrest survivor. He was after that he was found to have some lesions. Post CABG assessment was done where he was stented to LAD and circumflex. So subsequently he was admitted to the hospital frequently again and again with symptoms of heart failure. So he was found to have aortic stenosis. The gradient was only 12 millimeters of mercury at that time. We saw him about a year before, and at that time his aortic stenosis gradient was not significant. So we did the ejection fraction was about 45%. So dobutamine echo was done, which showed again the stroke volume was low, it's 34, and the gradient did not increase with dobutamine. So at that point, we decided to keep him on medical therapy. So since he would not he would have a higher risk and he would not benefit. But this was his echo. If you look at July 22 and 23, So he had, if you look at the aortic valve area decreased significantly to less than 0.7, and he had recurrent admissions with heart failure. So this was a patient who had low flow, low gradient aortic stenosis with poor contractile reserve. These are the subsets of patients who have a higher mortality, but they do benefit with TAVI. So this you can see that aortic valve opening was, I'm not sorry for the not moving images. So he had severe aortic stenosis despite the low flow and the poor contractile reserve. So we decided to go ahead with TAVI. So this is CT scan showing not much calcified tricuspid valve. So we decided here to use, this is a coplanar view. There's a pigtail in the right sinus. So we decided to use a accurate neo valve with a sentinel device. This is a cerebral protection device using a sentinel device, a sentinel filter, which is placed in both the carotids. And then if we place a wire, the LLB wire, and this balloon, this is pre-dilating with a balloon dilatation. So after that, this is an accurate neo 2 valve, the supraannular valve. So this was again placed. And this is done, you can see this, it's deployed in two parts. This is the upper crown and the stabilizing arch is first deployment, and then the second part of the valve is deployed. And this is the final deployment after, this is a fast deployment which is done as a second phase. You can see the center image where the valve just opens up. So, and this is the final result, aortogram. So the final result was good. There is no aortic leak, no paravalvular leak. Sorry, the last image. So this is the aortogram where you can see that there is no leak. So this is the echo post procedure. So patient's ejection fraction improved to nearly 50%, and the gradient came down to 3 millimeters mercury. So he did improve, but he had some persistent symptoms of heart failure. So we had to keep him on a dose of diuretic, and after prolonged hospital stay, he was discharged. So again, this is one slide where one needs to look at other features as well. If they have persistent heart failure following TAVI, one should particularly look at certain things like make sure you have to rule out amyloidosis. Again, that's again an important thing to rule out. And if they have atrial fibrillation, make sure their heart rate is well controlled. and optimize medical treatment, consider CRT if needed. So all this is again important in case the heart failure persists despite the TAVI. So to conclude, heart failure and severe aortic stenosis are commonly occur together, and TAVI has substantially changed the therapeutic paradigm in patients with concomitant aortic stenosis and heart failure. A large portion of patients with severe AS and heart failure, they previously declined because of the surgical risks, and now can undergo TAVI, and this is supposed to be safe and effective, which is good at long term. So exciting data support TAVI in patients with severe AS, irrespective of the aortic valve gradient, whether it's low flow or flow or ejection fraction. So all forms of aortic stenosis patients benefit from TAVI, although the mortality is higher in those patients who have low flow and low ejection fraction. Thank you.
Thank you for a wonderful talk. And regarding the one point that you have emphasized, the patient, despite on post-aware, if they continue to have failure, you should suspect amyloidosis. That is one learning point. And also, when you have a normal flow, low gradient aortic stenosis, which parameter you take it as an additional value in deciding the patient's symptom is due to aortic stenosis per se, like you told the calcium score, some other scores?
Yeah, I had shown a slide. We can look at both clinical as well as the calcium score. Usually the calcium score can be very high, and also the BNP. The BNP values are 3 times the normal. Then all these factors put together that they are at a higher risk for aortic stenosis, severe aortic stenosis.
So in what percentage of cases when you know that the LV function is impaired in non-ischemic, whether it's a non-ischemic DCM or is it related purely to aortic stenosis? So in those situations, how frequently would you consider doing a balloon valvuloplasty to see whether the LV improves and then consider TAVI, which is one of the things we used to do a lot in those days?
Yeah, nowadays we don't do that because we know that all forms of, as I mentioned to you, all forms of, regardless of the contractile reserve, regardless of the severity of LV function, all these patients improve. Only in situations where we have difficulty, for example, we had a situation like the patient had heart failure and he was suddenly had a cardiac arrest, we had to intubate him, he was on a ventilator, we didn't know about the brain status, so we did a balloon aortic valvuloplasty, and then the patient recovered, then we put in a valve. Some situations we do use it, but just for the sake of heart failure, nowadays it is not indicated that you have to do a balloon aortic valvuloplasty.
Like in TMER, MAC patients will have worse.
I agree. Actually, it is a good, we should do that, but because of, it may not have a good cost effectiveness. That's the only thing, because patient has to go through the scan, but the patient going through TAVI, there are some centers we start doing routinely a pyrophosphate scan to rule out amyloidosis. I think that's
at least you have got some markers
True.
like RBBB or etc.
Yes. Yeah. Yeah. True, I agree. That's what we should probably start doing, a routine pyrophosphate scan for all patients with heart failure and TAVI, yes, those undergoing TAVI.
Like in TMER with the MAC patients, worse prognosis. Similarly, the low flow, low EF, low gradient, the mortality is mainly due to the confounding comorbidities or due to the intrinsic heart failure per se. What do you think?
Possibly because if their cardiac output is still low, even despite the TAVI, okay, and also the arrhythmias and other causes, yeah. Okay.
With this, we can close this session. Okay. Let me call the next speaker, my dear friend, Dr. Vishal Rastogi from Escorts Hospital. Is going to talk on mechanical circulatory support devices in advanced heart failure. I think most probably short-term mechanical circulatory support device. Okay.
Good evening. I thank the organizer for giving me this opportunity. So for this talk, let me take you back to your physiology days. This is the pressure volume loop, and this, when we plot the volume against pressure, this is the LV volume against pressures, then we get this kind of loop. The On the x-axis the volume and the y-axis the pressure, and you can see that as the mitral valve opens at this point, and then it leads to ejection phase, and then the mitral valve, the aortic valve closes, and the pressure falls, and then gradually LV fills. So these pressure volume loops, they work within the boundaries of the ED-PVR and ES-PVR. The slope of the ES-PVR is the contractility of the heart. This endpoint where actually the the ejection begins, is the phase where which is the preload. That's mean this is the end of the diastolic volume, and against this volume, the left ventricle is going to contract. So this is the preload of the heart. This width of this curve is the stroke volume of the heart. This slope of this ES-PVR is the contractility, and this is the afterload, at which point the aortic valve closes, because the aortic valve pressure or the aortic pressure is the afterload against which the heart had to work. So these are the important parameters which define the cardiac output. What happens in patients with cardiogenic shock? You can see that in cardiogenic shock, the curves have shifted significantly to the right, and that has happened primarily because of simple reason that the contractility has gone down. This slope which we were talking about, the ES slope, has gone significantly down. That has shifted the curves towards the right. You can see here the stroke volume has significantly reduced and the cardiac output is reduced. Also, the peak blood pressure, which was very high at the time, is now very low. So the cardiogenic shock, as you all know, is defined by a cardiac index of less than 2.2 and a systolic blood pressure of less than 90. So this has been caused, as I said, because of the reduced contractility, and this leads to increased filling pressures. So CVP and PCWP both are increased. Dr. J.C. Mohan and Dr. Samir Srivastava both raised this point that for diagnosing that's a left heart failure, you have to have both filling pressures. The CVP has to be high, the pulmonary artery pressure has to be high, and pulmonary capillary wedge pressure has to be high, which is a marker of the left ventricular filling. But all shocks are not different. You can see that this is the classical progression of patient. We are talking about chronic heart failure here. Initially, the patient has one index event, and after that patient improves and continues in a stable phase. Then he may have multiple episodes of deterioration, but ultimately these events keep on occurring. So patient who is having the first event, which is the acute myocardial infarction cardiogenic shock, that is very different from this heart, which is advanced heart failure cardiogenic shock. You can see this is a very remodeled heart, which is dilated. The pressures are already high at baseline. The patient was well compensated, the pressures were high and the volumes were high, and to that the patient has developed an event which has led to worsening, as against a normal heart which has suddenly had a very acute insult. And if we go back to our Frank-Starling law, the curve 1 in the stroke volume is the normal heart, where the stretch or the muscle fiber length at the end, which is the preload, depends on the stroke volume. More is the stretch within the physiological limits, of course. More is the stretch, the more is the volume generated. So this is the normal heart, and as the myocardial infarction occurs from a normal heart, suddenly the stretch goes down, and gradually this leads to compensation and it becomes a flatter curve, and then in AMI Hfref the curve is farther low. You can see on the right these volume loops that initially there's hardly any time for the heart to compensate. So this curve is still there, and this contractility and these changes are very sudden and drastic, while in a very well compensated heart later it's very well compensated and the changes are not that much. So what we need in the cardiogenic shock, what we need is very important, is to maintain blood pressure, because circulatory support is very important, systemic perfusion is important, and that is determined by the mean arterial pressure, which is by lactate and creatinine level. You can see the second important aspect is ventricular support. That means that the LV and the RV are getting unloaded, and that will be determined by the systolic and diastolic and systolic pressures and the aortic pulse pressure also. And also, of course, you can see them by the heart rate and BNP levels. The other important aspect is to maintain coronary perfusion, because otherwise the patient will continue to be in shock. So mean arterial pressure is also dependent on the LV and diastolic pressure, and you can see this by STD changes and troponins and CPKs. However, as the problem progresses, this condition worsens and a hemodynamic problem may convert into a hemometabolic problem, and then gradually it becomes futile to do anything. These mechanical circulatory support will not act if you act late. What devices we have? We have these for left ventricle, we have these pulsatile device, which is IBP, and then we have axial flow devices, which is Impella and PHP, and we have centrifugal flow devices, which is tandem heart and VA ECMO. Similarly, for right ventricle, we have axial flow device like Impella RP, and we have centrifugal flow like VA ECMO, the RVAD, as well as the OxyVAD, dual Protect Duo. Not all devices are same, and they cause very different effect on the pressure volume loops. What IBP does, it reduces the filling pressures, but volumes do not change much because it's not a very effective device. VA ECMO, it definitely increases the pressure, but at the same time, it does not reduce the volume, and that's why it leads to problem of loading the ventricle, not unloading the ventricle. Tandem heart, on the other hand, will not change the pressures much, but the volume will be reduced because you are directly unloading the left atrium. Impella will reduce the filling pressures as well as reduce the volume, and it will truly rest the heart. This cardiac power output is another very important parameter and has been shown in the shock trial to be the independent predictor of mortality. You can see here that if you just give medical treatment, then the cardiac power output is just 0.28 and the mortality is 70%. If you add Impella here, you increase the cardiac power output to 0.68 and the mortality improves significantly because 0.6 and above is all right. And if you add, because the patient had RV dysfunction also, if you add RVAD here, then the cardiac power output is 0.8 and the mortality is much lower. So with that, I would just go in briefly in the different devices. IBP I'll be dwelling because we still use it. We have a certain use for IBP, we all use in our setups. And we know that that's how the diastolic augmentation leads to increased coronary perfusion, and the oxygen demand is reduced because of the reduction in afterload. So in chronic heart failure, IBP is still useful. In AMI shock, in like shock to IBP trial, it was a negative trial. But in chronic heart failure, it improves the diastolic blood flow, coronary blood flow and splenic blood flow, and it reduces the systolic blood pressure, leading to reduction in afterload. So cardiac output improves, LV EDP and wall tension is reduced, and rate of LV pressure rise, that is dP by dt, is reduced by 20%. But to be effective, you have to have the significant volume. So now you should use IBP mega, which is 50 ml volume, which displaces the LV volume significantly, or the systemic volume significantly to cause any effect. There have been multiple trials which are all negative, like IBP shock, CRISP, PROTECT, but the guidelines say that these are, it's a class 3 indication for shock. But there is still role of IBP in those patients who are chronically well compensated and then they develop heart failure because of slight decompensation, and that much compensation IBP provides, and it can stabilize the patient so that patient can be kept alive for a transplant or LVAD, and the IBP may be just sufficient for that. And there have been phenotypes. I'm discussing IBP because we still use it. So these are the phenotypes where IBP may be still useful. So all those patients in whom the cardiac index is low, but the cardiac power output index is not too low. The RV has to be normal. That means the PAPI has to be more than 2 and the CVP should be low. It will not work if the RV is also failing. The systemic vascular resistance, if it is high, because it reduces afterload directly. So if the SVR is high, this device is very good. The other thing is that mean pulmonary artery pressure should be high and pulmonary capillary pressure should be less than 25. That means the ventricle is not too bad, LV is not too bad, and the heart rate should not be very high because this device is dependent on the pulsatility. Impella, we know, is an axial flow pump, and it works on the principle of Archimedes screw, and it provides a flow of 4 liters. This important that the more is the speed, more is the flow, and if this is more gradient, that means if the systemic pressure is high, then Impella will not work. The tandem heart takes blood from the RA to the LA and then sucks blood from there and then gives back into the aortic circulation. It reduces filling pressures and preloads. However, it may increase afterload because of the reverse pressures, and it reduces the myocardial oxygen consumption. It's a very good support. ECMO, we all know that it loads the heart because of the reverse flow from the aorta. It is very important to have these tools before we diagnose our patients with cardiogenic shock. Pulmonary artery catheter, dual Lemon catheters for measurement. I'm just finishing. It is very important to have a shock team, because then only you can adequately diagnose the type of shock, phenotype of shock, because a lot of these patients may have a biventricular shock, and if the patient has biventricular shock and you just put one device, it may not be useful. So you have to have a discussion with your surgeon, with your other team, that what device is suitable for this particular patient. So this is just a brief summary as to which device is useful for which patient, and I think the key to success is that you should select the right patient for right indication and then initiate at the right time before the end organ damage starts, and utilize the right devices, and then regularly practice, and then you should have a very good shock team to take you through this. Thank you very much.
Thank you, Dr. Vishal. Fantastic talk and a fantastic overview of all the devices. Does anybody in the audience have any questions to ask Dr. Vishal or Dr. Sankatvelu?
Thank you.
If I may ask Dr. Vishal, I know we talk about LV pressure. In an acute situation, how do you decide? The patient comes to ER with an acute MI and a cardiogenic shock. Do you decide your device therapy on the basis when you see the patient in the ER, or would you decide depending on the financial status, or do you decide I want to start with the IABP and then upgrade? How do you? I know there are datas and all, but in simple terms, for practice for all of us, how do you decide when you see a patient in cardiogenic shock in ER?
Hfai, you have raised a very, very valid point. In fact, the most important deciding factor is probably finances in our scenario. Yes, but still we know that if there's a cardiogenic shock because of the acute myocardial infarction, there is not much role of intra-aortic balloon pump, but still we end up using it because of the finances. And we do slightly different than what has been done in the CSI shock program, where they do the where they unload the heart first and then they stent it. We always, more often than not, we end up doing the primary PCI first and then see the hemodynamics there, and then end up putting up intra-aortic balloon pump at that time. And if we still find that the support is not sufficient and patient is sinking down, the lactates are still high, and we take a cutoff of lactate of 4. If the lactates are still 4 and the urine output is reduced, then this is the time that the patient will need more support. And then we end up putting the pulmonary artery catheter, and we define the phenotype of the shock, whether it's a predominantly LV shock or predominantly RV shock or a BIV shock. If it's a predominantly LV shock and the cardiac power output is the only worry and the PAPI is all right, in that case we'll escalate the support from IBP to ECMO and Impella, depending on what the patient can afford. You must remember that ECMO still costs significantly less and is more easily available than Impella in our country. So we end up using a lot of ECMO in this scenario rather than Impella. Though we may have to have venting strategy on a day 2 or day 3, because ECMO is not going to unload the ventricle. We are in fact loading the ventricle. What we are doing here is just providing the circulatory support.
Having said that, what is though we have been doing, you have narrated what we have been doing so far. First of all, we have to do, first what we are doing is doing a primary and then ending up with a MCS. But have you changed, because you are from a reputed institution, have you changed based on the shock team protocols, or started at least attempting to practice such things? Obviously, it has a lot of practical limitations. Have you got any shock team protocols by just looking at the PA catheter and pack measurements and the lactate? And because recently I came to know that patients who have already been revascularized and finally ending up with a MCS after counseling them, when the patient is very sick, they will agree. That time, obviously, when we are going to institute, we have half the mind whether it is really going to benefit. Definitely, it is not going to benefit. So, and also, as you rightly told, most of the refractory cardiogenic shock where really the MCS is needed, the type of MCS needed is ECMO with immediate or later on unloading. But still, even with ECMO, what they are telling, within 4 to 6 hours we have to unload, otherwise there is no point of putting, because the afterload will go. So it is little tricky in terms of finance. But on the other hand, do you have anything, suppose like a ECMO with the unloading, which is cost effective? Because Impella is very, very expensive and it adds 2 arterial complications. Do you have any simple strategy? Like in those days, we used to do a septostomy and do something like that so that you can at least raise the mortality or reduce the mortality from say 70% or 80% to 50%.
So these are all valid points which we've raised, Dr. Damodaran. And one important point here is that we do see a lot of cardiogenic shock, AMI cardiogenic shock patients, but most of these patients are burnt out AMI shocks. That means they're presenting to us out of window period. We don't see those CSI type cardiogenic shocks where it's a proximal LAD occlusion, and that because of that the patient is in shock. So that means still the myocardium is preservable.
You
While
mean
what
to
we
say
see
in hemometabolic shock?
Yes, what we see, in terms of primary also, if I'm saying that these patients may have had infarction a day or 2 days back in some remote place where they were not revascularized, and now they are coming to us as in cardiogenic shock. So in that scenario, unloading the ventricle first and then doing the PCI, all those principles will not work, because even if you unload, what is the next exit strategy? If we are putting all these devices, we have to have an exit strategy, because if the LV is not going to improve because already the reserve is gone, in that case you may not get the heart in next 10 days or 15 days. So it's very, and this second important point is that when the patient is acutely sick and you're talking about a device of 20 lakh rupees, it's very difficult for them to understand that kind of, because primary angioplasty also they have understood with some difficulty, and then you say that you're going to put a device which is 20 lakh rupees. It's really very difficult to practice the CSI shock type of protocol in this country. That's my personal experience. Though we tried to do it, we tried to create a fund and a sort of a, some sort of discussion was there. But then unfortunately, the reason is that in acute situations, it's very difficult to have this kind of discussion, and then to have the pump available in the hospital and then implement it, that's also a very difficult part.
So as you said, you got most of our patients are multi-vessel disease patients presenting with an acute MI at that time. So they also have other vessel disease as well. So in those kind of situations, if you put a MCS and you do the primary PCI or the culprit vessel PCI, would you recommend to do the other vessels before you offload the MCS, or would you treat the patient, send them home and bring them back? What is your experience on these multi-vessel patients coming with primary, where you have an MCS? Without MCS, we have a clear data.
It is clear. Yeah, as you have very rightly mentioned, when there's, according to culprit shock, there is no role of opening the other vessels, irrespective of the viability and other things. Or whether, even if the patient is in shock, you don't open the other vessels. However, if the patient is on support, even if intra-aortic balloon pump support, before we take it off, we always have a discussion that whether we can do the procedure safely and whether the patient is going to improve the ejection fraction sufficiently so that we can wean the patient off. So we end up doing the other vessels also in the same setting more often than not. Same setting in the sense, same hospitalization.
Yeah, fine. I just have one comment to make. If we have instituted a VA ECMO for a patient, I think unloading the LV, as you rightly said, is so important in this scenario. It's a small matter to make a small thoracotomy, just open the LV apex and put a pipe. It is fraught with complications. You're doing it with an LV which has had a recent infarct, so the risk of bleeding is high. But the benefit of unloading is perhaps, so if you have a shock team and the surgeons are prepared to do it, I think it doesn't add to the expense. It's a small thoracotomy. The patient is already ventilated. Just put a small pipe into the LV apex and drain it down into the ECMO circuit.
Perfect. So yeah, venting strategies are very, very important after the ECMO, and this is one of them, as Dr. Sundar has said.
And even we interventional cardiologists also practice LAVA ECMO, LAVA ECMO, without doing without opening the chest. And one more cost-effective strategy, the LAVA ECMO, when you are able to prolong the patient on LAVA ECMO with an exit strategy like VAD, obviously it saves the money of Impella, which is 24 lakhs, which is equivalent to a VAD's cost.
Yeah,
that is what is practiced in Europe.
Yeah.
Europe, they are not much after Impella. They are putting a ECMO, venting with a central as well as interatrial septostomy, LAVA ECMO. Then at the earliest, maybe within 12 days or 14 days, they are taking up the patient either for a transplant or for a VAD. That is the exit strategy. Without the exit strategy, the short-term MCS has no meaning. That's what I understand.
Thank you.
I think we don't have the other speakers here, so let's close the session.
Thank you, moderators and panel members. It was a spectacular session. It was a pleasure listening to you. Moving on to our inaugural session, may I invite Dr. Chopra and HFAI team for inauguration. Delegates are requested to keep their mobile phones on silent mode during the session.
I'll request everybody to stay on. We have a very short inaugural session for just about 10 or 15 minutes. And then there's a joint session of Heart Failure Association with the European Society of Cardiology. There are 6 excellent talks. 4 of them will be virtual. They'll be live on the screen because for various reasons, some of the speakers couldn't come. And Dr. Mirza is already here. So I think in another 2 or 3 minutes, we'll start the small inaugural function, and this will be followed by the joint session. Ask them to connect with Dr. Rosano and others.
Good evening. We are starting the inaugural session. So I invite Dr. T. Sundar, cardiac and transplant surgeon, to the podium. I invite Dr. D.K. Chopra, our paper, and Professor Mirza to the podium. Dr. Harikrishnan, the president and the most active academic person to the podium. And Sanjay Mittal is here. Dr. Sanjay Mittal is the next year's organizing secretary. Okay, he will be joining us. So, Dr. Uday Jadhav, Dr. Uday is here. I request Professor Hussain onto the podium, please. So, Professor Mayor, being one of the senior most person, should see his academic interest. He came here at 8:45 and he has not left here. So I think that also requires an applause. So the flow of the proceedings should be like this: the new frills, HFIs, pure academics and new frills. So flow will be like Dr. Sundar will see the welcome address. They will be followed by Dr. Harikrishnan, the president of the HFI, the presidential comments. Then he would invite Dr. Chopra to share a few words. Then Professor Midja and Dr. Zoni and Dr. Taylor will be joining remotely. And following that, there will be a release of the Hfai Association of India's formal journal release. And Dr. J.C. Mohan will have his all 1 2 minutes each felicitation and final vote of thanks by me. So over to Dr. Sundar.
Oh my God. Good evening, ladies and gentlemen. It gives me immense pleasure to welcome you all for the 9th annual meeting of the Heart Failure Association of India, which is a combined session between cardiologists, cardiac surgeons, nurses, and allied professionals. It is indeed a double pleasure because it's 7 years on. It seems just like yesterday, but 7 years ago, in 2017, Chennai had the honor of hosting the similar program. We had great support from Dr. Chopra, as always. We thank Dr. Harikrishnan and the rest of the members, Dr. Mohanan, for the help given to us. We welcome you all. Thank you.
Dr. Bhagirath, Dr. Shah to the podium, please. So I invite Dr. Harikrishnan for the presidential address.
Good evening, ladies and gentlemen. Hearty welcome to this inaugural function. Heart Failure Association, since its inception in 2015, has grown to be one of the major academic bodies in the country. And our tagline is improving heart failure care. We are currently running multiple academic programs throughout the year in addition to the annual meetings which we do. Last year we have done 49 online academic programs. It is much more than the ESC, which is running only 48 programs. We run PG training programs, nurses courses and physicians courses to improve the prescription of guideline directed therapy and also evidence-based practices in heart failure. We support research activities by giving research grants and also recognize by giving awards to the best dissertation by the DM and DNP postgraduates. We have a research abstract session every year, and this time we have got an overwhelming response of 40 abstracts, and they were presented, and 3 of them will be awarded in this inaugural function. We started a newsletter called Heart Failure Rewind last year, which might have reached most of you. And we are now coming out with our own journal called Heart Failure Journal of India, which will be released by Dr. Medja. It is published by Walters Kluwer, and we have a significant international contribution in those articles. We also support basic research in heart failure by doing various activities. We started the meeting called Heart Failure Conflex, which is a meeting point of the basics researchers and clinicians caring heart failure. And this is a curtain raiser meeting, a week prior online meeting to our annual conferences. This time we have around 25 abstracts, very good, very high quality research. We were stunned to see the amount of basic research work happening in heart failure and cardiovascular research in India. We have an MOU with Heart Failure Association of ESC, thanks to ESC, which is a constant support for us since our inception. Thanks Dr. Medja, who has come a long way to represent the ESC. Unfortunately, Dr. Rosano and Dr. Metra could not join due to an urgent meeting with the ESC. And last year we had an MOU with Heart Failure Society of America. Dr. Tierling was supposed to come, but he had some viral illness and he could not join. We have now doing joint programs with Asian Heart Society. We have a combined session tomorrow. I thank Dr. Abraham Umman and Dr. Sundar and his excellent team for this wonderful meeting which they have arranged. And so with these words, I thank everyone for joining and welcome to this function. Thank you.
Dr. Chopra, please say a few words.
For me, it's very heartening to see what has happened in the last 8 years. We started this as a very small project, but thanks to the efforts and untiring contributions from our colleagues, this association has come a long way. We are very thankful to the Heart Failure Association of the European Society of Cardiology because they have constantly supported us, and right from the first year, we have had joint sessions with them in our meetings as well as in their meetings, in which several of our people have participated and had a chance to present their work. So it has been a very fruitful journey, and I'm sure this thing will continue. We look forward to more and more participation from delegates. The object is that we should improve the state of heart failure in our country by various educational programs, not only for cardiologists, but also for physicians, for nurses, and have very, very fruitful joint sessions with the surgeons, because it's only with an amalgamation of everybody that we'll be able to achieve what we have set out to do. Thank you very much.
Dr. Professor Rosano as well as Professor Tierling has joined us virtually. So can you can welcome Dr. Tierling and
Hello, Dr. Rosano. This is Vijay Chopra. Very warm welcome to you, and we look forward to a brief message from you.
Yes, thank you. And I see
you're
online
muted. Dr. Tierling, a very warm welcome. We have missed all of you badly. We wish you were here, but we understand for various reasons that you couldn't join us.
Yes, my apologies. Viruses had other intents for me.
Yes, and same with some of unfortunate meetings at ESC meetings that we couldn't avoid and skip. So I'm really disappointed not to be there in person. And I wish to thank you for the invite, and I wish to thank you for giving HFA also the opportunity to have this joint session together with HFSA, and it's a pleasure to coordinate, to work with also with Professor Tierling here, and who's a dear friend. So we have a very long-standing collaboration with the Heart Failure of India, and for us it's a privilege, both because of the scientific importance, but also because of the increasing importance of the Indian cardiology in the stage, in the world stage of heart failure. So it's a great privilege, and I look forward to this meeting and in the future sessions.
Thank you, Dr. Rosano. Dr. Rosano, as you know, is the president of Heart Failure Association of European Society of Cardiology. And may I now request Dr. Tierling, who is president of the Heart Failure Society of America, to say a few words.
Yes, fantastic. And I did want to once, just as well, please thank everybody, the organizers, for the great invitation here. The HFSA does not have as long as a relationship, although we've been involved with the Heart Failure Association of India for quite a while, and we look forward to many, many years of much closer collaboration. I think, as my dear friend Giuseppe already suggested, really these international connections, I think, are essential for us being able to advance the field of heart failure and learn from each other. And one of the things that I've loved about the meeting already is, even though I'm stuck here in San Francisco, I've had the opportunity to listen in on multiple of the lectures and have already learned a great deal, and look forward to learning more from all of our colleagues during this meeting. As you know, I mean, India has emerged as and I think it's now the most populous country in the world, and the largest democracy, and one of the leading scientific and technological centers of the world. And so it's fantastic that this organization has put together this meeting, and I'm very thankful for the opportunity to be part of it. So thank you for this, and looking forward to learning from all of you some more.
Thank you, John. Has Dr. Metra joined? Not yet. So maybe we can carry on, and if Dr. Metra joins, then we can ask him to speak a few words.
Thank you very much, Professor Mitra. A few words and your reflections on our country, and I guess it's your first visit to India and South India in particular.
So, thanks for the opportunity and the privilege to be here. As said, it's my first time in India. I just wish I could prolong my stay, but tomorrow I need to be back in office. Anyway, this was a great experience, full-packed program, great lectures, and happy to be part of it. Also the part of this session, which is ongoing for several years. Also, we are returning the hospitality at the Heart Failure Association Congress, which I had the pleasure to chair in 2018, and this year it will be organized in Prague. So I believe that such encounters, and primarily in person, if not possible, then online. Obviously, there are some reasons that kept my colleagues either in Europe or in the States, are the way to advance the friendship, the collaboration, and also scientific and clinical experience. So I believe we should pursue this in the future, and I'm more than happy to be part of the present event. Thank you.
Thank you. Thank you very much. I now invite two more aspects, the winners of the quiz, or the best paper, sorry, and the release of the journal. So, Dr. Hari Krishnan. Okay, while your persons are not at come. Okay, so I will ask both Professor Mohan as a senior most, one of the, I will not, senior persons, I would request him to say a few words.
Thank you, Dr. Abraham Mohammed. This has been one of the best meetings of the Heart Failure Association of India, and I would express my deep gratitude to Dr. Vijay Chopra for having founded this association 8 years back and introduced me to the enormous talent which exists in this country. And I am particularly indebted to Dr. Stephen Anker, Dr. Inder Anand, who helped us in founding this association, and of course to Dr. Chopra especially, because he has introduced me to such wonderful people like our current president, Professor Hari Krishnan, Dr. T. Sundar, Dr. Abraham Oman, Dr. Bhagirath, Dr. P.V. Jayagopal, and many more people who are far more talented than me, and I hope to continue to learn from them. Thank you very much.
Thank you, sir. And so next is we are releasing our journal, and Dr. Hari Krishnan in particular have been absolutely fervent in his belief that no organization is complete without a good journal, and for having a good journal you should have collaboration. It's collaborate or perish. So like he has put in a lot of work, and I think Professor Rosano has written a welcome Dr. Marco Metra. So we were we're in the middle of the program, and Dr. Rosano as well as Professor Tierling has given their views and messages. I request you to share your messages with your with the Heart Failure Association of India and the gathering here. Professor Metra, please.
Hello, everybody. Am I?
Am I chairing?
No, you should, you are in the inaugural session, so if you have few words of wisdom and comments and about this
Okay. Just no.
collaborative program.
Thank you. I'm extremely honored and proud of your invitation. Very happy to be with you. Unfortunately, I have these commitments. As soon as I will finish with you, I have this meeting for the Ministry of a University for the habilitation program that I am involved in. It's life. But I'm so happy to see you and to welcome you. Thank you very much.
Thank you, sir.
And then Professor Rosano will send the greetings from HFA officially.
He's already done that, sir. And thank you, Professor
Happy to see also John Diuretic.
kind words. So I invite Professor Harikrishnan to say a few words about the journal. And Professor Midja is here personally, so he would release the journal in the presence of the Presidents of Heart Failure Association of ESC, Professor Marco Metra, who's a doyen and the editor of European Heart Journal, and Professor Tierling, the President of Heart Failure Society of America. Over to Professor Harikrishnan.
So, Heart Failure Association is coming out with its own journal called the Heart Failure Journal of India. So, we have good support from ESC, and also we have multiple articles from international authors. So, I hope this will be the medium of communication to spread the message of guideline-directed therapy and improvement of heart failure care for physicians and general practitioners in India. So it is published by Walters Kluwer. We are planning it 3 times a year. So the first issue we are releasing now. So I request Dr. Medja to release the first issue.
And maybe a few words about the journal. Marco in particular knows how the journals are run, but I also have some experience, including other members of the panel. So this is child born, and it needs some help before it gets to the stage of maturity. These steps will be difficult, but I believe with the help of the friends, with a well-organized team as you have, you will reach the level of next step, that is inclusion in the citation database, and then the next step, inclusion by the Clarivate in a couple of years. And I'm very much confident that you can count on our help, and because that is what there are friends to help you when you need help.
Thank you so much. Now we invite the winners of the session, abstract session which we have conducted. The first prize is Dr. Devesh Kumar from All India Institute of Medical Sciences. He has presented his data on sarcoidosis, a large series from India. So I request Dr. Medja to hand over the prize to him. So the certificate is shown at the background. You will get a prize of 50,000 rupees. The check, believe us, the check will be handed over to him in 2 weeks' time. The second prize goes to Dr. Deebanjan Bhattacharya on pediatric pacemakers, one of the largest series. I think Dr. Medja was the judge, one of the judges, and he was appreciating the amount of work which has been done. Dr. Deebanjan Bhattacharya from Sri Chitra Institute, Trivandrum. And 25,000 prize again. A third prize goes to Dr. Sonu Thomas. Sunu C. Thomas. Is she around? She is not there. So she will also receive a prize of 25,000 rupees. She has presented the work on a model to improve the heart failure care patients. A software-based model to improve the care in heart failure patients. That is also from Achyuta Menon Center of Sri Chitra Institute, Trivandrum. Thank you.
So we are a little short of exactly 5. So I request both Bhagirath and Dr. Uday Jadhav to just 2 sentences, words of illustration.
I must say that I'm really proud and privileged to be part of this wonderful team. I'm learning every day. Thank you, Chopra sir, who's been a mentor to me. The previous conference I organized in Bangalore, he literally handheld me and got me to do the things. That's how I learned how to be in this team. And once again, truly privileged to be part of this wonderful family.
Dr. Uday is a vice president.
Yeah, thank you, Abram. Thank you, entire team, VK Chopra. When we started this organization at Medanta in that small boardroom, there were few eyebrows which were raised, and people thought that Heart Failure Association of India, is it even a territory to get into? And look at it, now heart failure has become so vital. To our help comes 2 things, the therapeutics, but more important, as you listen to the scientific deliberations today, how the science has advanced in heart failure. It's just amazing how we have come into an entirely new era of science. So thank you very much. I think it's been a pleasure.
So we take pride in being on time. So last is a vote of thanks by me. So big word shout of thanks to a lot of people who were part of this meeting, all the people on the chair, Dr. Sundar, Dr. Hilda, with my support, all the people, big and small, I'm not naming them. It's very difficult because a lot of regulatory changes came to the country, so organizing meetings were very difficult. And I personally thank all the international faculty. Professor Mitja came very short notice from a long distance, and Professor Tierling, Professor Rosano, Professor Metra. So thank you very much. And without much ado, I close the session and we go on to the scientific combined sessions between Hfai and the Heart Failure Association of the European Society of Cardiology. I declare the session closed. I forgot to mention, we are announcing not only next year, next year meeting will be in Delhi. So see you all in Delhi, and and the dates are also fixed, 9, 10, 11th. So it's easy to remember, usually the second Saturday. So you can remember second Saturday of February, and 9, 10, 11th. It will be in Delhi. Dr. Sanjay Mittal, the organizing secretary. And 2025 it will be from Bombay, so Mumbai. So I welcome all of you for that meetings also.
So you are the chairperson. So who all are there? Hari? Who all? Okay, so it's a great pleasure to go on to the next program, which is a joint session with the European Society of Cardiology. May I invite Dr. Mirja to please come and co-chair. Dr. Hari Krishnan, Uday Yadav, Abraham, all of you are invited. Dr. Tierling, are you around?
Yes, I am certainly around.
Okay. So,
it's lovely to see you, my friend.
Yeah, so you are co-chair, So please give your valuable comments whenever. So the first talk is coronary revascularization in patients with LV systolic dysfunction, current challenges and clinical outcomes. Dr. Midja will speak on that.
Thank you for the invitation. It was at a very short notice, and I, at this stage, need to thank also the ambassador, Indian ambassador in Ljubljana, who make possible that the visa was issued and I could travel to India. Happy to be here. In this talk, I will mostly rely on the guidelines, and because the guidelines were published in 2021, I also did a review what has appeared since then, and it's relevant to this topic. So the basic documents for the text in the guideline are the HEART study that had very ambitious goals. They planned to include randomized 800 patients with primary endpoint of all-cause mortality, but they eventually enrolled 138 patients, and the idea was based on the hibernating myocardium as evident at that time, but that was almost 15 years ago. So the patients were randomized to conservative strategy or invasive strategy. In invasive strategy, eventually they have pushed for revascularization if the patients were eligible. Now, these are the results of the primary endpoint. There was no difference whatsoever, but keep in mind that the study was largely underpowered to show any difference. And another study that is mentioned in the guidelines, a randomized trial, is the one that actually shows the benefit of revascularization against medical therapy alone, a large trial that entered the guidelines, and is also the basis for the statement in the guidelines as it is. The rest of the information in the guidelines was retrieved from, this one is from the registries, that was comparison of stenting versus CABG, showing generally no difference, but then in two subgroups, two endpoints, there was benefit of CABG over stenting in terms of myocardial infarction, whereas for stroke it was vice versa. Rest of the evidence from the guidelines comes from a meta-analysis, and in meta-analysis generally there was the signal in favor of CABG versus PCI in general, and also then in some specific scenarios like prevention of myocardial infarction, repeated revascularization, and stroke, or in patient-related scenarios, that is specific vessel or multi-vessel disease, and so on. So in the end, the text in the guidelines is as is, so that coronary revascularization should be considered to relieve persistent symptoms despite optimal anti-anginal drugs, and this, I believe, is very important. Coronary revascularization may be considered in some specific patients even without symptoms, and what is more important, also important, that CABG apparently has some advantages over if the patients are suitable for surgery. Now, the important thing is that although I'm here on behalf of the European side of cardiology, that our colleagues in the States generally share this opinion. This is an interesting paper I would like to draw your attention to. It is about comparison of guidelines from Europe and the States. I like this figure very much because it highlights what is the same, what is different. But here is the text for coronary artery disease, where the message is that we are generally on the same side. What has happened since the guidelines were published? Colleagues in UK have conceived this trial, so comparing percutaneous sorry, to compare percutaneous revascularization versus optimal medical therapy alone. So this trial eventually was published in New England, showing that there is no relevant difference between PCI or optimal medical therapy, with maybe one signal that is with regards to unplanned revascularization, in which group the PCI had some benefit over optimal medical therapy alone. In scientific community, this received was embraced based on the previous text from the guidelines, and actually saying that results of Revived confirmed the importance of guideline directed medical therapy for patients with heart failure. And again, emphasizing that this is the first step we should do, and then to re-evaluate whether the patient actually has problems and is in need of revascularization or not. And this brings me back to one trial that was published ages ago in Lancet. It's the Christmas trial that actually tried to show benefit of carvedilol in two groups of patients with hibernating myocardium and non-hibernating myocardium versus placebo, in terms of improvement of left ventricular ejection fraction, and also the number of hibernating sections in myocardium. So these are the results. The study population, as you would expect, there was no relevant difference in the primary endpoint. That was the left ventricular ejection fraction change at the end of observation period, but there was some signal that the more the ejection fraction was improving, the more benefit was there in the hibernating myocardium in particular. Also, at this figure 3, in particular in those that had more than 60% uptake, showing that there was the benefit of the drug, mean number of hibernated myocardium sections per patient was improved sections per patient was larger. So again, coming back to that, the first thing should be first, and that is optimal medical therapy, because we are talking about now the chronic condition, acute condition is something else. But in chronic patients, the first line therapy is beta blockers and then other therapies, and if the patients are still symptomatic, then consider potential revascularization. But if your patients have some specific anatomy or specific comorbidities, then you can maybe prioritize your patients. Now, these were the patients with systolic dysfunction, but this is only half of the world we live in. So therefore, I'm adding this very recent publication from European Journal of Heart Failure, where colleagues from the States presented the revascularization in ischemic heart failure with preserved ejection fraction. What was obvious is that the survival of patients that received revascularization and had HFpEF, that is the red curve, was very much the same as the patients that received revascularization but had no heart failure. So the best prognosis, whereas the prognosis for Hfref is much worse. What is also important is that in patients with HFpEF, the cumulative incidence of myocardial infarction was the highest, but this didn't translate into increased mortality. So what is the message from this study is that in HFpEF patients, the survival of these patients is very much the same as of the patients without heart failure. So these patients actually benefit a lot from the revascularization. And with this, the current treatment of the patients with heart failure and systolic dysfunction and with symptoms of angina, first consider medical therapy. Then if this is not successful, then potentially consider revascularization, and CABG has some advantages. If you have the other half of the patients that is heart failure with preserved ejection fraction, do CABG as soon as possible, because then their prognosis is the same as in the patients without heart failure but with coronary artery disease. I'll stop here and I would be happy to answer any questions. Thank you.
Mitchell, let me ask you, I mean, heart failure with preserved ejection fraction, that of course is easy to understand, the ventricle is still preserved. If a person has heart failure, EF of say 30%, and a PET scan shows viability, and they're good target vessels, should it not be a class 1A indication?
Well, we don't have any evidence for that.
Conceptually, I mean, if there's viability and they're good target vessels, so if you have a patient, will you or will you not send that person for revascularization?
Well, that is a very difficult question. I personally would also be inclined to that. I believe that generally we are over-treating our patients, in particular with PCI. But that is my humble opinion, because I believe that we should control the process that is in the vessel and not to open the vessel as such. And that is possible through medical therapy, cardiac rehabilitation, and this is pretty much neglected in many patients. So I would still be inclined that first to optimize medical therapy to be sure that the patient really takes medical therapy, and if the patient is then still symptomatic, okay, then I would go for revascularization. But first step is first.
Can I ask Dr. Tierling for his opinion? Yes, Dr. Tierling.
Yes, no, I think that was a really brilliant overview of the data. And it's, I think, you know, my colleagues have already brought out one of the real dilemmas here, because it makes perfect sense that if you have decreased left ventricular function in an area of the heart that has decreased blood flow to it, that by improving, and is viable, that by improving blood flow to it should improve outcomes, and it should help make the patient do better. And it's one of the things that we just all assumed was true. And yet in every study where we've actually looked at it, there has not been that kind of advantage emerge. So I guess the question that I have, you know, we know that the old adage that dead meat don't beat, right? So if it's dead, you can't improve outcomes there. But why do you think, even though in the trials, the Stitches trial, where they looked at you know, the viability, and Heart, where they looked at viability, in all of these studies where they revascularize, why do you think we aren't able to demonstrate a benefit? And that's a really hard question. So,
well, maybe we should look more in detail into myocardial metabolism. Maybe that is one of the ways how to handle it, because that myocardium was deprivileged for a certain period of time. We don't know how exactly in these myocytes the processes have changed, and only to revascularize those segments, maybe it's not enough. But I cannot imagine how we could study this. Maybe now with cardiac magnetic resonance and with specific dyes, with specific isotopes, we could potentially look into that. Because again, animal studies are one, and you cannot directly translate that to humans, I think.
And there is the potential signal that we see from Stitches, which is the largest of these trials, that where if you wait long enough, there may be a signal emerging for benefit. So, but I think your point about trying to looking at metabolomics and areas in terms of the myocardial metabolism is really crucial. I think Giuseppe has his hand up as well.
Let me ask JSP, if there is angina in addition, let me throw in another thing.
Yeah,
Would that change your...
absolutely.
But we
Absolutely.
know that many
That was the
diabetic,
point I want to also
but we know
make.
that many
Because
diabetic patients may not have angina. They may only present with dyspnea. I mean, it's well known. So the absence of angina, for example, in a diabetic person, I mean, should that be held against that person? Because you said if it is angina, that would make a difference.
Well,
I'm just trying to make things more difficult.
Yeah, I will not attend this meeting again because the questions are too difficult. But okay, if maybe what could be the way out is to be objective about the level of patient discomfort. We know that the diabetic patients may not present with angina; they present primarily with dyspnea. And then ergospirometry could be the answer. Cardiopulmonary exercise testing could be helpful in these patients. But I would put those patients on all the drugs possible, and if still symptomatic, then definitely revascularization is the last man standing for those patients, yes.
Okay.
I treat diabetes. So in diabetic patients who's already having ischemic heart disease, if they have on top of that CCF, congestive failure, what would we do? Will this revascularization help them? Because there the IHD in them is a diffuse disease rather than a localized block. So in a diffuse coronary artery disease in diabetes, will revascularization actually help?
So this is what has been answered, that if there's a diffuse disease and the person is in heart failure, that's what the STITCH trial and others have shown. First treat medically. And if there is angina, then maybe you can think about it. The big trials have not really shown much of a benefit of revascularization. With that, I think, thanks Mirja, and we go on to the next talk. So let me invite Professor Rosano to tell us, reconsidering the ejection fraction centric view of pharmacological treatment for heart failure. Is ejection fraction really that important, or have we moved on?
yes. Thank you, Professor Chopra. And when I was preparing my talk, then I noticed that Professor Tilling was here with us in the panel. So I skipped away from any comment on imaging and and left ventricular ejection fraction measurements. So this will be mostly a talk specifically on pharmacology. And I think when we look at the pathogenesis of heart failure, we always focused mostly on heart failure with reduced ejection fraction, and only most recently we had more interest in preserved. And the way of thinking was that we have an event, the event leads to a damage, and we have compensatory mechanisms that then become maladaptive. And part of these mechanisms, especially in the end stage or in the stage where the left ventricular ejection fraction is significantly reduced, are mostly represented by the activation of the neurohormonal response. And it was clear in the mid-80s that the increase in sympathetic activity expressed by norepinephrine or the activation of renin-angiotensin-aldosterone system are very important in patients with heart failure. And the first study that looked at that was the consensus study that looked at patients with severe congestive heart failure, demonstrated a clear benefit of enalapril over placebo. But when you look at the inclusion criteria, you can see that in those early studies, I mean, we're talking about mid-80s, the diagnosis was, the inclusion criteria was heart failure based on clinical history with signs and symptoms of dyspnea without a clear assessment of left ventricular function. And indeed, the measurements of left ventricular functions were not required at that time. Then we had the SOL study that demonstrated clearly a clear benefit again in patients with heart failure that were less severe compared to the consensus. And again, in this case, there was a measurement of left ventricular function. There was 35%, but as you can see, the ejection fraction was measured in different ways, going from angiography, radionuclide techniques, and only a minority at the measurement with echocardiography. And therefore, we can say that especially given this, the accuracy of measurement of left ventricular function, probably the left ventricular function could have been anything between, say, 20 and 40%. Then continuing on studies on renin-angiotensin-aldosterone system, we can see the effect on in rails, where the first of all, it was conducted in patients mostly on ACE inhibitors, and I think that that is very important. And it is important to note on the number of patients who are on beta blockers, and this is because often we tend to use the MRAs only when patients have received a beta blocker and ACE inhibitor, but that is shouldn't be anymore the case, as RAILS was clearly conducted in patients who were not taking significantly beta blockers, and the study was conducted in patients with a left ventricular function below 35%. Similarly, we had the eplerenone in heart failure that clearly demonstrated a benefit on mortality, morbidity, hospitalizations. In this case, the left ventricular function was 40% on or less. So we see we had studies that started with no assessment of left ventricular function. Then they selected 35%. Then they went up to 40%. At that time, it was clear that a sympathetic activation was important in determining the prognosis of patients with heart failure, and the greater the neurohormonal activation, especially sympathetic activity, the greater the mortality. And also there were evidence that probably the use of the short-term use of beta blocker was detrimental for contractility. However, data came suggesting that over the long run, the beta blocker therapy was significantly effective, and we had all studies with beta blockers going from the MERIT HF to CBIS and the US Carvedilol program that looked at the effect of beta blockers in patients with mild to moderate heart failure. And as you can see, it was a significant and consistent reduction in mortality in patients with a left ventricular ejection fraction below 40%. So some of the studies included 35, other studies 40%. Then CINUS came, and CINUS was conducted with nebivolol in elderly patients with an age greater than 70. And they needed to have heart failure documented either with hospital admissions in the previous 12 months, or documented left ventricular function less than 35%. But when we look at the distribution of the left ventricular ejection fraction in seniors, you can see that there was a significant proportion of patients that had a left ventricular ejection fraction greater than 40%, and even patients with a left ventricular function greater than 65%. So this was a first study that extended the left ventricular threshold above say 35%. Of course, I'm not talking about the digoxin studies conducted earlier on, or the one with hydralazine and nitrates, where assessments of left ventricular function were not clear. Then for beta blockers, it became evident also that there is a variability on efficacy according to all-cause mortality and cardiovascular mortality across the left ventricular function. That the benefit seems not to be entirely there in patients in atrial fibrillation, but in those in sinus rhythm, there is a loss of efficacy above 40%, 45%. And for sure, in those with left ventricular ejection fraction greater than 50% in sinus rhythm, there's no benefit for beta blocker therapy. We conducted a meta-analysis of all the beta blocker trials available to get this effort was led by John Cleland. And again, we demonstrated that in patients with below 40%, there is a clear effect of beta blockers on all-cause mortality, death, hospitalizations. In the group between 40 and 49%, there is loss of this efficacy, especially on cardiovascular hospitalizations and cardiovascular death on hospitalizations, and above 50%, there's no clear benefit. Continuing on trials that came along, there was the SHIFT study with ivabradine that was conducted again in order to enrich the criteria in patients with a left ventricular ejection fraction less than 35%, and the study clearly demonstrated an efficacy of ivabradine in those patients with a reduced ejection fraction, sinus rhythm, and a heart rate greater than 75 beats per minute. Just getting to the new era, 2016 onwards, where the paradigm HF that started the study in patients with an LV ejection fraction less than 40%, but then moved to a left ventricular ejection fraction less than 35%, together with other inclusion criteria. We know very well the results of the study that was very significant. And but again, there was a signal here that in patients with a left ventricular ejection fraction, that the sacubitril valsartan greater than 35%, sacubitril valsartan could not been entirely effective. And this was a signal that was then confirmed by Paragon, that was conducted in patients with a left ventricular ejection fraction greater than 45%, where basically sacubitril valsartan was not effective in reducing the primary endpoint and the secondary endpoints of the study of cardiovascular death and heart failure hospitalizations. So we are moving with the left ventricular ejection fraction above 40-45%, and we had a lot of trials that look specifically at this population of patients. You can see that apart from seniors that included patients with left ventricular ejection fraction below 35%, but when we looked at the population with a left ventricular ejection greater than 35%, there was an effect. All other trials were completely negative. With Lars Lund, we analyzed the data of the Candesartan program, of the CHARM program, and we confirmed what we had already demonstrated with beta blockers, is that you have a beneficial effect of the neurohormonal blockade up to 40-45% above that left ventricular ejection fraction in those patients with PEF or those with MREF or those with PEF. You tend to lose the efficacy. Then the era of the SGLT2 inhibitors came, and they demonstrated an efficacy in patients with at risk of heart failure. We had the data, as I said, of MRAs in patients with preserved ejection fraction, where you can see that above 50%, there's no effect. The study was negative, so we cannot really comment on a negative trial. But then the SGLT2 inhibitors then clearly demonstrated and efficacy of SGLT2 inhibitors in reducing mortality and morbidity in patients with heart failure and reduced ejection fraction. The soloist with an SGLT2 and inhibitor, SGLT1 inhibitor, with demonstrated a significant effect on even in patients with a left ventricular ejection fraction. There was in many patients above 50%, and this was the first evidence that we had of an efficacy of the SGLT2 inhibitors in patients with preserved ejection fraction. So ranging from, you can see that there was a similar efficacy in patients with a left ventricular ejection fraction less than 50 or greater than 50%. So we have started to gather evidence that whilst for all the classical heart failure treatment there was no benefit, then there is a clear benefit for patients with preserved ejection fraction. And then we had the DELIVER and EMPEROR trials that looked specifically at the effect of dapagliflozin and empagliflozin in patients with preserved ejection fraction. And they demonstrated clear effect on the composite endpoint of heart failure hospitalizations and cardiovascular death, and a slightly different effect on individual components, but I would say the effect was very consistent. And you can see in the meta-analysis of EMPEROR Preserved and DELIVER, there was a significant effect of these drugs on cardiovascular death, hospitalizations, and first hospitalization. So I think now it's time to reconsider the treatment of left ventricular function in our treatment. So I think that whenever we see a patient with clinical heart failure, we may wish to measure the natriuretic peptides and then start from the beginning either dapagliflozin and empagliflozin, because they have been demonstrated to be effective all across the board. Then if we have we need a measure of left ventricular function, because if it's below 40%, then we need to use, according to the European and American guidelines, the 4 pillars of treatment. Then we can use and modulate according to the different patient need and profile. But if the left ventricular ejection fraction is greater than 40%, then we will have to stick with the drugs that are effective, so dapagliflozin and empagliflozin, and then treat the comorbidities according with those medications that are more effective and have been proven to be effective in those populations. And I'll stop here, and I shall be happy to take your questions.
This one is on. Yeah, thank you, Professor Dr. Rosano. You are able to hear us well now. One quick question, as you looked at the entire spectrum of the LVEF, that in India, there has been a little renewed interest in combining ivabradine with one of the beta blockers, let's say bisoprolol, and for lowering the heart rate in Hfref. You think, how do you look at it? Is it necessary to optimize the beta blocker dose before we add ivabradine, or does it make sense to add ivabradine a little early in that set of patients which falls in the indication of sinus rhythm, EF less than 35 and heart rate above the desirable levels?
I think that here we may have a different opinion with John Tilling. And I think that, in my view, what is important is that, we very rarely manage to optimize the beta blocker dose. If we look at the STRONG HF, the STRONG HF was a study of intensive medical treatment and optimization of medical therapy. Only 50% achieved the maximum dose. If we look at CBCELD, we had, again, a study of forced uptitration of bisoprolol and carvedilol, where only 25% achieved a dose greater than 50%. On the other hand, we have some studies where beta blockers and ivabradines were used together from the beginning, and they demonstrated that you achieve a higher beta blocker dose if you use it together with ivabradine. Now, my reading of SHIFT is that the SHIFT is not a study of ivabradine versus placebo. SHIFT is a study because 92% of patients were on background beta blockers. So the SHIFT is a study of beta blockers. So 92% were already on beta blockers. So it's the effect, I agree, that was small, but the study demonstrated that in patients with high heart rate, beta blocker plus ivabradine confers a greater benefit than beta blockers alone. So I think that there is a rationale behind it. Also, given the fact that we have many treatments available today and that may have an effect on blood pressure, then probably that makes sense because it controls the heart rate without having such a negative effect on blood pressure. But I'm sure that Professor Tilling has a completely different opinion.
Yes, John, because that's the experience in India too. We have not been able to optimize the dose of beta blocker at all. And so this question comes up. Yes, please, Professor Dr. John.
So I agree, sort of. I will take my Buddhist middle way here. In as much as I believe that the beta blocker trials have all consistently shown a significant reduction in mortality. And so it's absolutely essential that you maximize the beta blocker dose first to maximize that beneficial effect. If at the end of maximizing that dose, and my colleagues love to use they aren't on the target dose. Well, most of the trials didn't get the patients on the target dose either. That's not how the trials were done. The trials were done to get patients on the maximally tolerated dose. And so once you have the maximally tolerated dose of a beta blocker, then I believe it's appropriate to add ivabradine or some other therapy. But given that ivabradine did not show any benefit on mortality, I would not use it instead in a way that might limit your ability to use a beta blocker. So I personally, and I think it's consistent with the US guidelines, and I thought it was actually consistent with the European guidelines as well, where you maximize your beta blocker dose before you initiate ivabradine.
Professor Marco,
if I can make one other comment about Giuseppe's discussion, I think it's very interesting how we have, he brings up consensus, but I'll point out the consensus actually used a radiologic measurement of left ventricular volumes, and the left ventricular volumes had to be greater than 600 mLs per meter squared body surface area, which is a huge heart. And so all of those patients had severely reduced ejection fractions. You can't get that big of a heart without a poor ejection fraction. And then finally, I think it's very important for us as we move forward to match ejection fraction with the mechanism of action of the drugs. There are going to be certainly some drugs that will work across the entire spectrum of ejection fractions, and there will be other drugs that specifically target the pathophysiology of HFpEF versus the pathophysiology of Hfref. So I think we need to be open to the future of heart failure, where I think we will get more personalized therapies targeting those specific etiologies.
Marco, your opinion?
Nothing to add, indeed. I think it's okay. Giuseppe and John Tiering, Professor Rosanna and Tiering, they say everything. I'm fine. I have nothing to add.
Is it the dose of beta blocker, or is it the heart rate which is achieved, which is more important?
So, you mean what's the importance of the heart rate? I think actually it's controversial also when we think about the maximal dose, the target dose. With the beta blockers, heart rate is a very good, is a perfect measure of the degree of sympathetic inhibition. So I think that even if heart rate is not everything, it's important to target an heart rate between 60 and 70 beats per minute. That's what also shift with Vibradin showed. And then if the beta blocker by itself is not enough tolerated, makes sense absolutely to add Vibradin. And I still think, even if there are not many demonstrations, but the southern countries, those with a more warmer and climate, people in that countries, they tend to tolerate less both ACE inhibitors and ARNI for hypotension and beta blockers for hypotension and fatigue. So it's much more a problem. When we did the biostat, I mean, it's incredible. In Scandinavian countries, the patient receive target doses of ACE inhibitors, which is very rarely seen in Italy, in my experience. And it's generally the complaints that the patients, that's when they go to the doctor, say, please, can I take away this drug? And so that's the reality. Yeah.
I agree with Mark on this point. And I mean, having worked in Italy and working now in the UK, I can see the difference in the tolerated dose. I mean, that can be related to that. It can also be related to body size, as we know that the tolerated dose differs between men and women because of body size and volume of distribution. But the point I wanted to make with my last slide was that we have to adapt and understand that we need to talk not just to our high specialized centers, but to all doctors that practice heart failure. And therefore, often, before getting to have an echo done in some countries, even in Italy or in Greece or in Spain, if we talk in Europe, it may take 6 months. So it is better if you have the evidence that there is heart failure, there is elevated natriuretic peptides, just start with the diuretic if there is congestion, start with an SGLT2 inhibitor. Once you have your left ventricular, of course, treat the comorbidities, but as soon as you have the left ventricular function, then adapt your therapy and implement the 4 foundation therapies and so on. It is easy to do it in the hospital because it's, of course, you have everything. It's more difficult when you're out there in the country where patients have to travel to get an echo or to wait for an echo for so long time. So the issue is start with an SGLT2 inhibitor and a diuretic, and as soon as it's possible, then implement therapy accordingly.
Thank you. I think we have to move on. So let me invite now Professor Marco Metra to tell us, are there pillars of GDMT in HFpEF, like in Hfref?
Who knows?
Okay.
But it's interesting. I mean, HFpEF is really everything, and with the risk of being nothing. So let me share my screen. Thank you again for the invitation. And sorry, I have to go to the first slide. It's 10 or 15 minutes. So, okay, 10 minutes, 15. Okay. So there are not pillars, but at least I think there is one pillar. We have it now. These are my disclosures. You can see my screen. Yeah. Yes. So the classification of heart failure is still based on the ejection fraction. This is the bottom line. And we have 3 classes of patients based on the ejection fraction. And the reason for this is that until 2 years ago, 3 years ago, all the evidence we had for treatment came from studies, including patients with a low ejection fraction. In 2016 guidelines, it was first introduced this Hfref for ejection fraction 40-49%. Then what changed was how MR is, which became mildly reduced ejection fraction, showing the homogeneity of these patients with those with reduced ejection fraction. And actually, we had retrospective analysis from trials in patients with an ejection fraction more than 40%. that allowed us, and also the US colleagues on the other side of the ocean, to conclude that neurohormonal modulators and antagonists can be given, may be considered also in the patients with mildly reduced ejection fraction. And here we are. And in 2021, we wrote that for patients with HFpEF, the only possibility was screening and treatment of etiologies, which we see is not meaningless, and treat for comorbidities, which we will see is important. However, just a few hours later, and this is the nice thing of science, cardiology, heart failure, and the current times in heart failure treatment, we had the presentation by Stefan Anker of Emperor Preserved, which I think is the probably the most important hallmark trial that we had in the last decades, because it was the first time that it was shown that one drug may affect the primary outcome, as well its major component, heart failure hospitalizations, not cardiovascular mortality alone, and this can be discussed for days, but the primary outcome, which is what we are used to look at, was reduced by 21%, highly significant, with empagliflozin compared with placebo. Other aspects that are important in this trial is that, for example, worsening heart failure events were clearly defined, and they were all reduced by empagliflozin versus placebo. Here you have the total number of hospitalizations for any reasons. You have the total number of adjudicated heart failure hospitalizations. And another important aspect is that also outpatient visits reporting intensification of diuretics, including oral diuretics, were also reduced by 26% with empagliflozin compared with placebo. So it's also important that all these heart failure decompensation events may now be considered together. They all have an impact on outcome because the patients have a poorer outcome after them, and they all may be reduced, in this case, with empagliflozin, SGLT2 inhibitor. Another interesting aspect that came out from this trial, and that has been widely demonstrated before and after, is that the effect of SGLT2 inhibitors starts early to appear. It became significant as early as 18 days after randomization in Emperor Preserved. Another aspect is the improvement in quality of life, which is also important, and it was also significant. Last but not least is that maybe for the first time, we may think about a kind of enabling treatment because there is surely a synergy between SGLT2 inhibitors and MRAs, because not only because you have a significant reduction in the primary outcome, whether the patients are or not on MRA, but also because treatment with SGLT2 inhibitor, this is the case of EMPA, but it was also shown with dapagliflozin, is associated with a reduction in the initiation of potassium binders and with a reduction in the rate of hyperkalemia events. So SGLT2 inhibitors may also favor concomitant treatment with MRAs. An aspect which was controversial in Emperor Preserved regarded the potential EF dependence of the efficacy, because in a subgroup analysis, the reduction in the primary outcome was not significant in the patients with an ejection fraction above 60%. However, this was less evident when ejection fraction was analyzed as a continuous variable. What we see is a wider standard deviation in the patients with the higher ejection fraction. And what it is important is that the subsequent DELIVER trial with the dapagliflozin in patients with preserved ejection fraction not only showed a significant reduction as well in the primary outcome with the dapagliflozin versus placebo, but also showed that this effect was independent from ejection fraction. And this was true also in pooled meta-analysis. You see here that the effect is completely independent from the ejection fraction at baseline. And it was also independent when the liver was analyzed with Emperor Preserved. And also when all the trials were analyzed together. So we have surely one pillar. I don't know if I have 5 minutes more.
Yes,
because
please.
then there is the problem. The problem is that, do we have time or I stop here?
Yes. No, please carry on.
Carry on. So to be short, but this is a word that still exists, I think, that is the word of the heterogeneity of HFpEF. This has led, for example, to artificial intelligence and machine learning with the phenogrouping of the patients with HFpEF with a different outcome. But can we conclude something from these studies? This is a very nice editorial comment that was published in European Journal of Heart Failure. And you see, I don't know who among these three authors made this table, because this is very amazing. They listed all the artificial intelligence phenogroups that have been done. They are completely heterogeneous as well. And in general, there is not a validation in a prospective study. So still artificial intelligence, I don't think can give us any guideline and recommendation. What we know is that the patients with HFpEF are heterogeneous. What we must remember is that at least some of them, 20–30%, have chronotropic incompetence. And I like this relatively small study done in Spain with a crossover double-blind design with withdrawal of beta blocker treatment in patients with chronotropic incompetence during exercise, and in which the withdrawal of beta blocker was associated with an increase in exercise capacity. And this was consistent across all the different subgroups. Then there are other phenogroups. We must remember of hypertension. How many patients with HFpEF have hypertension? You see from these trials that more than 90% of the patients with HFpEF have hypertension in their clinical history. And we know that antihypertensive treatment is associated with a highly significant reduction in heart failure events. So for sure, treatment of hypertension is important. Then coronary artery disease is present in at least 50% of the patients with HFpEF, but then we have another 60% of the patients with HFpEF, if not, that have coronary microvascular dysfunction, either endothelium independent or endothelium dependent, and therefore overall 85% of the patients with HFpEF in an unselected consecutive patient study group have some problems with coronary circulation. 91%. and this may be associated with a poorer outcome and may be a target for treatment. Obesity is another phenotype. It acts through multiple mechanisms. It's something which is specific for HFpEF, whereas it's not specific for Hfref as an increase in the risk. And there may be an obese phenotype with an increase in right atrial and central venous pressure because there is a pericardial constraint on the right ventricle, and decrease in body weight is associated with an improvement in exercise capacity in obese HFpEF patients. And all that we know are analyses from SGLT2 trials, but of course there is a future that we hope it's full of results. But at least SGLT2 inhibitors act independently from body mass index, this both in the liver, and this is my last slide, in emperor reduced and emperor preserved as well. Thank you for your attention.
Thank you, Professor Marco Metra. So one question for me is that in HFpEF, inflammation is the key factor. So do you think that finerenone would become a major player in the future?
Yes, I think so. I hope so, but because until we have until 3 years ago, I learned to be pessimistic when anytime I spoke about heart failure treatment. And now we tend to be optimistic. But finerenone reduced the heart failure events in the trials in patients with diabetes and CKD. And it was not, it was protective on kidney function. There is an ongoing trial that will give us a final response, but I think that above all, these new mineralocorticoid antagonists seem to have a beneficial effect also in heart failure. And Professor Teerlink is raising his hands, or not? Yeah.
Professor Teerlink, please.
So I'm a bit surprised. First of all, Marco, as usual, brilliant talk, and really just lovely to hear you go through these things. I'm a little surprised that I think both of my European colleagues didn't even mention spironolactone for heart failure with preserved ejection fraction, and didn't even mention an ARNI for, and maybe this is just because it was the FDA as opposed to the EMA, but the FDA did approve sacubitril valsartan for the treatment of HFpEF. A panel, an FDA advisory panel, voted to recommend approval for spironolactone for HFpEF. And spironolactone is a dirt cheap drug that's available pretty much everywhere, and can be given before you have the EF. So I would modify Giuseppe's protocol for patients who present with heart failure and say SGLT2 inhibitor plus an MRA to start with, and then you can wait until you get your EF. I also take care of patients who are 500, 600 plus kilometers away. And so I understand the challenges of getting those kind of things. So I'm interested in hearing, Marco, why did you not include MRAs or ARNIs?
The first reason was a shortage of time. And I prefer to talk about the phenotypes, but as well, as far as I know, but I may not be, of course, as updated as you, these drugs are approved for subnormal ejection fraction, or is it now also HFpEF? When did it come? You're muted.
Yeah, so Entresto has been approved for HFpEF in February of 2021.
Yeah, I think it's the issue is how you look at the trials, and also your economic sustainability. I mean, in Europe and in many countries where there are economic constraints, I mean, in Europe, everything is socialized, and so we need to decide on how to allocate resources. And the studies on preserved ejection fraction with ARNI was negative. Therefore, any sub-analysis of a negative trial makes no sense. And I was very, I mean,
So it's negative by a p-value of
regulator for years.
0.056.
Yeah, but it's being a regulator, then it's if it's a negative, it's negative, and you cannot have any sub-analysis. I mean, we've heard the Paradigm HF investigators for many years saying there is so many zeros after the P, and that is very important. So in the same way, P is greater than 0.05 is negative, and you're not allowed to have any sub-analysis. And this was the approach of the European Medicines Agency. Is the opinion of many other medical agencies around the world. So I think I think it's better to decide how to allocate resources. And of course, in limited resources, probably it's not wouldn't be my priority.
So but for an MRA, well, okay, I mean, so yes, the FDA has moved it, and the FDA doesn't rule the world, obviously. I'm not trying to suggest that. But when we make guidelines, I at least thought that the guidelines were to decide what was best for the patient and to give the physicians the best information to decide what to do with that. And that if there were economic concerns, that would enter into it. But in the US, as you know, the FDA is separate from our financial part, whereas in many countries, those approval processes are together. But anyway, I think we're missing an opportunity with MRAs.
As I can say, both US and ESC guidelines have the indication for mildly reduced ejection fraction, that is to say up to 50%. You may discuss that it can be also for up to 55%, but also the results of the analysis do not show a clear benefit above this value of ejection fraction. So yeah, okay, the answer is okay. Then I fully agree that there is no clear threshold. You have the patients with improved ejection fraction that have an indication to treatment. But if a patient has, for example, has a comorbidity, and of course, as you move to patients with hypertension, there is the indication. But until now, I don't think we can, and this was plenty and generally accepted, that because, you know, we have this voting, we have a task force with 30 members, but it was generally accepted not to have an indication for Entresto or MRAs in patients with HFpEF.
I think we should let our Indian colleagues have a let them move this along. Thank you, Marco.
Yes, otherwise we never finish. Yeah.
Yeah. So, Professor Tierling, is that approval sort of for a LVEF between 45 and 57 and in women only, or what is it? Will it work for everyone?
HFpEF?
HFpEF, yeah.
For the Entresto, you know, the FDA doesn't do those specific numbers in general. So it's for, I can look up the specific wording, but it's for heart failure. They've kind of expanded it to include patients with heart failure with preserved ejection fraction. So I can look it up specifically to look at I had the spironolactone one up. So.
Right. Thank you.
Thank you. We are moving forward. We are a little short of time. The topic is prevention of heart failure events with sodium SGLT2 inhibitors across a spectrum of cardiorenal metabolic risk. So there are a lot of discussion about cardiac part, but I would invite Professor Giuseppe Rossano to focus on the renal and metabolic risk. The topic is across spectrum, but renal metabolic risk is less emphasized in cardiology meetings. Over to Professor Rossano.
Thank you, Dr. Oman. I will be short because I understand you'll have many other talks on SGLT2 inhibitors, and you will have Professor Anke coming tomorrow. I've already penciled the 9th to 11th of February 2024 in my diary, and I look forward to, say, maybe a controversy session with my friends. And so focusing on the effect of the SGLT2 inhibitors. Now, I think it's important also to consider the universal definition of heart failure has been developed by the HFSA, the Hfai, and the Japanese Cardiac Society. And that basically considers heart failure not just patients where symptoms of signs and symptoms of heart failure, which are patients with stage C, but also those patients with at risk. So those with diabetes or patients with renal failure, or as being at risk of heart failure, or those with risk factors and evidence of structural or disease or abnormal cardiac function as pre-heart failure. Now, the SGLT2 started because of the concerns of diabetic therapy that that started with first with tolbutamide, and then with other drugs like the PPR gammas, and then at the peak with rosiglitazone that led to a withdrawal of the marketing authorization for rosiglitazone, but also led the EMEA and the FDA to set new rules for the approval of new anti-diabetic drugs. And the drugs that came along after the from 2008 onwards were the SGLT2 inhibitors, GLP-1 receptor agonists, and the DPP-4 inhibitors. Now, whilst the DPP-4 inhibitors seem to be quite useless class of drug, as they have a minimal effect on glucose and they have no effect on mortality, different data were gathered with the SGLT2 inhibitors and GLP-1 receptor agonists. Now we know very well the data with the early data with the SGLT2 inhibitors. So in patients with diabetes, the empagliflozin, dapagliflozin, and canagliflozin have been shown to reduce hospitalizations for heart failure and the composite of heart failure hospitalizations and mortality. Now, of course, there is a variability of the efficacy on across the three different groups and the three different studies. And the studies were different because if you look at the EMPA-REG outcome was included mostly patients with increased absolute cardiovascular risk. The canvas includes also patients with multiple risk factors, and DECLARE had 50% of patients with cardiovascular events, the disease, but 50% of patients who had only multiple cardiovascular risk factors. And therefore, I think that when we look at the patients with diabetes and when we look at the evidence that we have is that there is a clear event in those patients with an absolute increased cardiovascular risk of an effect on MACE, on heart failure hospitalizations. Whilst in those patients with only risk factors, then probably there is less of an effect, and that effect is mostly on heart failure hospitalizations. Now, for these reasons, and for the evidence that was generated, and then we had a change from the 2016 to 2021 guidelines for the indication of the management of patients with heart failure and diabetes, where the SGLT2 inhibitors, and in this case, the CANA, DAPA, EMPA, ER2, and SOTA, are recommended for patients with type 2 diabetes and at risk of cardiovascular events in order to reduce hospitalizations and cardiovascular death. Now, from the increased risk we've moved then into the evidence in patients with cardiovascular disease, and there's evidence that the SGLT2 inhibitors have a significant impact on cardiac metabolism. These are data from with empagliflozin that basically demonstrated that, as you can see, in a failing heart, there is a decrease in glucose oxidation and an elevated free fatty acid oxidation. After the empagliflozin, you see that there is an increase in glucose oxidation and reduction in free fatty acid oxidation. It's something like, for example, you get with drugs that you use a lot in India, and it's like trimetazidine. Now, of course, together with those effects, all sorts of other effects, and may explain the benefit of SGLT2 inhibitors in patients with heart failure and comorbidities because of the improved renal function, and other effects on inflammation and energetics, and also the effect on diuresis, glucose excretion, natriuresis, and but also the effect on body weight, and may have an effect on cardiovascular events. So I won't be focusing much on mechanisms, but I will say that there was a good segue from patients with increased risk to patients with heart failure demonstrated a clear effect of the SGLT2 inhibitors, reduction in mortality and morbidity, but also there was an evidence from EMPEROR-reduced, but also from DAPA-HF, that the SGLT2 inhibitors were effective in reducing the progression, the decline of renal function in patients with heart failure. We know that our patients with heart failure have a continuous decline in eGFR. Those that take an SGLT2 inhibitors basically have less of a decline. And the same was demonstrated in DAPA-HF, where there was a significantly lower event rate in those with taking dapagliflozin. In the same spectrum of looking at the effect of the benefit of the SGLT2 inhibitors, I think we have to look at their effect on progression of CKD as such. So in this case, there are 3 studies, the EMPA-Kidney, DAPA-CKD, and Credence, that looked at patients with different inclusion criteria, but patients with CKD. And as you can see, the DAPA-CKD demonstrated a nearly 40% reduction in the composite and combined endpoint in decline of eGFR and renal and cardiovascular death. What was important is that the study also demonstrated a 31% reduction in all-cause mortality. So in patients with CKD at increased risk, then there's a clear effect also on all-cause mortality with dapagliflozin. Similar data were demonstrated with canagliflozin that demonstrated an effect on all the components of the primary composite endpoints, including renal and cardiovascular death. So if we look at the overall evidence that we have in patients with CKD, there's a clear, and in patients with and without diabetes, there's a clear effect and overall reduction in patients with events. And therefore, we have now to reconsider the evolution of the SGLT2 inhibitors in the management of heart failure. Now, we went from patients with diabetes now to patients with no diabetes, in patients with renal disease, and therefore the SGLT2 inhibitors have clearly demonstrated to cover all spectrum of patients with cardiometabolic disease. And before concluding, I would just like to let those of you in the audience that are be interested in a master in heart failure, we're launching this MSc in heart failure together with the Hfai, and it's all the information are on the website. Thank you very much for your attention.
Thank you, Dr. Rosano. One question which was asked yesterday, that if somebody has an eGFR of say 25 and you start them on SGLT2 inhibitors and it drops down to 15, what do you do? Do you stop it or no?
I think that there's, patients with impaired renal function with CKD tend to have a progressive deterioration of ventricular function. What we've learned from trials like the DAPA-CKD is that even dapagliflozin in that study was effective in lengthening the time for renal replacement therapy. So that means that even in those patients with that during the trial went to an eGFR less than 20, there was a benefit because they went later to renal replacement therapy. So I think that I would continue it.
Sometimes the initial drop comes pretty early. Suppose you have started at say 20, for instance, because up to 20 you're allowed, and in a week's time you find it is 15. I'm not talking about late drop. At times what happens is that the physicians get scared that it's deteriorating fast, and also the patients get worried sometimes. So is that also an indication to continue, or what would you do?
Look, we have the luxury of running a cardiorenal clinic in patients with heart failure, thanks with the collaboration of our renal physicians, and Professor Banerjee has been instrumental in that. And so we get the reassurance from our renal physicians rather than in continuing therapy. So what we found is that, especially in patients with CKD, if you work closely with the renal physicians, then you probably will see that you optimize therapies, not just the SGLT2 inhibitors, but also all other therapies, where even us as cardiologists would be afraid to be so aggressive. So I think for those patients, the collaboration is very important.
Right. And also we learned from the Emperor trials that after the drug was stopped, there was a sudden rise of eGFR, indicating that this is only an artificial drop. So, that's the answer we also gave yesterday.
And we have that evidence also with other drugs. It's if you look at the fenofibrate, you have the same thing. As soon as you stop it, then you have a normalization. So the bottom line with the SGLT2 inhibitors is that in patients with any form of renal dysfunction, if you give the SGLT2 inhibitors, you reduce renal death, you reduce worsening of renal function, and you reduce overall mortality.
There's a question from the audience, Dr. Shastri.
These SGLT2 inhibitors, do they increase urinary tract infections or only general infections? We found urinary tract infections are also increased, sometimes leading to severe urosepsis. What is your take on that?
Look, for the urinary infection, it very much depends on glycemia, because in diabetic patients, of course, because of the significant increase in glucose, there is possibility of increase in renal infections, of urinary tract infections. They are very rare. If you look at the trials conducted in patients with heart failure, were very, very rare. Genital infections are a possibility. And although if you look at the data coming from both the Emperor Reduce and the DAPA-HF studies, it very much depends on personal hygiene. And if there is an good personal hygiene, then usually the occurrence is much less. And you can stop, and once is resolved, then you can start again, and with good genital hygiene, that should disappear. But the UTIs usually are mostly seen in patients with diabetes.
Thank you, Professor Rosano. We go on to the next talk. Invite Professor Marco to tell us what has been the impact of recent cardiovascular outcome trials in contemporary guidelines for heart failure and CKD. Professor Marco.
Yes, sorry, I'm a bit, some issues. Let me. Okay. Okay. What is the impact? I will be rather short. The first aspect which is important is that CKD is is the major barrier that we have for treatment of the patients with heart failure. We have a significant proportion of patients with heart failure with concomitant chronic kidney disease. This proportion has remained stable in the years. This is a very nice analysis from United States, and it clearly shows that approximately 20% of our patients have severe chronic kidney disease with an estimated glomerular filtration rate below 30 ml per minute per square meter. So we are dealing with this proportion of patients, and we know that most of the trials excluded these patients. And only recently we have trials which included the patients with a GFR of 20 to 30 ml per minute per square meter. Going to what are the drugs approved for the treatment, and of course chronic kidney disease is a major independent prognostic factor. These are data from the Swedish registry, but they are consistent with the overall literature that the patients with concomitant chronic kidney disease have a 30% increase in their event rate, and this is independent from the ejection fraction. So it's true both for Hfref and HFpEF and Hfref. So what we do, I'm sorry that my data are somehow incomplete, but it's a matter of fact that current guidelines recommended medical treatment slows the progression of kidney disease, also in the patients with heart failure. This is an analysis from Paradigm HF, that it is the positive trial that we have for sacubitril/valsartan in the patients with heart failure and the reduced ejection fraction. And you see that the patients randomized to sacubitril/valsartan had a somehow slower progression of chronic kidney disease. It is a matter of fact that the profile of the changes that we have in renal function with SGLT2 inhibitors are different from what we tend to be used with the other drugs. As most of the trials, above all in the patients with Hfref, and we will see in the patient with CKD, show a stabilization of kidney function, which follows an initial decline, which is generally of the amount of 3-4 ml per minute per square meter of GFR. There are trials, I'm sorry, there are analyses, I'm sorry that I am not including them as slides because I didn't have the time to retrieve them, but there are analyses from these trials showing that the initial decline in GFR is not associated with a poorer outcome. And actually, the effect of SGLT2 inhibitors versus placebo are the same independently from the initial decline in eGFR. Therefore, to come back to the question that was done before, at least from the analysis of trials, we can say that this initial decline is not an indication for any withdrawal of SGLT2 inhibitors. Then this initial decline is followed by a stabilization of GFR, at least for the duration of these trials. And in the end, the patient have a better renal function when on SGLT2 inhibitor than with placebo. These are the results with dapagliflozin. These are the results from Emperor reduced that because of the inclusion criteria were somehow more clear, but it's the same thing, initial decline and then stabilization. These are data, again, showing that the results are also independent from an history of or not of CKD at baseline. And this is the placebo-corrected early dip in GFR at week 4. You see 2.4 to 3 ml per minute per square meter. Now we have trials in patients with diabetic nephropathy and in patients with chronic kidney disease. We have at least 3 trials: Credence with canagliflozin, diabetic kidney disease only. We have DAPA CKD in patients with chronic kidney disease, and more recently EMPA-KIDNEY again in patients with chronic kidney disease. There is a major difference with EMPA-KIDNEY compared with the other 2 trials, because actually EMPA-KIDNEY allowed the inclusion of patients only with only a reduced eGFR, 20 to 45 ml per minute per square meter, even whereas all the other trials, and also EMPA-KIDNEY, included the patients with albuminuria. So EMPA-KIDNEY was the only trial, and this may have an influence on the results, where patients without albuminuria could be included. What we have is the results of the trials that showed consistently that gliflozins may slow the progression of chronic kidney disease, at least in the patient with concomitant albuminuria. These are the results from DAPA-CKD, where you have an effect on the primary outcome of which was a renal outcome, including, however, cardiovascular deaths, as well in the secondary outcome of cardiovascular death or hospitalization for heart failure. Therefore, we have data showing that the administration of dapagliflozin, at least in DAPA-CKD, may also slow the occurrence of a heart failure event in the patients who do not have necessarily heart failure at baseline, but that are included because of low GFR and albuminuria. The results of EMPA-KIDNEY. EMPA-KIDNEY also was showed a significant reduction in the primary outcome of progression of kidney disease or cardiovascular death. You see that the reduction in hospitalization for heart failure or cardiovascular death did not reach statistical significance, but again, further analysis, subgroup analysis, which we are European conservative, as we tend to be more conservative maybe, but however, the secondary analysis showed a reduction in the patient with albuminuria. It is likely that the inclusion of patients without albuminuria in EMPA-KIDNEY diluted a favorable effect. Then we have a meta-analysis published in Lancet in November 2022, where you see that cardiovascular events and heart failure hospitalizations and cardiovascular death were significantly reduced by SGLT2 inhibitors. Moving to another group of drugs, we have a few slides. I have 3 slides regarding finerenone, but I think that these results are landmark. We must remember that spironolactone and eplerenone in the earlier RAISE and Ephesus trials actually increased the serum creatinine in patients with chronic heart failure. Here we have trials with finerenone in patients with diabetes and chronic kidney disease. And finerenone reduced the primary outcome in Figaro, where patients had a high cardiovascular risk. And these results on the primary outcome was driven by a reduction 29% in heart failure hospitalizations, which was significant by itself. Fidelio was more focused on patients with kidney disease, and actually the primary outcome in this case was just reduction in kidney events, and you see that death from cardiovascular causes as well as hospitalizations for heart failure did not reach, although they were reduced numerically, the statistical significance. Then we have this pre-specified pooled analysis of the 2 trials that was called Fidelity, and that showed a significant reduction in heart failure hospitalizations alone by 22%, and this was significant. So to conclude, I think that we have drugs, SGLT2 inhibitors and finerenone, that prevent also heart failure events in patients with chronic kidney disease, with concomitant diabetes in the case of finerenone, but also without diabetes in the case of DAPA or EMPA. And therefore we have the potential to prevent heart failure in these patients. Secondly, we have these glyphosils also prevent the progression of kidney disease in the patients with heart failure. We lack of data in patients with a low GFR below 20, because this was the lower threshold used in the glyphosins and finerenone trials. Thank you.
Thank you, Professor Dr. Mittal. One question that comes up in clinical practice is, we see patients of diabetic kidney disease who have a ischemic heart disease, specifically a myocardial infarction, and a drop in their EF over a period of time. Do you see that sacubitril valsartan then would give them a better sort of, protection for their renal decline as compared to ACE inhibitor?
Well, to my knowledge, we don't have a trial specifically addressing this question. So we always base ourselves on analysis. We may say that in a patient with chronic Hfref, sacubitril valsartan is better than an ACE inhibitor, than an enalapril for the decline in GFR, as shown in this analysis of paradigm HF. I think we have this data on the other hand. I don't know if somebody knows more than me. And well, I think the evidence is less than what we have with other drugs that are those that I showed. Also, if we compare the data with finerenone with those with the other traditional MRAs, are also these data are much more clear-cut, showing a benefit in kidney function. Then, of course, there is the problem of the cost of treatment that Giuseppe has raised that are also to be considered. I don't know if... Two microphones.
Any questions?
You are also muted, eh? Okay.
Any questions from the audience? Okay. Yes, Dr. Jagopal.
Yeah, this question is actually, even there's a data on RNA in the use, even in end-stage renal disease, where it's shown benefit in terms of outcomes, the very small data, but then most of the SGLT2s have not been tested in the EGFR at a much lower level. So do you think there will be a future for this that way? RNA, well, there is some data.
Future for RNA in CKD?
SGL2, because we keep talking about the benefits in the renal, but not really in the end-stage renal failure patients.
For SGLT2 inhibitors in CKD patients, yes, absolutely. I don't know the guidelines from the nephrologists that will come out, but for sure we have data that are very straightforward. I think the effects of SGLT2 inhibitors in patients with chronic kidney disease are for sure significant, and based on the evidence, there is an indication to these drugs in patients with a low GFR to prevent the decline. What we don't have are data in patients with a GFR below 20 at entry for the initiation. There are a few things that I may take advantage to say, and sorry I didn't prepare the slides. At least three things. There are a very nice analysis from MRA trials showing that in patients with heart failure, the decline in kidney function also precedes the hospitalization for heart failure and then follows. So we have patients who are, whatever we may be the reason, maybe simply that these patients tend to receive more diuretics, but an increase in serum creatinine occurs both before and after hospitalization for heart failure. So the crosstalk between heart failure and kidney failure is very tight. Then the other thing is that there is for sure a large space for MRAs in patients with kidney failure also, and the protection from fibrosis may be beneficial both for the heart and the kidney. And for sure, there is a problem with the implementation of these drugs because of hyperkalemia and because of the early rise in serum creatinine, but I think that there may be a space. Third, not because I have John Tirling right in front of me, but omecamtiv mecarbil, drugs acting with mechanisms which are independent from neurohormonal mechanisms and also from metabolism, and which increase cardiac function. They are effective drugs to improve outcome as well. At least heart failure hospitalizations are reduced, also in the patients with an impaired kidney function, without detrimental effects on kidney function. So despite what regulatory bodies will wait or will do, I mean, based on the evidence, the Galactic trial, the effect was present. Fourth, but not least, also vericiguat was effective in patients with low GFR without any detrimental effect on GFR. So we may have sooner or later drugs available to treat also patients, at least with an GFR at 20.
Thank you, Marco. So, and now we move on to the last talk, which is slightly different. How to treat congestion, vasodilators, diuretics, or mechanical solutions.
Can advance the slides here. So talk about congestion vasodilators, diuretics, mechanical solutions. And I need to thank Professor Video Chionsel for the help, major help with this talk. Some of the slides are from him. I actually enjoy to talk about this topic, and when I scanned my previous presentations, this occurs every now and then, so I could also use some of my old slides. And this is the first slide, so you need to know something about physiology, what your heart and kidney needs to handle to know how to help heart and kidney when you have heart failure. What we know is that when a patient is hospitalized, then congestion is frequently present, and many patients are discharged with residual congestion, and this also translates into poor prognosis. So the more congestion you have at discharge, the lower the chances that you for your survival. But how do we assess congestion, and how do we say, okay, the patient is decongested? Mostly we rely on clinical examination, but this can be misleading, and that is the reason that many patients are still congested at discharge. And here are some independent predictors of residual congestion at discharge. So some of the comorbidities, need for intravenous diuretic, then patients in more advanced clinical situation, and also the status whether the patient came in due to worsening of already known heart failure. But how do we actually assess congestion? Maybe the most sophisticated way that is not performed in clinical practice is the way how to measure dyspnea. This is how this group of eminent authors suggest that we should do it, but I don't know if anybody does it. So we are actually not doing assessment as we should do. But what we should also be doing is to perform some imaging techniques, and lung ultrasound is at the very top when your patient is admitted due to heart failure, because it gives you insight into lung water. And those of us with gray hair or know what the B lines are for. Those are for Carly Bay lines from the chest X-ray. But lung ultrasound is much more specific for lung water, and it can detect much less lung water than chest X-ray. For instance, for the pleural effusion, the threshold is at the level of CT. Now you also need to know that some B lines are still normal, but if they are spread all over the lungs, then the patient definitely is congested. It's quite easy to perform that. It takes about 2 minutes, and I usually do it at every ambulatory visit when I'm talking to the patient. And actually, it was shown that if you do that, that was work by Elke Platz in patients that were followed in the clinic, that presence of B lines independently predicts worse outcome in your patients. The more B lines you had, the worse prognosis for the patients. But what is even more important, you could pick up lung congestion 3 times more often with lung ultrasound, and these are these bars, than with auscultation alone. So definitely that is more help than the clinical examination alone. but we are not doing it in clinical practice. For our trial, I had long discussions with my good friend Wilfried Mullens, but then due to lack of financing, this was not included in the trial, and I think that is a pity. Now, another thing that we are not doing so often, but our colleagues, nephrologists, tell us that, okay, inferior vena cava diameter, that is the way how to estimate dry weight in our dialysis patients. It's also quite easy to do. This is the way how you do it. You put the probe to visualize the whole heart, then you rotate the probe to visualize the inferior vena cava, you add M mode, and you have what you need to have, so collapsibility index and the measures of vena cava. But we are also not doing this in clinical practice. Now, we are leaving our patients congested, so what can we do? The mainstay for decongestion are diuretics. Here is the quote from the guidelines. So if the patient is congested, then we should use these drugs. But in clinical practice, we are faced with many challenges. One of those is diuretic resistance. Diuretic resistance, here are some definitions from our colleagues. This is from nephrology, how they define it. This is from our colleagues gastroenterologists, how they define it. So they actually have something in place how to do it. And for cardiology, until very recently, this is JAG review from 2020 that was quite specific about renal bits of diuretic resistance, but it said that we still don't know in cardiology how to do it. Then Wilfried Mullens again came up with a suggestion how we could do it, but we don't know whether this is the best way to measure urine sodium content after the patient is on diuretic. So to see whether the patient excretes enough sodium to drive the water behind it, because the natriuresis is the mainstay of diuresis. Wilfried now is conducting an observational study about this process. As far as I know, the results are not available yet. So if you somehow decide, okay, this patient has diuretic resistance, then you need to ask yourself, well, how to handle. The first thing is to check for true diuretic resistance or not. That is first the adherence to drug. Then you may increase dose of diuretic, then you may do some switches, then you may add the second drug, then you may go for, if this is the chronic patient, for intermittent loop diuretic, or in the end you may use some devices. That's taken from 2012 guidelines, and it didn't change much. So first is to ask yourself whether it's a true diuretic resistance, because at least in Slovenia, 6% of prescriptions are not taken, patients don't go to the pharmacy to take the medication. So the medication that is not taken cannot work. And then if it's true resistance, then maybe it's inadequate dose and or route. Maybe it's inadequate tubular secretion, because in heart failure, one of the main issues is low effective arterial volume, and this then results in insufficient renal blood flow and renal hypoperfusion that can also be helped through non-steroidal anti-inflammatory drugs, and as an end effect, you don't have enough drug where it should work, and that is in the tube. So the first things first, loop diuretics, we need to go back to pharmacokinetics again, because you can have the poor absorption of the drug, and for furosemide, bioavailability ranges from 5 to 80% if you take it orally. So that is also important. So the first step in heart failure would be either to change the dose or to change the route. And this was actually tested in one trial, the both strategies, but the results with the primary outcomes were 2. The results were not really encouraging, because there was no strong signal that any of the strategies has the superiority over the another one. And here is the Kaplan-Meier curves also showing that no significant benefit. Now, if we have several loop diuretics, then maybe change of a diuretic could be beneficial. Here are some trials before the major trial that was presented last year, TORIC, Tornado, and meta-analysis showing some suggestions that torazamide could have the edge over furosemide, but Transform HF that was presented last year at AHA and published in JAMA didn't really confirm that, but please be aware that here the primary endpoint was all-cause mortality, and this is the toughest endpoint to get to. Now, if we now switch from loop diuretics to thiazides, because they have different site of action in your kidney, then the thinking is that if we do the sequential blockade of the nephron, then there could be the additional benefit. Now for thiazides, what you need to know on top of similar thing that as for loop diuretics is that they are ineffective if your creatinine is above 220. So then there is no use to for the thiazides. But with this sequential nephron blockade actually demonstrated that, and this was on top of on loop diuretics, that there is an increased weight loss and urine output. This was confirmed then in another study. So this sequential nephron blockade, if the patient is eligible for that, so if the renal function still allows for that, this could be the way to go. If we are trying to block different sites in the kidney, then if we are going distal from the loop diuretics, we might also go proximal. And this is the idea of some obsolete diuretics, which is acetosalamide, which I still remember from the medical textbooks, but then it disappeared in Slovenia. Now it's the revival. But in the same site in the kidney, also the SGLT2 inhibitors work. Now, Advor addressed that, and Wilfried Mullins really needs to be congratulated for the effort because he showed that these trials are possible. Also with limited money, the budget was about 2.5 million, but it resulted in New England publication and also influences clinical practice a lot. So the primary endpoint was positive, but this trial needs to be seen as a whole. There are some limitations. 1 out of 6 patients screened was eligible. SGLT2 inhibitors were not allowed in the trial. What to do if congestion still persists? The trial doesn't answer this. And although the decongestion was successful, there was no outcome benefit. So it leaves some questions open for the future. Now, if I mentioned SGLT2 inhibitors, we've seen that the trials are moving more and more into acute phase when we stabilize the patients. And with SGLT2, there are several trials that would like to test the hypothesis in these particular patients. Now I'll mention one trial just to show whether there are some signals of uncertainty or problems. And for dapagliflozin, this trial showed that there is no interference with it. Then our colleagues in the States are planning to do a trial that will also have the endpoint of weight loss, but we know that from Impulse this was already published, and SGLT2 inhibitors in acute heart failure actually do the work with regards to the body weight change and clinical congestion score. Now, this opens the door for these drugs in acute heart failure as well, on top of loop diuretics. There are other possibilities as well. Here is one that is hypertonic saline with the idea that with this additional sodium, we will make an extra drive for the sodium from the body. But you see that many of trials by same authors, and as far as I know, these trials were retracted, these publications were retracted, and I will not go into that anymore. Now, we also know that loop diuretics are bound to proteins, and there was the idea to enhance natriuretic effect with addition of albumins, but this didn't prove to be very successful. Now, we also know that if we try to maintain renal blood flow, then we might have better effects on natriuresis. This was tested with dopamine, but didn't show much benefit, so I think we should or could abandon this idea. Now, this leads me to the devices, and here is an interesting paper showing the potential modes of action, mechanisms, which drug is that, and which device could act in the same way. Now, the first thing that was tested was ultrafiltration with no major benefit over medical therapy alone, and there are some devices under research, and they can be divided into two groups. So the pushers to increase the renal blood flow through pushing through arterial system, or pullers that remove the fluid from the venous system in order to either to decongest the kidney or to increase blood flow through the kidney. Promising results, but no definite answer yet. I'd like to draw attention to another method which I believe should deserve more attention, and this meta-analysis is 1 week old, or young as you would like to see it. It is about peritoneal dialysis in patients with refractory congestive heart failure. Many of these patients actually are on the way towards dialysis, and our nephrology colleagues always tell us, okay, then maybe peritoneal dialysis is the first step. And here authors identified about 20 studies, most of them prospective, few retrospective, but none randomized. They also, and there was benefit in terms of shorter hospitalization, in benefit for left ventricular ejection fraction that favored peritoneal dialysis. So there is a clear signal that there should be randomized trials. One randomized trial started in 2016, over 2 years, 10 patients recruited, so the study terminated. So definitely, in my opinion, there is the need to consider peritoneal dialysis in this respect. So where we are with congestion or decongestion in 2023, we know that this is that we discharge our patients in a state of congestion, and this is bad signal for them. Whether we can completely abolish that or not, it's unknown. And assessment of congestion, decongestion still requires medical doctor as such, with help of some devices. I here again highlight ultrasound for lung and inferior vena cava. That we also know that sequential nephron blockade is effective, but if the patient is eligible, that SGLT2 inhibitors may change the world in the future. Devices we don't know yet, and we should start some peritoneal dialysis trials in patients that are on the way towards end-stage renal disease. And I'll stop here. Thank you.
Thank you very much, Dr. Mitza. Couple of quick questions. So, what is your opinion on the pH neutral subcutaneous furosemide?
Okay. Yes.
Will it work?
That I didn't mention that. That was tested, and that is quite attractive because it can be also applied by the patients, and that could also be the way. I know that in the UK they had the nurses that went around visiting patients with intermittent intravenous diuretics, either as a bolus or as an infusion, but bringing the subcutaneous furosemide to the market, that is even more easy for the patients because it's like insulin.
Right. Do we have any comments from
Vidya here?
Your
comment about ultrafiltration versus intravenous loop diuretics.
Well, we always start with intravenous diuretics, and very few cases in my clinical practice where when we are unsuccessful and we need to go for intermittent dialysis. But usually, then that is 90-95% of the cases, we are successful enough.
No, it's particularly patients who have diuretic resistance or diuretic handicap, and you find that you have to, the patients are admitted, they're not responding to loop diuretics the way you want them. I mean, measuring the urine output, would you consider ultrafiltration, or you would consider ultrafiltration upfront in every case of acute decompensated heart failure?
I would definitely not consider ultrafiltration upfront, we still don't know, don't have enough information about this approach suggested by Wilfried Mullens, so to measure urinary sodium. Because if there is no sodium in your urine, then something is wrong. Either the dose is too low, and that is mostly the case, or the way how you apply your diuretic is not appropriate. But in hospital, if the patient is decompensated, the only way is intravenous. So then the dose usually is too low. And with the addition of this sequential blockade, either distal or proximal, I believe we have another weapon in our armamentarium, and I would really be keen to see whether SGLT2 inhibitors have similar effect as acetazolamide, or even a combination of both of these.
Can we take a comment from Professor Rosano on this matter? Yeah, Dr. Tierling.
Yeah, Professor Tierling.
Yeah, I think we are, as Professor Lajczak was saying, we are underusing diuretics. Even in the ADVOR trial, the maximum dose of furosemide was 80 milligrams. That in patients with impaired renal function is nothing. I mean, it's the usual dose should be at least around 300 milligrams, if not up to 500. So because otherwise you just don't have enough furosemide to reach the distal to reach the nephron. Also, the chlorotic study showed that the addition of hydrochlorothiazide or a thiazide diuretic is effective. And I think that ultrafiltration should only be reserved in patients where there is a clear and real diuretic resistance. But diuretic resistance should be defined according to resistance to the use to the diuretic use and according to the renal function, not to the dose. I mean, 80 milligrams in ADVOR was useless. And besides, we have to say that ADVOR also nominally increased mortality. So I don't see any benefit really of that trial.
Yeah, Professor John.
So I'll agree with my colleague. I think we do underutilize diuretics and don't use them nearly as efficiently as we can. I will also say that I was part of the original trial that looked at ultrafiltration and showed benefits in reducing subsequent heart failure hospitalizations. And I believe that ultrafiltration can be used in diuretic resistant patients, especially with the advances in technology that have occurred where they get simultaneous assessment of hemoconcentration and other things to try to avoid some of the adverse effects that occurred during the CARES trial. So I actually think the future looks really bright for us being able to use diuretics more efficiently and more effectively, as well as developing new technologies to help in the diuretic resistant patients. So, as I think the common theme of this session has been that heart failure has been a very exciting development area and will persist in being so, I hope. So it's great to have shared this. Thank you.
Thank you. Professor Mitra, just a quick last comment from you. Sometimes the urine sodium on an hourly basis is tedious to measure. So will the hourly urine output be good enough?
Yes and no, because you don't actually know how much fluid you need to lose. So I would still opt for urinary sodium. And what you can do if your lab is not 24/7, or any other reason, you can store the urine in the fridge and do the analysis the day after. So I would still like to see urine sodium, and we are now doing this more and more.
Dr. Shastri? One quick comment and question here. The patients generally with congestive heart failure don't tolerate the peritoneal dialysis because so much fluid in the abdomen, they feel uncomfortable. We have given for a few patients, they just could not tolerate. That's the comment. And the question is, do you think monitoring urinary sodium daily And a decrease in urinary sodium will precede a acute decompensated heart failure. Is it, do you think is there any rationale in that?
To comment to the first, we have very good experience with peritoneal dialysis, and because unless you put your patients on very high dose of MRA, you have difficulties with removal of fluid from the third space. Our colleagues in gastroenterology use up to 400 milligrams of spironolactone a day, and we stop at 50. But these are difficult patients. You really need a close relation with nephrology colleagues to be efficient in peritoneal dialysis. And the second question, I couldn't catch the second.
Monitoring urinary sodium excretion.
Yeah.
And a decrease in urinary sodium excretion in an ambulatory patient, does it predict a impending acute decompensated heart failure?
So if I measure urinary sodium in ambulatory patient, does it prevent hospitalization?
Does it predict?
Okay. I couldn't say. I'm not aware of any information, but it could well be that this could work. Yes.
Okay, I think we are over time, and it has been an exciting session. So I'd like to thank all the speakers, Midja, Giuseppe, Marco, and John. Thanks for joining despite your cold. So we'll move on to the next session, the last session of the day. And this is a very interesting and exciting session on Strong Heart Symposium. Midja, you're here. Now, Strong Heart was a trial which was presented recently, and I think to discuss that, and as a follow-up, to do a similar study in our country, we have this symposium, and this will be followed by an investigators meeting. Hari?
Good evening, everyone. We know that strong HF study has been a remarkable information which we have that the institution of guideline direct therapy should be made faster. That will improve the outcomes. That has been a remarkable information which we got. So the study was conducted by the team, Dr. Gad Cotter, Professor Alex Mabasa, and Beth Davison. These are the people who are the pioneers in that study. So they are joining us. The first speaker will be Professor Gad Cotter on recent advances in the medical treatment of patients with decompensated heart failure. Over to Dr. Cotter.
Dr. Cotter, you are probably muted. We can see your slides.
Can you hear me now?
Yeah, now we can, but I think there's an echo. Probably there are two devices on or something.
How about now?
Yes. Perfect.
Okay, good. So I think that my topic is going to be a little bit maybe different from the previous session that I've heard. And this is my point is that I think we have now new treatments to improve outcome in patients with acute heart failure, which is something completely new. And when I'm giving this talk recently, I mean, I'm saying all the time that this is very exciting to me because up to 2 or 3 years ago, when we were talking about treatment of acute heart failure, I would always say, yes, we have a huge neurohormonal inflammatory adrenergic activation. There is really terrible outcomes. But when it came to treatment, basically, I had to admit that there is nothing we can do to the patient, either in the hospital or post-discharge, that was shown to improve the short-term, let's say, 60 to 180 days outcome. And I think that in the last 2 or 3 years, things have changed dramatically, and I will share my view of that with you in the next few slides. So in 2003, me and some of my colleagues have published a paper in the then nascent European Journal of Heart Failure, which was in its first 1 or 2 years under John Cleland's leadership, in which we've suggested that acute heart failure treatment should be divided into 3 phases. The first 2 phases are the immediate stabilization in the emergency room, and its goal is to improve the dyspnea and the relief of congestion. And then the first 24 hours after the initial stabilization, that it is mostly, the goal is to prevent readmissions, worsening heart failure in the hospital and recurrences of congestion in the hospital. And then after the 24 hours, we should refocus our efforts towards preventing disease recurrence, which means readmission and death and in the long and intermediate care outcome. I will start by saying, and this is really interesting that this is coming in the tails of the previous discussions about diuretics, that in my opinion, diuretics are not the answer, at least not to improving outcomes. Obviously, diuretics are helpful in improving congestion and making the patients feel better in the first day or 2 of admission. But when it goes to longer term outcomes, their effects are marginal. I will quote here, obviously, the dose study in which the investigators have tried to either give the diuretics continuously or in boluses, high intensity versus low intensity. And it didn't matter really at the end of the day. So yes, giving a little bit more of diuretics in the high dose strategy led to slight improvement that was marginally statistically significant in symptoms, but it had really 0 effect on outcomes. When we come at the back end of this, the recent publication of the acetazolamide study in patients with the compensated heart failure, we again see that we are really replicating the results of the dose study, because what was achieved was giving acetazolamide on top of the loop diuretics, the same as giving high dose loop diuretics. You get a little bit better the congestion, a little bit better symptom improvement. You can see that there is more diuresis, more natriuresis. The congestion is improved by day 3 and even beyond that, statistically significantly so. So undoubtedly giving diuretics helps in decongesting the patients in the very short term. But when we start looking at the outcomes, you can see that basically we have not achieved anything, because the death from any cause at 3 months was actually higher in active than in control, with hazard ratio of 1.28, which was obviously not statistically significant. The hospitalization at 3 months, again, higher in active than in control, hazard ratio of 1.07. And this hence diuresis came at the price of some adverse events. There was more need for renal replacement therapy. There was more hypokalemia and more hypertension. So I think starting from those and going up all the way to the ADVOR study and all the studies in the middle, we get the same picture. You give more diuretics to patients, you get a little bit more decongestion, a little bit more dyspnea relief at the price of more adverse events, and you never improve outcomes by doing that. So this is definitely not working. Maybe to some extent, there is some help that can be achieved by giving vasodilators. This is a study that my team has published in 1998 in the Lancet, in which we gave patients high doses of isosorbate dinitrate on top of furosemide when they had pulmonary edema. We did achieve better decongestion as measured, for example, by better oxygen saturation at within an hour of starting the therapy. And we had also some improvement in harder endpoints like reduction in MI and rates of mechanical ventilation, but this has never translated into, again, longer term outcomes. Now, inotropes are also not the solution, because as you can see here, both from the OPTIME study in which patients were treated with Renal versus placebo, there was no improvement in outcome, and in patients with ischemic cardiomyopathy, actually Renal was associated with worse outcomes. And in the Greek casino study, which was never published for some reason, but was presented a few times with very impressive results, there was actually an increase 6 months mortality in patients who received dobutamine versus placebo. It started already at 30 days and continued to 6 months. So clearly, inotropes do not, at least the classical ones, do not help. Of recent, Marco and myself and a few others, including Alex, have published a new study on istaroxime, which is a new drug that has a dual mechanism of action. It inhibits the sarcolemma and sodium potassium ATPase in a way that is similar to digoxin, but also activates SERCA2A. And when we gave this drug to patients with pre-cardiogenic shock acute heart failure that was not due to MI, we were managed to achieve for the first time ever a simultaneous increase in both blood pressure and cardiac output at the same time when it was given to patients with for 24 hours, and that was also associated with reduction of left atrium, the left atrium size, and left ventricular end diastolic and systolic volume. So maybe there is one drug that may be developed in the future that will help with that, but obviously we are far off from showing any improvements in outcome. So I would say that up to now, what we have learned in the last 20 or 30 years of research in acute heart failure is that diuretics and hemodynamically active drugs can help reduce some of the symptoms of acute heart failure, especially short-term in the first days of the admission, but they are in no shape, form improving the outcomes of the patient, and some of them might actually be harmful. There has been some interest recently in inflammation in acute heart failure. We have seen in previous analysis that inflammatory markers are strongly associated with adverse outcomes in acute heart failure. Interleukin-6 will be the number one among them, that has been shown in multiple studies to be highly significantly and independently associated with adverse outcomes in acute heart failure. A recent analysis that we have done and that was published in European the ESC Heart Failure Journal from a Spanish registry has shown that patients that had high CRP and were treated with steroids, but this is obviously a retrospective analysis, had better outcomes than patients that were not treated with steroids. And I think that there are a few studies that are being planned now and in the way of execution with IL-6 blockers, for example, in patients with chronic heart failure, regretfully nothing in acute heart failure. And we are starting also 2 studies of steroids in acute heart failure. One of them, Marco Metra, who is present here, is going to PI, and another one will be done in the group in Paris with Alex and Jonathan Freund as being the PIs there to try to examine whether we can improve the short-term outcomes of patients with acute heart failure by giving steroids. So basically, up to now, I would say, regretfully, I have to say that giving this presentation today, I have to continue to say what I've said for many, many years, which is that the in-hospital outcomes of patients with acute heart failure are really terrible. There is a lot of neurohormonal, inflammatory, and adrenergic activation, but no treatment today has been able to show any improvement in those bad outcomes. Diuretics, hemodynamically active drugs, including inotropes and even inflammatory blockers to this day, have shown some improvements in symptoms, some decongestion, but never ever have been shown to improve the outcomes of patients. And I think that these 2 first stages of acute heart failure, the immediate stabilization and the first 24 hours, still remain quote unquote orphan, with no treatment shown to benefit patients in reducing the bad outcomes during this period. However, once we have gone through this first 1 or 2 days of admission, and we are going towards starting to approach discharge, the world has changed. And there are many therapies now that have been shown to potentially improve the outcomes of these patients. For example, omecamtiv, which was studied in the study of patients with both post-acute and chronic heart failure, has shown some trends towards more improvement in outcomes in patients that were randomized to the study as inpatients. You can see here in the first interaction here on the top that the treatment effect, although the interaction was not significant, at least numerically is bigger in inpatient. And I think that it will be extremely interesting in the future to look at the effects of omecamtiv in patients in the post-acute period. So the iron, when given to patients that have some measurements of iron deficiency, like low ferritin, etc., after an acute failure admission was also shown in the AFFIRM study to improve outcomes to some degree. So readmissions and death, and there are many ways to skin the cat, if you will. But in any one of these outcomes, you can see trends towards improvement that starts a few weeks to months after admission when you give iron to patients with iron deficiency after an acute heart failure event. Soloist may be the first big study to show really a tremendous treatment effect in patients given after an acute failure admission. This study, in which admittedly only patients with diabetes have been enrolled, was published recently in the New England Journal of Medicine, that had an acute failure admission. Regardless of ejection fraction, and this was the first time really that somebody has been able to show that in the acute failure field, and I think Alex will talk about it later on when he comes to his presentation about strong, that in the acute failure field really doesn't matter if you what the ejection fraction is. The therapies are effective in patients with high and low ejection fraction to the same degree. Sotagliflozin, which is obviously a SGLT2 inhibitor, was shown when given to patients after acute failure to improve outcomes substantially with the reduction in the event rate of readmissions and death, either as a cumulative effect or the time to first event in both cases. This has been occurring, and as you can see here by the arrow, the effect has started extremely early, like 1 or 2 weeks after randomization. We're already starting to see divergence of the graphs with improvements in the outcomes of the patients who are treated with sotagliflozin, and this has been replicated with empagliflozin in the EMPULSE study that again targeted patients with acute failure with empagliflozin. The study had a combined interesting endpoint of win ratio that included quality of life, death, heart failure readmissions, and heart failure events. And I think, again, because I think until recently it was not appreciated that the post-acute failure period is a period in which the patients, because of this neurohormonal inflammatory adrenergic activation, are so susceptible to therapy that you really don't need to enroll thousands of patients in order to show that the treatment is effective. So the authors of the study and the people who planned it, and obviously John Turnick, who is among the authors of the study and is with us today, have opted for an endpoint that is a little bit more powerful with the win ratio that combines multiple facets of the disease, both quality of life and readmission and death. But in a presentation that was just made in HFSA recently, but not published yet, you can see that even if they would have opted just for heart failure readmission and death, they still would have gotten statistically significant effect, even with the small number of patients that have enrolled. So they were themselves pessimistic about the effects of treatment and opted for a more powerful endpoint that combines everything together, but they would have just won if they were just gone for readmission and death by itself. And so this is interesting. And the one study that I find the most striking of them all, which is again the same issue as that happened with empagliflozin study. The authors were enrolling only a few hundred patients, and they thought, well, you know, there is no way in the world that we are going to hit with a few hundred patients readmissions and death. So they went for a simple endpoint of reduction of NT-proBNP, which obviously they achieved by giving patients empagliflozin versus an enalapril post-acute failure admission. But look at this secondary analysis that was just published in Circulation recently by David Morrow, and you can see that within 60 days of discharge, putting patients on Entresto instead of enalapril has led to an effect size with a hazard ratio of 0.58, meaning there was more than 40% reduction in heart failure events and death within 60 days. And we have calculated in a paper that we've just published 2 weeks ago in European Journal of Heart Failure that discusses all these issues about the new light at the end of the tunnel that we are now seeing in the post-discharge treatments of patients with acute heart failure, that the number of patients needed to be treated by Entresto in Pioneer was in 60 days, was smaller than the number of patients needed to be treated for 3 years in Paradigm. So within 60 days of discharge of a patient with acute heart failure, you can improve the outcomes of acute heart failure patient by giving them Entresto instead of enalapril, obviously in this study with an ejection fraction with less than 40%, although Novartis people have told me that there is another study that is going to be probably presented at the European Heart Meeting in August that will address also patients with high EF. This study enrolled only patients with low EF, but in those patients with low EF and acute heart failure, giving Entresto post-discharge instead of enalapril has improved the outcomes by more than 40% and was already highly statistically significant with just a few hundred patients. So the investigators, again, were pessimistic about their own study result, and they were very cautious. They went with the primary endpoint of NT-proBNP, and really, this analysis of outcome has been criticized as being a post-hoc analysis. But the reality of it is that when you target patients with acute heart failure early after during the admission and post-discharge, you can induce massive improvements in outcomes with medications that in chronic heart failure take years to achieve the same effect sizes. So this is the reality that we are faced with now, and obviously Alex is going to talk about STRONG a little bit later in more detail. But this is the reality we are faced with now. Between the effects of Entresto that were seen in Pioneer, the effects of SGLT2 that were seen in MPulse and in Soloist, the effects of iron, and the highly significant effects that were seen with STRONG that, as you remember, we had to stop after 1,000 patients because of the result was so highly significant that the DSMB thought it was not ethical to continue the study. We are seeing now that treating patients with acute heart failure post-discharge with medications that modify the neurohormonal, at least the neurohormonal adrenergic pathways. I'm still hoping that somebody will be able to also do the same with inflammatory therapies and show the same with anti-inflammatory therapies, has massive treatment effects. 0.65 in MPulse, 0.62 in STRONG, 0.58 in Pioneer. We're looking at the improvements of outcomes in the vicinity of 35 to 40%. And this is for each one of them separately. Obviously, it is not ethical to do a study that will combine all of them together because I don't know who is going to randomize patients to a study such as this and not give patients either an SGLT2, a beta blocker, an MRA, a RAS inhibitor, or an Entresto. But I am sure that the effects are not going to be completely additive, but I'm sure that if we are to give all these therapies together post-discharge, the improvements in outcomes are going to be completely staggering. So for years, we've been saying that this is an analysis of biostat that BEF that is going to be talking after me and myself have done, published in European Journal of Heart Failure 2 or 3 years back. We've been saying for years that it is true that in chronic heart failure, there is neurohormonal inflammatory adrenergic activation, and therefore giving neurohormonal adrenergic blockers leads to some small clinical benefit that is can be measured in a 5,000 or 6,000 patient study. In acute heart failure, the neurohormonal inflammatory adrenergic activation is way, way bigger, much more substantial, and the evidence for that is overwhelming. This analysis that Beth, Alex, and myself did out of biostat shows it without any doubt. So it would have made logic that giving neurohormonal adrenergic blockers in patients in the immediate acute heart failure period, starting a few days after admission and going through the first week after discharge, will lead to larger clinical benefits. But nobody has ever been able to prove that until STRONG, on which Alex will be talking about in a few seconds. So I think that the challenge that we as heart failure physicians are facing now is that the world has not caught up with this knowledge base that we have created in the last 2 years. So if there are 2 patients that come to the hospital, and one of them is diagnosed with stage 3 colon cancer, which meaning is already colon cancer with metastasis, and the other one is diagnosed with heart failure. The patient with the stage 3 colon cancer has better prognosis. I was just talking to Dr. Sim from Singapore, who is going to participate in Robust, which Beth is going to present in a few minutes, about the Robust registry, etc. And he told me that in the same day he saw a patient that came to his clinic, and the patient went to do a routine chest X-ray, and they found a 1 centimeter lesion on his chest X-ray. And obviously nobody knew what it was, so they did some MRI of the lungs and whatever. And the result came out that the patient did not have a 1 centimeter cancer, but he had heart failure. So the patient came to him and said, "Thanks God, I don't have cancer, I have heart failure." And we were saying, stage 1 lung cancer, you can do a small resection, you have 95% 5-year survival. With heart failure, his 5-year survival is 60%. So the patient was happy that he didn't have cancer, while in reality, he has a disease that is much worse. And not only that the stage 3 colon cancer has a better prognosis than heart failure, but also the treatment effect that we have now between Soloist, MPulse, Pioneer, STRONG, and the iron study is much bigger. And still, the effect of chemotherapy has in colon cancer. And I don't even want to talk about the side effects. I'm just reading here from the package inserts of the medications that we give for colon cancer: hair loss, mouth sores, loss of appetite, weight loss, nausea, vomiting, diarrhea, skin changes, infections, bleeding, death. You give beta blockers, RASi, MRAs, and SGLT2 to patients, you're mostly going to cause some dizziness. So we have here heart failure, okay, that in the post-acute phase has terrible prognosis, has very effective therapy, it's very minimal side effects, and yet most patients around the world don't get it. I just came back from a visit to South America where I went to a city of 10 million people. I'm not going to name the name of the city. In that city, we calculated there were about 150,000 patients with heart failure, about 50,000 of each are admitted to the hospital every year. And in the city, there are 2 clinics of heart failure, each of them seeing 300 patients. Most acute heart failure patients post-discharge not only don't see a heart failure expert, don't even see a cardiologist. In Paris, in France, in the general city of Paris, where everybody is treated by a group of hospitals that belong to the APHP network, and there is good statistics. If you're admitted with acute heart failure, only 70% of the patients have any follow-up after discharge. And those who have follow-up after discharge, their follow-up is 45 days after discharge on average. 45 days. If somebody in Paris would have been diagnosed with colon cancer stage 3 and be told to discharge, well, maybe we will see you after discharge, maybe nobody will see you after discharge. And if we do, it will be your family physician probably is going to see you in about a month and a half. There would have been revolution on the streets of Paris. There would be red flags. There would be there would be trampled the Élysée Palace. But the thing that we need to change is that people are not taking heart failure seriously. And I think now the patients understand how difficult the disease is, and now the payers and the governments who provide the healthcare understand the importance of the disease and the fact that we are able now in the post-acute phase to really make huge differences to outcomes. And I think this is what we need to do next. So I will stop here. And I see that we have Dr. Alex Mebaza here, eager to take over for me. So I'm going.
Thanks, Gant. I think the subject is interrelated. Let's have the next talk also, and then we can have question and answer session before Professor Beth Davison tells us about the robust heart failure. So over to you, Alex.
Thanks very much for the invitation. I'm really honored. I guess you see the slides.
Yes.
Then my lecture will follow very, very well the presentation of Gadi. And after acute heart failure, you all know that all of you already, when you are doing the teaching to the residents, to the fellow, you clearly explain, and this is true, that there is a vulnerable phase after the acute heart failure episode. This vulnerable phase usually lasts at least 2 months with a high rate of rehospitalization. We will see data in a minute, and also a high rate of mortality. Can we try to prevent this? In fact, in this study, mixing data from Europe and data from Asia, you see here close to 20,000 patients. It's a retrospective analysis. Acute heart failure patients followed 1 year after being discharged from an acute heart failure episode. And as you can see here, the patients who had a combination, without even talking about the dose, but the combination of 2 classes of drugs after an acute heart failure episode, basically here beta blocker and RAS inhibition, had a better outcome than those who had only 1 drug and those who didn't have any drugs. And you see that the patient who had the combination were only half of the patient, and half didn't even have the combination of beta blocker and RAS inhibition. Now, talking about the dose of classes of drug, this is a very important paper published in 2017. As you can see here, you have the survival rate. Here you have ACE inhibitor ARB. Here you have beta blocker. Blue and dark are the patients who had at least 50% up to 100% or more of ACE inhibitor. And you see that if you had 50% or more over the next following years, the outcome was much better than those who had less or even no ACE inhibitors. And for beta blocker also, there is a threshold around 50%. You see that again, patients who had beta blocker 50% or higher, up to 100%, had a better outcome than those who had a beta blocker less than 50%. Then clearly, after a few studies, it appears that patients coming out after an acute heart failure episode should be treated optimally, meaning more than 50%, ideally 100%. And you see, by the way, that the benefits of being under treatment comes rather quickly. And as you can see here, if beta blocker and ACE both are at 100%, you see that for a long period, a year or even more, we can have really almost no evidence. Then why oral heart failure therapies are not implemented after being discharged? It could be related to many causes, and I even not sure that I'm covering everything. No disease program, cardiologists are busy. At what dose should we start? Does the region, continent matters? Does age matter? Let's talk about readmission after an acute heart failure episode. This is a study we performed in two large Lithuanian university hospitals. And you can see clearly here that when we looked on the acute heart failure patients over a year, you see that 50%, half of the patients who were admitted and discharged after an acute heart failure episode, half of them were readmitted, mostly for cardiovascular reasons, but you see that there are also non-cardiovascular reasons, but you see that the readmission for cardiovascular reason over a year was close to 1/3. This readmission was directly linked, highly linked to mortality, as you can see here. If we look on the readmission, regardless to the time of readmission, whether this readmission happened in the first month or later on, there is always a high link between readmission and death. As Gadi Kotter was telling you earlier, heart failure here is green, mortality over several years. Many cancers have a mortality that is higher, both in men and women, than heart failure. And for that reason, because we have data to tell us we need to quickly give the oral heart failure therapy, because we felt that cancer are doing better than what we are doing for heart failure, we felt that we should treat quickly, early, patients after an acute heart failure episodes. The European, but also the American guidelines are saying similar thing. Here in the European guidelines, it is said that it is recommended, an early follow-up visit is recommended 1 to 2 weeks after a discharge. AHA, ACC, HFSA, the association that is led by John Terling, are saying also the same thing. Then both North American and European guidelines are saying you should see your patient as early as possible after discharge. However, details are missing, details on what to do if we see them. Should we just do a clinical exam? Should we do biology? And the other information that is missing is how to start the oral heart failure therapies. And to try to answer to those two questions, Strong HF was designed. Here is the main inclusion criteria. Patients who are ready to be discharged from the hospital after an acute heart failure episodes. We took patients who had no or suboptimal dose of heart failure therapy. Those patients were highly congested. You will see the NT-proBNP level was very high. Patients were randomized in 2 arms. One arm was usual care. Usual care means we had a comprehensive medical report, and this medical report was sent to the cardiologist in town who was taking care of the patient like he was doing usually. In the other arm, high intensity care arm, before being discharged, we were combining 3 pills, 3 categories of drug: beta blocker, ARNI, RAS inhibitors, and spironolactone, mostly as an aldosterone antagonist. The combination of those 3 drugs were giving at half of the optimal dose. Then the patient, before being discharged, were giving at least those 3 drugs, 3 classes of drugs at half of the optimal dose. Exactly 1 week later, the patient again was discharged. We asked he or her to come back to the outpatient center, and we were checking that the combination of the 3 classes of drugs giving at the half of the dose was safe. What do we mean by safe? The physician were checking biology, meaning potassium, creatinine, and NT-proBNP, was checking 3 clinical parameters: heart rate, blood pressure, and the level of edema. And if everything is green, then we say to the patient, nice to see you, and we see you the next week, exactly the same day. Week 2 is a very important visit because, again, we are going to check safety, but when safety is fine, if all the lights are green, then the cardiologist had to up-titrate some or all the heart failure therapies to full optimal dose. Week 3, safety to check that the combination of the 3 classes of drug at full optimal dose is safe. And then we are seeing the patient at week 6, and all the patients, whether from the usual care group or high intensity care group, all were seen at 90 days by the investigators, and a phone call was giving an 180 days to catch the primary endpoint, heart failure readmission or all-cause mortality. As Gadi was mentioning earlier, the study was stopped because the DSMB felt that the difference was higher than expected, and they felt that it's not ethical to keep the patient in the usual care. Patients, here are the characteristics, maybe just to mention that, and this is important, that 2/3 had a left ventricular ejection fraction below 40%, and 1/3 had the left ventricular ejection fraction higher than 40%. This is important for us. Why? Because we know that acute heart failure patients coming to the emergency room, coming to the CCU, coming to the ICU, it's a mix between low ejection fraction and preserved ejection fraction. However, we know that guidelines are not saying so many things on patients with acute heart failure and preserved ejection fraction. Here is the level of medications. You can see here that at 90 days, and we have the 3 classes of drug, beta blocker, RAS inhibitor, and spironolactone, you see that already at 90 days, almost half of the patients had a full 100% full of the optimal dose of beta blocker and of RAS inhibitor. And already at 90 days, we had more than 80% of the patients who had a full dose of spironolactone. And it's interesting to see that at 180 days, there are almost the same prevalence. Now, interestingly, you remember I told you 50 to 100% of the optimal dose is already can already be translated on benefits. And as you can see here, at 90 days, more than 80% of the patient had half to full doses of beta blocker, RAS inhibitor, and spironolactone. Was this translated in change in hemodynamics? The answer is yes. There was in a high intensity care arm, lower heart rate, lower blood pressure, slightly higher potassium, and no change in eGFR. Surprisingly, we saw at 90 days, a clear improvement in the congestion parameters compared to randomization before discharge. Weight was lower, respiratory rate, peripheral edema, jugular venous pressure, NYHA, and NT-proBNP were all better in the high intensity care arm. If we look now on the primary endpoint, combining 180-day readmission or all-cause death, we found a much lower number of events in the usual care, in the high intensity care, compared to the usual care. Interestingly, when we ask the patients how they felt, and the quality of life was also markedly improved in the high intensity care arm at day 90 compared to the usual care. There were less event death over the first 180 days in the high intensity care arm compared to the usual care. If we exclude, and this was indeed pre-specified, if we excluded the death related to the COVID, as you can see here, both the primary endpoint and the 180-day all-cause death, where the difference was larger, both again on the primary endpoint and also 180-day all-cause death. And it's interesting to see that the benefits here appeared rather early. You see here that after the first month, almost already during the second month, we can already see the difference. And just to mention that when we look on the chronic heart failure studies, you see that the difference starts really later at least at 3, 4, 5 months. We can see the curves diverging. Coming back to STRONG, this benefits was seen, and this was really a surprise for us, was seen in both patients with a low ejection fraction or the preserved at least higher than 40% ejection fraction. Clearly, we could not see a difference. The benefits was seen regardless to left ventricular ejection fraction. Concerning safety, slightly higher adverse event in the high intensity care arm compared to the usual care arm. However, no difference in serious adverse event or fatal serious adverse event. Then to conclude, a rapid titration, indeed, with an environment that is highly safe. As you may have seen, there is a clear procedure that every cardiologist has to follow for every visit, combining biology, including NT-proBNP and clinical exam. Combining this rapid titration to a safety measures, we could show that it was safe and reduced heart failure readmission and all-cause death and improved quality of life. And I guess in the next minutes, Beth Dyson is going to show us how we are going to try to assess that rapid education can help implementing strong heart failure procedure into our daily practice. Thank you very, very much.
Thank you, Dr. Alex, for that presentation. Any comments from the floor? So apart from the Dr. Shastri, please.
Yeah, in what percentage of patients you could reach the maximum treatment considering hypotension or bradycardia and other things? In what percentage of patients you could achieve the maximum tolerated dose of beta blockers or ACE inhibitors within short time?
As you may have seen, if we take only one category of drugs, we achieved at day 90, but in fact, you will see in the following papers, in fact, it was achieved already at week 2. We had roughly half of the patients for beta blocker, half for RAS inhibitor, and close to 80% of MRA. Now, if we look on patients who got together the maximum of beta blocker, maximum optimal dose of RAS and optimal dose of spironolactone, we are talking about more than a third of the patient, close to 40% of the patient. I think, Beth, you agree, close to 40% of the patient, which is already great, had 100% of each of the 3 classes of drugs.
John, you wanted to?
Yeah, I think so. Fantastic presentations, and it's really some very important work being done here. And I think the thing that both of the speakers, both Alex and Gadi, stressed is this is actually a strategic, it's a strategy, it's a treatment strategy approach. So in the STRONG HF, as great a trial as it is, does not actually give us much information in terms of which component of that strategy was the thing that actually did it. And I think that's one of the exciting things about it, actually. And this is kind of making the bug actually into a feature. It kind of gives a great direction in terms of how a comprehensive program of care can provide dramatic impact on our patients. And I think, Alex, you did a great job of answering that question, because the question was, what was the maximally tolerated doses that the patients got to? And actually, I would suggest that STRONG HF may have been the first trial where every patient got to 100% of their maximally tolerated dose, because they strongly worked towards pushing patients to the tolerability limit. And so the target doses that we all talk about, and I said this in our previous meeting, are not usually, weren't even met in the clinical trials where the target doses were used. They were all defined by the maximally tolerated dose. And this is what this program actually pushes people towards. So very nice presentation.
Thank you, John. And you're right. We can see the thing the other way around. We can say, and I think it's totally fair, that 60% of the patient did not have 100, because they didn't tolerate one of the drugs. And I think this is one of the analysis we are going to do, is to see which intolerance was more important than the others. Was it heart rate? Was it blood pressure? But this is further analysis will tell us more.
Dr. Marco, you have any comments?
No, I've been honored to be part of this trial, and I thank also Gadi and Beth and Alex for having included me. I think the main question and the main analysis to do is just what John Terling was asking, which is the component. It's actually a strategy, but as written in the discussion of the main paper, all the trials comparing a disease management program, so without forced up titration of the drugs with the traditional treatment have failed. So I think that the implementation of and the administration of target doses is an essential component, although it cannot be taken away from the close follow-up of the patients. And actually, the only way that you can titrate to target doses is if you see the patients frequently, so that if the patient doesn't tolerate, you can change treatment. The other thing that I think was very important is that I don't know how it will be possible to quantify this, but the worse the patient are treated traditionally, the best the result. So, I mean, it's very important to, if my best friend has heart failure, he probably, I would behave as in strong HF with my best friend, talking with him by phone every day. But the far this person is from my reality, the most he can benefit from a strong HF program. So this is the real thing, and probably this is the reason why other programs have failed, because if the patients are treated in specialized centers, they may have the results as well.
Yeah,
this is my
the point that Dr. Teerling was stressing was we have data to show that even if you achieve 50 to 99% of the target doses, that is the maximum tolerated doses, they will derive almost the same benefit as you achieve the target doses. So that is the point which we have to, especially in many of the Indian patients, we cannot go to the higher doses due to the very low blood pressure and low heart rate. So that is the point we have to.
If you are a little bit patient, data should be ready, I hope in the next 2 or 3 months, to show whether 50, 50, 50, 100, 100, 100, what is the difference in outcome. I guess we will have that data to help you answering how things could be done in India. Yeah.
Dr. Sanjay wanted to make a comment.
Yeah, it was wonderful presentation, Dr. Alex. You did mention that you are going to look into the reasons why the people could not reach to the 100% dose. It would be very important, but also it would be important to understand from the usual care people why they did not increase the dose, because there is two arms here. One arm is the trialist group, which is the best hospital, and the other arm is the real world scenario when the people are using the practice. So if you can also look at the reasons why and what kind of practices they were doing in the usual care arm, it would be an eye-opener.
Yeah, thank you. Again, here, Gadi and Beth can help me. We didn't get those information from the usual care group, but let me tell you something. I'm sorry, too quickly in some slides, but there is something incredible that we saw. is the change between 90 days and 180 days in the usual care. I remind you that at 90 days, the usual care was seen by investigators. And you have to remember that the investigators over months were taught to do the strong procedure. And suddenly they were seeing the patients of the usual care coming. And you will see that the spironolactone, for example, did a big jump in the usual care between 90 days and 180 days. It shows that when you are a good physician, you cannot have your brain to do the best and the other brain to do a usual thing. Then it shows that education, very likely education, when the physician knows that you need to give quickly those medications, at the end of the day, they apply it. Because again, they did apply it for the usual care, at least for spironolactone, where you saw going from low to high. Again, we didn't took those parameters. Why in the daily life it was not done, but I agree with you, it's very important.
Yeah. Another point is that we should also consider the economic, the considerations in developing countries, so where the cost of therapy will also matter. So.
Sure. Yeah, absolutely.
Now we'll go to Professor Beth Davison for her presentation on the robust HF, which is the next step in the strong HF study. Over to Dr. Beth.
You can see it.
We can't hear you, Beth. Maybe you're muted.
Sorry, I'm my husband here is helping me with the slideshow. So you can see the slides, I hope.
Yeah.
Yeah. Given the promising results of strong HF and of the other studies of medications initiated or uptitrated around the time of discharge from a hospital admission for acute heart failure, we are launching this registry of post-acute heart failure management called Robust HF, for registry of best uptitration strategies in acute heart failure. These are my disclosures. We have 3 objectives in this study. The first is to describe in this multinational, multi-site registry the post-discharge care of patients with acute heart failure, including the number of post-discharge visits and their timing, who conducts these visits, medications which are prescribed, what follow-up exams are done, what labs are taken, is NT-proBNP monitored, for example, and then also outcomes during the first 6 months post-discharge. Our second objective is to provide professional education and resources for physicians to accelerate the initiation and uptitration of evidence-based guideline-directed medical therapies in appropriate patients following an acute heart failure hospitalization. And third, we aim to provide hospitals and country leaders information on patterns of care for patients discharged from an admission for acute heart failure by providing reports summarizing the data and comparing with benchmarks. So we want to enroll patients who have been admitted for acute heart failure for at least 72 hours, who are not treated with optimal doses of oral heart failure medications. So we have, I think, these rather simple eligibility criteria. First, they have to have been, as I said, admitted to the hospital for acute heart failure, diagnosed by dyspnea at rest and pulmonary congestion on either chest X-ray or lung ultrasound for more than 72 hours prior to being enrolled. They should have systolic blood pressure of at least 100 and heart rate of at least 60 in the 24 hours prior to enrollment. The last measurement of potassium should be less than or equal to 5 before enrollment. Then the last measurement of NT-proBNP of more than 1500. And then at admission at the time of enrollment, they should have been prescribed none or less than half of the optimal dose according to the protocol of RAS inhibitors, including ACE inhibitor, ARB, or ARNI, and none to less than half the optimal dose of beta blocker, and none to less than or equal to half the optimal dose of MRA. And for this study, we'll require written informed consent in order to participate. The inclusion criteria are age less than 18 and MI, unstable angina, or cardiac surgery, or PTCI within a month before enrollment, any severe valvular stenosis or regurgitation that needs surgical correction, renal disease, or history of dialysis, or the last measurement of eGFR of less than 30 during the admission. And then finally, we would exclude patients who are currently enrolled in a clinical study that mandates a particular schedule of follow-up visits for heart failure, or particular assessments or treatments for heart failure, because we want to capture what's being done in the real world and not protocol mandated management of these patients. So here's basically the overall design of the study. Investigators will receive professional education, enroll about 15 subjects, follow each of those subjects to 6 months post-discharge, and then they'll receive a report summarizing the post-discharge care of patients at their institution, in their country, and overall. And then the process would be repeated. So this would cycle over the course of the registry being open, basically. And then from the patient perspective, patients admitted to hospital for heart failure at least 72 hours will be identified as eligible to participate. They'll sign informed consents. They'll have their data collected over 6 months post-discharge. And then they'll receive a phone call at 6 months to see if they're still alive, if they've been hospitalized, and what heart failure medications they're taking. So the study will last 6 months for the individual patient, and we anticipate the study to last 4.5 years overall. So we're not asking investigators to treat or follow patients any differently than they normally would. So the protocol doesn't mandate any particular treatments or follow-up schedule. We just want to collect data on what is currently done to manage these patients post-discharge. So here's an idea of the data that will be collected. These will be collected into an eCRF, cloud-based, so it should be accessible to pretty much everybody. First, details on the acute heart failure admission itself, including baseline patient characteristics, laboratory exams, and medications given. Data on the discharge from the hospital, basically including its timing, what medications were prescribed, and again, what laboratory tests were done. And then we would like to, as much as possible, collect data on each post-discharge outpatient visit that's done. So that would include the timing, the location, who provided the healthcare, whether or not a physical exam was done, including an evaluation of heart failure signs and symptoms, whether any laboratory evaluations were done, what medications were prescribed. And then through 6 months, we would like details on any readmissions or death that occurred. Again, at 6 months, the patient would be contacted and the chart gone through to make sure that any visits with other healthcare providers had been captured. We really intend this to be a global registry with 3,000 patients in 100 sites and 44 countries and 6 of 7 continents. So here's a preliminary country list with sites in Eastern and Western Europe, North and South America, Africa, and Asia. And the country lead here in India would be Professor Harikrishnan, with the global principal investigator being Professor Mabasa. Here's sort of a rough timeline. The protocol is nearing finalization. It was pretty much final the end of, middle of last month, but we've had a few weeks since then. We have sent out a request for proposal to contract research organizations who can help manage the study. We'll select those next month. We're in the process of selecting countries, identifying country leads who will then help us to identify sites. We hope to do that by April, and then have regulatory submissions starting in April or May of this year, with a first patient first visit in June or July. The last patient enrolled in July of 2026. And the current plan is that we would have data reviews over the entire study for the executive and steering committee members annually in the summer, and hopefully we would be able to publish those results annually. Thanks.
Thanks, Beth. So I think that is exciting. Yes, John, we share your claps. So this is really exciting and wonderful results that have been shown in the Strong HF study. Let's see, hopefully we can duplicate them in our practice also by applying the same yardsticks and same methods of treatment. Any comments from any participants, any persons? Dr. Mittal?
Yeah, the exclusions excluded people only to 1 month of PCI and surgery, bypass surgeries and all. Any reason 1 month, not 3 months?
But we are trying to make.
Yes, Beth. The
We're
question
trying
is
to
that
make it.
you are excluding people within 1 month after bypass surgery or PCI. Any particular reason for choosing 1 month and not 3 months?
We were trying to make it as easy to use for as generalizable as possible. Usually within 1 or 3 months, 1 month of intervention, there is a lot of severe adverse events that can still happen, readmissions, etc. It could have been either way. I think the executive committee looked at it and we thought 1 month is good enough. The push from the executive committee was to reduce the exclusion criteria as much as possible and broaden the inclusion criteria as much as possible. So I think that was the main reason.
Okay, so minimum is 1 month, but you can, if you choose, you can choose your patient later.
Yeah, of course.
Okay, John, any words of wisdom?
No, I think it's an exciting international initiative, and I'm honored to be part of it, and really looking forward to how this progresses over the multiple countries. I think it goes back to what we said earlier in today's sessions in terms of this is the exact kind of international collaboration that I think can really move the field of heart failure forward and help us all learn from each other in terms of how best to implement these life-saving practices. So I'm looking forward to it.
Midja?
Also from my side, congratulations, Alex and team. Maybe 2 questions. One is, and for the first one, I can anticipate the answer because it's based on Strong. Inclusion criteria, SGLT2 inhibitors, none or will not be inclusion criteria? Because
there will just not be an inclusion criteria. You can, the patient can be enrolled regardless of how much SGLT2 they receive.
And the second one is the set of the countries able to participate already finalized, or any open door?
Any ideas are more than welcome. At the last count, the countries that are going to be participating in the study represent 80% of humanity. We are happy to go up to 90.
Okay.
Yeah. Final comment from.
Yeah, one question. Do we also include pregnancy-induced heart failure or we have to exclude them?
Oh, that's a good question.
Very good.
We did not think about it. Let me take it back to the executive. Good, very good question. Right now, it's not excluded. Maybe you're right. We should.
Probably should be an exclusion.
Yeah.
I think it should be an exclusion. Very good question.
We'll take it back to the executive committee and think about
Thank you.
So thank you, everyone, for this wonderful session. And I think we will follow with the investigators meeting. It's a small group. It will be on the side of this meeting room. I think the team in the screen can join. I have sent the link to you, another Zoom link. You can join that. And so thank you, everyone. So we'll close the meeting. And the dinner is served outside.
Okay, good for you.
Joining. Good night.
Right.
Thank you very much. Enjoy your dinner.
Come get some breakfast.
Enjoy. Bye-bye.
John, go and see a doctor.
Do you know any good doctors?
We'll find one for you.
Thank you, my friend.
Good night. Good night.
Good evening to all. Welcome to this session, Adjunct Symposium 6. Now, I would like to introduce our today's first speaker. Technical team, can you give me some rights to share the screen? Yeah. Yes. Thank you. So our today's first speaker, Dr. Sanjay Mittal, who is a Senior Director of Clinical Cardiology and Research at Medanta, the Medicity, Gurgaon. He is the Director of Medanta Duke Research Institute. He is also the in charge of the Heart Failure Program at Medanta, the Medicity. More than 50 publications to his credit in various national journals and textbooks having high impact factors. He is also the recipient of many professional awards. Now, I request Dr. Sanjay Mittal, who is going to talk on early initiation of ARNI in acute decompensated heart failure patients. Over to you, sir.
Good evening, friends. I am Dr. Sanjay Mittal, and I am going to discuss with you early initiation of ARNIs after acute decompensated heart failure. The importance is that today, and my subsequent speaker would be talking on these 4 pillars, but heart failure with reduced ejection fraction today has these 4 pillars, and ACE inhibitors or ARNIs are the first and the most important pillar in this particular regimen. We know since 2014, when the Paradigm HF trial results came, which shows remarkable whooping 20% risk reduction of CV death and heart failure hospitalization, 20% reduction in sudden cardiac death, 16% reduction with death from any cause, and 23% reduction in heart failure admissions. With ARNIs, as compared to already established ACE inhibitors, is a remarkable discovery after 30 years of the treatment of heart failure. But unfortunately, there was still the unanswered question at that point. One, what was taken here was stable patients with stable heart failure medications. And they were already ACE inhibitors, on ACE inhibitors and tolerant to ACE inhibitors. And the eGFR was more than 30 ml per minute per 1.73 meters square. So those were the things which we had to adhere with after the Paradigm HF trial. As of today, the rationale is that ARNIs over an ACE inhibitors should be used in heart failure with reduced ejection fraction patient chronic stage as well. And the reason for that was, if you look at the meta-analyses and the sub-analyses of Paradigm HF, within 7 days, there was a greater reduction of NT-proBNP levels as compared to the ACE inhibitors. So that is one. That means the effects start very early after the switching over from ACE inhibitor to ARNIs. Within 2 weeks, there was significant improvement of quality of life as compared to the baseline. In 1 month, there was lower rate of hospitalization. So within 30 days, we could see the effect on repeated hospitalizations after the switch over to ARNIs. And in 12 weeks, that is 3 months, it was a greater reduction in the volumetric analyses of the ventricles as far as ejection fractions, stroke volume index, and systolic volume and diastolic volume is concerned as compared to ARNIs. Also, there is enough data now that in chronic heart failure with reduced ejection fraction patients, as we go ahead with timeline, there is ejection fraction improvement in majority of patients to almost 4.8 points improvement in 6 months, on an average of about 9.6 points over 1 year after switching over from ACE inhibitor to ARNIs. So that is something which makes it hugely effective to even take the patients out of the indications of ICD. So many of the patients would increase the ejection fraction above 35%. Almost 32% of patients improve the ejection fraction above 35%. So that is something which is remarkable and a point in favor of using ARNIs over ACE inhibitors. So let me now start with the acute decompensated heart failure scenario. Where are we and what field should we do? Let me begin with this case who came to me. Mr. AM presented with breathlessness on exertion for last 8 days only. And he had some retrosternal chest discomfort 2 weeks back and was being treated as gastritis. We did find there was no ischemic heart disease. He denied any previous breathlessness and did have a sedentary lifestyle though. So it was very difficult for knowing when did the disease start, but this was the first admission for heart failure. He presented with tachycardia, 104 pulse rate, sinus rhythm, blood pressure was 130/90, saturation and room air was okay, but he was having increased respiratory rate, JVP and pedal edema, all suggested of a congestive heart failure in presence of S3 and no murmurs. Ejection fraction was whooping 15%. And there was some degree of mitral regurgitation and diastolic pressures were elevated, which was a main concern. So the main concern was what should be done. The pressure head was all right. There was congestion and there was something, the person was symptomatic. We had to decongest, obviously evaluate the cause of acute decompensated heart failure. So in acute decompensated heart failure, we have certain questions to be answered when we choose the right therapy. What is the problem with, why are we bothered about acute decompensated heart failure in the first place? I'm going to discuss about the role of ARNIs as the evidence has been telling us over the last few years. When can we use ARNIs? How can we use ARNIs and how safe is it to use ARNIs and what precautions should we take during the initiation of ARNI therapy? So the first thing which I would like to mention and discuss with you is the importance of acute decompensated heart failure, and we pronounce it as a vulnerable phase during the course of heart failure. We know heart failure with reduced ejection fraction is a continuum progressive disease. It starts with some kind of myocardial injury, heart injury, which leads to reduction in cardiac output and blood pressure. And because of this reduction in cardiac output and blood pressure, there's a counter-regulatory hormones which are meant to increase the cardiac output so that the vital organs, the brain, and the other vital organs are preserved and they are not damaged. So that preservation cycle is to maintain the cardiac output. For this, we have to increase the cardiac contractility, increase the heart rate by the adrenergic system, and other neurohormonal activation is there, including the renin, angiotensin, aldosterone axis. But in the long run, this leads to sodium and water retention, which means increased preload. Cardiac contractility is more, the blood pressure does go up, but on the count of peripheral vessel constriction, which leads to increased afterload. So increased preload and afterload combinedly cause increased workload, and the heart, which is already dysfunctional, is overloaded, and this vicious cycle of heart failure goes on and on. So initially, what are the compensative mechanisms actually lead to a long-term decompensative mechanism. So the understanding here is during the acute phase of heart failure, when the person first presents with acute decompensated heart failure for that matter, there's obviously a deterioration in quality of life because the person requires admission. But after the handling of that acute emergency, the reason for the myocardial injury or the insult, there is an improvement in the heart function, and the person does stabilize. And for a varied period of time, the person does stabilize. So here is the time of concern because there is a deterioration in heart cycle, and this is called as a vulnerable phase. After a certain period of time, maybe going to months and years, the person has a dip again because of recurrence of certain factors, cheating on diet, not controlling the risk factors, or the myocardium burning out. A vicious cycle of heart failure sets in, and then the heart failure repeated hospitalization is there. But each point in time, we can control by upscaling diuretics, upscaling the pharmaceutical management. If you can see, the disease-modifying agents are going to be upscaled. But at some point in time, there is a point when the person does not tolerate this upscaling and there is a deterioration, and this is stage D or surgical heart failure, talking about end-stage heart disease or end-of-life care or transplant or ventricular assist devices. So this is the continuum of heart failure where each particular episode of hospitalization is laden with deterioration in the outcome, increase in risk of the readmissions and death, subsequent death. So if we can draw the whole system into the plot with a risk plotted against the readmission risk. So if you look at when the first admission has happened, the first 2 months are the vulnerable period, because in the first 2 months, because of that myocardial injury and the process of stabilization of cardiac output just take 2 months, and repeated hospitalization is very common. If you look at this vulnerable phase after first hospitalization for heart failure, nearly 30% of all the cumulative heart failure hospitalization happened within that first 2 months. So that is why it is called as vulnerable phase. And as the heart failure progresses towards the end, normally almost 50% of rehospitalization of heart failure happen towards the end of the progress. That means the heart failure rehospitalization is leading to death within 2 months. So that is why these two peaks count for 80% of the heart failure hospitalizations. When the person is stable or plateau phase, only 15 to 20% of the total hospitalization happen, and this is the time when the person is stable. So what is happening here is we have to recollect that vulnerable phase and the rehospitalization towards the death of the heart failure patient is something which accounts for 80% of the hospitalization. So whenever the ADHF happens, it actually is remarking subsequent poor prognosis, much higher chances of rehospitalization within the 30 days period. So if you look at the chances in India, almost 1 in 6 people who have hospitalization for heart failure would die within 30 days of hospitalization. So that is almost 17% mortality. The other thing is rehospitalization within 90 days is whooping high after the discharge. And we have to be very cautious in not ignoring heart failure admissions, acute decompensated heart failure. How to recognize the high risk group in a person who has been acutely decompensated is by looking at all these pressures. The person is hypotension, much higher risk of rehospitalization and death. Elevated urea nitrogen, again, looking at the vital organs, hypoperfusion, hyponatremia, history of previous heart failure hospitalization, elevated NT-proBNP, and Hfai. All are markers of suggesting this person who has been admitted with acute decompensated heart failure is more likely to present to us again. So these have to be handled more cautiously. When a person presents to us with acute decompensated heart failure, we have to be cautious because that time the compensatory mechanisms have or may have to be supported. And that is why the criteria or guidelines say that that time we have to decrease congestion by diuretics, loop diuretics for that matter, maybe injectable or drip form, or the oral, depending upon however the patient can be decongested. Optimize volume status, and then identify the causative and precipitating factor and recur them. And then the timeline takes over. That after the stabilization, we have to graduate into the chronic heart failure therapies because there has to be the gap which has to be minimized so that the outcomes or rehospitalized rates are minimized. So the algorithm which is here is that in acute decompensated heart failure, after the adequate decongestion has happened, the reduced ejection fraction people have to be started on all four pillars: ACE inhibitors, beta blockers, or ARNIs, MRAs, and ivermectin, depending upon the heart rates. And we talk about SGLT2 inhibitors as the fourth pillar now. If the person is in refractory heart failure, obviously there is palliative care or transplant surgeries or ventricular assist devices we are talking about. So this is something which we have, that acute decompensated heart failure, as soon as the person is adequately decongested, we have to swap to a heart failure with reduced ejection fraction therapies. So if we draw this whole process, the continuum of a timeline of a process of acute decompensated heart failure, the priorities do change. The first focus during admission is to decongest the person, and pressure and other things have to be monitored. So that is taking the priority. But as soon as that phase is taken over, there is a crossover to a chronic phase. That means we have to resort to the transition therapies, or like beta blockers, ARNIs, ACE inhibitors, and SGLT2 inhibitors and MRAs. And that should happen before the person is discharged. Otherwise, there is huge risk of the person landing up in a problem. And what is the data showing is, if we don't give these therapies before discharge, there's less likely of those persons getting the therapies even after discharge. At 60 to 90 days follow-up, look at those who could be started within the hospital, much higher. But if we think that we'll start it after the first follow-up, it is usually not startable at that point in time. So we better do that at the time when the person is getting discharged. So if we look at the Indian data, the unfortunate signs are dismal. Only 25% people who are discharged out of hospital after acute decompensated heart failure are discharged on the guideline-directed medical therapy. And if you look at the anti-RAS inhibitors, only 57% people with Hfref have that. Beta blockers, only 53% people. And ivabradine and digoxin are dismal, 4.9%. So these are the data which was published from 2020 in Indian Heart Journal, and I'm quoting that data for you. So this is dismal, and we have to improve that. There could be a lot of issues. There could be patient-related issues, physician-related issues, but most importantly, how we can take it forward is what I'm going to discuss about from the ARNI's perspective. There is always a concern of hypotension. There's always a concern of worsening renal dysfunction and hyperkalemia. but armies are safe